Now you'll notice, however, there is another fiber postganglionic that appears to be releasing acetylcholine. Acetylcholine can also be a postganglionic transmitter in sympathetic nerves. Not many of them. The most important of these for exam purposes is to recognize that the thermoregulatory sweat glands have receptors for acetylcholine that are muscarinic. Now, normally, you see, we've thought about muscarinic receptors as being postganglionic in the parasympathetic nervous system. They're the ones that we generally think about. But this is in the sympathetic nervous system. And in the sympathetic nervous system to the thermoregulatory sweat glands, acetylcholine is activating a muscarinic receptor. Now, how do they challenge you in this way with this little, apparently innocuous piece of information? They might do it in the following fashion. What would you expect if you increased acetylcholine at that junction, at the thermoregulatory sweat glands? You would expect to sweat a lot. And you would, because this is a thermoregulatory sweat gland. And therefore, drugs that work on cholinergic function to increase acetylcholine have the tendency to do that. What would you expect atropine to do? Remember, atropine is a muscarinic blocking agent. Atropine is going to make you very hot, and you're not going to be able to do too much about it. Why? Because you can't sweat. And if you can't sweat, you can't get rid of heat. And if you can't get rid of heat, what are you going to do? You're going to vasodilate, and you're going to get very hot in terms of vasodilation. And if you're of the right skin pigmentation, you're going to become bright red, right? And that is typical of an atropine action. It's called atropine flush. So this is how they ask you about thermoregulatory sweat glands and how they relate to cholinergic function. Even though it's a sympathetic by innervation, it is a cholinergic postganglionic mechanism. So it's important that you recognize that aspect of the system here, particularly I like to think of with respect to the thermoregulatory sweat glands. It's not the only one. Piloerector muscles can also be affected, and there are some muscarinic receptors of the sympathetic nervous system in certain vasculature. But this is by far the most likely thing to be asked about is thermoregulation. So I do emphasize that very, very strongly. Okay, the next aspect of this is to remind you about it in a sort of a, rather than in a figurative way, in a more tabular way. NN stands for nicotinic receptor, all ganglia, whether it's parasympathetic or sympathetic, and in the adrenal medulla. NM stands for nicotinic at the skeletal muscle junction, and that's at the end plate. That's not autonomic, that's somatic. That's our voluntary nervous system as opposed to involuntary autonomic. And M stands for muscarinic. That's all postganglionic parasympathetic innervation and a few places in the sympathetic system, most notably the thermoregulatory sweat gland. I think I've repeated that now 3 times, so you probably got that squared away. Now, what about adrenoreceptors? Well, these are at all postganglionic innervations of the sympathetic nervous system, and they will fit under the various subtypes of alpha and beta adrenoreceptors. Now, the neurotransmitters, acetylcholine, will activate both N and M receptors. Norepinephrine appears to be the major transmitter of the sympathetic postganglionic neuroeffector junctions. And dopamine in the periphery seems to be pretty much localized to the renal vasculature. And activation of dopamine receptors there increases renal blood flow and is protective in cases of patients who are in shock. One of the important clinical uses of dopamine as a drug is the increase in blood flow to the kidney to protect the kidney in a shock-like state. So that's a little bit different. Chemically speaking, dopamine is only small different from norepinephrine, but it is different in terms of its neurotransmitter role. What about epinephrine? Epinephrine would not be thought of in a classic way as the neurotransmitter in the sympathetic nervous system, but you know, epinephrine released presumably from the adrenal medulla will activate nearly all of the adrenoreceptors that we've ever identified. It doesn't even matter whether the systems are, or the tissues are innervated. Epinephrine just gets there and activates all of these types of receptors. Now, we have several other potential neurotransmitters generally thought of as being restricted to either the enteric nervous system, which is a nervous system a little bit different from both sympathetic and parasympathetic, but obviously related to the gut, enteric nervous system, and certainly some of the autonomic fibers that cross over between enteric and ordinary autonomic innervation. Among the transmitters that are present there are serotonin, and many drugs that work on serotonin receptors have gastrointestinal effects, as we'll describe later. Purines are among the category of potential transmitters or co-transmitters here, and a number of peptides. Among the peptides that seem to be present in the GI tract as possible neuroregulators are the opioid peptides, and that is of obvious specific interest to us in pharmacology when we recognize that opioid analgesics work through these types of receptors. Now, it's always helpful to do a little bit of physiology review when doing autonomic drugs. It's not that you don't know this, I think you know it, but you need to be reminded about it in the context of pharmacology. I mean, I'm sure you're well aware of what the major determinants of blood pressure are. Total peripheral resistance and cardiac output. These multiplied together give us blood pressure or mean blood pressure. You should know that the control of blood pressure by the autonomic nervous system involves feedback. Feedback mechanisms are very important in physiology, and they also are important in pharmacology because you'll see them invoked when we use drugs that might modify, for example, blood pressure. For example, when you get an increase in blood pressure, the baroreceptors detect that increase in mean blood pressure, and they do something about it by sending messages to the autonomic control centers, the vasomotor centers, which will increase outflow of the parasympathetic nervous system, PANS. Now, what does the activation do of the PANS? It slows the heart. So you can anticipate that with an increase in blood pressure, you'll get a reflex effect on heart rate. It's called a reflex bradycardia. And you will also get a decreased outflow from the autonomic centers of the sympathetic nervous system. And that, since sympathetic control of the heart stimulates the heart, the decreased sympathetic activity leads to a drop in heart rate and, importantly, a drop in contractility of the heart. The force of contraction declines. And in addition, since sympathetic tone dominates vascular tone, then you will get a decrease in vasoconstrictive activity of the sympathetic nervous system. So you see both branches of the autonomic nervous system, increased PANS and decreased SANS, actually is trying to restore blood pressure to a normal level because of an increase in blood pressure. Now, if we then say, well, what would happen if you decrease blood pressure? What's a good way of decreasing blood pressure? Hemorrhaging. Right? In physiology, they always give you that example. Your blood pressure goes down because you've lost blood. What are you going to get? You're going to get a feedback in control that will lead to a decrease in vagal tone to the heart. So instead of having the heart slowed, the heart will increase. And you'll get increased sympathetic tone, which is going to increase the heart as well, increase cardiac output, and increase constriction of the blood vessels, leading to an increase in total peripheral resistance. And we just said blood pressure is CO times TPR, or cardiac output times TPR. We're increasing both of those parameters as a means of reflexly dealing with the situation of a change in blood pressure. All of the things we've said about these mechanisms are neural mechanisms, neural feedback loops. And you can see them described in the diagram here by virtue of what would happen if you increase blood pressure. Increasing blood pressure causes an increased baroreceptor discharge. That leads to an increase in vagal tone, all right, from the vasomotor centers, and a decrease in sympathetic tone. So we see our, if you like, increased vagal tone leading to a bradycardia. We see our decrease in heart rate by decrease in sympathetic tone, a decrease in contractility, and a decrease in vasoconstriction. So once again, then, we bring ourselves back down to a normal type of blood pressure. Now, under this arena of neural control, there is something else I have to draw your attention to, and that is what happens when you modify total peripheral resistance. And I'm particularly interested in that in a drug way. All right? What would increase TPR? Any vasoconstrictor. How would you bring that about? Activate an alpha receptor. And that vasoconstriction action then will elicit a reflex bradycardia. So when we talk about, for example, the use of decongestants, which are alpha receptor activators, and cause vasoconstriction so that we get, the ability to breathe because they're decongestants, too much of a good thing can actually have an effect to change blood pressure, and changing blood pressure will lead to a reflex bradycardia. Right? That's one of the things that can occur with anything that's vasoconstrictory. Likewise, or if like conversely, I should say really, anything that can lead to a decrease in peripheral resistance, like a vasodilator. Do we use vasodilators? You bet. I mean, the largest part of treatment of hypertension is to get vasodilation. What are you going to get when you get vasodilation? A drop in blood pressure. Sure, because you've decreased TPR. And what do you think the outcome of that's going to be? A reflex tachycardia. You're going to increase heart rate because of that action. And that may or may not be desirable to all of us to have an increased heart rate. Remember, uncontrollable increases in heart rate is a very good way to get a cardiac arrhythmia and sudden death. So, obviously we have to keep these things in mind with respect to pharmacological actions. All of this is neural, everything we've said so far. What about hormonal? There is a hormonal feedback loop that is largely influenced by decreases in mean blood pressure. Very little evidence that an increase in blood pressure has much impact on this hormonal loop. It's the lowering of blood pressure that seems to do that, like hemorrhage, for example, or like the use of a vasodilator. Whenever you lower blood pressure, you decrease the blood flow to the kidney. So you see a drop in renal blood flow. That means that the pressure goes down in the renal vasculature. Every time you do that, you release renin from the kidney. And that renin increases the formation of the angiotensins. So angiotensin 1 is formed. This gets converted to angiotensin 2. Angiotensin 2 increases the release of the mineralocorticoid aldosterone. Aldosterone causes water and salt retention, and that increases blood volume. And it's like plumbing, isn't it? If you increase blood volume, like increasing the amount of liquid in a tube, you'll increase the pressure. And that's indeed what happens. It helps to restore blood pressure by the increase in mineralocorticoid release. You also then will help out by increasing venous return. You see, when venules contract or increase blood content in them, they increase cardiac output by increasing venous return. As it turns out, angiotensin 2 not only releases aldosterone, but is in its own right a vasoconstrictor, because we can find angiotensin 2 receptors on the vasculature, which when activated by angiotensin 2 in the blood, lead to vasoconstriction, which increases total peripheral resistance. So this is the humoral side of things in terms of feedback mechanism. How does this relate to pharmacology? Largely in the context of management of drugs that management of conditions that require drugs that lower blood pressure. I'm thinking here of the millions of people in the United States who are treated with antihypertensive medications. You lower blood pressure with an antihypertensive medication, you know what our bodies try and do? They try to compensate for that. And they compensate for that by both neural and humoral mechanisms. And why do they do that? I don't know, but we're very cussed beings, right? And we do it because we don't like to have our blood pressure brought down. We do the best we can to bring it back up again. So this is something very, very relevant to pharmacology. It's shown here in a diagrammatic form. Notice that I emphasize once again this works pretty much only in hypotensive situations where you've lowered blood flow to the kidney, and that releases renin. Renin actually causes formation of angiotensin, which relates to the increase in aldosterone. This causes an increase in blood volume, ultimately an increase in cardiac output, an increase in blood pressure. Angiotensin by itself can cause vasoconstriction, which can lead to an increase in total peripheral resistance. We now have to go over to adrenergic pharmacology, and here I want to describe the system first of norepinephrine neurotransmission. Here we're going to have more complexity than we saw in terms of the cholinergic nerve ending, but the general principles are for the most part the same. You're going to synthesize the neurotransmitter, you're going to release it by excitation of the nerve membrane here, and it's going to go across the junction and interact with receptors on the effector cells. However, I have to describe the steps to you in much more detail, so we'll start at the beginning with tyrosine. Tyrosine is the precursor molecule of the catecholamines, and by that we mean not only norepinephrine, we also mean dopamine and epinephrine. And tyrosine is taken into the nerve endings by an uptake system, an active uptake system, and is a substrate for the enzyme tyrosine hydroxylase. This enzyme, which is not outside the nerve ending, is actually present inside the nerve ending. Item 1 here is the rate-limiting step in the synthesis of norepinephrine. And this then forms dihydroxyphenylalanine, or DOPA, L-DOPA, and this is a substrate for the enzyme DOPA decarboxylase, which is converting DOPA to the compound dopamine. Now, in most sympathetic nerve endings, probably all, dopamine is not the transmitter, but is actually the precursor molecule to norepinephrine. And it's a substrate for the enzyme called dopamine beta hydroxylase. And dopamine beta hydroxylase, as it converts dopamine to norepinephrine, actually leads to the accumulation of norepinephrine in these little circular granules here, just in the same way that we sort of described the ability of acetylcholine to be sequestered in these granules. The catecholamines, like norepinephrine, can also be put into these granules, waiting for their release with an excitatory event. Now, although there are inhibitors of tyrosine hydroxylase, they have no clinical uses. Inhibitors of DOPA decarboxylase are not used specifically in what we call autonomic pharmacology, but we will see them later when we discuss the matter of the use of levodopa as a drug for treatment of Parkinson's disease. We actually prevent metabolism of DOPA to dopamine in peripheral tissues by using an inhibitor of DOPA decarboxylase. We have no drugs that are used clinically that will interfere with the conversion of dopamine to norepinephrine. So as far as synthesis is concerned, although molecules do exist that inhibit these different enzymes, they have very limited clinical applicability. Now, what's going to happen to norepinephrine in terms of its release? Well, the release mechanism is very similar to the release mechanism that we've described for acetylcholine. You're going to have the influx of calcium. It's not drawn specifically as an influx shown here in the diagram for simplicity reasons, but what we're saying is that calcium influx initiates the release of amines by causing fusion of these vesicles with the presynaptic membrane. So norepinephrine will be released into the junction and can activate receptors according to which receptors are present on the effector cells, alpha, beta, etc. And that's very, very similar to what we described for acetylcholine. Where we begin to see some divergences, however, is in what is the major mechanism for termination of the action of norepinephrine on these receptors. And that actually is the mechanism involving reuptake of norepinephrine back into the nerve ending. And this is by a system that's referred to as uptake 1. And we now also use interchangeably with that system the idea of a norepinephrine transporter system. So in order to, if you like, terminate the action of norepinephrine, this transporter system, uptake 1, has to be operable. In other words, we bring norepinephrine away from this junction by bringing it back into the nerve ending. Notice that does not happen with acetylcholine. We never mentioned anything about that. We said there's an uptake system for choline, but not for acetylcholine. So here we have an uptake system for norepinephrine, which is probably the major way of terminating the action of norepinephrine at postjunctional receptors. Now, what else could happen, however? Well, you might get some diffusion away from this site. That's a possibility. And to some extent, enzymes present outside of the site and also in tissues close by, glial cells, like catecholomethyltransferase, may also be responsible to a small extent in metabolizing norepinephrine and therefore reducing its activity at the level of these receptors. But it is a minor pathway. The major pathway is uptake through uptake 1. There is also in many nerve endings a feedback mechanism, and that feedback mechanism, as shown here, as I'm describing for you, in the ability of some norepinephrine that's been released into this junction to actually come back and hit a receptor that's pre-junctional, right, or presynaptic, which is a receptor for norepinephrine referred to as an alpha-2 receptor. And this is an autoregulatory mechanism because the alpha-2 activation actually inhibits the release of norepinephrine. It may also inhibit tyrosine hydroxylase. So it's a feedback mechanism. So that also influences, it doesn't terminate action of norepinephrine, but it does influence sympathomimetic transmission. So you've got several things on the go here, but the most important for us in the context of termination, once again, is the uptake 1 or norepinephrine transporter. Now you'll notice that in the nerve ending there is also a mobile pool of norepinephrine distinctive from the norepinephrine present in the vesicles. This mobile pool does provide some of the norepinephrine for uptake into the vesicles, and it can be modified by enzymes present in the presynaptic nerve ending. The most important of these is monoamine oxidase, or MAO. So MAO can actually work to metabolize norepinephrine to inactive products. It also happens to work on dopamine and therefore can control dopamine levels in this nerve ending as well as norepinephrine present in the nerve ending. It works on the mobile pool of norepinephrine, not on the granular norepinephrine. Now, just thinking about this, you would say, all right, I've already told you that we don't have many drugs that work on synthesis. But I can tell you, we have quite a lot of drugs that can work at the level of the mobile pool, at the level of monoamine oxidase, at the level of the transporter, at the level of the release mechanism, at the level of alpha-2 autoreceptors. And all of those, all right, have to be considered by us, as well as drugs that might work at the level of the receptors themselves. So adrenergic neurotransmission, as you can see in our description here, is much more complex than transmission in the cholinergic systems. Now we're going to see each of these aspects now in a somewhat different way. We've talked about how we synthesize norepinephrine, and I want to remind you that tyrosine hydroxylase is rate limiting, but it has very little clinical applicability. It may be relevant to physiology, but it's a very minimal clinical applicability. We said that the DOPA form, dihydroxyphenylalanine, is converted to dopamine by an enzyme called DOPA decarboxylase, otherwise known to biochemists as L-aromatic amino acid decarboxylase, and we do not use drugs specifically in peripheral pharmacology for this purpose, but we do use carbidopa to inhibit that enzyme when we're treating Parkinson's disease. Dopamine gets converted by beta hydroxylase to norepinephrine. That's stored in granules. And we may be able to inactivate some of our presynaptic norepinephrine via monoamine oxidase when it's in the mobile pool, but not the granular norepinephrine. Here we describe again the process of membrane depolarization, and then of course the release of norepinephrine has actions on adrenoreceptors, which are the alpha and beta type, depending on individual tissues. We mentioned that the major mechanism of termination of norepinephrine is its removal from the junction, and this is uptake 1, the system that we described. We said we can activate prejunctional receptors, alpha-2 receptors, in terms of feedback inhibition. I also mentioned to you diffusion and potential metabolism by catechol O-methyltransferase. I feel it worthwhile to restate this for you here so that you can see that it's hard to remember everything by just looking at a diagram, and I want you to try and memorize the things also by this mechanism as well. Now, what about drug targets? I start off here with monoamine oxidase. We don't use monoamine oxidase inhibitors for their peripheral effects, but we still continue to use MAO inhibitors for central nervous system dysfunction. For example, inhibitors of MAO have been used traditionally in the treatments of depression or treatments of anxiety states, particularly panic attacks. And certain inhibitors of monoamine oxidase are used in Parkinson's disease, where we have a deficiency of dopamine. What I would suggest you do is that you know the names of perhaps 1 or 2 MAO inhibitors. If you can only go for one, I always prefer phenelzine because it is the most widely used of the MAO inhibitors in CNS pharmacology. But there are others. Isocarboxazid is one and tranylcypromine is one. What are they going to do? Well, they're going to increase the prejunctional levels of norepinephrine. And that means that when you get excitation of that nerve ending, you probably have got more norepinephrine to be released. So they're acting indirectly, aren't they, inhibitors of MAO, to enhance sympathomimetic action. That's how they could work. Now, there are 2 types of monoamine oxidase, and you've got to remember the 2 types. Monoamine oxidase A metabolizes pretty much anything, anywhere. Although it is found in high content in the liver, it's found pretty much anywhere. So we sometimes underline the A for anywhere to remind you that this monoamine oxidase A. What does this metabolize? Well, norepinephrine certainly, so this is a major action, obviously, in sympathetic nerve terminals, but it also metabolizes serotonin. This becomes perhaps more important when we get to the central nervous system. We mentioned tyramine as being present in foodstuffs and beverages. Tyramine is metabolized by monoamine oxidase, and this is of interest to you because if you inhibit its metabolism, then sometimes tyramine gets to a high enough level that it's going to exert effects on sympathetic tone, and you need to keep that at the back of your mind. Now, monoamine oxidase B has got a much narrower substrate spectrum. It really likes dopamine. And this is the dominant way of enzymes in the brain that actually metabolize dopamine. And so we remind ourselves about the brain by underlining the B of brain for monoamine oxidase B. Right, what about drug actions at the level of the mobile pool? Now, this may not seem like much to you, but effects on the mobile pool are used very extensively in medicine. Because this is a class of drugs, the indirect acting sympathomimetics, that has central nervous system stimulants in it, and also many drugs that are used as decongestants. What's going to happen with drugs that influence the mobile pool is that they're going to release norepinephrine into the junction. So you're going to enhance norepinephrine's actions at the postjunctional receptors. Amphetamine does this. Now, the primary uses of amphetamine are not for sympathetic stimulation, although it will do that. If you take amphetamine, you're probably going to get signs of sympathetic stimulation, but its primary uses, of course, are in the central nervous system in terms of its CNS stimulant properties there. But ephedrine is used very extensively as a decongestant, and it causes vasoconstriction, and the vasoconstriction is responsible to making it sort of easier for you to get airflow through various spaces. And so it works in a very reasonable way and is really the prototype of many drugs that are decongestants. So recognize that their mechanism is indirect. They indirectly release norepinephrine from nerve endings. That means that they won't have any actions on receptors that are not innervated. If a receptor is not innervated, that means there's no norepinephrine there. And if there's no norepinephrine there, that means that you're not going to get an effect. Uptake 1. Uptake 1 is the major mode of termination of the action of norepinephrine, and this can be inhibited, again, by indirect sympathomimetics. Your best example is cocaine. Again, cocaine, is not a commonly used drug in terms of medicine, although a commonly used drug recreationally, but cocaine is used as both a local anesthetic and a vasoconstrictor in a surgical sense. And how does it work? It works by actually preventing the reuptake of norepinephrine. And in the brain, it also actually prevents the reuptake of dopamine. But in the periphery, it's largely used to increase post-junctional actions of norepinephrine by blocking the uptake system. What about the prejunctional alpha receptors, the ones that are alpha 2? Well, if you remember that these are involved in autoregulation, you might guess then, if you were to activate those receptors with drugs, that you probably decrease norepinephrine release from the nerve endings. And you probably will, because this is an autoreceptor action. And drugs like, for example, clonidine or alpha-methyl dopa, which forms alpha-methyl norepinephrine, are drugs that activate alpha-2 receptors. What about granular uptake of norepinephrine? Well, we have a very old drug that prevents that called reserpine. And reserpine, by preventing the uptake into granules, really means that there's less norepinephrine available there for release when you get excitation of a nerve ending. Where would that come in? How would you sort of see that as a clinical use? Well, if you can decrease norepinephrine at sympathetic nerve terminals in the vasculature, that would probably mean then you'll decrease vascular tone. So reserpine ought to lower blood pressure by acting to decrease vasoconstriction. And that's what its clinical use is. Although it's not used commonly, it is used in hypertension. And you can understand why it would work in that fashion. You can actually block the release from granules. Guanethidine, also used in hypertension, decreases the actions of norepinephrine by preventing the release from the granules. And of course, although there's only 2 lines here of it, you can activate post-junctional receptors. Why is there such a short amount here? Well, because you see, we have to talk about all the direct activating sympathomimetic drugs, and of course all of the drugs that block those receptors as antagonists, and that's going to take us some time. So this is just a sort of a setting us up for that aspect of things. Now I'm going to tell you about, or remind you about, the activation of individual receptors for norepinephrine. And we'll start with alpha receptors, and these are subdivided into alpha 1 and alpha 2 receptors. And again, like we did in acetylcholine pharmacology, I need you to do the same thing here for adrenergic pharmacology. Start with the eye. The eye radial muscle, which is a dilator muscle, is innervated by the sympathetic nervous system via an alpha-1 receptor. Activation of that leads to contraction of the dilator muscle, and contraction of the dilator muscle is associated with mydriasis. So parasympathetic stimulation causes meiosis, and sympathetic stimulation causes mydriasis. Let's test you. All right, amphetamine actually causes stimulation of alpha-1 receptors in the eye. What do you expect to see when you look in the eye of somebody taking amphetamine? You'll expect to see a dilated pupil, and you'd be right. Right? And that's one of the symptoms of amphetamine. You see how we can use the information predictably if we know the innervation. Vasculature, dominated by the sympathetic nervous system. And for example, arterioles contract by activation of alpha-1 receptors. That leads to an increase in peripheral vascular resistance, which means an increased afterload. In other words, you're going to increase blood pressure by activation of alpha-1 receptors in the arterioles. When we look at the veins, we see that they're contracted too by alpha-1 receptors. So not only is this going to increase venous return, it's going to increase preload, which has an impact on cardiac output. So you can see that alpha-1 activation is very likely to increase blood pressure by both of these mechanisms. When we go to the bladder, the trigona muscle and sphincter, we see contraction and the possibility of urinary retention here. If you were thinking about, what might happen in terms of excessive sympathetic tone, where you can't go to the bathroom, how would you imagine that you might be able to ease that? You might be able to ease that by giving a drug that blocks alpha-1 receptors. And in fact, we do use that as a clinical application. And if you understood that it was an alpha-1 response that led to that urinary retention, then blocking alpha-1 receptors ought to make it a bit easier to go to the bathroom. What about the male sex organs, the vas deferens? Well, you can't ejaculate without getting activation of alpha-1 receptors. Now, I'm not saying that, one wants to take a drug that activates these receptors because you want to ejaculate, but I can tell you that drugs that block those receptors prevent ejaculation. And that's one of the side effects of using certain alpha-1 blocking drugs, because they're very important, by the way, used in hypertension, but they do cause sexual dysfunction. Alpha-1 receptors are also present in the liver, and activation leads to an increased breakdown of glycogen and therefore an increased production of sugar. So those are the alpha-1 sites that I need you to remind yourself about. What about alpha-2? Well, if you can only remember one alpha-2 site, it has to be the prejunctional nerve terminal. That one is critical, really, because it gets asked about quite commonly. And remember, we said that this is an example of autoregulation. So what we could see then is if we have a drug that activates an alpha-2 receptor, like clonidine, it ought to decrease transmitter release, and that should have an effect then to decrease sympathetic tone. And to some degree, that's where we see the clinical uses of drugs that work on alpha-2 receptors to activate them. There are other sites for alpha-2 receptors. Platelets, of course, have many, many different types of receptors on them. Sometimes a good idea to know which cause aggregation and which are stabilizing. Far more of them seem to be responsible for aggregation than for stabilization. But anyway, alpha-2 receptors lead to platelet aggregation and therefore would tend to, foster clotting mechanisms. The pancreas, the B cell of the pancreas, which is the one that releases insulin, is dominated by alpha-2 receptors in the context of decreasing insulin release. So that then tends, with less insulin running around, to increase blood sugar, and you'd see it in that fashion as a hyperglycemia, because insulin, of course, normally pushes blood sugar into the tissues and brings blood sugar down. Now, I think that would be okay for the alpha receptors. Now let's take a look at the beta receptors. We split these really into two, really, beta 1 and beta 2, although there are some people like to consider beta 3 receptors as well. But mechanistically, they're all the same, and I don't think there's much different between beta 3 and beta 2 in their properties. But beta 1 is very distinctive. The first thing you think about with beta 1 is the heart. And that's very important, because beta 1 receptors are very important in terms of cardiac function. They're present in the SA node and the AV node. They work in an opposite action to acetylcholine. Acetylcholine slows activity, and of course norepinephrine here increases heart rate, and that would be called positive chronotropy. We also see an increased conduction velocity across the AV node, and that's called a positive dromotropy. When we look at the heart muscle and the Fmge system, we see that beta 1 receptors are present in all of these tissues as well. And as far as the heart muscle is concerned, norepinephrine increases force of contraction. That's referred to as positive inotropy. It increases conduction velocity through heart muscle. And because of these increases in the activity of the heart, you'd anticipate an increase in cardiac output, and going along with that increase in cardiac output, an increase in the demand for oxygen. So oxygen consumption will go up. As far as the Fmge system is concerned, once again an increase in conduction velocity, but also an increase in automaticity. And you might begin to guess here that drugs that activate beta 1 receptors can, under certain circumstances, do too much of a good job. And when they do too much of a good job, they may be actually responsible for an arrhythmia. And that's certainly one of the things you keep at the back of your mind. Beta-1 receptors are also present in the kidney. Now, if we remind ourselves about the kidney and the control of blood pressure, we know that renin can be released independent of these receptors. What releases renin? Anything that decreases renal blood flow, because renal pressure in the kidney is responsible for an enhancement of renin release. But there are also beta-1 receptors there, and activation of those receptors would also increase renin release. So with sympathetic outflow, if you're scared or something, you tend to increase the release of renin. Now, what about beta-2 receptors? Well, we start off with blood vessels. Beta-2 receptors are present at some blood vessels, but not necessarily all blood vessels, and they may or may not be innervated. Actually, we often think of beta-2 receptors on blood vessels of being rather distant from nerve endings, which means that actually they may be more like a humorally controlled than neurally controlled. In any event, beta-2 responses, as far as the vasculature is concerned, are the opposite to what we saw with alpha-1 receptor activation. Instead of constriction, we get vasodilation, and this tends to decrease peripheral vascular resistance. We decrease diastolic blood pressure, we decrease afterload with drugs that have an effect on beta-2 receptors in terms of the vasculature. We have beta-2 receptors in the uterus, which leads to a relaxation of the uterus, and under certain circumstances, you may want to do that. Supposing you have a delivery that is coming a bit quicker than you want it to come. If that be the case, then a drug that activates beta-2 receptors can slow things down by causing relaxation of the uterine smooth muscle. Bronchioles, now this is very important. Beta-2 receptors activate smooth muscle to bring about a dilation of bronchiolar smooth muscle. The dominant class of drugs used today in the treatment of asthma in this country, of course, are drugs that are beta-2 activators. And these are the drugs that most people use as their substrate, as it were, when they have asthma. And this is clearly an important indication. Now, you might predict, of course, here that if a drug were to block those receptors, that would not be ideal in the asthmatic patient. Would you not think that? You should be thinking that. You should be able to turn that round as well. Drugs that activate receptors are good in asthma. Drugs that block those receptors are not so good in asthma. And so you could guess that this would be the opposing effect there. What about skeletal muscle? Yeah, well, this is mainly biochemistry, but a little bit of functional activity as well. There is an increase in glycogenolysis in skeletal muscle through beta-2 activation, and there's also a bit of a tremor that can come about from an increased contractility there. Actually, interestingly, you may see signs of systemic effects of inhaled beta-2 drugs in asthma by seeing a slight tremor. That may be indicative of the likelihood of systemic toxicity. And certainly drugs that are blockers of beta-2 receptors have been used in tremor. And so you can see that it's worth our while knowing about skeletal muscle. Liver, pancreas, yes, these are more in the area of hormonal or biochemical or metabolic functions, increased glycogenolysis in the liver, and increased insulin secretion by activation of beta-2 receptors. However, I should tell you that alpha-2 receptors tend to dominate release, and that works in the opposite direction. But both of them are working on B-cell receptors for catecholamines. What about the sensitivity of the individual types of receptor? As a rule, we would say that beta receptors are usually more sensitive than alpha receptors, but it really sort of depends on the drug and on the dose. And drugs that activate both receptors tend to be more beta-like at low dose, but then can become more alpha-like when you get to higher doses. So you can imagine then that we have to keep our eye on dose. And when we have some questions, as you'll see a little bit later, on the effects of individual drugs, always look out for that little qualifier. Did they say low dose or did they say high dose? Because if you actually see that, you would then be like sort of tuned in to the idea that, maybe the actions are different at one dose over another, and that helps you sort of decide what is going on here. So if a drug is both alpha and beta, at low dose, I would look towards beta responses, and at high doses, I would look towards alpha responses. And of course, what drug are we thinking about here? Epinephrine. Epinephrine's both alpha and beta. All right, before we get into the actual drugs themselves, I need to say a few words about dopamine receptors. Dopamine in the periphery can activate receptors in a variety of vascular beds. The renal bed is the most important for you, I think, but certainly some of the mesenteric vessels and perhaps the coronary vasculature can be dilated by dopamine. So it is a vasodilator. Its action in the kidney leads to an increase in glomerular filtration rate, an increase in renal blood flow, and an increase in excretion of sodium. And so I would know that aspect of dopamine for its peripheral actions. Now, we've been talking about all these receptors, but we haven't said an awful lot about which types of second messenger or effector system are involved as far as receptor activation is concerned. So this slide summarizes that for us. Alpha-1 activation receptors leads to an increased activity of the enzyme phospholipase C. Now that's brought about by a GTP binding protein that is called a GQ protein, and so that mechanism, alpha-1 receptors are what we say are GQ coupled. So you're going to increase diacylglycerol and inositol triphosphate. This is going to increase intracellular calcium. This is going to lead to stimulation of various protein kinases. By contrast, alpha-2 receptors don't do anything to GQ systems at all. Alpha-2 receptors remind you a little bit of muscarinic receptors because they're negatively coupled. M2 receptors, for example, in the heart, are negatively coupled to adenylyl cyclase. So if we activate an alpha-2 receptor, we decrease the production of cyclic AMP, and that decreases the phosphorylation of specific proteins. Whereas beta receptors, doesn't matter what subtype, and dopamine D1 receptors are coupled to GS proteins. So they activate adenyl cyclase and increase cyclic AMP levels. So from the standpoint of receptor mechanism and the biochemistry of the actions of drugs, I think this summarizes it reasonably well for you. So if a drug was capable of activating both alpha and beta receptors, like epinephrine, you can see it's doing multiple things to the biochemistry of cells and tissues because it's got all of these messenger systems involved. Now let's take a look at some of the drugs. We'll start like alphabetically with alpha-1. Alpha-1 agonist drugs tend to increase mean blood pressure because they bring about a vasoconstriction. And that invariably, if it's enough of an increase in blood pressure, is going to bring about a reflex bradycardia. You're going to slow heart rate because you've increased blood pressure. It's just our body does this. We don't have much control over it, so our heart begins to slow. Now, in this arena, under the alpha-1 drugs, everybody should know phenylephrine. I mean, that is the prototypic alpha-1 agonist. There are many of them out there that are used as decongestants, for example, much more commonly perhaps than phenylephrine. But phenylephrine is the more common one asked about by name in the context of examination questions. Now, you would also remember that alpha-1 activation leads to mydriasis, and too much of it, of course, can cause problems of ocular function. You will not get cycloplegia, though, with alpha-1. I mean, cycloplegia is not something that you'll see. You'll see that with drugs that will actually block muscarinic receptors, but not with alpha-1 receptor activators. One of the drugs that has a rather distinctive use in this category is methoxamine. Methoxamine, and this is the reason I mention it, is because it is a distinctive use, is used in paroxysmal atrial tachycardias, PAT. And the reason it's used is a sort of a tricky one, and because it is a drug that can vasoconstrict, it brings about a reflex bradycardia through the vagus. And sometimes that reflex, vagal reflex, is enough to offset an incipient proximal atrial tachycardia. So you're slowing the heart in a sort of a roundabout way by causing a vasoconstriction, eliciting a reflex bradycardia, which then opposes the natural situation of a paroxysmal atrial tachycardia. It's not a common use, obviously, but it is a use that has been asked about. After considering the different types of receptor, their location, and the responses, it now becomes our job to look at the individual drugs that are capable of activating adrenoreceptors. We'll start with those drugs that are direct-acting adrenoreceptor activators, which means that they will be interacting with the receptor specifically. The first group of drugs would be those that activate alpha-1 receptors, and alpha-1 receptors, as you would remember, would lead to vasoconstriction. This in turn causes an increase in blood pressure, and that would elicit a reflex bradycardia. Phenylephrine is certainly the name of an alpha-1 agonist that I suggest you remember. It may not be the most widely used of the alpha-1 agonists as a decongestant, but certainly is a prototypic drug of the alpha-1 class. Remember that activation of alpha-1 receptors will be seen in terms of ocular function. Mydriasis comes about by activation of those receptors without any cycloplegia. Methoxamine is another alpha-1 selective drug, but does not have a lot of clinical uses, but surprisingly it is sometimes asked about. Its primary clinical use is in the management of paroxysmal atrial tachycardias. And I think it gets asked about a bit because it's a sort of an interesting mechanism of action. By virtue of its vasoconstrictive properties, it brings about an increased vagal discharge. An increased vagal discharge is then going to counteract the likelihood of a tachycardia occurring in atrial tissue. So that is a sort of a mechanistically oriented type of question when we're looking at methoxamine. But anyway, know that alpha-1 agonism leads to vasoconstriction and also to mydriasis. Alpha-2 agonists, the only two drugs you're really going to need to know here are clonidine and alpha-methyl-dopa. But our primary interest here is really in the context of hypertension, because both alpha-methyl-dopa and clonidine are used as antihypertensive drugs. Interestingly, although as an alpha-2 agonist drug, each of these should actually decrease the release of norepinephrine from sympathetic nerve endings in the periphery, it's thought that their major antihypertensive action occurs in the brain. It's their CNS actions as alpha-2 agonists that appears to decrease vasomotor outflow as far as the sympathetic nervous system is concerned. And that decreased sympathetic outflow actually leads to a decrease in blood pressure. So they are antihypertensives, but probably not working specifically at the level of the peripheral sympathetic nerve endings. Clonidine, I'll say this now, and we may mention it again under antihypertensive drugs, is a bit of a dangerous drug in a sense that if patients stop taking it abruptly, there can often be a very marked increase in blood pressure. It's referred to as a rebound hypertension, and sometimes has led to hypertensive crisis. Alpha-methyl-dopa is distinctive for us in the sense that it is not a drug until it is converted to other compound called alpha-methylnorepinephrine. So here's an example of a prodrug. Remember we said something about prodrugs when we were talking about the metabolism of drugs. Now, what about direct activators of beta receptors? The prototype here is going to be isoproterenol. Isoproterenol doesn't care very much whether it activates beta-1 or beta-2. What are beta-1 responses? Increase in heart rate, stroke volume, and cardiac output. What are beta-2 responses? Decrease in peripheral vascular resistance. Remember, beta-2 receptors in the vasculature, particularly those in the vasculature to the skeletal muscle, relax under the influence of beta-2 receptor activation. This leads to a decrease in peripheral vascular resistance. As I say, isoproterenol works on both of these receptors. It is a drug that will decrease mean blood blood pressure, but it will increase pulse pressure. Why? Pulse pressure is largely determined by stroke volume. Stroke volume is, of course, a beta-1 response. So the blood pressure goes down because of beta-2 activation leading to vasodilation, but pulse pressure goes up because of increase in stroke volume that comes about through beta-1 receptor activation. And obviously beta-1 receptor activation leads to an increase in heart rate as well. There are no reflexes to worry about here with isoproterenol. Treatment of bronchospasm is an indication for isoproterenol. Heart block, I think you would predict that because of the stimulatory effects on the heart. And in some cases of bradyarrhythmias. A bradyarrhythmia, of course, is the opposite to a tachyarrhythmia. It means that there is some difficulty in terms of the rhythm where we're slowing the heart rate rather than increasing heart rate. You might anticipate, because of the effects at the beta receptor level, flushing, and because of the effects on the heart, sometimes we see exacerbation of angina or even an anginal attack in patients that had not been diagnosed as suffering from angina. That comes about, of course, through the stimulation of the heart. The faster the heart goes, the less time that is spent in diastole, and the less time spent in diastole, the less you perfuse coronary vessels. And if you can't perfuse a coronary vessel as adequately as you need, then you're getting less oxygen, and that's where you get the pain of angina. Stimulation of the heart can also lead to arrhythmias. So anticipate that from drugs that activate beta receptors, and isoproterenol is our prototype there. What about drugs that are a bit more selective? Well, we've got beta-1 selective drugs and beta-2 selective drugs. Your best example of a beta-1 drug is dobutamine. That doesn't mean to say that it doesn't work on any beta-2 receptors. It just means that beta-1 is greater than beta-2. So dobutamine is going to have a greater action on the heart and less of an action on the blood vessels. So you'll see an increase in heart rate, stroke volume, and cardiac output, but you're probably not going to see too much on peripheral resistance because the beta-2 activity is much less. Neither will you see much happening in terms of glomerular filtration rate or renal blood flow. That's not going to be affected much by dobutamine. This is used, this drug, in acute congestive heart failure. Recognize that, as is the case in many adrenoreceptor activations, that sometimes the receptors begin to lose their responsivity to a drug. And this is a good example. Dobutamine has very marked acute actions, but it has very little use in a chronic fashion because of the phenomenon of tachyphylaxis. Tachyphylaxis is very similar to tolerance, except that it takes place over a time frame that is much faster than tolerance. You see, generally we think that tolerance to drug action is something that might take days or weeks even, whereas tachyphylaxis can be as short as minutes and certainly hours. But we use the term somewhat interchangeably. But here's a very good example of activation of these receptors can really lead to actually a state of tachyphylaxis or tolerance. What about those drugs that work more on beta-2 receptors than beta-1? There are lots of these. I've just mentioned 3 of them for you here: metoprolol, albuterol, and terbutaline. These are the drugs that we think of very quickly in terms of the management of asthma because they are very good bronchodilators, and they are most commonly used by the inhalational mode these days. And we'll talk about that when we deal with asthma at a later time. Ritodrine is a drug that's been approved fairly recently for its use in premature labor. As we described before, that beta-2 receptor activation can cause a relaxation of the smooth muscle of the uterus, and this would be an example of a drug that is used in that fashion to slow things down until it looks more appropriate to sort of get on with the delivery. Now, under the direct activating adrenoceptor activators, we have 2 drugs that really dominate, don't they? Norepinephrine and epinephrine. So we've got to know a lot about norepinephrine and epinephrine. What I generally do with norepinephrine is remind you that norepinephrine actually is not a complete sympathomimetic in the following way. It really doesn't activate beta-2 receptors. So while it may work on alpha-1 and alpha-2, and certainly works on beta-1, it really has very minimal action as a drug on beta-2 receptors. and therefore its pharmacology is somewhat different from that of norepinephrine. It will increase peripheral vascular resistance. You'll expect that because obviously it's a vasoconstricting action coming through alpha-1. This leads to an increase in diastolic blood pressure. There is an increase in heart rate and stroke volume from beta-1 activity, and that will increase systolic pressure. But when you have both an increase in systolic and diastolic pressure, you actually don't get a dramatic change in pulse pressure. So actually you have to look very carefully to see whether norepinephrine increases pulse pressure. There is certainly an increase in mean blood pressure, and under normal circumstances, norepinephrine tends to actually end up slowing the heart, despite the fact that it actually stimulates beta-1 receptors in the heart. It does, which should increase heart rate. So how do you slow the heart? You do it reflexly. You see, of course, an increase in mean blood pressure, and there is enough reflex bradycardia to overcome the direct stimulatory effect of norepinephrine on beta-1 receptors. So look for reflex bradycardia when you're dealing with the actions of norepinephrine. That would be a very common characteristic there. It's not a direct action, it is merely a reflex action brought about by increase in blood pressure. Now, epinephrine is, I suppose, the complete sympathomimetic in the sense that it will activate all of the receptors, both forms of alpha receptor, both forms of beta receptor. But the complexity with epinephrine comes about in the sense of dosage. Low dosage is more beta-like, right? Therefore, we will see increases in heart rate and a small decrease in mean blood pressure. High doses are more alpha-like, and therefore we're more likely to see an increase in peripheral vascular resistance, diastolic pressure, and a bigger increase in mean blood pressure, sometimes to the point that you might even elicit a reflex bradycardia that, again, can overcome the beta-1 activation. So really it depends on dosage. Moderate dosage, by the way, it's not written down here for you, but moderate dosage will probably be a mixture of the two, where we may see a small increase in mean blood pressure, an increase in systolic, a decrease in diastolic blood pressure through beta activation, and essentially rather modest increase in mean blood pressure. So you may have something that looks like something in the middle. Now, epinephrine, of course, is released from the adrenal medulla, and it has lots of what we would say would be called humoral actions. Those humoral actions include actions at the level of the liver to increase glycogenolysis, and that's likely to increase glucose. We have, of course, sympathetic innervation of the bronchiolar smooth muscle, and epinephrine on occasion can sometimes be used to afford a bronchodilation. This is not going to be a drug that you're going to see used much in asthma, because, you know, asthma, you like beta-2 selective drugs. You don't want drugs that work on every adrenoreceptor. You can't put up with all the side effects that you see there. Other properties of epinephrine concern the muscle, where we stimulate glycogenolysis and glycolysis, and also fat tissue, where we activate lipases to increase free fatty acids. Epinephrine, as I say, is a bit of a tough drug to imagine to be used in any chronic fashion, but it also is a drug that can be life-saving. In anaphylaxis, the actions of epinephrine make it the drug of choice for the management of an anaphylactic episode. In cardiac arrest, you get things going again with epinephrine by direct injection into the systemic circulation. Adjunctly, they can be used in with local anesthesia because they actually cause vasoconstriction, which will prolong the duration of action of a local anesthetic simply by decreasing blood flow to a region. And epi has also been used in open-angle glaucoma. So not a lot of clinical uses, but some very important clinical uses. And most of the questions on epinephrine in exams tend to be about the basic pharmacology, because it's a great drug for illustrating activation of all of the receptors, and it's a great drug to sort of test you as to whether you know what the difference is between high dose and low dose. And that comes up, as you'll see in a few minutes, in a variety of ways. Epinephrine is sometimes asked about in examinations in terms of the phenomenon of reversal of its effects on blood pressure. Remember we said that low doses of epinephrine are more beta-like, and therefore they would tend to lower blood pressure, but high doses of epinephrine are more alpha-like, and therefore they quite clearly do increase blood pressure. And when we talk about this, we actually can illustrate the phenomenon of epinephrine reversal. This describes the effects of an alpha blocker when used following a hypertensive response due to a high dose of epinephrine. As we said, high doses of epinephrine, leading to alpha-1 activation, are going to increase blood pressure. So you're going to get a hypertensive response. Now, if you add an alpha-blocking drug to the system and then challenge the patient with a high dose of epinephrine, you will not get any alpha receptor activation. And if you can't get alpha receptor activation, you can't get an increase in blood pressure. What do you get instead? You get very strong beta receptor activation. You see, what you've done is neutralize alpha receptors, but actually really stimulate beta receptors because you've used a high dose of epinephrine. Now, what does stimulation of beta receptors do? It lowers blood pressure through vasodilation. So instead of a hypertensive action, we get a hypotensive action when we block a high dose of epinephrine with an alpha blocking drug. So this reminds you, epinephrine at high dose is alpha-like. And it's very interesting that this rather unusual phenomenon, it can occur. It's been reported in pheochromocytoma, for example, in a tumor producing very large quantities of epinephrine that one sees a hypertension reversible under certain circumstances by the use of an alpha blocker to not only neutralize the increase in blood pressure, but actually to reverse it to a hypotensive situation. Now, these drugs that we've been discussing are all direct activators of receptors. Although they vary in their selectivity, they are direct activators. The drugs we're going to look at now would all be called indirect activating adrenoceptor agonists. And we'll start off with amphetamine, which we've described already, releases norepinephrine from the mobile pool. The peripheral effects are just those equivalent to sympathetic stimulation. You can't imagine it would be any different. If you release norepinephrine, wherever norepinephrine is a neurotransmitter, you'll see sympathetic stimulation. But actually amphetamine is largely thought of as a central nervous system stimulant. And in the brain, not only does it release norepinephrine, but it releases dopamine and maybe even other neurotransmitters. So most of the clinical uses of amphetamine concern the central nervous system. Amphetamine and drugs similar to amphetamine, like methylphenidate, which is Ritalin, are extensively used in attention deficit disorder. Attention deficit hyperkinetic disorder is the real name of this condition. We estimate that at any given time, somewhere up to 2 million children, or young persons anyway, are being treated with this type of drug for this type of dysfunction. A lot of people use amphetamines for short-term weight loss. You begin to lose responsivity after a few weeks, but they may help out for a brief period of time because they decrease appetite. That makes a lot of sense. And although there are not many people who suffer from narcolepsy, the drugs of choice in narcolepsy, where you just abruptly fall asleep, are CNS stimulants like amphetamine, for example. So I like amphetamine as a name drug, but I like it even more in your understanding of the clinical uses and its mechanism. Ephedrine is a drug that releases norepinephrine, but also actually crosses the blood-brain barrier and has stimulant effects that remind you of amphetamine on the central nervous system. However, its primary peripheral activity concerns its decongestant effects. So you probably remind yourself when you think of ephedrine of pseudoephedrine or Sudafed. It's a very similar type of compound. You also might know that the compound phenylephrine phenylpropanolamine is the, if you like, the drug that we use mostly as an over-the-counter decongestant. When you look in the drugstore of something that might help you by dropping it into your nose, you'll find that phenylpropanolamine is a very common drug used in that way. And phenylpropanolamine works like ephedrine to release norepinephrine from the mobile pool of norepinephrine in sympathetic nerve terminals. Dopamine, as I mentioned earlier, I don't think people consider it to be a natural transmitter, although it is found in nearly all sympathetic nerve endings, because you see, to make norepinephrine, you've also got to make dopamine. Dopamine is fascinating in a way, because when used as a drug, its actions are very highly dose-dependent. At low doses, and this is the primary clinical use, we activate D1 receptors in blood vessels to the kidney, so we increase renal blood flow and glomerular filtration rate. At medium doses, however, that's doubling or tripling the dose, we increase cardiac output, and that would be a positive inotropic action, and that reminds you very much then of dobutamine, which is a beta-1 activation. At really high doses, and one doesn't use this activity, but I suppose in overdose situations you could imagine it, we get vasoconstriction, which is alpha-1 activation, and that has a remarkable effect to increase blood pressure. So we have at one level the lowering of blood pressure, and at the opposite level the raising of blood pressure. And so it really is a highly dose-dependent set of pharmacological actions. Now, we've been describing the important adrenoreceptor stimulants, and what I thought would be nice would be to see what activators can do to heart rate and blood pressure by examining some tracings of blood pressure and heart rate when we use drugs that can work on different receptors. So what we have in this figure here is a series of excursions of a blood pressure where the top of an excursion would be systolic and the bottom would be diastolic, and if you were to trace something in the middle, towards the middle of them, you'd see whether or not something increases in mean blood pressure. And what we've tried to do in the diagram is also accentuate what might be happening to heart rate by actually either separating or squeezing together the excursions. So if we look at the first diagram here, we're giving a drug at this point of the arrow, which is an activator of alpha-1 receptors, a drug like phenylephrine. That would be good enough. Now what we see here is, of course, when you activate alpha-1 receptors, we see a constriction of the vasculature, and that constriction is going to increase blood pressure. So mean blood pressure goes up. But when it does, because of increase in blood pressure, we see a reflex decrease in heart rate. So you can more or less identify phenylephrine by this rather characteristic tracing of its effects on blood pressure and heart rate. And you could do the same thing for any alpha-1 agonist. Alpha-1 agonists do this. You can anticipate that. Notice there is not much change in pulse pressure. And the reason for that is that pulse pressure is actually determined largely by activation of beta-1 receptors, and phenylephrine is not active against beta receptors. It only activates alpha-1 receptors. So the general properties of alpha agonist activity are to decrease heart rate reflexly, to increase mean blood pressure, but to have very little effect on pulse pressure. Pulse pressure being the difference between systolic and diastolic blood pressure. And you notice that's not much different here than from this situation here. Now, what if you have a drug that can activate alpha receptors and also activate beta receptors? Well, this is very typically epinephrine. Epinephrine, of course, does depend on dosage. Remember, we did say that. We said the high doses are more alpha-like and the low doses are more beta-like. But let's just look at a moderate dose of epinephrine. What we see here is if you're going to activate both receptors, you're going to actually have rather a modest effect on mean blood pressure. There may be a small increase in mean blood pressure, but you are certainly going to lower the diastolic blood pressure through the beta 2 activation, and you probably are going to increase the systolic blood pressure because of the ability to activate beta 1 receptors. So on the one hand, the large drop in diastolic and the increase in systolic come about through activation of beta 2 and beta 1 receptors respectively, and epinephrine can activate both of those receptors. Now that's distinctive, isn't it, because norepinephrine can't activate beta 2 receptors, so you do see a difference there between epinephrine and norepinephrine, and that's very important to note that. But this would be a moderate dose, so remember, a high dose, it's more like alpha, all right, above, A for alpha, A for above, and a low dose, it's more like beta, B for beta, B for below, and that might help you think about it. Now, what about a drug that just simply works on beta receptors? So your prototype here is going to be isoproterenol, right? Isoproterenol works on beta receptors. Now, what beta receptors do? Beta 1 receptors increase heart rate and contractility. Beta 2 receptors cause vasodilation. So we're going to have a big drop in diastolic blood pressure here. Sometimes we actually see a transient increase in systolic blood pressure up here, which will be seen in some tracings I'll show you a little bit later. But in any event, the major drop in diastolic blood pressure is responsible for the drop in mean blood pressure. So we'll see certainly a big drop in mean blood pressure. We'll expect to see a very, very fast heart rate. That comes about really largely through activation of beta 1 receptors, but also because mean blood pressure goes down, we also decrease vagal flow to the heart. And if you decrease vagal flow in a sort of a compensatory way, then you'll also get a greater increase in heart rate. So here, isoprel, a typical beta activator, is bound to increase heart rate. It will lower mean blood pressure, and it's pretty much bound to increase pulse pressure because diastolic drops much more than systolic drops. So in essence, this is characteristic of a beta receptor activator, something that works on both beta 1 and beta 2 receptors. All right? So these three diagrams then were to help us sort out what happens with these two cardiovascular parameters with activation of the individual receptors. Now we go to the area of antagonist drugs. We've been talking about agonists. Now I want you to look at antagonists. We'll start once again with alpha receptor antagonists. These will decrease peripheral vascular resistance because remember, alpha agonists lead to constriction. So blocking that action would lead to dilation. So you're bound to lower PVR and you'll decrease mean blood pressure. And therefore, what you're likely to see? Compensation. How does that compensation come about? By a reflex tachycardia and by humoral mechanisms that will lead to salt and water retention. Now, the tachycardia with alpha blockers depends a lot on whether the alpha blocker is a blocker of both types of alpha receptor or whether it's more selective for alpha 1 receptors. Now, why is this? If a drug blocks alpha 2 receptors, now what do alpha 2 receptors do? These are prejunctional. They're the ones that control norepinephrine release. Well, if you block those receptors, you're not going to stop norepinephrine from being released. And at the level of the heart, the more norepinephrine released, the more you're going to get an increase in heart rate. So drugs that block both types of alpha receptor do cause marked reflex tachycardia, and that limits their clinical applicability, certainly in a chronic fashion. Drugs that are more selective for alpha 1 receptor blocking action cause less reflex tachycardia. Now, I would like you to know the names of two non-selective drugs. They're very old drugs, phentolamine and phenoxybenzamine. How do they differ? Well, phenoxybenzamine is our example of an irreversible antagonist that makes a covalent bond with alpha 1 receptors. Therefore, you can't readily reverse phenoxybenzamine. You could reverse phentolamine because that's a competitive antagonist. But you see, because of the inhibition of the feedback mechanism, they're not going to have very, common clinical uses. They have been used in tumors that produce catecholamines, pheochromocytomas, because they will lower blood pressure. I mean, they're alpha blockers, they'll lower blood pressure. But the reflex effects, the tachycardia, the water retention, tend to be offsetting in terms of their availability for chronic use. If you want to use an alpha blocker chronically, go over to the alpha-1 selective drugs like the Usmle family. Prazosin was the first of these drugs, but we have about 8 or 9 of them now. And you could see if you have 8 or 9, since these are all like copycats, Me Too type drugs, there must be a big interest in that commercially. And there is, because these drugs have been widely used in the management of mild to moderate hypertension. And there are so many millions of us that suffer from hypertension. The big deal about this class of drugs, which I say could be called the Usmle family, is that they are selective, but not specific, but they are selective for alpha-1 receptors. So although they will cause a reflex tachycardia, you still have your intact feedback mechanism. So it will not be as bad. Right? It won't be as bad as what we just described for phenoxybenzamine or phentolamine. You will get some degree of postural hypertension, although you actually get tolerant to it. But the first doses of alpha-1 selective blockers have sometimes caused fainting. So that's referred to as first dose syncope. And so you warn your patients about that, especially the elderly patient who is a bit more prone to, changes in terms of vasodilation. Remember, elderly patients tend to be more sensitive to drugs in general, and that goes also for drugs that lower blood pressure. So those particularly you remind that you may get dizzy or you may actually faint with the earlier doses of these drugs. They're used commonly in mild to moderate hypertension, and they also have another clinical use which is really based on knowing about alpha receptors and what happens in terms of bladder smooth muscle or smooth muscle of the urinary genital system. In benign prostatic hyperplasia, which is a fancy set of words meaning you've got a big prostate, right? Then the prostate tends to impede urination. You can't go to the bathroom. And if you can actually cause a relaxation of the musculature there, it makes it easier. So alpha-1 selective drugs are quite commonly used in BPH, benign prostatic hyperplasia, which is not linked directly in any fashion to prostatic carcinoma, as you probably remind yourself. Okay, what about beta adrenoceptor antagonists? Now, these have multiple actions, and we take advantage of some of these actions clinically, and also have to remind ourselves that the side effects of beta blockers, as we more familiarly call them, can be quite marked. We'll start with the heart. You certainly can decrease contractility because that's a beta-1 response. That will also carry with it a decrease in heart rate, cardiac output, and oxygen demand, and should bring down blood pressure because one of the determinants, obviously, of blood pressure is cardiac output. Remember, blood pressure equals cardiac output times, peripheral vascular resistance. And so if you can bring down the cardiac side of things, you can lower blood pressure. That should set you up, I think, for thinking about 2 clinical uses right off the bat here. I mean, hypertension, sure, we like to bring down blood pressure. Angina, yeah, we like to decrease oxygen demand on the heart muscle. So here you immediately see sort of 2 clinical uses staring you in the face here. There isn't any orthostatic hypertension because you see you can't get much of an action of a beta blocker on beta receptors. And the reason for that is that beta receptors in the vasculature are not innervated very well. And antagonist drugs only work where they're getting in the way of an agonist. If the agonist isn't there, what can an antagonist do? Nothing, So antagonists work by stopping the action of an agonist. Well, certainly we know that norepinephrine is present in the heart, and that certainly seems to be responsible there. But at beta receptors in the vasculature, we don't think that norepinephrine really plays a fundamental role by neural innervation. Certainly if you have enough of a beta-2 stimulant, you can get vasodilation. But beta blockers don't seem to have much of an effect on vascular tone. Therefore, they will not cause orthostatic hypotension. And that's a very valuable thing in the treatment of blood pressure. Because part of the trouble with using drugs that lower blood pressure is just that you might get pooling of the blood, and therefore when you stand up, you fall down. That's orthostatic hypotension. Okay, however, there is beta blocking action that can be seen, and that may be undesirable. Sometimes you can block AV nodal conduction, which is not a grand idea, and even cause exacerbation of heart failure. Beta activation of the bronchiolar smooth muscle leads to relaxation. Therefore, beta block is likely to lead to constriction. And bronchial constriction, of course, and sometimes bronchospasm, is undesirable. So if you're blocking beta-2 receptors, which are part of the innervation of the bronchiolar smooth muscle, then you may get bronchospasm. And certainly, drugs that block beta-2 receptors are not ideal in the asthmatic patient. You decrease glycogenolysis, and you may mask the symptoms of an overdose of insulin. Overdose of insulin lowers blood sugar. And what do you get when you lower blood sugar? You get both central nervous system dysfunction and sympathetic discharge. Now, how do you express the sympathetic discharge? Well, you have to express that through beta receptors. And if you're blocking beta receptors, how could you see it? So you will not see the increased heart rate that you normally would see in an insulin overdose situation, because you can't get an increased heart rate in the presence of a beta blocker. So we refer to it as a masking of the sympathetic signs of insulin overdose or the hypoglycemic situation. Now, one very important clinical use of beta blockers used topically is on the eye. They decrease the activity of the ciliary epithelium. Now, the ciliary epithelium is under the control of beta receptors, and it produces fluid or secretions which are contributory to the aqueous humor. The aqueous humor, if we increase aqueous humor formation, we increase intraocular pressure, and that, of course, causes the symptoms of glaucoma. Now, if we can decrease those secretions, as we can by a beta blocker, we'll lead to a decrease in intraocular pressure, and that's a clinical use of beta blockers. The prototype beta blocker is propranolol. Propranolol has been with us for, I think, over 50 years. It is non-selective, works on both beta-1 and beta-2 receptors. Now, I want you to know about a rather unusual effect of many beta blockers, and particularly propranolol. This is a drug that's been used very importantly in the treatment, for example, of hypertension. And it can be used in a chronic fashion there, where it is actually shown to have long-term survival benefit in patients who suffer from hypertension. Interestingly, while you're using the drug in a chronic fashion, there is often a compensatory metabolic change taking place, and it leads to the increase in unfavorable lipids, lipids like low-density lipoprotein cholesterol and triglycerides. And that is a rather fascinating result of giving a drug for hypertension that actually our bodies actually try to avoid the action of propranolol by making lipids that are associated with atherosclerotic dysfunction or disease. And as you may recall, elevations of LDL and elevations of triglycerides are associated with an increased incidence of atherosclerotic disease, the same as hypertension is associated with an increased incidence of atherosclerotic disease. So here's an anomaly of a drug that's proven to be useful in hypertension, but actually sometimes leads to increases in lipids that are unfavorable. What are you going to do about it? Well, two things. Don't use beta blockers in patients who already have pre-existing dysfunction of the lipid profiles in their blood, and perhaps even use a drug that is less likely to do this, because this is largely a beta-2 type of response. Now, the other thing, while we're on the subject of chronic use of beta blockers, which again was first demonstrated with propranolol, but I think probably relates to most beta blockers, is that our body compensates for the blockade by changing our receptors. we have the phenomenon of receptor upregulation occurring. What does that mean? And it's been shown, by the way, in humans, that it's not just an animal type of study. We've seen it in humans. Chronic use means we get more beta receptors. And that's okay. It may mean that you may need a little bit more of a beta blocker to work, but where the problem occurs is on abrupt discontinuance. You take away the beta blocker, or you as a patient may just discontinue it without asking your physician, all right? And what happens? You've got all these new beta receptors there ready to be activated by circulating catecholamines. So here you've been using a beta blocker to lower blood pressure. The drug is stopped, and we get a tremendous increase in activation of beta receptors. And that, particularly in the case of the heart, causes a marked stimulation of the heart, excessive cardiovascular effects, and on occasion has led to cardiac arrhythmias, sudden death, etc. So here's a good example of when a patient's put on a beta blocker. If they're going off it, they have to have the dose tapered, where you gradually lower the dosage of the drug, and that then allows for the upregulation of receptors to be actually brought back into line with the normal situation. It's a dose tapering type of principle. Now, in order to sort out the beta blockers just a little bit more, we have to say something about cardioselectivity. We have a number of beta blockers that work more on beta 1 receptors than on beta 2 receptors. And what I would like you to know is why, and if you can, I'd like you to know what. Now, the why is probably more important than the what, in the sense that the why is because you want to avoid beta 2 effects. You don't want to interfere with beta 2 receptors in all patients. For example, in patients who have peripheral vascular disease, it doesn't make sense to actually use drugs that will actually cause problems of the vasculature. And the vasculature, of course, is a beta 2 receptor. In patients who have asthma, we don't want to actually cause problems with beta 2 receptors in the bronchiolar smooth muscle. Why should we? In patients who have diabetes, for example, not a grand idea to use drugs that work at the level of beta responses. So these types of reasoning, and it's more the reasons perhaps than the individual drugs, make these beta 1 selective drugs safer in asthma, safer in diabetes, and safer in patients who have peripheral vascular diseases. And I'd like you to know the names of a few of them. There are more than this out there, but I like the idea of these three because you can make it into a word that has a little bit of significance from the standpoint of medicine. I mean, the AMA stands for the American Medical Association. And if you knew that, which I'm sure you do, you'd be able to say, well, okay, the first letters in these three drugs that you see here would be remembered if I remember AMA, all right, or AMA. So acebutalol, metoprolol, atenolol are beta 1 selective drugs. So you might like to do it that way. It's not the only beta 1 selective, but it's a good step in that direction. You know, there are more than this, but this is, I think, a good start. We have also another type of beta blocker that actually is thought to work as a partial agonist. Now, what's a partial agonist? A partial agonist is a drug that might, under certain circumstances, work either as an antagonist or as a stimulant of receptors. We've said that, you know, under our considerations of basic principles. Now, here, if a drug has partial agonist activity, it's said to have intrinsic sympathomimetic activity. It's a beta blocker, but it's got a bit of stimulation as well. And the designation for that is ISA. I actually think you might be better off thinking of them as partial agonists because it might help you a little bit. You see, if you have a partial agonist activity, you should get less depression of the heart. So there should be less slowing of heart rate. There should be a minimal change in plasma lipids. And therefore they would be ideal for patients who have pre-existing hyperlipidemias, because you're not going to make it worse by chronic administration. And the reason I say partial agonist is that the actual two drugs that are most well known as having intrinsic sympathomimetic activity are pindolol, and acebutolol. So you can use the term PA or PA to remind you about the first letters in the names of those two individual drugs. So that may help you a little bit. There may be one or two other drugs out there that are partial agonists or have intrinsic sympathomimetic activity, but I think this is a step that I would take, and as far as I would go, actually. Now, what about other things or other properties of beta blockers? You know, there are many, many beta blockers. I'm going to show you a table in the moment, but not ask you to remember everything about it. But there are differences in kinetic properties. Some drugs do not readily cross the blood-brain barrier. That could be good or bad. If you didn't want central nervous system effects, that's certainly a good effect, but certainly some beta blockers are used for central nervous system dysfunction. I'm thinking here largely of what we might call anxiety associated with public performances, that type of thing, where we can decrease the anxiety with certain beta blockers. At least you don't see the sweating and the other sympathetic signs, etc. But it's more than that. There is central nervous system actions as well. And we have differences in half-life. Many of the drugs can be given at once-a-day basis. Carvedilol and nadolol are examples there. Interestingly, carvedilol is an example of a drug that is not a single drug anyway, and it has properties of both alpha and beta block. And likewise, the drug labetalol, and both of these should be known to you, because you'll see why when we get to the applications in cardiovascular pharmacology. Both labetalol and carvedilol have alpha blocking activity, although they're nominally classified as beta blockers. Interestingly, most beta blockers you can identify by the end of the word being olol, O-L-O-L. But you'll notice that these two drugs happen to be exceptions to the rule, carvedilol and labetalol. It was called labetalol to actually designate that it had alpha blocking action as well as beta blocking action. Here's our table, and I don't think I need to go through it formally with you, but I just want to point out to you which drugs are beta-1 selective, which drugs are thought to have intrinsic sympathomimetic or partial agonist activity, which cross the blood-brain barrier and may have sedating properties. And notice that not all beta blockers increase plasma lipids, and for that reason there may be choices made here on the basis of particular patient set of circumstances. It really depends, on comorbid conditions. I mean, the most obvious one would be, if you have hyperlipidemia, why would you want to use a beta blocker that would encourage an increase in plasma lipids? Yeah, I think you get the idea there. You might like to sort of glance under propranolol at the widespread clinical uses there of propranolol. It is our most famous beta blocker, has tremendous widespread use in the cardiovascular arena, but is also a type of drug used in migraine, for essential tremor, for performance anxiety, and of course beta blockers would oppose excessive thyroid hormone actions on the heart, and that's another property that you might think of in the context of beta blockers. So they have quite a widespread set of clinical uses, as you can see. The SA and AV nodes, sinoatrial and atrioventricular nodes, are innervated by both the parasympathetic and sympathetic fibers. So the parasympathetics through acetylcholine activate M2 receptors, and the sympathetics through norepinephrine activate beta-1 receptors. The phase 4 slope is increased by anything that will increase cyclic AMP. For example, beta-1 activation. You remember that when we look at the coupling of beta-1 receptors, we activate adenosylcase and therefore increase cyclic AMP. When you activate M2 receptors through GI proteins, you inhibit adenosylclase and therefore decrease cyclic AMP. So you can see that biochemically and mechanistically, the two effects both focus on cyclic AMP, but in different directions. When you look at what happens with increasing cyclic AMP in terms of the heart, you'll see that it increases the velocity of the upstroke in terms of pacemakers by increasing calcium ion flux. So calcium can go in faster. If calcium can go in faster, then the upstroke in pacemakers is increased. You also know that cyclic AMP increases potassium ion currents that are responsible for the delayed rectifying current. That's the current that repolarizes the membrane. That's the current that determines the duration of the action potential. So what we can see there is if you increase potassium ion movement, you shorten the duration of the action potential. That's what cyclic AMP can do. You can increase heart rate by virtue of increasing IF. What's IF? IF is the current that's involved in sodium ion movement during phase 4 in cells that are pacemakers. And if you increase that sodium ion current, then you increase the rate at which you get back to the threshold potential. Remember, we said the faster the slope of phase 4, the more rapidly you're going to achieve a potential that is the kickoff or threshold so that you can depolarize again. And that then influences heart rate. Now, if cyclic AMP does all those things, you'd make a pretty good idea. If increasing cyclic AMP does all those things, you'd probably make a pretty good guess that decreasing cyclic AMP will do the opposite. So if you knew it one way, you've almost got it sorted out in terms of what would happen if you knew what happens when it goes up, you know what happens when it goes down. There's also another thing that cyclic AMP does with respect to having an effect on slowing heart rate. It happens to produce a potassium current through the action of acetylcholine, and so therefore we call it the I for current, K/ACH. That stands for acetylcholine. And that's a current that's brought about by acetylcholine, which tends to slow diastolic depolarization. Remember that under normal circumstances, we close down potassium ion channels during phase 4 in a nodal cell. But if we also then start moving a current through the channel, then obviously we're going to slow diastolic depolarization. And that then will prolong the time taken for you reaching the threshold and therefore decrease the heart rate. So cyclic AMP does have an additional role to play, at least its deficiency does, in the sense that it would normally actually be doing just the opposite to what we described for increases, but there's a bit more to the story concerning potassium ion currents that are related to acetylcholine, which of course decreases cyclic AMP. Now, we're now almost to the point of talking about pharmacology. I actually have been saying something about drugs, as you probably can tell when I talk about the antiarrhythmics. I talk about which type they are and which channel they block. This series of diagrams actually shows most of the different classes of antiarrhythmic drug. And what I'd like to point out to you is the following. The items 1 concerns the effects on Vmax. In other words, here's an example of a normal Purkinje action potential. Item 1 represents the voltage change that occurs during depolarization. So if you see an effect here in the dashed line showing that it's slowed, then that's showing you an effect on the speed of achieving Vmax. Item 2 concerns the threshold for depolarization, and that's the sort of little rather small changes you see here, where in some cells we may have a threshold that is a potential that is closer to the threshold than in other cells, and that's certainly then, if you have changes here, by increasing the threshold you can have an effect on action potentials. Item 3 concerns what happens in diastolic depolarization, or the phase 4 slope. If drugs influence phase 4 slope, as they would here, as shown by the dashed line, you might see some effect on slowing the likelihood of another event occurring because it takes longer to get back to the threshold potential. And item 4 shows the duration of the action potential. And so drugs that influence potassium ion channels are likely to have an effect to increase the duration of the action potential. So having described what these items 1 through 4 mean, and showing you that a drug action is shown in a dashed line, whereas the normal situation is a solid line, let me just briefly describe some of the drug actions of drugs that can influence cardiac action potentials. Class 1A drugs. Now, these are drugs that include quinidine and procainamide. Quinidine is typical of a class 1A drug. It slows the rising phase of the action potential, and in most cells this is due to sodium entry. So you can pretty much guarantee then that quinidine on any class 1A drug is a sodium channel blocking drug, which it will be. But then you notice that there is also another effect. There is a longer period of time before the membrane comes back to the resting state. And this is because class 1A drugs also slow the repolarization phase by blocking potassium ion channels. So these are not very clean drugs. They are sodium channel blockers, but they also are potassium channel blockers. And as I said, any drug that blocks a potassium ion channel is likely to prolong the duration of the action potential. Now, we also have other sodium channel blocking drugs like lidocaine, which is a class 1B drug. Now, a class 1B drug may certainly slow the time to depolarization, although the slope may not change. It will certainly slow the time because of the effects to change the threshold potential. But it is unlikely to have an action on the repolarization phase, as shown by the 1A drugs, that would represent a prolongation of the action potential duration. Indeed, by the action of these drugs to block the sodium current that is occurring right through to phase 3, you might actually get a restoration of the resting membrane potential more rapidly. And that then often leads to a decrease in the duration of the action potential. So phase 1A drugs prolong the action potential duration. Class 1A drugs prolong the action potential duration, and class 1B drugs shorten the action potential duration. What are class 2 drugs? Class 2 are beta blockers. Beta blockers have multiple actions, as you can see here. They may slow the rising phase of the action potential, and they may slow diastolic depolarization. And both of those actions then is very likely to slow heart rate, as you can see, and decrease the excitability of the cell. Class 3 drugs are potassium channel blockers. And the most striking effect of potassium channel blockers, although they may slow phase 1, is really a very marked prolongation of phase 3. You'll notice that you don't repolarize for a very, very long period of time. This means your action potential duration is increased quite markedly. So almost by definition, class 3 drugs will prolong the duration of the action potential because they affect the delayed rectifier current, which is a potassium ion current. Now, what about class 4 drugs? Class 4 drugs happen to be drugs that are calcium channel blockers. And most of our action here concerns cells that are slow responding fibers or slow responding cells, particularly those involved in pacemakers. And you can see that class 4 drugs will actually slow to some extent the magnitude or decrease the magnitude of depolarization that occurs due to calcium ion flux, and certainly will have an effect in phase 4 to slow the diastolic depolarization slope so that it takes longer to get back to a potential that would allow for another event to occur in an excitable fashion. Digitalis, which we'll talk about separately when we get to congestive heart failure, has multiple actions on the heart, but can include an effect to increase the speed with which sodium ion channels open, and to have an impact on potassium flux, and also to have an action on the fluxes that take place in ions in terms of the diastolic depolarization. This is in a Purkinje fiber. As you see, all of these diagrams are shown for a single type of fiber, but you'll excuse me if I actually talk about calcium channel movement when I'm really referring largely to AV nodal and SA nodal cells. Well, I agree, this is pretty much a lot of physiology review, but it does permit us then to go fairly fast when we come to the antiarrhythmic drugs. We mentioned just a moment ago that class 1A drugs are sodium channel blockers. So you can say to yourself, yes, these drugs will slow the rising phase of the action potential in cells that use sodium for their depolarization. And we said already that the ability to do this depends on the state of the sodium-ion channel. Channels in the activated state or the open state are more likely to be affected by these drugs than those in the resting state. It appears that in order to interact with the sodium-ion channel components, they have to be in a particular conformation. That's referred to as state-dependent blockade. All right, that's when you see that phraseology, you know it. They're talking about the state of the sodium-ion channel. Now, 1A drugs also block potassium ion channels in phase 3. So they will have an effect to increase the duration of the action potential. They increase the action potential duration, APD, and they'll actually also increase the effective refractory period, meaning, of course, that the cells can't respond while they're in the effective refractory period. So this class of drugs is certainly not what we would call a highly selective drug group. Quinidine is the prototypic drug of our class 1A agents, and I might say that quinidine is a very heavily tested drug on examinations. I sometimes use the phraseology top 10. I include in the top 10 drugs warfarin and aspirin, and I also include quinidine as a drug that you should know very, very well. This drug is a sodium channel blocker, and as we say, all class 1A drugs are also potassium channel blockers. So you know two things about quinidine just because we've been describing what 1A drugs do. But quinidine's got some other properties as well. It is a muscarinic blocking agent, and any drug that blocks muscarinic receptors in the heart is very likely to increase heart rate and possibly to increase the conduction across the AV node. Now, this in and of itself is not a bad thing in the sense that that would actually make the drug less cardiodepressant, but it might not always be a good thing. Sometimes quinidine tends to push things across the AV node faster than they should go, so that sometimes if a patient has a fast atrial rate being transferred to the ventricle, perhaps in a 2-to-1 ratio, imagine this, a rate in the atria of 300 being transferred to the ventricle at a rate of 150. That's a 2-to-1 transfer. What if you slowed the rate in the atrium to 200? That should actually, if it was a 2-to-1 ratio of conduction, bring down ventricular rate to 100 per minute. But if you increase AV nodal conduction, you might actually increase the ventricular rate to 200. So here's an antiarrhythmic drug that can actually sometimes increase ventricular rate by virtue of its effect on AV nodal conduction. So it's not always a good thing. Quinidine certainly is very useful in the sense of its oral effectiveness. So it's a drug that has been used in many, many different types of arrhythmias in the ambulatory patient, both atrial and ventricular arrhythmias. Because it's so widely used, you should know something about its adverse effect profile. It does cause gastrointestinal distress, nausea and vomiting. It's derived from the bark of the willow tree, just as is its optical isomer, quinine, the antimalarial compound, and cinchona is the name of those trees, and cinchonism means the toxic pattern seen when one either ingests quinidine or quinine at, levels that are toxic. And that includes not only gastrointestinal distress, but ringing in the ears, tinnitus, for example, ocular dysfunction, and sometimes central nervous system effects leading to excitation. Quinidine also has some alpha blocking properties. Alpha blocking means, of course, vasodilation, and that can lead to hypotension. We often use the term in talking about drugs of quinidine-like actions on the heart. What do we mean by a quinidine-like action on the heart? Well, actually, what we really mean is something that can prolong the QRS complex or increase the QT interval. Now, this is brought about largely by virtue of the potassium channel blocking action of quinidine, which slows phase 3 and therefore increases action potential duration. We used to talk about a term, and we still do on occasion, of quinidine syncope, or fainting brought about by quinidine, and sometimes that certainly is still used. We now believe that quinidine syncope is actually an expression of a particular type of cardiac arrhythmia referred to as torsades. Torsades is a word that we've sort of anglicized. It comes from the French torsade de pointe arrhythmia, which means twisting of the points. And it's like taking a hold of an ECG and twisting it to make it a very polymorphic, flat sort of structure. In any event, it obviously is something that you would not want to happen to your heart, and if it's transient, you might faint, and then you come back to a normal heart rhythm. If it becomes persistent, then it has lethality associated with it. With quinidine, most of the time, of course, it's a transient arrhythmia, but obviously you don't want to have the business of fainting when you're not quite sure, that you want to faint at this particular moment. There are a lot of drug interactions with quinidine. Elevations of potassium in the blood tend to increase toxicity. That most commonly comes about actually by patients who are using supplementary potassium for other purposes because they're on a diuretic. But, any type of clinical condition that leads to hyperkalemia can increase the toxicity of quinidine. Quinidine, in turn, can affect other drugs. If you were looking for a drug that was most likely to enhance the toxicity of the cardiac glycoside digoxin, look no further. This would be the one I think that most people would pick on as an example of a drug interaction that enhances digitalis toxicity. And you might see also a decreased effect of cholinesterase inhibitors when they're used in the myasthenic patient. Quinidine, like many other drugs, has a sort of a muscle relaxing action, and this muscle relaxing action may be of a disadvantage in patients who suffer from myasthenia. Now, the second of the drugs that I would think you should know about that are class 1A drugs is the drug procainamide. It is different from quinidine. It is much less likely to cause muscarinic block, therefore it won't increase AV conduction, and there isn't any alpha block with procainamide, and therefore it's not likely to cause hypotension. But it is more cardiodepressant overall than quinidine. As a 1A drug, I'm hoping that you will remember that not only would it block sodium ion channels in phase 0, but it will block potassium ion channels during phase 3. So this drug too should prolong the action potential duration. This one works orally as well. It undergoes metabolism by an enzyme that is a phase 2 drug metabolizing enzyme called N-acetyltransferase. And we have differences between people in the activity of that enzyme. The bulk of the population of North America happens to be a slow acetylator, but certainly Native Americans, Eskimos, and a number of other genetic groupings of patients have the ability to rapidly metabolize procainamide because they have a high activity of N-acetyltransferase. The metabolite formed by the action of this particular enzyme is called N-acetylprocainamide. So NAPA means N-acetylprocainamide, and it's an active metabolite that appears to be responsible for prolongation of the action potential duration. Under the adverse effects, the most distinctive for us, and I would want you to remember this, is a lupus-like syndrome associated with the use of procainamide. Its overall incidence in the literature is anything from about 15% to 50%. So I've given you a middle number here of 30% incidence. Of course, 30% incidence of severe lupus would be untenable in medicine. Most of the signs and symptoms of a lupus-like syndrome with procainamide are relatively mild, but in some patients they are very, very severe. The incidence is tied in with slow acetylators. If you're a slow acetylator, which most of us are, then you have a higher likelihood of a lupus-like syndrome. This is obviously very characteristic, and I want you to remember that. Of all the drugs that I think of that causes lupus-like reactions, presumably by modifying immune function in our body, procainamide has to be very near the top of your list there. It also is different from quinidine in terms of its hematotoxicity. It can cause thrombocytopenia, and fortunately not commonly, but it has been also associated with agranulocytosis. Like quinidine, it can cause central nervous system effects, dizziness, etc. That's very like quinidine, hallucinations, and like quinidine, being a prolonger of the action potential duration, it has also been associated with the arrhythmia called torsades. Now, there are other class 1A drugs, but you know, we can't cover everything and we wouldn't want to. But I will say this once again to you, know your quinidine and at least know something about procainamide. What about the 1B drugs? Well, 1B drugs are also sodium channel blocking drugs, and they will decrease the maximal, voltage occurring in change occurring during phase 0 of the action potential. And this is very helpful, obviously, in a tachyarrhythmia that's faster than normal. As a general rule, drugs that are 1B rather favor cells that happen to be partly depolarized at rest. And you may remember that I said that this could be cells who'd been damaged by ischemia or hypoxia. Lidocaine, which is a good example of this class of drugs, actually decreases action potential duration. And as I said to you, this may be, although it's never been fully proven, but it may be because the drugs can block the slow sodium window currents. Remember I said there's a slow movement of sodium right from phase 0 through phase 3 that actually contributes to the action potential duration. Because you see, as sodium's constantly going in, it constantly keeps the membrane depolarized. Well, if you were to interfere with those slow window currents, as apparently lidocaine can do, you might well shorten the duration of the action potential. Suffice it to say, it's not of major clinical significance. There are a number of drugs in this class, but the one I want you to know well would be lidocaine. Lidocaine is not used orally. I mean, lidocaine, by the way, is also, as you well know, I think, a local anesthetic. But here we're talking about it as an antiarrhythmic. It's actually the drug of choice in at least 3 settings. Given intravenously, it's the drug that you would think of in the immediate management of arrhythmias in a patient who's had a myocardial infarct. It's not a drug you're going to use prophylactically. You can't go around using IV lidocaine, but you will use it in a hospital setting in the immediate time frame of an arrhythmia occurring post-MI. Certainly arrhythmias that develop following heart surgery, this would be the drug of choice there, or arrhythmias due to digitalis. All right, this is a good drug to use there. And sometimes when we get an arrhythmia, when we've been trying to actually cure an arrhythmia by electrical means, attempted cardioversion, where you've tried to change the potential by sudden changes in voltage, and sometimes you cause an arrhythmia by that mechanism. So lidocaine is a very important in-hospital drug. That's the way I think of lidocaine as a cardiovascular drug. It's intravenous, and therefore it's not going to be used in an ambulatory patient. It's actually the least depressant of all of the drugs that are used as antiarrhythmics. It actually is much more reminiscent of its local anesthetic action when it comes to toxicity, because as a local anesthetic, it happens to be neurotoxic. And when using lidocaine as an intravenous antiarrhythmic, you have to be careful with the dosage, because if you do get entry into the central nervous system, you can get quite marked CNS effects, including seizures. And that's certainly not something that you'd want to see. The reason why lidocaine can't be used orally is the old one, the good example, rapid first-pass metabolism. So here's a particular drug that's specific in that regard. Now, what about class 1C drugs? These were very fashionable about, I would say up to as much as 8 or 10 years ago. they like these drugs, at least in concept, because they seem to really have rather selective actions on sodium ion channels. They didn't do much else. They didn't seem to affect action potential duration, and they didn't seem to have autonomic side effects like quinidine, blocking muscarinic receptors or alpha receptors, etc. And they did seem to be purer, as it were, more selective sodium channel blockers. They're called class 1C, so they only work at the rising phase of the action potential in fast response fibers. Unfortunately, they were embraced into medicine really rather quickly and before one recognized that actually they don't work very well. And what has happened with this class of drugs is that their usefulness appears to have declined rapidly during the last decade. Part of the reason for that is that they had been used prophylactically following a myocardial infarct. You see, we do use antiarrhythmics post-MI. There's no argument about that because we're frightened of sudden death because of an arrhythmia, etc. So many patients will use antiarrhythmics in a chronic fashion. The use of these agents, though, happened to increase the incidence of sudden death. And that increased incidence was greater than the use of a placebo. Now, when a drug is worse than nothing, you don't like it. And so this type of drug, I don't believe you're going to see too much more about it. It has been used prophylactically, MI. Flecainide, encainide would be names of two of them. There is more than that, but I think we can sort of just put it into a category and then move on. That gets me to beta blockers. Class 2 drugs, or antiarrhythmic drugs, or beta blockers, will decrease SANAV nodal activity. They'll decrease phase 4 particularly, the diastolic current in pacemakers, so it takes longer to get back to the threshold, therefore you'll slow down the heart. Well, you know how they work. They're going to prevent activation of beta-1 receptors. Normally that would increase cyclic AMP. What you're doing with a beta blocker is preventing that increase in cyclic AMP. No big deal. It's very straightforward. If you want to know a little bit more about cyclic AMP, refer back to what we said earlier when we were discussing basic physiology, as it were, of the heart. Propranolols are prototype. Remind yourself that this is non-selective. Remind yourself about the possibility of cardioselective drugs, ones which block beta-1 receptors without affecting beta-2 receptors. Remember, we used AMA to distinguish that. Here's two of them again for you. And esmolol happens also to be a beta-1 selective blocking drug. It's a drug, esmolol, by the way, that is used intravenously, largely in the setting of the emergency room or the operating room. Now, when these drugs can be available for use orally, they have become very important drugs in post-myocardial infarct prophylaxis and in prophylaxis in patients who suffer from supraventricular tachycardias, SVTs. As I said, esmolol may be used in an acute fashion. It's a very short-acting intravenous drug. It's also actually been used as an antidote to overdose with theophylline. The methylxanthines, as you might remember, happen to be cardiac stimulants and sometimes can cause arrhythmias. And the way to deal with that is to actually use an intravenous beta blocker, and esmolol fits that bill. That leads us then to the class 3 antiarrhythmic drugs. These nominally are classified as potassium channel blockers, and therefore I think you'd make the prediction that they will increase action potential duration, increase effective refractory period. And that is the case. Most of their actions happen to be of phase 3 class 3 drugs on the cells that have fast responses. They decrease the potassium ion current that's responsible for the delayed rectifying current, and that's in phase 3 of the action potential. So they slow restoration of the resting membrane potential. We already seen some drugs that can do this. Class 1A drugs can do that, even though they're classified as sodium channel blockers. Beryllium is the first and oldest of these drugs we'll look at. It's not used very commonly. It's an intravenous drug as a backup agent in life-threatening ventricular arrhythmias. The trouble with beryllium is really that it can actually be pro-arrhythmogenic because it releases amines, and it has caused Torsades-like arrhythmias that have been persistent and therefore life-threatening. So that's the primary limitation of beryllium. Try to identify it. Just identify it as a potassium channel blocker or a class 3 antiarrhythmic drug. More recently, we've had the introduction of other drugs into this class. One of them is a drug called Sotalol, and the name sounds like it ought to also be a beta blocker. And in fact, that's true. This is actually not one compound. It's actually two compounds in a single drug. They are mirror images of each other. One of them happens to be a potassium channel blocker, so it'll do everything that potassium channel blockers will do, and the other will do what things that you will get out of a beta blocker, and mainly a beta-1 blocker, so it's got that cardioselective component about it. It's becoming more and more used. It's effective as an oral agent, and I believe there is a parenteral preparation available. Its problems really remain to be defined. I think you can anticipate that Torsades-like arrhythmias can occur with this drug, because any drug that blocks potassium channels can do that, but there's also quite marked central nervous system effects. Perhaps that comes largely from the beta blocking actions, because beta blockers do make people depressed and sometimes sedated, and this would seem to fit with the beta blocking action. The beta blocking action probably is also responsible for AV block, isn't it? I mean, beta receptors are involved in AV nodal conduction, and so this is probably related to a beta blocking action as much as anything else. Perhaps you should identify it because it is an interesting compound, and one more of the potassium channel blockers should be identified by you, and this is a drug called amiodarone. Amiodarone is a fascinating drug. It probably is the most effective antiarrhythmic that we've ever seen in medicine. And I suppose it should be really because, this will do everything. You can't imagine a drug that can do everything, but this can. It can act to block sodium channels, so it's a class 1 drug. It can act as a beta blocker, so it's a class 2 drug. It can act as a potassium channel blocker, so it's a class 3 drug. And although we haven't got to calcium channel blockers yet, I can tell you already that it's also a class 4 drug by blocking calcium channels in the heart. So it will do pretty much everything, and therefore perhaps it's reasonable to assume that it's a very effective antiarrhythmic. You expect to see an increase in APD and effective refractory period, and we've seen the use of this drug in a very, very wide range of arrhythmias, from atrial to ventricular. So it's certainly an interesting compound. Its primary problem is the very widespread, or what should we say, not widespread, but very divergent types of side effect that occur, and to some extent the magnitude or severity of such side effects. Any drug that causes pulmonary fibrosis has to be looked at with a certain amount of caution, and the overall incidence of pulmonary dysfunction with patients on amiodarone is greater than 10%. So, you have a 1 in 10 chance of rather severe pulmonary dysfunction if you put a patient on amiodarone. You have visual defects because of deposition on the cornea. You have pigmentation, smurf skin, the sort of bluish type of discoloration of the skin can occur. You may find that going out in sunlight causes a very marked type of reactivity as far as a sunburn's concerned. Sometimes the thyroid gets bigger because it's deficient, therefore you're hypothyroid, and sometimes you actually become hyperthyroid. Notice the increase in plasma lipids. That's not a wonderful thing. Low-density lipoprotein cholesterol is associated with atherosclerotic disease, and as a general rule, we would like not to increase that particular lipid in our blood. Any potassium channel blocker can cause torsade-like arrhythmias. And if you'd finally wanted to sort of cap it all, you could say, I don't think I like drugs that cause hepatic necrosis. So really the problems with amiodarone are those largely. The extent or the divergence and the extent of the toxicity is a limitation. There are drug interactions with this compound as well. It decreases the clearance of digoxin, phenytoin, quinidine, theophylline, and warfarin. By decreasing clearance, what do we mean? Enhancing the activity of those drugs. So that is a drug interaction that has rather major consequences. It is not good to increase levels of any of these agents if you want to survive. All right, that's the end of our potassium channel blockers. Now, what about our calcium channel blockers? These are class 4 drugs, and as you would anticipate, since calcium ion channels are particularly relevant to nodal activity, you'd expect SA node and AV nodal activity to be decreased by such compounds. They will also decrease the slope of phase 4, the diastolic currents that are responsible for returning to a threshold in pacemaker cells. The prototype drug is verapamil. I want you to know that name. That would be a good idea to do that. It is the prototypic calcium channel blocker. It does, I suppose, have some degree of cardioselectivity, but it will also block calcium channels in the vasculature. This can lead to hypotension, and sometimes the lowering of blood pressure can lead to a reflex tachycardia. But it's going to be blunted because you're also blocking calcium channels in the heart. We have another drug that's widely known, or at least widely used, diltiazem, but it's not the prototype, and it's not particularly different. If you wish to remember that one, that's fine. It does have activity on calcium channels in the heart, and to a small extent on the vasculature. Verapamil is used prophylactically, particularly in arrhythmias that concern anything above the node. So we could say reentrant, nodal, and atrial tachycardias, not Wolff-Parkinson-White arrhythmias. It's contraindicated in that type of arrhythmia. You also shouldn't use this type of drug really in ventricular tachycardia. It has the tendency to make the tachycardia go faster and end up with a ventricular fibrillation. The side effects are fairly straightforward: gastrointestinal distress, sometimes a dizziness, a flushing. We do get some degree of hypotension, and certainly you would anticipate that in higher doses you're bound to cause AV block, because you see AV nodal transmission is due to calcium ion channels, opening. And so if you close those calcium ion channels, then it doesn't surprise one that you get some degree of AV block. Now, we have one more drug that is a genuine drug, that doesn't fit into any of the classes of antiarrhythmics we so far mentioned. This is adenosine. Now, adenosine is a natural compound. We can find it in the heart, we can find it in the lungs, you can find it in the GI tract, you can find it in the brain for that matter. We're dealing here with the heart, and adenosine is capable of decreasing nodal activity in pacemaker cells and increasing AV nodal refractory period. It activates its own receptors. They're called adenosine or A receptors, which are actually coupled by the GI type of protein to adenyl cyclase, leading to a decrease in cyclic AMP. They have other there are other actions that the adenosine receptors are involved in. They'll increase potassium efflux, and that, of course, tends to cause membrane stabilization by virtue of a hyperpolarizing action. Adenosine has become a drug of choice for paroxysmal supraventricular tachycardias, AV nodal arrhythmias. It has to be given intravenously and has a very, very short duration of action, possibly less than 30 seconds. Therefore, since it's going to be given under rather strict conditions here, whenever you give an IV drug, you will probably not be too perturbed by the fact that you might flush or become sedated, but the dyspnea sometimes is awkward, in terms of effects on respiratory function. The action of adenosine is antagonized by theophylline. Actually, we take advantage of that to some degree in the use of theophylline and other methylxanthines in terms of their use in asthma, because adenosine actually is responsible for bronchoconstriction, and we can antagonize that by theophylline. Now, magnesium's not a drug, but I think we can at least sort of talk about it as an antiarrhythmic drug in a sense. It was first brought into medicine in arrhythmias associated with digitalis. First brought into medicine as an antiarrhythmic. In arrhythmias associated with digitalis in patients who were hypomagnesiemic. And they'd become hypomagnesiemic probably because they'd been treated with a loop diuretic. Anyway, the idea was to give the magnesium back and see if you couldn't decrease digitalis toxicity. It turned out actually that you could get an effect of magnesium as an antiarrhythmic even if magnesium was at normal levels in the blood. And this then got sort of extended into the use of magnesium in torsades. So magnesium is a drug that you could possibly use in arrhythmias caused by potassium channel blocking agents. You know, the torsade de pointe arrhythmias caused by 1A drugs and by drugs that are the class 3 drugs, the potassium channel blockers. So I do include magnesium, you know, in this discussion of antiarrhythmics. We have to look at the angiotensin system, which we described a little earlier when we were talking about autonomic pharmacology, because we got some very important antihypertensive drugs, and drugs, by the way, which are useful in congestive heart failure, that influence the angiotensin system. Angiotensin 1 is made by the action of renin released from the kidney from angiotensinogen, a compound made in the liver. Angiotensin 1 is then converted to angiotensin 2 by the action of an enzyme, which is a peptidase called angiotensin converting enzyme, otherwise known as ACE or ACE. Now, angiotensin 2 has two major targets relevant to the maintenance of blood pressure. One is the adrenal cortex, where angiotensin 2 increases the formation of aldosterone, the major mineralocorticoid in our bodies. And what does aldosterone do? Well, it goes to the kidney from the adrenal cortex and acts to increase the reabsorption of sodium and carry with it the reabsorption of water. So this is an action that's going to be water and sodium retaining, increasing blood volume, and by increasing blood volume, you increase blood pressure. In addition, angiotensin 2 can act on blood vessels through its receptors to bring about a vasoconstriction. Now, if one can prevent the formation of angiotensin 2 by inhibiting ACE, or angiotensin converting enzyme, you obviously are going to help lower blood pressure. You're helping because you are not making aldosterone, and you're helping because you're avoiding the vasoconstriction that angiotensin 2 can cause. Now, it turns out that the enzyme angiotensin converting enzyme, or ACE, also metabolizes bradykinin, another peptide. Now, bradykinin is a vasodilator, and it is inactivated by ACE. If one inhibits its metabolism by this enzyme, we get higher levels of bradykinin occurring, and therefore a greater degree of vasodilation. So that makes a lot of sense to imagine that it's an advantage to increase bradykinin by virtue of inhibiting its metabolism, because that will be contributory to the lowering of blood pressure. So there are at least three things to be thought of in the context of ACE inhibitors in a mechanistic fashion. Now, we've had ACE inhibitors for about 15 years. There's about 8 or 9 of them out there in terms of clinical use. More recently, we've seen the introduction of some drugs that work on this system, but not by inhibiting the formation of angiotensin 2 or the breakdown of bradykinin, but actually working to antagonize the receptors for angiotensin 2 in both the adrenal cortex and in the blood vessels. So you're not influencing formation with angiotensin II receptor antagonists like losartan. Notice here the nomenclature is a little bit confusing. There are two types of receptor for angiotensin II, AT-1 and AT-2. It's the AT-1 enzymes, which are receptors for angiotensin II, that are blocked by the artan family, like losartan. Now, losartan, while it will inhibit formation of aldosterone and inhibit the action of angiotensin II on blood vessels, will not do anything to bradykinin. You see, because these are receptor antagonists, they're not enzyme inhibitors. So they can't do anything to bradykinin, which obviously has a significance, as you'll see momentarily. Now, if we look at the pharmacology then in a way that sort of is descriptive, we've said already ACE inhibitors like the drug captopril. Most of the ACE inhibitors, in fact I think all of the 9 of them, end in the word pril. I think we're still okay there to use that as a family name. So you'll decrease angiotensin II, you will decrease the activation of receptors both in the adrenal and in the vasculature. That is a very helpful action to lower blood pressure. You'll inhibit bradykinin metabolism, and we think that this is going to have an effect to enhance nitric oxide formation, and that would then get to a vasodilation and decrease peripheral vascular resistance. The antagonist drugs, losartan and the rest of the ARTANs, block the actions of angiotensin II, but they don't affect bradykinin levels or do anything to enhance its effects. So here's a verbal description of what we were just saying, looking at that scheme. Now, both types of drugs are used in mild to moderate hypertension, and they've also become major drugs for the treatment of congestive heart failure, CHF. They slow the progression of nephropathy in patients who are diabetic with existing nephropathy. They decrease the efferent resistance in the glomerulus. Now, this is of much interest because many diabetic patients, of course, do have severe problems of nephropathy. And if you have to treat a diabetic patient who is hypertensive, and they often are, then this type of drug might be a very good choice because it slows the problem that's occurred during diabetes in terms of renal damage. However, you should recognize, and you'll see that in a moment, that these drugs actually also happen to be damaging to the kidney, although not specifically in that group of patients that already have renal damage. But in any event, it has always been considered an anomaly that in one group of patients it can be helpful to protect against further renal damage, and in most other patients there is the risk of possible renal damage due to the drug. You can anticipate that any drug that lowers blood pressure is likely to cause some degree of hypotensive sequelae. Hypovolemia can occur, sometimes with hemodynamic consequences. But probably one of the more striking things about the ACE inhibitors is the high incidence of a dry cough. That occurs with an incidence of about 1 in 3 patients. And it's very difficult to eradicate. You either sort of put up with it, you can try other drugs or other things that might be helpful, or you change therapy. But in any event, we think this is largely due to the formation, to the increased effect of bradykinin. Bradykinin not being metabolized may be responsible for the dry cough that we've seen there. Hyperkalemia can occur with the ACE inhibitors, and in patients who particularly have renal artery stenosis, there may be renal failure. Sometimes we see angioedema. This is very interesting because there's a sort of a genotypic variant here. Black patients have at least 3 times the incidence of this rather severe state than the white patients. So, there does seem to be some connection there. ACE inhibitors are okay in patients who are hyperlipidemic because they do not have effects on plasma lipids. However, they're not okay in pregnancy. This is the first group of drugs in the cardiovascular arena that we've come across where these agents should not be used in pregnancy. And that goes, by the way, for the angiotensin II receptor antagonists. They also appear to be teratogenic. So look for the problem there of renal failure, malformations in renal structure, skull malformations, and even fetal hypotension as being the reasons for not wanting to use these drugs in the pregnant patient. I should tell you that the incidence of dry cough is very much lower than 30% in patients who are on receptor antagonists. That certainly makes the idea fairly I think clear that bradykinin is being implicated in the cough. And we also think that bradykinin may be implicated in the angioedema that is seen. Let's just look for a moment at drugs and their vasodilating capability. Now we know some of these drugs, or are reminded about some of these drugs, we can say which drugs are most likely to affect arteriolar tone. And among that category, 3 of the drugs happen to be the direct-acting vasodilators: diazoxide, hydralazine, and minoxidil. Which drugs will affect venular tone? Well, we haven't quite got to these drugs really, although we did mention nitroprusside, and that would fit in there. But many of the drugs used in angina, the drugs like, for example, nitroglycerine or isosorbide dinitrate, are venular dilatants. And the rest of the drugs will actually cause dilation in both arterial and venular beds. Now remember this, orthostatic or postural hypotension results from venular dilatation, where you get pooling rather than from arteriolar dilatation. Excuse me for putting this in, really. It may be too obvious to you, but perhaps it isn't to some. Now, the family names of antihypertensive drugs can also be helpful for you in the game playing in terms of examinations. OLOLs, with the exception of labetalol and carvedilol, are usually beta blockers. As I said earlier, the prils are usually ACE inhibitors. The ARTANs, like losartan, are angiotensin receptor antagonist, and the vascular selective calcium channel antagonists are the dipines, like nifedipine or nimodipine, etc. And so maybe this will help you to some degree in sort of sorting some of them out. Now, we're going to change our drug group now to drugs that might be useful in the management of patients who have heart failure. Heart failure comes about due to defects in cardiac contractility, and therefore the patients have an inadequate cardiac output. The best way, really, theoretically anyway, to deal with heart failure is to replace the heart. But, you know, the numbers of heart transplants annually don't go anywhere near, in terms of the numbers, the people that need a new heart. And certainly patients with congestive heart failure can live for many years with the heart that they have and live productive lives if one manages to deal with the symptoms and signs of heart failure in a reasonable fashion. What are the signs and symptoms then? Well, the early signs and symptoms include decreased exercise tolerance and tiredness, muscle fatigue. But you get a lot of compensatory response brought about by the drop in blood pressure due to the inadequate cardiac output. I mean, you already would predict this, wouldn't you? You would say, our bodies, every time the blood pressure goes down, then what do we get? Increased sympathetic outflow. So the very first thing that happens is the heart goes faster. And that's not really fair on the heart, is it, really? Here you've got a heart that can't do a good job, and the sympathetic nervous system is saying, but go faster anyway, all right, which is not very nice. Anyway, the tachycardia is a fairly early sign of congestive heart failure. Increases in arterial tone occur, so that then increases the afterload. It makes it harder for the heart to pump against the afterload. That's obviously a disadvantage because output goes down. Your decreased perfusion of vital organs, including the kidney. Venous tone goes up, and what does that do? That's going to cause an increased preload. More blood's going into the heart, getting a bigger stretch of the fibers, and the poor little heart is again being forced to do more than it really can do. We activate the renin-angiotensin system, edema occurs, and much of the fluid gets into the lungs and leads to shortness of breath. And even the little heart wants to get bigger. Right? It's called intrinsic compensation or myocardial hypertrophy. All of these things actually are further contributory to heart failure. You can't make a heart go faster without making it sicker, actually. And unfortunately, these compensations in the realm of trying to maintain function actually are deleterious to the heart. We often talk about heart failure in the context of ventricular function curves. Here's an example of a ventricular function curve where on the vertical axis we have cardiac output, and on the horizontal axis we have some index of ventricular function. It could be fiber length, but in this case we've chosen to use ventricular filling pressure. Now, first I want you to look at the situation under normal circumstances in those of us that have a normal heart. Over quite a marked range of ventricular filling pressure, you notice that the cardiac output goes up. It can't go on forever, but it's a very long range where you see an increment for every increment in filling pressure. So as blood is going back into the heart, and therefore filling pressure increases, we're getting more out of the heart in terms of cardiac output. Now, in the case of the failing heart, we see that the lower tracing represents what happens in the failing heart, which means that for every increase in ventricular filling pressure, instead of getting the cardiac output we should have got, we get much less. And you notice it's a much flatter curve, and would then, by the time you get to about 15 millimeters of mercury filling pressure, you're actually beginning to go in a negative fashion. So the failing heart just can't do the job in terms of cardiac output. But our compensatory mechanisms that come into play are trying to make it do a better job. I mean, just imagine it in this way. Your defect is in contractility. Sympathetic stimulation leads to an increase in contractility. So the compensatory mechanisms are to try and promote contractility and actually push the Frank-Starling relationship, as it is called, upwards and to the left. That's what you're trying to do by your compensation. Now, from the standpoint of this compensation, accepting that this is sort of deleterious, what I would like you to understand is that it is possible with the appropriate pharmacological management to actually replace the compensation with the drugs. Now, obviously, there's always give and take here. You may have to put up with the adverse effects of the drug, but it's been shown, particularly in the last decade, that many drugs not only can improve the day-to-day living of a patient with congestive heart failure, but now can increase survival. We now know that. And so, in the sense of pharmacology and its relationship to the so-called Frank-Starling relationship or left ventricular function curves, what we're trying to do with drugs is once again what is happening with compensation, to push these relationships upwards and to the left as best we can. And digoxin certainly has been a drug that has been shown to do that by its increase on contractility. So when you can do that with drugs, then the compensatory mechanisms are not needed. So you don't have to make the heart bigger and perhaps more fragile because of that, and you don't have to make the arterioles constrict as much, or venous return to increase as much, or fluid to be retained as much, and that's where pharmacology comes in. Now, in terms of the drug actions in heart failure, I see it as sort of three primary mechanisms, and each of them is designed to offset compensation. You could decrease preload. Diuretics will do that by decreasing blood volume. ACE inhibitors will do that by their vasodilating properties. Angiotensin receptor antagonists will do that because they will also produce a vasodilation. And of course, any of the direct-acting vasodilators may have that value as well. What are you going to do when you decrease afterload? You're going to decrease arteriolar tone. ACE inhibitors will do it. Angiotensin antagonists will do it. And vasodilators will do it. What about if you had a drug that can actually increase the contractility of the heart muscle? Well, certainly digitalis is well known to do that, but the beta agonists will do that. Remember the drug dobutamine? Dobutamine stimulates beta-1 receptors, and that's a beta agonist. And we have a few other odds and ends, including bipyridines, that also have at least some utility in the area of pharmacological management of failure. Remember then that if a drug is useful in heart failure, it ought to displace a ventricular function curve upward and to the left. I use that phraseology because others have. Okay, What about the ACE inhibitors once again? We just discussed them a little while ago under hypertension. The reason I give them pride of place here in congestive heart failure is based on the acceptance in the last half a decade that these drugs happen to be not only capable of improving the symptoms that a patient suffers when they're suffering from heart failure, not only improving exercise tolerance, but actually slowing the progression of failure and prolonging survival. Now, you may not think much of that if you've been assuming that digitalis prolongs survival, but I can tell you that digitalis does not do that. Digitalis is commonly used in congestive heart failure and for many years was considered to be the drug. But it is no longer the drug because it does not prolong survival, whereas ACE inhibitors and angiotensin II antagonists do prolong survival. So this is my reason for wanting to place this class of drugs a little bit ahead of digitalis. Now, it's not to say that we don't need to know something about digitalis. We do, but I just thought that for the order of consideration of drugs in heart failure, now we have to place this two pairs of drugs or classes of drugs fairly high on our option list. One of the very interesting things about ACE inhibitors is that they oppose remodeling of heart structure that often occurs following a myocardial infarct. Now, you might say to yourself, well, so what? Well, you see, remodeling leads to heart failure downstream. Later on, after a myocardial infarct, the remodeling that takes place can ultimately lead to a patient suffering from heart failure. And that does not sound like a good idea. So if you put the patient on an ACE inhibitor after a myocardial infarct, you can slow that remodeling and therefore protect against failure. This is a prophylactic action. So I like to think of you placing these drugs now not only in the antihypertensive category, but in the congestive heart failure category. I think that would be ideal. That leads me then into cardiac glycosides. Cardiac glycosides have been with us since the time of the English physician William Witherin, who extracted from the leaf of the foxglove certain compounds that he used in what was a condition then that we think probably was congestive heart failure. It was called dropsy, and it had all of the symptoms of congestive heart failure. That goes back in almost 2 centuries, and so digitalis leaf extracts have been with us for a long period of time. Now, a much shorter period of time has elapsed since we had a notion of how the drug was acting. We knew that it stimulated the heart. We didn't have any argument about that, but we didn't know what the mechanism was. And now we do know the mechanism rather well. Its receptor is the enzyme sodium potassium ATPase. Now, that enzyme is ubiquitous. It's present in all cells in our body, and in excitable cells really is very important because, you see, it restores the ionic gradient that we need for resting membrane potentials. And in the case of the cardiac cell, this is the same sort of function there. It restores the gradients after you've stimulated a heart cell. Now, when you inhibit the cardiac membrane ATPase, you actually cause an accumulation of sodium on the inside of the membrane. On the membrane, we have a sodium-calcium exchange mechanism. By inhibiting the ATPase, we impact on that sodium-calcium exchange mechanism such that calcium is not pumped out in exchange for sodium. Instead, its intracellular level rises. And if it increases inside the cell, in the cytoplasm, we then see an increase in the calcium content in the sarcoplasmic reticulum, the SR. So when the cell is excited and calcium is actually the, if you like, the messenger for the release of calcium from the sarcoplasmic reticulum, then we have greater amounts of calcium released. This binds to the compound troponin, which means that the tropomyosin molecule moves and allows actin and myosin to bind to each other and bring about a contraction. So there are multiple steps, obviously, in the mechanism of action of digitalis glycosides, but you can see that ultimately you're going to help out by increasing contractility, but your original target was the sodium-potassium ATPase. Now, the binding of digitalis to this pump, the sodium-potassium ATPase enzyme, is inhibited by potassium. It binds to the same site, actually, as potassium on that enzyme pump. So elevations in blood potassium, hyperkalemia, decrease the effects of digitalis, and hypokalemia, low blood levels of potassium, can sometimes enhance the effects of digitalis. So this would be a verbal description of the mechanism of action. The improvement in contractility obviously improves cardiac output, and that reverses the increase in heart rate that we saw because of compensation, the increases in blood pressure and peripheral resistance, etc. We help out in terms of the perfusion of vital organs, including the kidney, and therefore we get more diuresis, so we get rid of some of the fluid that's been retained. However, I want you to appreciate cardiac glycosides, while they may improve the day-to-day functioning of the patient, decrease the problems of hospitalization, do not make you live longer. There is no evidence of improvement of survival in patients taking digitalis glycosides. The diagram shown here allows us, for me now, to show you what really happens with the action of the cardiac glycoside. Under normal circumstances, calcium, when we get excitation of this membrane, runs through its channel, as we described a little earlier, and has an action on the sarcoplasmic reticulum to release calcium from within the SR. And it's the calcium action on the troponin-tropomyosin system that, by movement of tropomyosin, allows actin and myosin to bind together and interact together to increase contractility. This is the most important component that interests us at the present time. But at the top here, on the left-hand side, in this particular circle here, we see that this is the sodium-potassium ATPase, an energy-dependent action to bring potassium into the cell at the expense of sodium. It's an asymmetric system. 2 potassiums are brought in for 3 sodiums, etc. This goes on all the time. This is our pump. This is what restores the ionic gradient. Now you inhibit it, and this allows more sodium to accumulate in the cytoplasm. Now you'll notice that there is also a transporter, or an antiporter really, in a sense, because calcium goes out for sodium coming in, which normally then brings sodium in and pushes calcium out. But there's no reason to bring sodium in if you've inhibited the pump, because sodium's already relatively high in the cytoplasm. And that means then, if you don't bring sodium in, you don't push calcium out. Calcium goes up in the cytoplasm, more calcium goes into the sarcoplasmic reticulum, more available for release when you get an excitation. So these are the most important features related to digitalis. We happen in this particular figure to also show what happens with respect to beta-1 receptor activation in terms of its effect to promote formation of cyclic AMP and through adenosylase. And the cyclic AMP, one of its actions is, of course, to foster the movement of calcium down its concentration gradient. Phosphodiesterases inactivate cyclic AMP, forming adenosine monophosphate. So if you were to inhibit a phosphodiesterase, you'll increase cyclic AMP. So while we had the figure in front of us, although it's not germane to the action of digitalis, it's a good little review of what is happening with respect to beta-1 receptor activation in a cardiac cell. Now, I need you to know some of the cardiac effects of digitalis. The inhibition of sodium-potassium ATPase has actions that will cause a decrease in action potential duration and in effective refractory period in atria, and also in ventricles and Purkinje systems. At the AV node, there is a decrease in conduction velocity, so there's slowing of AV nodal conduction when one inhibits the sodium-potassium ATPase. However, digitalis, by its general mechanism of affecting sodium-potassium ATPase, is not the only action on the heart. Digitalis actually has a vagotomimetic action on the heart. If you like, you can call it a cholinomimetic. I like the idea of vagotomimetic actually a bit more because it then tells you really how it comes about. It comes about through stimulation of the vagus centrally. So as we see a CNS action, there is increased vagal outflow, and that leads at the level of the atria to a decreased SA nodal rate, and at the level of the AV node, a decrease in conduction velocity and an increase in the effective refractory period. So this is a vagotomimetic action. This is exactly what acetylcholine would do at the level of the AV node or the SA node. So I like to call it vagotomimetic, but it is also a cholinomimetic action, but it is indirect. There is a third property of digitalis which makes life a little bit difficult, which is beta-1-like. So we have a sympathomimetic action, and this can be seen at the level of atria, AV node, or ventricular Purkinje systems. We again increase conduction velocity in the atria, but not in the AV node. We don't change that radically, but we do change effective refractory period. And there is an increased conduction velocity and abnormal automaticity in ventricles and Purkinje cells. Now, I mention this to you particularly because sympathomimetic-like actions are pro-arrhythmogenic. And certainly we know that digitalis can cause arrhythmias. It's one of those cases where here's a drug that we know can actually be an antiarrhythmic by virtue of its ability to decrease AV nodal conduction, but also through its sympathomimetic action can be pro-arrhythmogenic. That's not uncommon with drugs. They can do more than one thing, and a lot of it depends actually on the dosage used. Now, I want to compare digoxin with digitoxin for you. We don't use digitalis leaf anymore. Probably 9 times out of 10, if you put a patient on a cardiac glycoside, it will be digoxin. It's very inconvenient. It's very convenient to use digoxin because it's got a half-life that permits once daily dosing. The half-life is better than a day, but not so long that you will get too much accumulation. Digitoxin has got a much longer half-life, approaching about a week, 6 days or so, and that makes dosing rather difficult. The clearance of digoxin is largely renal, not completely but largely, whereas digitoxin is by the liver. There is a difference in protein binding. One of the problems with digitoxin is its extensive protein binding, and there are differences in volume of distribution, which to some extent reflect the ability of the drugs to penetrate into tissues. We use the vagotomimetic action of digitalis on occasion as an antiarrhythmic action in patients who suffer from supraventricular tachycardias. I'm thinking here of patients who have atrial fibrillation. And we can also slow AV conduction caused by drugs like quinidine by a small dose of digitalis. The phraseology dysdigitalization prior to quinidine has been used in the medical literature, and what you're trying to do is to take advantage of digitalis slowing AV conduction to prevent quinidine from increasing AV conduction by its M blocking type action. The toxicity of digitalis when it occurs, and the drug happens to have a relatively narrow therapeutic window. Therapeutic window really means that there's not a big difference between the plasma level that's needed for effect and plasma level that's needed or not needed to cause toxicity. And so that's a fairly narrow therapeutic window. And early signs usually concern the gastrointestinal system. So the patient may become anorexic or nauseous and sometimes will vomit. If you're capable of monitoring ECG, you'll see evidence of effects on the QT interval and effects on T wave, a decrease in T wave, sometimes inversion. As the toxicity continues, premature ventricular beats may occur, or bigeminy. By the time you get round to CNS effects, you're usually getting rather marked cardiovascular effects. And in fact, you might have stopped all this by just not taking a digitalis dose. That might be enough to prevent further toxicity. When you get disoriented or you see halos around objects or hallucinate, you're usually pretty well on in terms of digitalis toxicity. And so you're probably going to be seeing supraventricular tachycardias, sometimes an AV nodal tach, but on occasion an AV nodal block. Ventricular tachycardia occur, and in the extreme you could have ventricular fibrillation. First step here, of course, is to stop giving the drug, and probably the second step is to get the electrolytes right in the patient, because electrolytes very markedly influence digitalis toxicity. If you're going to use an antiarrhythmic drug, it will be a drug probably of the 1B class of antiarrhythmics. The prototypic drug there is lidocaine, but the drug phenytoin also fits into that category, so you might even consider that drug as well. If you're in severe toxicity, then antibodies should be used. Digibind is the antibody in mind here. They're Fab antibodies, which will complex both digoxin and digitoxin, and therefore act as a chemical antagonist. And pacemakers may be needed in the case of changes in AV nodal conduction. People don't usually like to use cardioversion unless the patient is in ventricular fibrillation, because attempts at cardioversion often push the patient into fibrillation. Now, I mentioned to you that electrolyte balance was important here because toxicity can be affected by electrolytes very readily. If a patient is hypokalemic, they have enhanced toxicity to the digitalis. Now, it's not uncommon that patients are hypokalemic, especially if they've been on diuretics, because both thiazide and loop diuretics lower blood potassium. Loop diuretics are very good at lowering magnesium, so hypermagnesemia tends to enhance toxicity. Thiazide diuretics tend to elevate calcium in the blood. They are known causes of hypercalcemia. Why am I mentioning these diuretics? Well, generally, these are the first sort of things you resort to when you're dealing with congestive heart failure to get rid of some of the fluid and help lower the blood pressure. So these agents will probably be used even before you get round to using digitalis. So at least look towards balance of the electrolytes towards the normal range. I mentioned earlier that quinidine is a bad actor when it comes to digitalis, and you should also know that one of the most common causes of actually excessive digitalis effects are the non-steroidal anti-inflammatory drugs, many of which, of course, you don't need a prescription for. Ibuprofen, for example, naproxen. Both of these types of drugs tend to enhance the toxicity of digitalis, and you really don't have an awful lot of control over the dosage there when you're dealing with over-the-counter drugs. Sympathomimetics will also enhance toxicity. Some antibiotics will do that as well, including erythromycin. So digitalis is worth knowing about. Perhaps a little bit less because of its clinical importance, so they're still widely used, but it still happens to be a drug that is a high-yield drug when it comes to looking for examination questions. Other drugs in heart failure include a couple of compounds that are not really very good. They're inhibitors of phosphodiesterase, and you saw in that diagram what that would lead to an increase in cyclic AMP, and that would lead to a positive inotropic action. And they also are vasodilators. The trouble with amrinone and milrinone is their toxicity. Amrinone is a fairly likely drug to cause thrombocytopenia, and milrinone, when used in congestive heart failure, actually decreases survival. So that would more or less, I think, push you away from the idea that these drugs have a very important clinical application. In any event, those are two of the types of drugs that are available. We mentioned earlier that dobutamine can be used in acute failure, but not chronic because of tachyphylaxis. Dopamine can help out in terms of renal perfusion, and at higher doses also has a cardiac stimulant effect. And here's a drug that we've not said much about other than identifying it, carvedilol. Carvedilol is both an alpha and beta blocker. Now, the beta blocking aspect of it, there's nothing terribly wrong with that really, except that, over the years, we've always tried to avoid beta blockers in congestive heart failure. I mean, I think it's more like intuitive than anything else. I mean, you've got a patient whose heart is not working well. Would you want to depress it with a beta blocker? I think ordinarily the answer to that would have been no. But it turns out that at least some drugs that happen to have beta blocking activity can be useful in congestive heart failure. And I like this one particularly because this one has been shown not only to slow remodeling, which then would decrease the likelihood of further congestive failure, but actually, and this is the proof of the pudding, increase survival rate. And if you can decrease morbidity or mortality with a drug, that's pretty convincing that it might be worthwhile. So there's been a rather big increase in the last 2 or 3 years in the addition of carvedilol to the management of patients with congestive heart failure. Similarly, we have dihydropyridine calcium channel antagonist that has gained a good deal of interest and excitement in the area of congestive heart failure. This is a drug that is in the same family as nifedipine or nimodipine. Now, those drugs ordinarily would have said lower blood pressure. Well, that could be helpful in congestive heart failure, but I don't think most people thought that they would be very useful drugs that could possibly help out the heart. But actually it happens that amlodipine increases survival, just like carvedilol. So all of a sudden now, we're seeing more and more drugs that improve survival. By the way, this is all taking place since the year 1994. We're talking about the last half decade that we found this information out. And it's only in that time frame that we've actually come to the conclusion that digitalis does not prolong survival. So when you've got all these drugs that do seem to have value, you can see it's rather changed our ideas of the management of congestive heart failure. As recently as May of 1999, there was another rather big, exciting development. An old drug called spironolactone, which is usually classified as an aldosterone receptor antagonist and therefore put into the category of drugs that work at the level of preventing aldosterone's actions on the kidney. All right, it's called aldactone, was then shown to decrease mortality rate when used with an ACE inhibitor. Now, that again is another drug that decreases mortality rate. So you've got alpha-beta blockers, dihydropyridine calcium channel blockers, spironolactone, a mineralocorticoid receptor antagonist, ACE inhibitors, and angiotensin II antagonists. 5 groups of drugs prolong survival in congestive heart failure, all found out about in the last half decade. So you can see that this is a very interesting and evolving area at the present time. Now, that leads us then to anti-anginal drugs. Right? Anti-anginal drugs are relevant to angina because of the pain that occurs when oxygen delivery to the heart cells is inadequate. And there are really 3 basic, or rather classical, I suppose, forms of angina. The most classic angina is sometimes called angina of effort or exercise-induced angina, and that's thought to be largely due to occlusion in the coronary vessels, atherosclerotic occlusion. In other words, the tubes are narrower and therefore not as much blood is getting through and not enough oxygen is being carried through to the cells. This is the most common form of angina, and you would test for that, of course, perhaps in some form of exercise test. Put somebody on a treadmill and see how far they can go before they can't go any further because of lack of oxygenation. Careful does it. Vasospastic or variant forms of angina are reversible. People sometimes wake up in the middle of the night and feel pain in their heart due to vasospasm in the coronary vessels. And that is a reversible decrease in coronary blood flow, vasospastic or variant angina. Unstable or crescendo angina is a sort of a combination of both classic and vasospastic angina coupled with platelet aggregation. Now, this is not something that goes untreated. This is what we would actually now reclassify as an acute coronary syndrome that is life-threatening. This is not the form of angina that you see people walking around with. This is the form of angina that is a hospitalized state and requires many drugs to manage. And we'll see that as a very separate item. For the moment, though, let us look at the most common types of angina, the classic angina and the vasospastic angina. The drug strategy here is fairly obvious. Increase oxygen delivery or decrease oxygen requirement. And how could you increase oxygen delivery? Well, maybe you cut down those vasospasms. And the two drug groups that are capable of doing that are the nitrate family and the calcium channel antagonists. The other way to go about it would be to decrease oxygen requirement. And that you can do by decreasing peripheral vascular resistance, decreasing cardiac output, or both of these effects. Nitrates will do that, calcium channel antagonists will do that, and of course you already remember that the beta blockers will decrease oxygen requirement. Now, so far, we have not really discussed nitric oxide in any real detail, but I thought it would be a good time now to talk about nitrates and nitric oxide pathway. Nitric oxide is made via the enzyme nitric oxide synthase from L-arginine. And nitric oxide, as I said, is a stimulant of guanyl cyclase. It actually promotes formation of the active form of guanyl cyclase, which takes guanosine triphosphate and makes it into cyclic GMP. And cyclic GMP is the responsible second messenger leading to relaxation in vascular smooth muscle. Now, you can make nitric oxide endogenously, receptors for acetylcholine on the endothelial cell, for bradykinin, for serotonin, for histamine for that matter, I forgot to put that one in, can activate these NO synthase, leading to increased production of nitric oxide. Now, you can also make nitric oxide from nitroglycerin and other nitrates. And by doing so, you're really bypassing the synthase, but you are not bypassing the guanyl cyclase. You're making the stuff and therefore still activating guanyl cyclase. So this figure just really simply describes for you that you can get nitric oxide either by, endogenously, and that will lead to vasodilation, or by providing it in the form of a drug that can actually break down to form nitric oxide. Either or will actually lead to the same event of vasodilation. So we can trigger nitric oxide formation by muscarinic receptor activation, bradykinin receptor activation, serotonin receptor activation, and histamine receptor activation. And as we said, we activate guanyl cyclase, we increase cyclic GMP. This brings about a dephosphorylation of myosin light chain phosphate, preventing its interaction with actin. Now, when we form nitric oxide from a nitrate, we dilate particularly large veins, decreasing preload and therefore decreasing cardiac work. And if you're not working so hard, you don't need as much oxygen. So that's certainly a very, principal action of the nitrates in that regard. They are thought to do some other things as well. In addition to doing that, they increase blood flow through collaterals in the vasculature, into the heart, into the coronary vasculature. They'll decrease the vasospasm, and so this class of drugs can be used in vasospastic angina. And interestingly, there's a little bit of an effect to decrease platelet aggregation. It's not enough of effect that would be useful in the more severe acute coronary syndromes, but at least it's in the right direction. With high doses of the nitrates, you dilate the arterioles and therefore can decrease afterload. And once again, that will help out regarding cardiac work because you don't have to work so hard to get the effect. They decrease infarct size post-myocardial and also decrease mortality. Nitroglycerin would be one that I'd want you to identify. It comes in lots of shapes and colors, etc. Oral, sublingual, transdermal, IV formulations. Isosorbide dinitrate usually is the one that we think of as an oral agent for extended release. And what would you expect with the vasodilator? I'm hoping you will tell me flushing, headache, orthostatic hypertension or fainting, syncope. I'm hoping you will tell me reflex tachycardia and fluid retention, which obviously would be rather counterproductive. And it's for this reason that we sometimes actually use other drugs with nitrates. You see, a little bit of a calcium channel blocker might prevent the tachycardia, a little bit of verapamil, or a little bit of a beta blocker might do that. And so that's part of the rationale behind combinations. The adverse effects of nitrates, well, I'm not sure whether tachyphylaxis is an adverse effect, but it certainly is a limitation to their use. You should not use preparations that are present in the body for anything longer than about 10 hours. Anything that gets close to 12 hours or longer, is not appropriate. You need a rest period, at least half the day, where the drug is not present to retain responsivity. So once again, tachyphylaxis is like a tolerance, but it can occur rather quickly. You'll see some evidence of methemoglobinemia occurring, but actually it's more likely with nitrites than it is with nitrates. Amyl nitrite is a good example of a drug that can cause methemoglobinemia, and that's not really used anymore, but it used to be used for an acute anginal attack. Watch out for other vasodilators. That's my message to you, all right? Because you're getting quite marked vasodilation with these drugs, and excessive vasodilation from other drugs can lead sometimes to such a reflex tachycardia that you may get an arrhythmia and sudden death. The drug sildenafil fits that category perfectly. Here's our Viagra. How does Viagra work? Well, it inhibits an enzyme called phosphodiesterase 5, PDE5, which is in blood vessels supplying the corpora cavernosum, and in fact that's a rather selective but not completely selective action. When you inhibit PDE5, you increase cyclic GMP. That leads to vasodilation, blood flow increases, and this increases erectile response. However, if used with nitrates or other potent vasodilators, you're going to get an excessive fall in blood pressure. So there have been very many warnings about the use of sildenafil in patients taking nitrates or other vasodilating drugs because of sudden death occurring, presumably through either an arrhythmia or a myocardial infarct. So I'm getting in two strikes here. I'm reminding you about the problem in a clinical sense, and since this is the only time I'm going to mention phosphodiesterase 5, now you know where phosphodiesterase 5 fits into pharmacology. It fits in with Viagra. Cyanide poisoning is not really a topic of, managing angina, but you should at least know that cyanide poisoning is treated with nitrites. What happens is that you want to prevent the cyanide binding to the components of the electron transport chain. So what you do is you convert hemoglobin to methemoglobin purposely, because methemoglobin really loves the cyanide ion, and it grabs a hold of the cyanide ion to cause the formation of cyanomethemoglobin. So it's better to form that than it is to stop respiration in terms of complexing with compounds that are important for electron transport. You then convert the cyanomethemoglobin back to methemoglobin by using a thiosulfate, and this forms the less toxic ion thiocyanate. And we mentioned thiocyanate as being a breakdown product, didn't we, earlier, of nitroprusside. It is less toxic than the cyanide ion. So I suppose the sildenafil and the cyanide poisoning could be looked at as really, little sidebars in our mind, but they are relevant to nitrates. Here's the mechanism of smooth muscle contraction. What we see here is that we have an entry of calcium through an ion channel, which can be influenced by a variety of receptors. Calcium enters the cell, interacts with calmodulin, and the complex converts myosin light chain kinase in its inactivated form to the activated form. This then acts on the substrate myosin light chain to phosphorylate it, and it's the phosphorylated form of myosin light chain that can interact with actin to bring about a contraction. So I think you can fairly obviously see here that if in the production, for example, of guanyl cyclase activation, you are going to end up making more of the nitric oxide, as you do here, that this would in fact have an effect to cause dephosphorylation of myosin light chain phosphate, and if it's in the dephosphorylated form, it can't bind to the actin. You also see in this slide then the role of cyclic AMP in terms of beta-2 receptor activation, causing phosphorylation of myosin light chain kinase. And in the slide you also see what would happen with a calcium channel antagonist. Since the whole business of contraction involves calcium entry to bind to calcium calmodulin, if you plug the ion channels that let calcium through by using a calcium channel antagonist, then how are you going to get a contractile event? You can't get it. So the diagram's good for several purposes here, and I think it would be a good review for you. As far as the CCAs are concerned, the CCAs, when used in the management of angina, are presumed to simply block, the movement of calcium through these ion channels. And as I've just described, the words here are pretty much what I've said regarding how this influences the myosin-axin interaction. We can block the vascular L-type calcium channels, and that's important in terms of vasodilation. Arterioles are more sensitive. That will decrease afterload. That decreases cardiac output. You don't need as much oxygen if you're not doing as much work. All right? Those drugs then would also actually have the ability to decrease vasospasm. So we already talked about the calcium channel antagonists in terms of their side effects when we were dealing with hypertension. So I would suggest you refer back to that section if you want to remind yourself about the adverse effects here. Just for the record, let me tell you that nifedipine is vascular selective. Once again, it's a dihydropyridine, but verapamil and diltiazem are not so selective because they will block calcium channels in the heart and decrease cardiac output by that mechanism, again decreasing the requirement for oxygen. One drug in this family, bepredil, dilates coronary vessels. That's a very distinctive property. There aren't that many of them will do that. It's nominally classified as a calcium channel blocker, but notice it also blocks sodium and potassium channels. So it does more than simply block calcium channels in the smooth muscle. Lastly then, in the area of the treatment of angina, we have beta blockers. Now, beta blockers don't do anything to the vasculature because I told you that, if they did anything, they would probably oppose actions on beta receptors, but they really don't do that. So mostly we think they're working at the level of the heart to decrease cardiac output, decrease oxygen requirement by that mechanism. They're prophylactic rather than useful in an acute attack. They're not much good in vasospastic angina, for example, but they do offset reflex tachycardia caused by the nitrates. You see, you can't get a tachycardia in the presence of a beta blocker. One of the beta blockers, carvedilol, which is fairly recently introduced, happens to have fairly good activity as an antianginal agent by itself. It's been shown to be equivalent to isosorbide dinitrate, which would be one of the drugs for which we compare other agents in the management of exercise-induced angina. What about unstable angina, this life-threatening condition? The usual drugs that we've already talked about that we might use here are nitrates with beta blockers. Calcium channel antagonists have never been shown to improve outcome in these rather severe situations. You certainly are going to need oxygen, and that would be part of the pharmacological management. You also got the problem of clotting, of coagulation, platelet aggregation. And so we use anti-clotting drugs like heparin and warfarin and antiplatelet drugs like aspirin and ticlopidine. The last step in platelet aggregation is a cross-linking reaction that involves a particular receptor called the glycoprotein 2B3A receptor. And in the last 2 or 3 years, we've seen the introduction of 3 drugs that can inhibit that receptor. One of them is a monoclonal antibody called Mbbs. One of them is a snake venom derivative called eptifibatide. These are drugs that have just come into use in the area of acute coronary syndromes, but they could be part of the management of unstable angina. Renal pharmacology, particularly that concerning the actions, the clinical uses, and the adverse effects of the diuretic drugs, is highly tested on examination. So our next section would represent high-yield material. We discussed the main drugs used in the treatment of hypertension and in congestive heart failure, but at the time we did that, we said that diuretics are used, but let's wait a little while before we get to the actions of diuretics. Well, we're going to do that now, and I'd like to start off by asking you to consider the variety of clinical uses that diuretics have. We already know that they can be used in the management of hypertension and in patients who suffer from congestive heart failure. Certainly by removing fluid from our bodies, they would be useful drugs in the treatment of a variety of edematous states. They have value in renal dysfunction. They're useful in certain electrolyte disturbances, most notably hypercalcemic states. They can be useful in renal stones. They're used in the treatment of nephrolithiasis. They can go beyond the kidney, of course, by virtue of being useful in ocular dysfunction, including open-angle glaucoma, and even can reach the heights of being useful in mountain sickness. So we can see that while we talk about renal pharmacology, we're often actually talking about indications for these drugs that are thought to work, at least largely at the level of the kidney, in applications that perhaps are non-renal. Now, we'll focus on renal function, and to start off, we remind ourselves from renal physiology of the relative proportions of sodium that is filtered through the glomerulus in terms of the reabsorption of that iron at levels of the different parts of the renal tubule. Most sodium is reabsorbed at the level of the proximal convoluted tubule, or the PCT. Well over 60% of sodium filtered gets back into the blood at that level of the renal tubule. As we turn the corner, as it were, we descend the loop of Henle and begin to come up the thick ascending limb. At the region of the thick ascending limb, we reabsorb perhaps a quarter of the total amount of filtered sodium. So we say that the TAL is about 25%, perhaps a little less, of total sodium reabsorption. Reaching the distal convoluted tubule, the DCT, maybe 10% of sodium's reabsorbed there. And finally, when we actually get to the collecting tubules, we usually think of something less than 4% of sodium reabsorption takes place there. We need to know this really, because what we're going to see is that any time we interfere with sodium absorption before you get to the collecting tubules, you're actually putting a load of sodium on the mechanism for reabsorption towards the end of the tubule. One of the problems that you get when you use drugs that work above the level of the collecting tubule is, of course, that by imposing a large sodium load at the level of the sodium channels in the collecting tubule, you tend to lose potassium. So what we can almost say is that thiazide and loop diuretics are likely to lead to hypokalemia. In addition, those two classes of drugs actually also lead to a loss of hydrogen ions, and this makes the patient alkalotic. So loss of potassium, loss of hydrogen ions is to be anticipated with any drug that interferes with sodium absorption upstream, as it were, from the collecting tubules. This is a downstream event that takes place that leads to hypokalemia and alkalosis. Now, if we look at the overall diagram of the renal tubule, I can use this as a sort of a starting point to say what we're going to do in terms of consideration of the different regions of the tubule as far as sodium reabsorption is concerned. For example, here's your glomerulus and here's your proximal convoluted tubule. This is where we reabsorb the bulk of our sodium at this level, and this is a target, this region here, for carbonic anhydrase inhibitors. You see, we're applying our pharmacology now to the renal physiology situation. So this is a target then for drugs like acetazolamide that can inhibit sodium reabsorption by their action on enzymes present in the proximal convoluted tubule, both on the lumen side, or the membranous side of the lumen, and also inside the cell. As we go down through the thin descending limb, drugs that work here and also in the proximal convoluted tubule include the osmotic diuretics, because both the PCT and the thin descending limb is a site of water reabsorption, and osmotic diuretics impede water reabsorption. So at least 2 of the 3 sites of osmotic diuretics like mannitol occur here, either in the PCT or in the thin descending limb of the loop of Henle. As we begin to come up the thick ascending limb of the loop of Henle, we have about 20 or 25% of our sodium reabsorbed, and this is the target or the site of action of the loop diuretics. It's easy to remember because if we say thick ascending limb of the loop, then that already says that the drugs that are called loop diuretics are probably going to be working here. So they can be very potent diuretics, because even though perhaps only a quarter of the sodium is reabsorbed here, that can have a significant impact ultimately on the clearance of sodium and also water from the body. When we reach the distal convoluted tubule, where we said perhaps 10% of our sodium is reabsorbed, this is the site of action or the target for the thiazide diuretics. And they can have actually rather significant diuresis as well, and although not as potent as the loop diuretics. And then as we begin to turn the last corner, as it were, into the collecting tubules, this is where we actually reabsorb only a very small quantity of sodium, although this is a site which actually determines the final sodium concentration in the urine. It's also a site where we actually regulate both hydrogen ion concentration and potassium ion concentration. And as we said, this can be impacted upon by any drug that works upstream. This is the site of action of the so-called potassium-sparing drugs, drugs like spironolactone, the aldosterone receptor antagonist, drugs like amiloride, which actually block the sodium channels on the luminal membrane of the cells in the collecting tubules. So just to go back over it again then, the drugs that work at the level of the PCT are the drugs that inhibit carbonic anhydrase. We also will have osmotic diuretics working at this level. Osmotic diuretics will also work at the thin descending limb. The thick ascending limb of the loop of Henle, we have the actions of the loop diuretics. The distal convoluted tubule, we have the actions of the thiazide diuretics. And as we go into the collecting tubules and collecting ducts, this is a target for the potassium-sparing drugs, and also is a target for the osmotic diuretics, because water is also reabsorbed at this part of the tubule. So that should set the stage then for our consideration of the individual drug groups. And we'll start off at the beginning with the drugs that work at the level of the reabsorption of water. Osmotic diuretics, of which I think only one of them needs to be remembered by name by you, mannitol, they will actually inhibit water reabsorption at any of the sites. And so we've said PCT, that's the main site, the thin descending limb, and when we get round the corner, final corner, to the collecting ducts. So know where the actual osmotic action takes place. They're going to increase urine volume, because if water is kept in the tubule, then that actually will increase how much urine you have. So they're useful in patients who have anuria. They also are useful in patients who, for one reason or another, have had the breakdown of red blood cells leading to hemolysis, or the breakdown of muscle leading to rhabdomyolysis. And you can also use the osmotic diuretics to facilitate the elimination of certain toxic drugs that are normally cleared by the kidney. You can actually get them to go out faster from our body if you use an osmotic diuretic. One good example for you would be the anti-cancer drug cisplatin. Cisplatin is very renotoxic and also ototoxic, and it's quite common to see when you put a patient on cisplatin that you actually would also use mannitol to facilitate the elimination of cisplatin from the kidney. Now, the osmotic action of osmotic diuretics is not simply confined to the kidney. Anywhere that mannitol goes, it will tend to draw water towards it. That's the whole process of osmosis. So it can draw water out of tissues and out of cells. For example, it can decrease both intraocular and intracerebral pressure, and it has applications in that way. Because of its ability to draw water out of cells, it can sometimes actually cause fluid accumulation. For example, in pulmonary edema, it may make things worse by actually drawing water out of cells. Side effects of the carbonic anhydrase, of the osmotic diuretics, I largely like to think of nausea and vomiting and chills as being the most likely side effects. It's a difficult drug to give, mannitol. You've got to give it parenterally, and that means that it isn't something that you can easily walk around taking. Any time that you have to inject a drug means that you're not going to be using it in any chronic fashion. It may actually cause hypovolemia, and some patients complain of chest pain. So even though these drugs work at sites other than the proximal convoluted tubule, I think if you focus on their osmotic properties at 3 levels, that would be enough, I think, on the osmotic diuretics. Now, while we're in the proximal convoluted tubule, we have to also focus our attention on the drug group called carbonic anhydrase inhibitors, of which acetazolamide is probably the most well-known one of this class, and that would be certainly a name I would suggest you keep in mind. Now, in order to discuss this, I have to first remind you that the enzyme carbonic anhydrase is present both on the luminal membrane of the proximal tubule cells and is also present within the cells themselves. And it's an enzyme that is rather interesting because it can catalyze reactions in both directions. For example, the enzyme on the luminal membrane can take carbonic acid, H2CO3, and convert it to carbon dioxide and water. And the carbon dioxide, which is freely permeable, as is water across the membrane, can enter the cell. However, within the cell, carbon dioxide and water can be converted back to carbonic acid by the action of carbonic anhydrase, and that breaks down to form the bicarbonate ion and hydrogen ions. So this is an enzyme that can work in both directions. It's very important that you know this because this is the major site whereby we reintroduce bicarbonate ions back into the blood after they've been filtered through the glomerular apparatus. Our bicarbonate, of course, can be readily filtered, but fortunately, when we add a proton to the bicarbonate ion to form carbonic acid, we can actually bring the bicarbonate back in, but not in a bicarbonate form, but having to go through carbon dioxide first to get it back. So this is the important feature of carbonic anhydrase in terms of renal function. Now, what's the important feature in terms of sodium? Well, it turns out that there is a sodium hydrogen ion antiporter on the luminal membrane, so that as hydrogen ions or protons are made by the action of carbonic anhydrase, those hydrogen ions are exchanged for sodium, which is brought into the cell, sodium also being filtered through the glomerulus, and this is our way of getting back most of our filtered sodium. So hydrogen ions go out, sodium ions come in, and then on the other membrane, the basolateral membrane, we actually get a exchange of sodium for potassium using the pump, the sodium-potassium ATPase. So what we are seeing here normally is activity of carbonic anhydrase that is bringing back bicarbonate into the blood and bringing back sodium into the blood. That's the normal situation. So what happens when we inhibit carbonic anhydrase? Well, I think you can see that if you inhibit carbonic anhydrase on the luminal membrane, you can't form carbon dioxide. And since you can't bring in bicarbonate ions by any other means than forming carbon dioxide, what's going to happen? The bicarbonate ion is going to continue down through the tubule and it's going to end up in the urine. And that's called bicarbonaturia. So we're going to lose bicarbonate equivalents. Now remember this, bicarbonate is an alkaline equivalent. It's a basic type of equivalent. And therefore if you lose bicarbonate as bicarbonaturia, then you're very likely to become acidotic. And that indeed can occur. So you're going to lose your bicarbonate ions, and then, of course, by inhibiting the carbonic anhydrase at the level of the cell itself in the cytoplasm, you're going to decrease the formation of hydrogen ions or protons. And since you need those protons to exchange with sodium by the sodium proton antiporter, then you can't bring sodium back in either. So you've lost your bicarbonate and you've lost your mechanism by which you bring sodium back into the cell so that it can get back into the blood by the pump, the sodium-potassium ATPase. So carbonic anhydrase inhibitors then are going to have a major effect on sodium reabsorption and a major effect on bicarbonate reabsorption into the blood. So by looking at the diagram, we can not only see the physiology, as it were, of the action of carbonic anhydrase, but you can see the pharmacology. So the target then for the carbonic anhydrase inhibitors is a dual target. It's still carbonic anhydrase, but it's actually carbonic anhydrase at the level of the luminal membrane and carbonic anhydrase at the level of the cytoplasm. Now, having described the mechanism, you should know a little bit more about this class. I always put mechanisms high priority in the area of diuretics, but you need to know a little bit more. I think if you knew acetazolamide, that would probably be enough, but we have also mentioned in autonomic pharmacology the action of dorzolamide. Dorzolamide is a drug that we talked about when we were looking at the management of open-angle glaucoma. In either case, both of these drugs inhibit carbonic anhydrase, so that's going to lead, obviously, to a decrease in intracellular bicarbonate and hydrogen ions, and because of that inhibition of carbonic anhydrase, you'll end up decreasing sodium reabsorption. So the statements here in this slide pretty much describe what I've said for you by looking at the diagram. Bicarbonaturia is going to occur, and that's going to present, because of the effect on sodium reabsorption, a major load of sodium downstream. And I'm going to repeat myself again now. Anytime you have sodium load downstream, you are likely to lose hydrogen ions. When you get to the collecting tubule, you are likely to lose potassium ions. So hypokalemic alkalosis is a very likely event under normal circumstances. In the case, of course, of carbonic anhydrase inhibitors, since they lose bicarbonate ions, you can't really become alkalotic because you're losing alkaline equivalents, but you certainly can become hypokalemic. The clinical uses then of carbonic anhydrase inhibitors, largely I think the most important use actually is in the treatment of glaucoma, which has very little to do with the kidney. Carbonic anhydrase is present in the eye and is needed to form aqueous humor. And in glaucoma, of course, the increased intraocular pressure can be relieved if you can interfere with the synthesis of aqueous humor, because that decreases the volume, which in turn decreases the pressure. So I would certainly know, that this is of an important clinical use. We use the carbonic anhydrase inhibitors in mountain sickness. Does apparently decrease the likelihood of problems occurring, both prophylactically and in management, particularly in terms of the effects centrally. We use the carbonic anhydrase inhibitors when we want to make things acidotic. When we want to bring things from the alkaline towards the acidotic, such as in metabolic alkalosis. And we can also use pH of the urine when we're trying to eliminate acidic drugs, like, for example, aspirin. By changing the pH of the urine, what are we doing? Bicarbonaturia is essentially making the urine pH alkaline, and when you make the pH alkaline, you actually can get rid of acidic drugs more readily because you're forcing them into the ionized state. And remember, ionized forms of drugs do not readily get reabsorbed across the renal tubule. We mentioned that you're likely to see acidosis if you lose bicarbonate. That's fairly straightforward, I think. I've already told you that you can lose potassium ions by presenting a large sodium load downstream. We're also going to lose the chloride ion as well because of the influence of the effect on carbonic anhydrase. Loss of sensation in the extremities has also been reported for carbonic anhydrase inhibitors, and the hypercalciuria and phosphaturia that has been seen as well may be, I would say, predisposing towards the formation of renal stones. So carbonic anhydrase inhibitors is certainly worth reviewing. I would say, however, that I would put more emphasis overall on both loop diuretics and thiazide diuretics for examination purposes. So where we are now then in the next figure is in the thick ascending limb of the loop of Henle. We have the luminal membrane once again on the left-hand side and the basolateral membrane on the right-hand side, and we have the target for loop diuretics with an arrow pointing towards it on the luminal membrane. This is a co-transporter. It's an interesting co-transporter because at the same time as it's bringing in sodium and potassium, it's bringing in chloride ions. And so it brings in 2 chloride ions and 2 positively charged ions at the same time. So this brings chloride, potassium, and sodium into the cell. Now, under normal circumstances, without using drugs, for example, the sodium that's brought in is actually then a substrate for a co-transporter with chloride ions on the basolateral membrane, and we bring sodium back into the cell partly by that mechanism, back into the blood partly by that mechanism, and also partly by the pump, the sodium-potassium ATPase. Now, as potassium comes back, into the cell through the pump mechanism, it gets back into the blood by passive diffusion, but some of the potassium actually leaks back across the luminal membrane, providing, since it is positively charged, a positive potential on the luminal membrane. Now, very interestingly, this positive potential drives the reabsorption of magnesium and calcium through the spaces between the cells. So under normal circumstances, this would be one of the sites by which calcium and certainly magnesium can be brought back into the blood. Now, what's going to happen if you inhibit this co-transporter, which you do with loop diuretics such as furosemide or ethacrynic acid? Well, you're not going to bring potassium back into the cell, just as you're not going to bring sodium or chloride ion into the cell. And because of that, you get less back diffusion of potassium across the luminal membrane. With less back diffusion, there is less of a positive charge on the luminal membrane. Therefore, there is less driving force for the reabsorption of magnesium and calcium. So actually, the action of loop diuretics is not just confined to inhibiting reabsorption of sodium. That's certainly one of the important properties that it has. But by effects on potassium reabsorption, it actually also impacts on the reabsorption of the divalent cations, magnesium and calcium. So we might predict then that we would find magnesium and calcium in the urine if we impede its reabsorption at this level, just like we would probably find potassium and sodium and chloride ions in the urine if you're not bringing them back into the cell by the co-transporter. So that is the mechanistic aspects of the action of the loop diuretics. We can state them again. They inhibit the sodium-potassium 2-chloride co-transporter, and this is at the thick ascending limb, the luminal membrane of the thick ascending limb of the loop of Henle. As we said, normally sodium reabsorbed there is brought back into the blood by the activity of the sodium-potassium ATPase, but the potassium back diffuses to provide the positive charge on the luminal membrane that is needed to bring in magnesium and calcium at that level of the tubule. When you inhibit things, then you stop this type of back diffusion, and that then leads to a decrease in the reabsorption of magnesium and calcium. Like any of these different diuretics that block sodium reabsorption upstream, you are likely to lead to a load of sodium downstream at the level of the collecting tubules, which in turn is going to lead to the loss of hydrogen ions. Therefore, losing hydrogen is going to make you alkalotic, and the loss of potassium ions, which is going to make you hypokalemic. So if we were looking at urine levels of electrolytes, what we would find with a loop diuretic is an increase in sodium, with an increase in potassium, an increase in calcium, an increase in magnesium, and an increase in chloride ions. Why am I stating this in this way to you? I'm stating it in this way because it's not unusual for you to have to look at data that concerns urinary electrolyte levels and make some judgment about what drug could cause those changes in urinary electrolytes, either identifying it by name or perhaps identifying it by mechanism of action, or perhaps even where the action occurs within the renal tubule. So you can see there's a sort of a method in my madness here. The primary loop diuretics are the two drugs furosemide and ethacrynic acid. These are interesting drugs really because they can be actively secreted at the level of the proximal tubule into the lumen. And that sounds like a fairly good idea because you see they're going to inhibit a luminal membrane transport system. And so they would be at high concentrations in the lumen because of this active tubular secretion, which coupled with the filtration gives you a fairly high level within the urine of these particular drugs. They're used particularly in, as is by the way, hypertension. In many cases one can use low doses of a loop diuretic and actually have the same beneficial effect in terms of getting rid of water and sodium as using a moderate dose of a thiazide, in which case the loop diuretic might be more suitable because it may have less adverse effects. Any state where we have a high blood level of calcium, I'm thinking here perhaps of patients who have been treated for cancer where many cells might have been killed by chemotherapeutic agents or by radiation. What happens when you kill a cell? Well, you're going to release calcium, and so it's very common to see hypercalcemias in those situations. How do you get rid of the calcium? Infuse furosemide, and if you do that, of course, you can't bring calcium in across that particular part of the lumen membrane. So certainly these are very common and standard uses of the loop diuretics. What goes wrong? Well, loop diuretics have a structural relationship to sulfonamides, and so that might clue you into thinking that there could indeed be allergic reactions to the loop diuretics. They do occur, but not as commonly as you might think. I would say that you must know about alkalosis, and of course you should, by virtue of sort of understanding about this business of a load downstream. You should recognize that the patient is likely to become hypokalemic, and remember that when we discuss digitalis, one of the problems with digitalis concerns the blood levels of potassium. Hypomagnesemia, this is certainly something that you keep in mind. Low magnesium levels in the blood again enhance digitalis toxicity. Like sulfonamide drugs, the loop diuretics actually may increase the blood levels of uric acid. Now, you don't like to do that, particularly in a patient who has a history of gout or gouty arthritis. This may be a contraindication in those regards. They're very potent diuretics. Sometimes a really potent diuretic can get rid of so much fluid from your body that your blood volume goes down, and you may have resultant hemodynamic consequences of the hypovolemia. One property that I suppose is not particularly anticipated, but is certainly rather distinctive, is the effects on hearing, hearing imbalance, the ototoxicity. The worst offender there is ethacrynic acid. So if you're put into a position of deciding which drug of the well-known loop diuretics is most likely to do that, I think ethacrynate would be the one you'd choose. And recognize that the ototoxicity often is additive with other drugs that are ototoxic. So, for example, aminoglycosides, which are well-known, drugs like gentamicin, for example, which are well-known ototoxic drugs, would have enhanced toxicity if used in conjunction or combination with a loop diuretic. One of the actions of the loop diuretics is to increase the toxicity of lithium. We think that's largely by an effect to decrease the clearance of lithium, lithium being a drug that we use in bipolar affective disorder or manic depressive disorder. Now, having looked at the loop, now what we've got to do is get to the distal convoluted tubule, and we'll look at the next figure, which shows us where the target is for the thiazide diuretics. This is a sodium chloride cotransporter. It doesn't involve potassium reabsorption at this site, and under normal circumstances, we bring in perhaps 10% of our sodium at this level of the tubule. The sodium, as it's brought in, would be exchanged for potassium by the pump once again, and the potassium diffuses back into the blood down its concentration gradient. The chloride also does that. When it's brought in, it diffuses across the basolateral membrane in this fashion. Now, what I want you to see here is there is also at this level of the tubule ion channels for calcium, which are influenced by parathyroid hormone in terms of the synthesis of those components. Calcium runs down its concentration gradient into the cell through these channels and then is exchanged for sodium on the basolateral membrane. Now, that's the normal situation. So this is certainly part of the, well, at least part of the tubule that will reabsorb calcium. Now, under normal circumstances, one sees that the sodium that's being brought in would actually be capable of modulating the calcium-sodium exchange mechanism and therefore actually allow one to increase our reabsorption of calcium. If we are not bringing sodium into the intracellular space, then the activity of this calcium-sodium exchange mechanism is stimulated. And that means then that the intracellular concentration of calcium declines. Whenever that declines, then that allows for a greater concentration of gradient for calcium to come into the cell. So lack of sodium within the cell promotes the reabsorption of calcium by virtue of changing the activity of the sodium-calcium antiporter. And so instead of losing calcium in the presence of the diuretic, we gain calcium in the presence of this type of diuretic. This is completely opposite to loop diuretics. Loop diuretics prevent the reabsorption of calcium. Thiazide diuretics foster or stimulate the reabsorption of calcium. So it's very likely that the patient might become hypercalcemic because of that action. This is a very distinctive feature, as you would predict. Once again, by interfering with sodium absorption here, you're anticipated to give a load at the level of the collecting tubules such that you may get hypokalemia and alkalosis. So here's your mechanism stated. You inhibit the sodium chloride cotransporter at the level of the distal convoluted tubule. We've talked about the normal sodium exchange for potassium via the pump. Calcium diffuses across that membrane, the luminal membrane, regulated by parathyroid hormone, PTH, gets back into the blood by an antiporter. If you inhibit the cotransporter for sodium and chloride, you increase the luminal levels of those ions. This will ultimately lead to hypokalemia and alkalosis downstream. And we increase the activity of the calcium-sodium antiporter that facilitates the reabsorption of calcium, leading to hypercalcemia. So once again, if we were looking at urinary electrolyte levels, what would we anticipate seeing? we'd see an increase in sodium, increase in potassium because of the alkalosis, because of the effect of sodium downstream. We'd see an increase in chloride ions, but we should look for that decrease in the urinary levels of calcium. You can easily identify the difference between loop diuretics and thiazide diuretics by what happens to urinary calcium, and for that matter, what happens to blood calcium. Obviously, they go in opposite directions. So that's certainly a very key marker if you had to distinguish between the two types of drug. Now, there are lots of thiazides used clinically. Fortunately, in most examinations, they don't usually push you into a corner asking you which drug does which, but there must be a dozen or more different thiazides, and even more than that in combination with other drugs. The prototype thiazide is hydrochlorothiazide. I usually say to people, no, that one, and I also often add indapamide as another one because it's got some distinctive properties. Like the loop diuretics, these compounds can be actively secreted across the tubule. So once again, they will be at high levels in the urine, and that would seem appropriate since they're going to act on a transport system that is on the luminal membrane. The use of these thiazides is very widespread in the treatment of hypertension and congestive heart failure. One of the beauties of them, as it were, is that they've been proven to have long-term efficacy in many situations that concern hypertension, and in some situations for the congestive heart failure patient. They are used quite frequently in edematous states, sometimes in combination with loops. When used together, that's sometimes referred to as high ceiling diuresis. The edematous states associated with the pulmonary edema, nephrolithiasis. Nephrolithiasis, of course, is promoted by calcium in the urine. And if you decrease urinary concentration of calcium, then you decrease the likelihood of that type of renal stone. And the thiazides also have value in diabetes insipidus, where it's caused by resistance to antidiuretic hormone or caused by lithium-induced diabetes insipidus. Diabetes insipidus, characterized by polydipsia, polyuria. The side effects of the thiazides, I think you should know a little bit here. Again, they're related to the sulfonamide family, and therefore it's not to be surprising, I suppose, that you will get some allergic reactions. I expect you to be able to easily identify that you're likely to get alkalosis and hypokalemia. I think the message is getting through there. Hypercalcemia as opposed to the hypocalcemia with the loop diuretics. And here's another interesting thing for us regarding management of patients who are hypertensive. Do you recall when we were discussing the value of beta blockers? We said beta blockers work in hypertension, and they do have long-term efficacy in terms of decreasing the consequences of atherosclerotic disease. However, many of them actually change blood lipid profiles in the wrong direction. They increase certain of the bad lipids, as it were. Well, the same thing goes for thiazides. They've been shown to have long-term efficacy in hypertension. They decrease morbidity and mortality, but rather surprisingly, they tend to increase low-density lipoprotein cholesterol and triglycerides when used in a chronic fashion. Not all of them do this, and as you can see, one of my reasons for identifying indapamide is shown here, because that does not appear to occur with indapamide. But the traditional thiazides seem to be capable of causing hyperlipidemias. Many of the thiazides, and I suppose that's true of many drugs used in hypertension, can have effects on sexual function, decreasing libido, for example. Now, the last part of the tubule that we need to discuss is the collecting duct and collecting tubules. Here we have two cells. We have a principal cell and we have an intercalated cell. The principal cell luminal membranes have channels for sodium. Now remember we said that this part of the tubule is really like the final part of sodium reabsorption. Less than 4% of sodium normally comes in at this stage, running down its concentration gradient. the sodium-ion channel components are under the control of the mineralocorticoid aldosterone via its receptor, which can, when activated, can increase the synthesis of the components of the sodium-ion channel. Now, what happens under normal circumstances is that sodium coming into the cell is once again exchanged for potassium on the basolateral membrane by the pump, but there is also a change in terms of hydrogen ions and potassium ions at this level as sodium enters the cell. As sodium enters the cell, we see a loss of hydrogen and a loss of potassium ions. And in particular, the increased positive potential brought about by sodium in the cell actually drives potassium out. So here's your basis for the hypokalemia that might occur if you have a lot of sodium out here. Why would you have a lot of sodium out here? Because you interfered with its absorption upstream. So I think you could see what's going to happen here. As far as the intercalated cell is concerned, there's an energy-dependent proton pump that pushes hydrogen ions back into the lumen and actually controls our body pH, and also, of course, will be reflected in urinary pH at this stage. Carbonic anhydrase also plays a role here, although we don't generally think that the carbonic anhydrase inhibitors are having a striking effect at this level. They certainly can do that. So what happens when sodium comes in is that we lose a little bit of hydrogen ion here and certainly a certain amount of potassium ion here. Also, with sodium coming in, we increase the activity of this energy-driven proton pump, and so we lose some hydrogen ion there. Now, the extent of such loss depends on how much sodium is available in the luminal region to come in. And so, as I've said, if you've interfered with things upstream, more sodium comes in, therefore more hydrogen ion goes out, more potassium goes out, more activity of the energy-driven loss of protons. So, as I say, you're pretty much guaranteed to get hypokalemia and alkalosis with drugs that work upstream from the collecting tubule. What about drugs that work at the collecting tubule? Well, we have two types of drugs that work here. We have drugs that can actually plug this sodium-ion channel. Amiloride, triamterene are examples there. And we have drugs that can actually block aldosterone from stimulating the aldosterone receptor. And in both cases, of course, either by plugging the sodium channel itself or by interfering with the synthesis of the components of the sodium channel, sodium can't get in. So drugs that work at the level of the collecting tubule or collecting duct actually interfere with reabsorption of sodium by those mechanisms. Now, under normal circumstances, since less than 4% of sodium comes in there, you would anticipate that these drugs would not be very strong diuretics, because already 96% of your sodium is being reabsorbed earlier as far as the tubule is concerned. However, they do have a mild diuretic action in that regard. Perhaps more importantly, you should recognize that if you prevent sodium coming in here, then we do not lose as much of our hydrogen ions or our potassium. And that means that you tend to retain potassium. So instead of hypokalemia occurring, hyperkalemia may occur. And instead of losing protons, right, which leads to alkalosis, you will actually retain protons, which will lead to acidosis. So drugs that we think of as acting at collecting tubules, the so-called potassium-sparing agents, do the opposite to thiazides and loops in terms of potassium and in terms of hydrogen ions. And I think you can see by looking at the diagram how that comes about. We describe it now in words then. We've mentioned that the final sodium concentration in our urine and hence in our blood occurs by virtue of the action of the sodium ion channels in the collecting tubules. Normally this is controlled by aldosterone. And aldosterone stimulates the formation of the components of the ion channel. As sodium comes in, it changes the positive charge within the cell, and that tends to drive potassium back into the lumen. And as we said, sodium coming in increases the energy-dependent mechanism that extrudes hydrogen ions back into the lumen. That takes place in the intercalated cell. So when we're looking at the potassium-sparing agents, we've got either an aldosterone receptor blocker, spironolactone, or we've got the sodium channel blockers like amiloride. And in both cases, then, we're going to interfere with sodium reabsorption. Therefore, we're going to retain hydrogen ions, we're going to retain potassium, and therefore what we're likely to see is an acidotic condition and hyperkalemia. And so if you were looking at urinary concentrations of things, I think we might anticipate a very small increase in urinary sodium, rather marked decreases in urinary potassium and hydrogen ion, leading to hyperkalemia and acidosis. Potassium-sparing agents, then, I would identify spironolactone, amiloride, and triamterene in that regard. They're weak because, as I say, most of our sodium's already been reabsorbed. The uses of spironolactone are certainly very important in the area of hormonal pharmacology in conditions of excessive aldosterone. Preventing the action of the mineralocorticoid at its receptors would have a great deal of value. Sometimes we see spironolactone used along with other drugs in terms of their management of hypertension and congestive heart failure. You may recall that we said spironolactone used with ACE inhibitors actually increases survival rate in patients who suffer from congestive heart failure. Females who suffer from excessive hair growth, hirsutism, appear to have some value when they are administered spironolactone, which actually is not through its mineralocorticoid blocking action. It really just implies that spironolactone can also block androgen receptors. The uses of the sodium channel blockers are usually thought of as adjunctive to other diuretics, and the idea behind them is that since the other diuretics like loops and thiazides tend to cause loss of potassium, the use of a potassium-sparing agent should balance that. And it's important to remember, of course, that if a patient is already on a loop or a thiazide, they're probably taking supplementary potassium. And if they're then put on a potassium-sparing drug, they have to discontinue the potassium, otherwise they're at risk for hyperkalemia. We also use the potassium-sparing agents for lithium-induced diabetes insipidus. Amiloride is an example there. What can go wrong? Well, we said acidosis and hyperkalemia. That's certainly a possibility. The block of androgen receptors with spironolactone can lead to endocrine dysfunction, which includes gynecomastia, enlargement of the breasts, and also decreases in libido. And triamterene has been associated with nephrolithiasis. So if we look at the summary tables, we see that I've described for you in these tables the mode of action, or the primary mechanism of action, of each of the four primary classes of diuretic. I've shown you what might happen in terms of urinary electrolyte concentration and what happens in terms of blood chemistry that could be easily identified. And as we see, we can possibly identify a drug by name or identify a mechanism of action simply by looking at what's happening in the urine and sometimes by what's happening in the blood. So I thought if you saw it all together, this would be a very good summary for you. So on this particular slide, we have both the carbonic anhydrase inhibitor acetazolamide and our two examples of loop diuretics that I'd want you to know about. And then on the second part of the slide, we have the thiazides and the potassium-sparing agents. I suggest that you know the urinary electrolyte pattern, and as far as possible, of course, know the mechanisms of action. Drugs for Parkinsonism. Signs and symptoms of Parkinson's disease we already described. Bradykinesia, meaning decreased motion, decreased movement, muscle rigidity, postural instability, flat faces, tremor at rest. There are a number of them. This is really medicine more than pharmacology, but you should at least know some aspects of the diagnosis of the Parkinsonian state. Pathology, degeneration of the nigrostriatal tract so that we have unbalanced situations neurochemically in the striatum. Too much acetylcholine, not enough dopamine, so we have a sort of a negative balance there. Why do we get Parkinson's? Well, most times we have no idea why we get Parkinson's. We know that trauma to the brain can be associated with it. That's a possibility, but that's a fairly low incidence of Parkinson's. We know that sometimes chemicals can do that, but again, very low incidence. So most of the time, all we say is that, some of us are unlucky enough to lose those neurons. Most commonly, it's been in the 6th or 7th decade of life, but in some people it is earlier than that. So we really don't know why this occurs, but it's certainly is well known to be a neurochemical basis. The strategy is fairly obvious. Why don't we try and increase dopamine and get it back again if we possibly can? Or perhaps we can decrease acetylcholine's actions on muscarinic receptors in striatal neurons. In actual fact, you might be able to do both, and you might be able to use both types of strategy together. We do not really alter the course of Parkinson's disease by drug treatment. We improve symptomology and make things easier on the patient, but actually, ultimately, there is a time when the drugs are not going to work anymore, and actually, we really have not got a cure for Parkinson's disease at the present time. We've got drugs that can manage the Parkinsonian patient and make life a lot more reasonable. Here's a little cartoon of the situation regarding input into the striatum. The left-hand neuron, you may not think of much of my drawing, but the left-hand neuron is supposed to be a dopaminergic neuron that has its origins in the substantia nigra, and this is the nerve ending that's going to release dopamine here that will have an action on another neuron through a dopamine receptor. And it will be an inhibitory action, so I put a little negative sign in here. And we have another neuron, which is an acetylcholine-containing neuron, which is excitatory, and this is working on a different receptor, the muscarinic receptor, and I put a little plus in here to show you that that would be the normal activity that you'd get. Well, of course, if we've lost our dopaminergic neurons due to degeneration, then we've got too much acetylcholine coming in, exciting this neuron, which is probably, by the way, a GABA-containing neuron. So we talk about GABAergic transmission downstream from here, meaning involving gamma-aminobutyric acid. But we don't have any drugs that work on GABA that have been any use to us in Parkinson's disease. Now, on the left-hand side, though, what we can say is, look, possibly we could increase dopamine in some of the neurons that are left. Even though some of them are degenerating, maybe we can increase dopamine here. They tried to do that in the late 1960s with L-DOPA, and it did work, L-DOPA being dihydroxyphenylalanine, the immediate precursor of dopamine. Why can't you use dopamine? Well, it doesn't cross the blood-brain barrier. That's why you can't use dopamine. And also, dopamine is very toxic at high dose when it runs around in our blood. So we want to use the precursor molecule, L-DOPA, which does cross the blood-brain barrier, and if we're lucky, may form dopamine in these nerve endings, so that we have more released and therefore a greater dopaminergic transmission. Well, perhaps you could even bypass this neuron altogether. Maybe we can use some drugs that will just go straight to this receptor and activate it. The first of these drugs, dopamine receptor agonists, was bromocriptine. But now we've got several other drugs that we'll hear about that also will activate this receptor. They don't need the neuron. And you might imagine that these drugs should continue to work forever if you don't need the neuron, but that's not the case. You also run out of activity with these drugs in time, not in a day, not in a week, not in a year, but in a decade, very possibly. Right, item 3 here, selegiline. Now what's selegiline? Selegiline is an inhibitor of an enzyme called monoamine oxidase B, which is the enzyme that metabolizes dopamine. And that means if you inhibit this enzyme, you should increase presynaptic dopamine. And this is a drug that came into medicine in this country just 10 years ago or so, and it does have a value, and we'll see what that is in a few minutes, but I, at the moment, want you to know what the mechanism is. And then, of course, you could go on the other side here, and you could sort of plug up this receptor with a muscarinic blocking drug. And if you stick atropine or something like atropine on here, then it would make it very difficult for acetylcholine to activate it. And that might have some value in restoring the balance. And in fact, not might, it does have some value in restoring the balance. All right, why don't we take a look at some of the drugs and what their cardinal properties are. I'm going to start with drugs that increase dopaminergic function, and the most important of these is levodopa. L-dopa or levodopa is the immediate precursor of dopamine, which can cross the blood-brain barrier and therefore can get into the brain. And hopefully it gets into the nerve endings that are dopaminergic, where it can be a substrate for dopa decarboxylase, which, as you may recall, is an aromatic amino acid decarboxylase, certainly present in many tissues of the body. Now, because the enzyme is present particularly in the liver, we usually try to avoid metabolism of L-dopa in periphery by inhibiting that enzyme with a drug that can do it in the periphery, but which can't cross the blood-brain barrier. And that drug is carbidopa. So most times people use L-dopa in the Parkinsonian patient. They use L-dopa in conjunction with carbidopa. That increases the central nervous system levels of L-dopa and actually decreases the likelihood of peripheral side effects from L-dopa. It may enhance central nervous system effects, good and bad, but it decreases the likelihood of peripheral effects. What am I talking about in terms of peripheral effects? I'm talking about if you make dopamine in the periphery, your blood pressure is going to drop very markedly, and you're going to throw up because dopamine's an emetic. So you don't like that. So you try and prevent formation of dopamine in that regard. The trouble with L-dopa is it won't last forever. All right. Well, of course, that's not the only trouble. We've got side effects and all sorts of things. But it doesn't last very long, maybe 5-10 years at max, because I suppose one would imagine that continued degeneration of those neurons means that sooner or later you have very little nerve ending left. And that would mean that you can't even make dopamine in the right place if you have no nerve endings. One of the real serious troubles, of course, is dyskinesias, something like a 30 to 40% incidence of irregular muscle movements, making it very difficult for the patient to function. Remember, in Parkinson's, you have fully cognitive. You have no problems with that or understanding, but you have this physical difficulty, which is really very distressing, and it's not helped by irregular muscle movements. You will still get some drop of blood pressure because some of your L-dopa will get converted to dopamine in the periphery. Sometimes at really high doses the patient might get mental dysfunction, hallucinations, although psychosis is pretty rare. And there's a phenomenon called the on-off phenomenon, where within the space of a fairly short period of time the patient seemed to be capable of moving, and then just after a few minutes finds it very difficult to move. And that's been referred to as the on-off phenomena, and nobody really quite knows why this occurs, whether it's because there's some critical level of dopa needed in the neurons, or whether it's a matter of the receptors changing their responsivity. Nobody's very clear about that. So identify L-dopa as being certainly a first-line drug, an important drug. When I use the word first-line, that implies that I would use it first. Let me change that. Not a first-line drug, but an important drug used in Parkinson's disease. Now, what can we do to help out a little bit other than using carbidopa? In the last 2 or 3 years, we've seen 2 new drugs brought in. I think they're going to be called the Capone family, really, tolcapone and entacapone. And these are inhibitors of catecholomethyltransferase. I draw them to your attention because in all these years that we've known about COMT, we've never had a drug clinically available for inhibiting that enzyme until the past couple of years. So this makes it sort of a little bit distinctive. The idea is that some L-dopa gets metabolized in the periphery by catecholomethyltransferase. And if you can inhibit that metabolism, then you might increase L-dopa's availability for the central nervous system. That's true. I think that's a reasonable theoretical way of approaching things, but I should tell you already that there's some concern about these drugs, particularly tolcapone, because some patients have developed liver toxicity. So whether they end up having the real value that they should depends, I think, on how things evolve. Here's a little diagram showing you some of the steps of getting L-DOPA to do things for you in Parkinson's disease. If, for example, we imagine that these two horizontal lines represent the blood-brain barrier, we know that levodopa can cross the blood-brain barrier, and when it gets into the central nervous system, it can be converted by aromatic amino acid decarboxylase, dopa decarboxylase, to dopamine. It also can be metabolized in part in the central nervous system by catechol-O-methyltransferase, and tolcapone will inhibit that and possibly increase levels within the brain of L-DOPA. But the actual capone family was introduced largely on the grounds that it would work in the periphery. So I think the primary action is out here. So here's L-DOPA, can be metabolized particularly in the liver by the same enzyme that makes dopamine in the brain. And we're wasting all our L-DOPA here if it all gets converted to dopamine before it gets into the brain. And of course it will have rather marked effects here in terms of peripheral receptors. Carbidopa blocks the enzyme here, but won't block the enzyme in the central nervous system because carbidopa can't cross the blood-brain barrier. Levodopa is also metabolized by catechol-O-methyltransferase in the periphery, and the drug tolcapone and its relatives inhibits metabolism here. So there's your description, really, of why it is we're interested in carbidopa and why we may be interested ultimately in the capone family. Bromocriptine is the prototypic dopamine receptor agonist, although its usefulness is being questioned of late. Know it as a dopamine receptor agonist. It does cause a lot of side effects, marked dyskinesia, irregular muscle movements, a lot of central nervous system effects. It's an hallucinatory compound, can even cause psychoses that mimics the schizophrenic state. And a lot of neurologists now are suggesting that we push that drug towards the back of the shelf and bring forward 2 new dopamine receptor agonist drugs. So perhaps it is time for us to put those into our review. Pramipexole and ropinirole are now accepted by many neurologists in the United States as drugs that you might actually prescribe very early on in newly diagnosed Parkinsonian patients, perhaps before you even resort to levodopa. So they're seeing these drugs in that light, that the drugs may be of value very early in Parkinson's disease. So I do think we ought to keep our eye on that. They're not without their problems. One of the problems that we're seeing a lot of lately is central nervous system depression. It's not just as simple as that. You may get people falling asleep abruptly. And by that I mean, they were talking to you and the next minute they're not. They're out. And that doesn't sound like a good idea if you're doing anything important, right? If you're just listening to somebody rant on with a review in pharmacology, perhaps it won't matter. But if you're doing anything that's really significantly important regarding function, then it's not a good idea to suddenly fall asleep. So that may be a limitation to the usefulness of those drugs. I mentioned to you a little bit earlier that we don't now use bromocriptine for hyperprolactinemia. I'm only emphasizing it because in past examinations, when they've asked you what is the drug of choice for hyperprolactinemia, you would have answered bromocriptine. Now I want you to answer something different, pergolide, should you be asked that. Selegiline is the MAO inhibitor. It had been used in Europe at least 15 years before we ever got round to approving it in this country. It was evolved actually from Budapest in Hungary. They had designed an inhibitor of the enzyme that metabolizes dopamine to try and enhance the activity of dopamine in the brain. And it does seem to do that. It increases presynaptic dopamine levels. When we approved it in this country, we used it as a solo drug in early Parkinson's disease, like as a first step and so on. It still can be used in that fashion, or it can be used adjunctively with levodopa, etc. And long as you understand the general principle about how it's supposed to work and know about MAOB, I think you're probably going to be okay. MAOB does not metabolize tyramine. MAOA metabolizes tyramine, and so you will not see tyramine interactions with selegiline like you see with other MAO inhibitors. There's a little bit of fringe benefit out of selegiline. It breaks down to form amphetamine, and therefore you're getting a bit of a CNS stimulant effect when you're taking selegiline. That actually has ended up, of course, being a reason why the drug is abused. If you get anything that makes amphetamine, then you can see why people might like to use it and misuse it for that matter. Okay, what about the other side of the system, the cholinergic system? Drugs decreasing acetylcholine function. I would try and identify, if you can, 2 of the 8 or 10 drugs that are helpful in this regard. Benztropine is one of these, and trihexyphenidyl is another one of them. Why are they different from atropine? They're more lipid soluble, so they can penetrate into the blood, across the blood-brain barrier, into the central nervous system at lower doses. That means their peripheral side effects, although they are like atropine, would be less intense than atropine. Are they any good? Well, they do decrease the tremor and the rigidity of the Parkinsonian patient, but in iatrogenic Parkinson's, not iatrogenic, in Parkinson's disease that has an age-dependent relationship, they don't help very much in terms of the bradykinesia. In other words, they don't help in terms of movement. I had to change iatrogenic because that, of course, means physician-induced, and iatrogenic Parkinson's is really drug-induced Parkinson's. That's what I wanted to say. And we can use these drugs in drug-induced Parkinsonism, in physician-induced Parkinson's. We decrease EPS dysfunction caused by dopamine antagonist drugs. This is what I'm referring to in terms of what we might call iatrogenic. I may be a bit unfair on physicians in that regard, but certainly when one treats the schizophrenic patient with most of the older antipsychotic drugs, which are dopamine antagonists, you will decrease extrapyramidal system function. So recognize that these drugs will reverse that, so they'll decrease the dysfunction seen in the presence of dopamine antagonists. They actually exacerbate one of the things that we do get with dopamine antagonist drugs called tardive dyskinesias. I'll define and explain that to you when we look at the drugs for schizophrenia. Just keep at the back of your mind at this stage that muscarinic blocking drugs are not ideal in this regard. They will have atropine-like side effects. Now, amantadine is not really a drug that we would have classified as a muscarinic blocker, although it does have weak actions to decrease acetylcholine function in the brain. So we say possibly via muscarinic receptor block. Amantadine, you may recall, is an antiviral drug. This is the drug that works against influenza A. It was accidentally discovered in Parkinsonian patients to have at least partial activity in the Parkinsonian patient. It doesn't last very long, maybe a couple of months at most, but it's sometimes been used adjunctively for that purpose. It will have atropine-like side effects. This is amantadine, all right, and it does cause skin problems, including livedo reticularis. All right, that leads us then to the antipsychotic drugs. These are sometimes referred to as neuroleptics. Lepsis, again, meaning to take hold. So these drugs take hold of your nerves. And we use the terms interchangeably, actually. The older drugs, of which the parent molecule is chlorpromazine, were discovered accidentally in the late 1940s. And we didn't know for some time how they were exerting their actions. It became clear over perhaps 10 or 20 years that they were capable of blocking dopamine receptors, and this certainly is part of their pharmacology because you can make some, if you like, predictions about what is going to happen when you take an antipsychotic drug that's an older drug. Some of the newer drugs actually have very limited activity on dopamine receptors. By the way, the dopamine receptor that's affected most is the old D2 receptor, which we now call 2A. And those are the ones that are in the striatum. They're the ones that are in the anterior lobe of the pituitary, etc. Some of our newer drugs that have come in the last decade or so are not very strong dopamine receptor blockers, but I can block other neurotransmitter receptors. To some extent, they can block alpha receptors, and certainly the interest these days has been in serotonin receptor subtypes, most importantly, the 5-HT2A receptor subtype. So I sort of keep that at the back of my mind if I were you regarding possible questions about the mechanisms involved in newer antipsychotic drugs. Unfortunately, most antipsychotic drugs do not just simply block one type of receptor. They may block other receptors as well. Muscarinic receptors can be a target, adrenoreceptors can be a target, and they may even have some value as antihistamines, some of them, because they'll block histamine receptors as well. They are nearly always sedating, additive with other CNS depressants, and unlike most sedatives, where you imagine that if you calm someone down, you shouldn't really cause seizures, these drugs actually are associated in overdose with seizure formation. And so what we use as a phrase of this is they lower the seizure threshold. That means it's easier for a seizure to occur. Right? So when you ever see that term, lowering seizure threshold, think that seizures are more likely to happen. Which drugs then? We've got a lot of names here. I mean, no, we don't have a lot of names here, actually, because I'm actually cut so many of them out for you. There must be at least a dozen phenothiazines that you possibly could know, but I don't want you to know all of them. I want you to know chlorpromazine and thioridazine definitely, because we know that they like those drugs. If you can know some others, that's fine. Fluphenazine is fairly well known as a phenothiazine antipsychotic drug. I want you to know haloperidol. Different chemical structure, probably one of the most commonly prescribed of the older drugs, and certainly one of the most frequently asked about of these drugs. Under the newer drugs, I like clozapine, which has certainly got some rather interesting properties, and perhaps olanzapine would be another good example of a newer antipsychotic drug. These drugs are listed in table 4.8 in the text, and so you can examine them there and see what other properties that I consider to be of some importance. When you antagonize dopamine receptors, you're going to get a lot of effects occurring. And therefore we ought to know, first of all, which drugs are the strongest at blocking dopamine receptors and what's going to happen when you do that. If I were to put in order which is the most potent as a blocker of dopamine receptors, I would have to put that with haloperidol. Haloperidol is the most likely of any of the antipsychotic drugs to actually block these receptors. Pimozide comes second, then the high potency phenothiazines. Drugs like fluphenazine, for example, trifluperazine are high potency phenothiazines. Now, what are you going to get when you block those dopamine receptors? Well, as far as the extrapyramidal system is concerned, you're going to get pseudo-Parkinsonism, right? Slowing of movement, bradykinesia, rigidity, and tremor. As far as other dysfunction, you may get uncontrollable restlessness, akathisia, sit down, stand up, pacing, back and forth, back and forth. This is another extrapyramidal dysfunction. And thirdly, it is possible, particularly early in treatment, certainly in young adult patients, particularly the male, one may get acute muscle cramping, acute dystonias. Now, all of these effects are reversible. And how would you reverse them? Well, you could lower the dose, I suppose, if you're suffering from pseudo-Parkinsonism or perhaps from akathisia. That may not be good enough if you happen to have a savage muscle spasm that is causing great pain. You may have to do something else there. You could change to a different drug. They are different, especially a newer drug. If you can afford a newer drug, then you may escape these dopamine receptor antagonism. And that's a possibility. Or you could add a muscarinic blocking drug to the regimen. Now that means then that you've got more than a single drug on board here in the management of the patient, but perhaps you would wish to do that. And drugs like benztropine, etc., trihexyphenidyl have certainly been used in that regard. Now, that would be effects that you would be able to handle perhaps a little bit more leisurely, but you won't handle acute dystonias leisurely because the patient is probably screaming. These are muscle contractions that can sometimes twist you up almost like a pretzel, and they're in any part of the body. They're not restricted to any particular place. They can be in the back of the neck. They can even be in the external eye muscles, which can be extremely painful. So what you've got to do there is give something that can handle it quickly. Usually as a drug, drug that has muscarinic blocking properties, but it should be given in a parenteral fashion. You see, because spasms in the throat, they stop you from swallowing anything, and you want this on board as quickly as possible. Diphenhydramine has been used, even though it's an antihistamine. It's a strong muscarinic blocking drug. Benztropine would be a possibility as well. Now, we've talked about those extrapyramidal dysfunctions as if all drugs cause them. That's not the case, all right? There is a big variance. I would pick as my top drugs that don't cause such dysfunction both clozapine and olanzapine, and that's part of my rationale for asking you to know those two names. It's not the complete rationale, but it's part of it. Now, what about if you block dopamine receptors in the pituitary? Well, you know what's going to happen there. You're going to increase prolactin. You're going to have hyperprolactinemia as the side effect. That's going to lead to gynecomastia, amenorrhea, galactorrhea, and libido changes. Libido changes in the male are usually down. Libido changes in the women are quite commonly up. But in any event, there are things that you don't particularly want. Now, there's another thing that happens with chronic use of antipsychotic drugs, and that is something called tardive dyskinesias. Now, TDs, as they're sometimes abbreviated to, simply are late occurring, tardy, if you like, irregular muscle movements. These are not like Parkinson's disease. These are much more like Huntington's chorea, actually, because they present as chorioathetoid-like muscle movements, little writhings of the musculature, particularly of the face and the lips and the tongue, and they lead to smacking movement, smacking sounds, etc., tongue profusions, these types of side effect, which are really quite unpleasant and actually debilitating. They occur with long-term use of older dopamine receptor blocker drugs, especially haloperidol and fluphenazine. I picked those two as being the bad offenders here, although it's not restricted to only those drugs. Even some of the newer drugs have been reported to cause tardive dyskinesias. Now, the trouble with them is they don't go away when you take the drug away. They're not readily reversible, and in fact, they may not be reversible at all. In addition, we don't have any drugs that make it better. So you're stuck. Once you've got it, as it were. And muscarinic blocking drugs actually make things worse. So once again, you can see why I like you to identify clozapine and olanzapine. They don't seem to cause this. Now, you've got to remember, by the way, that the cost of clozapine and olanzapine is somewhere between $200 and $300 a month to the pharmacist, which may be more to the patient, whereas the cost of haloperidol to the patient, to the pharmacist, is about $1.75 per month. So there's a very big fiscal impact of moving towards the drugs that don't cause permanent extrapyramidal dysfunction. But you know what you would prefer. Specific features of antipsychotic drugs, well, the neuroleptic malignant syndrome should be in that category. This is very reminiscent of what we described earlier in terms of the malignant hypothermia that we saw with using anesthetic molecules with skeletal muscle relaxants. Again, it presents as a muscle rigidity, a hypothermia, cardiovascular instability. There's often an altered level of consciousness, and in fact, this appears to be due in these rare cases to patients who have an inordinate sensitivity to blockade of their dopamine receptors. When it occurs, it usually occurs early in therapy, and there's no prediction of if it's going to happen. Fortunately, it's not that common. I don't know what the numbers are, but perhaps in the 1 in 30 or 40,000 patients you might see this, but it can be life-threatening when it does occur. The way you manage it is largely symptomatic, but sometimes dantrolene is used, although there isn't any direct evidence that this is due to calcium release from the sarcoplasmic reticulum, but there certainly is muscle rigidity, so probably it's helpful, all right? And bromocriptine, the dopamine agonist, has sometimes been used as well, but it's largely a matter of controlling cardiovascular stability and also of lowering body temperature and doing your best to ease the difficult situation. The toxicity of antipsychotic drugs in a more general way would be really probably a mixture of pharmacodynamic effects in excess. For example, if a drug acted to antagonize muscarinic receptors, you'd see all of the symptoms that you'd see with atropine overdose. If a drug blocks alpha receptors, you'll see all of the things that you would get with an alpha blocker, like postural hypertension, like, for example, inability to ejaculate, these types of things. And so, you just manage them as best you can. There are two specific toxicities that are worth reminding yourself about. One is clozapine. Like all things, there's faults in everything. Clozapine, while it does not cause tardive dyskinesias or extrapyramidal dysfunction, is hematotoxic. It suppresses white blood cell formation, and when you use clozapine, you should be monitoring white blood cells and seeing whether or not they go down. And if they go down, then possibly you should stop, not possibly, you should stop administration of the drug, and it will not then progress to agranulocytosis. The wet pillow syndrome and weight gain are two other, much less important, but not much less significant. If you're using a drug to treat schizophrenia, then I think it's reasonable to expect that you might have to put up with certain side effects, because those side effects are far outweighed by the symptoms of schizophrenia. I think thioridazine, however, is a little bit more, if you like, selective or specific. Thioridazine, in addition to being a fairly strong muscarinic blocking drug and causing atropine-like side effects, and like any of the phenothiazine and older drugs can lower the seizure threshold, this causes problems in vision. There is pigmentation of the retina, and this pigmentation changes both visual acuity and also changes what you see. It's referred to as browning of vision, so that instead of seeing nice colors, you see the sepia tones, the browns and the shades of browns, etc. And it is not freely reversible. So this is an ocular dysfunction that is characteristic of one drug and one drug only in this family, and that is thioridazine or Mellaril. There is another property of thioridazine that's not shared by the other drugs as well, that are antipsychotics, but is shared by plenty of drugs, and that is cardiotoxicity. Quinidine-like action on the heart, prolongation of the QRS, prolongation of the QT interval associated with a torsade-like cardiac arrhythmia. And that's been seen with thioridazine. So this is a distinctive property. I always try and remind you about distinctive properties because, that's what people like. Clinical uses. Well, schizophrenia, of course, is a rather difficult thing. You know from behavioral science that this is a problem that has no cure. It has features of disordered thought processes, features of hallucinations, largely auditory hallucinations, changes in perception, for example. It has aspects of paranoia, aspects that are negative symptoms of withdrawal, etc. And this is a difficult situation. You can improve many of these symptoms, even with older drugs. Don't expect quick effects, though. This is not a quick-acting sort of pharmacology. Several weeks are usually required to make a judgment about whether the drug's going to be any good at all. And so you've got to try it out for a period of time. The newer drugs probably overall are at least equivalent to the older drugs for the positive symptoms of schizophrenia, and definitely better for the negative symptoms of schizophrenia. So obviously, once again, if you can afford it, you can see several reasons why you might want to choose one of the newer drugs, because they may be somewhat better than the older drugs in efficacy, and they certainly seem to have less side effects. So schizophrenia is certainly on the top of our list in terms of indications. States that are mixed states of schizoaffective disorder could also be an indication for antipsychotic drugs, as could be drug-induced psychoses. We often use antipsychotic drugs in patients who are brought in, say, with an overdose of something like phencyclidine and they're acting crazy, or amphetamine and they're acting crazy. And we often say, well, let's give them an antipsychotic drug parenterally. We've got to quieten them down, so we've got to put something in them to quieten them down. We're probably not getting an antipsychotic action in that fashion quickly. unlikely. I doubt that very much. It's mainly a sedative action. You probably could do the same thing by giving an intramuscular injection or an intravenous injection, preferably, of a benzodiazepine. That would probably quieten them down too. But nonetheless, we use the drugs in this way. Some of the antipsychotic drugs have value in other disorders, including Alzheimer's, like, for example, the delusions and, if you like, psychosis associated with Alzheimer's often responds to these agents. We're also using them in bipolar dysfunction to quieten a highly manic patient down. Once again, I don't think it's really a specifically anti-manic action. I think it's a sedative action, but still we use it. Outside of psychiatry and into neurology, the dysfunction called Gilles de la Tourette syndrome, characterized, by outbursts and swearing and things of that sort. Pimozide is now the drug of choice for the management of that particular function. We usually say Tourette's syndrome. Outside of the whole area really of neurology and psychiatry, we have preoperative sedation. Promethazine is used in that fashion, a phenothiazine that doesn't have much antipsychotic activity, but it's a pretty good muscarinic blocker, sedative, and H1 blocker for that matter. And then we mentioned a little earlier that prochlorperazine might be of value in terms of emesis, both drug-induced emesis and radiation-induced emesis. Now, this seems like an appropriate point, having discussed the different eicosanoids, to look at a family of drugs called the non-steroidal anti-inflammatory drugs, of which, of course, aspirin is our dominant drug. Now, there's always questions on aspirin on examinations, and so I want you to look at this as if this is a high-yield area. Most drugs in the family, however, are non-selective inhibitors of cyclooxygenases. In other words, they can't distinguish between cyclooxygenase 1 and cyclooxygenase 2 in terms of inhibition. So they're bound to have multiple actions on the synthesis of prostaglandins and thromboxanes in many tissues. I mean, obviously, they'll interfere with the role of prostaglandins in the GI tract to protect the lining of the GI tract. And therefore, obviously that would be a typical side effect. When we look at what we get out of inhibition of cyclooxygenases, the useful therapeutic properties include an ability to lower elevated body temperature, an anti-inflammatory action, an analgesic action, and antiplatelet actions, really, as well as much of the toxicity of these drugs seems to relate to inhibition of cyclooxygenases. Aspirin, as I said, is the prototypic drug. It's the only non-steroidal anti-inflammatory drug that brings about an irreversible inhibition of cyclooxygenase. Actually, the acetyl group in acetyl salicylic acid, ASA, is responsible for this. It actually is joined to the cyclooxygenase by a covalent bond at the point of a serine hydroxyl near the active site of the enzyme. And you can't break that bond very readily. You have to make new cyclooxygenase. That can certainly happen in most cells of our body, but it really can't happen in terms of the platelet because the platelet doesn't synthesize protein. So if you inhibit cyclooxygenase in a platelet using aspirin, you actually have inhibited that enzyme for the lifetime of the platelet, which is greater than a week. So the platelets cannot actually make thromboxane A2, therefore they're stabilized for that length of time. The actions of aspirin are dose-dependent. Low doses are certainly quite antiplatelet, and I suppose that you could say it's because of this irreversible action at a low dose to actually acetylate the enzyme. So this leads to a drop in the ability to produce thromboxane A2, and since thromboxane A2 is a platelet aggregant, when its levels are decreased, you are stabilizing platelets, preventing their aggregation, and there are many instances where you would like to do that, perhaps most famously the ability to be used post-myocardial infarct to prevent reinfarction and sudden death due to a thrombus formation. The analgesic actions of aspirin require what we would call a moderate dose, Not a high dose. You don't really get too much more analgesia out of aspirin at a high dose, but a moderate dose, which is usually thought of as 2 aspirin tablets, usually is thought to be brought about in terms of pain relief at the periphery. Prostaglandins appear to be sensitizers of pain receptors, and if you can interfere with their synthesis, you presumably then can decrease their likelihood of stimulating nociceptive pathways. They particularly actually seem to be involved in bradykinin responses and histamine responses. Histamine and bradykinin are both naturally occurring compounds that are capable of activating nociceptive pathways. And if you can interfere with that, then you've got yourself an analgesic action. On the other hand, lowering elevated body temperature, an antipyretic action, is probably more related to a central nervous system effect than anything else. Pyrogens, which are responsible for elevations of body temperature, increase not only prostaglandins, like prostaglandin E2, but also interleukins. Interleukins actually themselves have an ability to increase prostaglandin E2, and this then tends to change our temperature set point upwards. So instead of maintaining our normal body temperature in hypothermic conditions, fevers, brought on by pyrogens, then we increase the set point for our temperature control. By virtue of interfering with prostaglandin E2 formation, the action of aspirin, and possibly also of other NSAIDs, is to bring the temperature set point back down towards the normal situation. So antiplatelet actions then low dose, maybe even as low as a quarter or a half of an aspirin tablet. Analgesia and antipyresis, moderate doses, let's call that 2 aspirins, 600, 700 milligrams. Anti-inflammatory actions are generally seen most vividly when you push the dose. And we're talking here perhaps 4, 6 aspirin tablets at a single dosage, which is quite irritating to the GI tract, I'm sure you would expect. I think that most people believe that high doses of aspirin happen to inhibit probably more than usual cyclooxygenase 2, which is present in inflammatory cells. Certainly there are other actions of high doses of aspirin. We have inhibition, for example, of the formation of integrins and selectins, which are known to be involved in leukocyte adhesion. So this may go more than just simple interference with prostaglandin formation like it occurs in any cell in the body. This may be more directed to cells involved in inflammatory responses. So you can get more than you get out of an analgesia by increasing the dose as far as, decreasing inflammatory responses, which are responsible for pain. But you will have to pay the penalty with aspirin of marked side effects, including gastrointestinal ones. Aspirin has an unusual action on uric acid elimination from the body. Low doses of aspirin actually decrease tubular secretion. That leads then to the raising of blood levels of uric acid or hyperuricemia. High doses does just the opposite. A high dose of aspirin interferes with tubular reabsorption of uric acid and therefore promotes uric acid movement into the urine or uricasuria. High doses of aspirin should be part of your itinerary, I think, in terms of the toxicity descriptions of effects of aspirin on acid base and electrolyte balance. I've listed here in the next 2 slides what takes place as you increase the doses into the high range, which could include, by the way, the clinical high range used as anti-inflammatory agents. When you get above the normal therapeutic range, you're into a situation where you will get an increase in respiratory rate. This is usually brought about by a mild uncoupling of mitochondrial oxidative phosphorylation. When you breathe more rapidly, of course, you lower our PCO2 in our blood, and this then, by lowering our PCO2, tends towards a alkalotic state. That would be called a respiratory alkalosis. It might be mild, it could be severe. In any event, it generally leads to compensatory mechanisms on the part of the kidney. For example, the kidney would like to try and restore the pH, Not that it thinks about it, but it would like to actually be involved in restoring pH towards the normal. And in order to do that, it has to increase the elimination of the bicarbonate ion. Getting rid of the bicarbonate ion actually would compensate for the respiratory alkalosis that has occurred and might bring the pH back into the normal range, but in doing so, of course, would lower bicarbonate in the blood. If you're excreting it, it can't be in the blood. So bicarbonate will go down, PCO2 goes down. In adult patients with aspirin toxicity, this might not be a real hazard. In children, it might be a hazard, and certainly children are much more susceptible to aspirin toxicity than the adult. But this would be under the category generally, although it's high dose, of mild toxicity. What happens when you really get up there in terms of toxic doses? We're talking here perhaps ingestion of, instead of perhaps a gram or so of aspirin, or so maybe 3-4 grams. We begin to do two things, actually. We inhibit the respiratory center and therefore make it more difficult to breathe, and that means your arterial PCO2 will go up. Since it's related to respiration, we call that a condition of respiratory acidosis. Blood pH is down, bicarbonate's down because the kidney is trying to get rid of it. PCO2 may be normalized by getting rid of the bicarbonate. In addition, that's one thing, all right, inhibition of the respiratory center. In addition, marked inhibition of the Krebs cycle, severe uncoupling of oxidative phosphorylation in the mitochondria leads to a decrease in the formation of adenosine triphosphate. This in turn leads to a condition of metabolic acidosis with hypothermia. Dehydration is characteristic of this situation, and hypokalemia, a loss of potassium ions. You would guess then that by this time we're actually in trouble, real trouble. The effects on acid-base and electrolyte balance obviously can be very severe and lead to life-threatening situations in overdosage. Before we discuss the management of overdose of aspirin, however, I want to look at the adverse effects of aspirin when used at more conventional clinical doses. Even low doses of aspirin can be associated in some patients with marked GI irritation. So they may have symptoms of gastritis. We certainly know that aspirin is one of our drugs that can promote the formation of GI ulcers. And in some patients, you can show that it causes bleeding from effects on the GI tract. And this, again, is one of our reasons why we like to use a compound that is a prostaglandin E1 analog to protect against the type of insult caused by aspirin on the GI tract. Salicylism is a syndrome caused by salicylates. It has GI distress as part of its profile, so I perhaps should have put that, but you can see the GI distress before. But it also carries with it some other more characteristic things, like ringing in the ears. Tinnitus would be a rather cardinal symptom of salicylism. Dizziness, vertigo, a decreased audition. Right, you can't hear quite so well. So salicylism, don't just think of it as simply the three items we see here. It will also include gastrointestinal distress. Some patients are quite sensitive to aspirin in terms of bronchoconstriction. This can lead to not only difficulty in breathing, but exacerbation of the asthmatic state. Some patients are allergic to aspirin, and they may show hypersensitivity responses that are characteristically a triad of bronchoconstriction giving you symptoms of asthma, nasal polyps, and rhinitis are part of the features of hypersensitivity responses. Reye's syndrome with the encephalopathy is nowadays quite rare, but it certainly was a possibility when aspirin was used much more commonly as an antipyretic or analgesic in children that happened to be suffering from viral infections. But fortunately these days people are very well aware of it, and so it's become much rarer. Antiplatelet action, of course, is a desirable thing if you're trying to protect against a myocardial infarct, but certainly is not a desirable thing if you want to impede the ability to clot. This increase in prothrombin time that can be seen with aspirin is certainly an antiplatelet action, and it may make it difficult for one to clot if one suffers from either hemorrhages or cuts or what have you. With chronic use, the ability to decrease prostaglandins has been associated with both renal dysfunction and hypoglycemia as far as aspirin is concerned. Aspirin also gets itself involved in quite a lot of drug interactions. For example, if patients use regularly large quantities of ethanol, this with aspirin will lead to an increased chance of GI bleeding. They sometimes have said that one aspirin tablet is equivalent to 1 teaspoon of blood loss, and aspirin with alcohol is equivalent to 1 tablespoon. It just tells you the rough approximation of enhancement. Aspirin actually can displace some drugs from plasma protein binding sites. For example, it can displace sulfonylurea blood sugar lowering drugs that are used in diabetes, type 2 diabetes, and enhance their hypoglycemic effect. It can displace warfarin from plasma protein sites and enhance the anticoagulant properties of warfarin. Actually, aspirin decreases the effectiveness of uricosurics that are used in the management of gouty conditions. What about aspirin overdose and management then? Well, if you followed what we've said about the effects of aspirin, and of course the effects particularly on acid-base imbalance and on electrolytes, you would guess that this is very important for us to want to rectify. At high plasma levels, and I'm talking about the toxic range, we actually end up with vasomotor collapse and failure of both respiratory and renal function, and recognize that we have no antidote to handle high doses of aspirin. So what we try and suggest is, of course, to try and get any aspirin out of the stomach that has not already been absorbed. Activated charcoal is sometimes used here because it will actually bind aspirin, and if you can pull out any undissolved aspirin or any non-absorbed aspirin, that sounds like a very appropriate action. You provide the patient with ventilatory support because the patient's respiratory function is going to be impaired at high doses, and you do your best to rectify the acid-base and electrolyte imbalance. You try your best to keep the body temperature down, the hypothermia and the dehydration, of course, replacing fluid. As far as getting rid of aspirin is concerned, you might be able to get rid of aspirin simply by increasing urine volume, but you'd be better off if you alkalinize the urine as well. You see, the urine pH might be quite low by the time you get yourself into an acidotic condition. Urine pH is low, and if you can push the urine pH up by bicarbonate, you can often really hasten the elimination of aspirin out of the body. What doses are associated with severe toxicity? 150 milligrams per kilogram. So if you were to say to yourself that in a patient weighing 70 grams, that would be about 10 grams. Now, what's the average aspirin tablet? About 325 milligrams. So what are we talking about here? 30 to plus types of tablet of aspirin, all taken at the same time. If you happen only to weigh 10 kilograms because you're only 22 pounds and you're a little infant crawling around, and you put aspirin into your mouth and swallow it, then as little as 4 to 6 tablets can be life-threatening. So this obviously is an important thing in terms of the accessibility of children to aspirin in the home. Know the pharmacology of aspirin very well. It's a top 10 drug for examination purposes, and certainly as the prototype of the non-steroidal anti-inflammatory drug class, it certainly would have a high priority in my mind. What about other non-steroidal anti-inflammatory drugs? Well, there's certainly plenty of them out there. They're very distinctive in one thing immediately, and that is that they don't irreversibly inhibit the enzyme. They are simply reversible inhibitors of cyclooxygenase. They are similar to aspirin in the sense of not having any selectivity for either cyclooxygenase 1 or cyclooxygenase 2, and they're rather like aspirin in the sense of some of their pharmacological properties. If one compares these drugs with aspirin in terms of their analgesic effectiveness, there is some variation here. Of all of the non-steroidal anti-inflammatory drugs, if we had to say, well, which is the strongest in terms of relief of pain, we probably would pick ketorolac. Ketorolac has sometimes been compared favorably with strong opioid analgesics in postoperative pain, and also happens to be a very effective drug in many cases of patients who have severe back pain that is refractory to any other of the conventional medications. So I would say that if you're looking for the strongest of the non-steroidal anti-inflammatory drugs from the standpoint of analgesia, ketorolac would take that particular prize. Ibuprofen and naproxen, which are certainly available over the counter, are considered to be somewhat more potent as analgesic drugs than aspirin, but really only marginally so, I think, in most cases. There are a lot of variations in one's interpretation of which drug is considered to be the best for which type of pain, because even in situations of what you might call a standard pain, say the pain of a tooth extraction, individuals are very variable in terms of what they consider to be effective among the NSAIDs. There is GI irritation with the NSAIDs, but not as much as you see with aspirin, so they do have a somewhat advantage over aspirin in that regard. Acid-base dysfunction is minimal, actually. I suppose it could occur if you were willing to ingest perhaps 80 or 90 ibuprofen tablets. It's possible, I suppose, but it certainly is not a very common sort of feature. There aren't any effects on uric acid metabolism or elimination like there are, for example, with the elimination of uric acid affected by aspirin. Allergies are quite common, and there's a good deal of cross-allergenicity between individual NSAIDs, although on the face of it there should not be quite so much because they come from very different chemical classes in some instances. There is even cross-allergenicity with aspirin, and aspirin, of course, is different chemically than some of the other non-steroidal anti-inflammatory drugs. So if you're allergic to one, you can't guarantee really how to try another one without a certain amount of risk. When you use the NSAIDs chronically, they are rather like aspirin in terms of potential for renal toxicity. So chronic use can lead to nephritis, certainly has been associated with the nephrotic syndrome and occasionally acute renal failure. Again, I would suspect that this is largely a dose-dependent phenomena. I doubt very much that there's a great deal of evidence for the nephrotoxicity if one uses an occasional NSAID, or even perhaps every 4 weeks is in need of an NSAID. But chronic administration in inflammatory disorders is associated with renal toxicity. There are some drug interactions. NSAIDs tend to enhance the action of hypoglycemic drugs that lower blood sugar, so there may be an increased hypoglycemia. They've been shown to increase the activity of methotrexate and of lithium, although the latter, lithium, does not appear to be affected by aspirin. They also can decrease the activity of some drugs, especially drugs used in the management of mild to moderate hypertension. For example, the ACE inhibitors and the loop diuretics, and to some extent the beta blockers, may have their activity diminished in the presence of an NSAID. I would say if I'm going to remember a specific toxicity, it would probably be the hematotoxicity of indomethacin. I mean, that certainly indomethacin is a very potent NSAID, not so much in terms of its analgesia, but perhaps in terms of its anti-inflammatory action. I would say if I had to pick a drug among this family that was the strongest anti-inflammatory drug, I would pick indomethacin. but I'm not saying I would necessarily use it. But indomethacin certainly is very potent in that regard. However, it does cause hematotoxicity, and that's a risk that is singular or specific to indomethacin. Sulindac has been associated with pancreatitis, and as far as diclofenac is concerned, any patient that has pre-existing liver dysfunction, that would be a contraindication. And I'd certainly be looking at what happens to liver function enzymes if people were taking diclofenac in a chronic fashion. Now, in the last period of perhaps 2 years, we've seen the introduction of selective cyclooxygenase 2 inhibitors. Now, cyclooxygenase 2, as we've said before, is expressed by cells that are involved in inflammatory responses. It may be present in other cells, but this is the particular feature that led to the introduction, the investigations and introduction of drugs that were more selective than the NSAIDs. We have several of these compounds. I pick for you celecoxib and rofecoxib as examples. I think the family name is going to be coxib, I suppose referring to cyclooxygenase inhibitor, but it's the COX-2 enzyme that seems to be more selectively inhibited. It's a reversible inhibition, and I would say that whether that leads to greater anti-inflammatory action is really quite moot, because most studies fail to demonstrate any greater activity when it comes to dealing with inflammatory disorders and the symptoms of inflammatory disorders. And there's also actually evidence of potential nephrotoxicity and allergy with these drugs. So in that sense, they're not particularly superior to the standard non-steroidal anti-inflammatory drugs. Their major claim to fame, of course, lies in the arena of gastrointestinal distress and antiplatelet action. They don't seem to cause as much GI distress or as much potential for causing ulcers as traditional non-steroidal anti-inflammatory drugs, and they don't seem to get themselves involved in bleeding tendencies brought about by antiplatelet action. They can actually increase prothrombin time when used with warfarin, so at least in the context of effects on blood, keep that in mind, but by themselves they don't appear to have an antiplatelet action. Celecoxib is related to the sulfur drug family, and sulfonamides used as antibacterial agents are quite well known to cause allergic reactions. I mean, I think sulfonamides are second only to the penicillins in causing allergies. Now, the interest here then is that if a patient has experienced an allergic reaction to a sulfonamide, then celecoxib would probably not be the ideal drug to use, because there would be a high tendency for a reaction. So I thought you might like to keep that at the back of your mind in the context of selecting one COX-2 inhibitor over another one, depending on patient factors. Now, when we talk about NSAIDs and cyclooxygenase inhibitors, we leave acetaminophen to the very last, because it is neither a non-steroidal anti-inflammatory drug nor really, at least in peripheral tissues, a cyclooxygenase inhibitor. However, we always talk about it around the time that we talk about aspirin, because both its analgesic and antipyretic actions, this ability to lower body temperature, are very similar to those of aspirin. And of course, in our homes, nearly most families have both aspirin and acetaminophen for purposes of either providing analgesia or antipyresis actions. I would say acetaminophen has very minimal anti-inflammatory effects, so that's a distinctive feature in comparison with the non-steroidal anti-inflammatory drugs, and probably the action leading to antipyresis and analgesia, if it involves cyclooxygenases at all, is an involvement with neurons and neuronal function. Now, certainly cyclooxygenases and prostaglandins are important in the central nervous system. They're thought to be modulators of neurotransmission in part. So it is possible that inhibition of the enzymes present in the brain are responsible for the lowering of body temperature and the pain relief that you get with acetaminophen. I like to compare acetaminophen formally with aspirin because of the differences between the two types of drugs. You see the similarities, you see the analgesia and the antipyresis, but acetaminophen does not have antiplatelet action. It has certainly not been implicated in Reye's syndrome, doesn't do anything to uric acid elimination, doesn't do anything to your respiratory function, it is not bronchospastic, and at conventional doses of acetaminophen, gastrointestinal distress is minimal. So you can see that in comparing it with aspirin, it really is a very different drug. That's not to say that you can't get into trouble with acetaminophen. You can. And of course, it's well known to have the potential in overdose situations to cause damage to the liver, sometimes irreparable damage. And certainly, this is a good example for you of metabolism being linked to toxicity. Normally, acetaminophen metabolism by the liver involves a phase 2 enzyme reaction involving the conjugation of glucuronide with the drug. And the enzyme that does that, of course, is glucuronyl transferase. Now, that's the normal situation, and the product of that is acetaminophen glucuronide, an inactivated conjugate, in other words. There is always a little tiny bit of metabolism in the liver by one of the cytochrome P450 enzymes. And what this does is to actually form a metabolite that has the potential to be toxic. It's called N-acetyl benzoquinone imine. Now, normally, this gets inactivated by glutathione. Now, glutathione is stored in the liver and other cells, and glutathione can then inactivate this imine toxic metabolite. However, in overdose, the stores of glutathione are often depleted. This means that the toxic metabolite, the amine, increases in its levels in the hepatocyte. And an increase in the levels then tends to cause toxicity. It might be a mild toxicity originally, such as a nausea or vomiting, etc., but it develops slowly towards very severe abdominal pain, brought about by ultimately a central lobular necrosis and a failure of the liver. Among the candidates, for example, for liver transplantation are patients who have had their livers ruined by acetaminophen overdosage. Now, recognize this is a very interesting interaction. If a patient is a chronic user of ethanol, ethanol induces the P450 that forms the toxic metabolite of acetaminophen. And therefore, in overdose of acetaminophen, in patients who are used to using alcohol on a regular basis, right? You don't have to be overdoing it, you just have to be doing it, but I don't know what overdoing means anyway. But if you use chronic ethanol, you'll enhance the likelihood of toxicity to the liver in overdose situation. What are we talking about here in terms of numbers? Severe toxicity with acetaminophen is usually thought to occur at levels of dosage greater than about 12 grams, 12 to 15 grams. Now, what's the usual dose of acetaminophen? Well, it can come as 325 milligram. It can come as 500 milligram. So what are we talking about if it was 500 milligram? We're talking about something between 24 and 30 acetaminophen tablets ingested all at once. All right? That's certainly a possibility to do that. If you're used to using ethanol, perhaps 2/3 of that number might be appropriate. So instead of 15 grams, 10 grams. Or if it were 12 grams, perhaps 8 grams. So less is needed to severely damage your liver. And the reason for it is the formation of a P450 that converts acetaminophen to a toxic metabolite. You do have an antidote, though. And that antidote is N-acetylcysteine. It's called Mucomyst. And administration of N-acetylcysteine actually binds to the toxic metabolite and inactivates it. And it should be used as quickly as possible. ASAP, as soon as possible, is the way that you go about using the antidote in toxicity due to acetaminophen overdose. Right, now we should look at some of the anti-inflammatory drugs used in the treatment of both rheumatoid arthritis and in the treatment of gout. In terms of RA, rheumatoid arthritis, NSAIDs have a traditional role to play there. I mean, many patients who suffer from rheumatoid arthritis do get some benefit from the use of non-steroidal anti-inflammatory drugs. Unfortunately, there is a tendency to require a high dosage to get an anti-inflammatory action, and therefore one has to put up with rather severe adverse effects in many instances. This is part of the reason, of course, for the introduction of the cyclooxygenase 2 inhibitory compounds like celecoxib, because they should be less toxic, at least if they are selective for those particular cyclooxygenases connected with the inflammatory cell responses. What happens with NSAIDs, however, is really quite symptomatic. They'll decrease pain and swelling, but they don't decrease the progression of rheumatoid arthritis. Specifically, they don't affect bone deterioration. Now, because of that, they're usually only used adjunctively when you get into chronic management of rheumatoid arthritis. They may be used early in therapy as solo drugs, but sooner or later the patient is going to require something that would perhaps modify the course of the disease. And these drugs that are effective in this way are called DMARDs, which stands for disease-modifying anti-rheumatic drugs. We're always putting little names on everything. So you have NSAIDs and you have DMARDs. Now, a DMARD, if it's going to be a drug that can be called that, has to have some evidence that it will actually slow the progression of rheumatoid arthritis. It will have an anti-inflammatory action, no doubt, but it may actually be used adjunctively or together with, perhaps that's a better word, with NSAIDs. Now, among the drugs that we can use in this way, we have anti-malarial drugs and methotrexate. They're not the only ones that we can use, so I want you to sort of follow through some of the properties of drugs that are considered to be DMARDs. We'll start with the anti-malarial drug chloroquine or hydroxychloroquine. This drug, of course, being effective in malaria has very little to do with its ability to be effective in rheumatoid arthritis. We don't know the precise biochemical mechanisms by which this drug works, but we do know that it works to decrease the chemotaxis of inflammatory cells and also to stabilize lysosomes. And whether or not this is the key issue in terms of its mechanism of action has never really been fully elucidated. However, the antimalarials do have efficacy in slowing the progression of rheumatoid arthritis. Now, you will have to put up with some things. For example, gastrointestinal distress is quite common, and so is visual dysfunction. Synchronism can occur because this is related to the quinine family. And this is a drug where patients who happen to be deficient in glucose 6-phosphate dehydrogenase are susceptible to hemolysis. There are a number of drugs in medicine, this is certainly a rather characteristic one, that have this potential side effect. And so if patients from various genetic groupings, of course, including both the Black American patient and patients of Mediterranean origin who are usually somewhat deficient in G6PD, they are more prone to an acute hemolysis when using the anti-malarial, anti-inflammatory drugs. Methotrexate, of course, is an anti-cancer drug, and we will discuss anti-cancer drugs in a separate section, but methotrexate is an inhibitor of dihydrofolate reductase and therefore acts to interfere with the synthesis of purines and certain proteins that require methionine. Whether it's, if you like, cytotoxic action is the key issue here in immunosuppression. I think you'd probably say it was. When you kill cells, presumably you also kill inflammatory cells, and by killing inflammatory cells one would imagine that you might slow the progression of rheumatoid arthritis. Certainly methotrexate is quite widely used. Like any of the anti-cancer drugs, it tends to suppress the formation of red blood cells and other cells in the bone marrow. and therefore hematotoxicity is fairly common with methotrexate, as would be irritation of the GI tract leading to mucositis, and to some extent renal damage due to crystalluria. Patients on methotrexate should be made aware that it's important for them to ingest reasonably large quantities of fluids to provide a hydrated state, which will tend then to increase urine flow, and that should get rid of methotrexate before it can come out of solution in the renal tubules. The third drug that we might want to draw our attention to is a very old drug called sulfasalazine. Sulfasalazine breaks down in our body to form a sulfur derivative called sulfapyridine. And the sulfapyridine appears to inhibit the formation, or the functions anyway, of B cells. And that certainly would be an immunosuppressive action that might be useful in terms of delaying progression of rheumatoid arthritis. There is also the possibility of decreasing the prostaglandins by virtue of inhibition of cyclooxygenase, because the other product of breakdown is a salicylate. And salicylates, as well as acetyl salicylic acid, aspirin, are quite capable of inhibiting cyclooxygenases. Not irreversibly, but reversibly. The problems that you run into are fairly obvious. They remind you of sulfur drug problems and salicylate problems. GI distress going along with the idea of salicylates, rashes going along with the idea of sulfonamides. Sulfonamides are another group of drugs that actually cause hemolysis in patients who have a deficiency of glucose 6-phosphate dehydrogenase. This is a sulfur-containing drug, so I'm not surprised about that particularly. Some of the allergic responses can be quite severe. There may be skin rashes, but they've also seen in some patients a systemic lupus-like syndrome occurring with the use of sulfasalazine. Sulfasalazine also, by the way, is a drug that you might have associated with the inflammatory condition of ulcerative colitis, because certainly it's been used in that fashion as well. Right now we're talking about rheumatoid arthritis. Gold salts go back historically probably hundreds of years in terms of their clinical usefulness. They are used on occasion in rheumatoid arthritis, both by intramuscular and oral modes of administration. Mechanistically, I don't know how these metals really work, but they decrease the function of lysosomes and macrophage, and these are both types of activity that lead to inflammation. I can't imagine a drug type that does not cause more types of hematotoxicity than a gold salt. Gold salts are well known to cause hematotoxicity of almost all types, with, funnily enough, not hemolysis. They don't seem to be associated with hemolysis, but almost every other expression of hematotoxicity has been described for gold salts. They also are very irritating to the skin. They cause very marked dermatitis, and they do have the potential to be damaging to the kidney. Penicillamine is a chelating agent used in a variety of situations, including, for that matter, Wilson's disease, where it can bind copper. But penicillamine, when used in rheumatoid arthritis, is thought to suppress T-cell function and also inhibit rheumatoid factor. It's a strange drug, really. I would say you resort to it when others have failed, because in order to get it to do much in terms of rheumatoid arthritis, you will have to put up with a lot of side effects. It's damaging to the kidney, can cause proteinuria. It's damaging to the blood, causes hematotoxicity. It can change immune balance to the point of causing autoimmune diseases like systemic lupus. So I would say that that's towards the end of our list of drugs that we might want to use of the traditional ones. What about steroids? Well, certainly glucocorticoids have a long history in terms of their usefulness. I'm not sure whether I want to call it specifically a DMARD, but the immunosuppressive action of glucocorticoids in any inflammatory or immunological dysfunction is probably related quite intimately to the ability of these drugs to decrease formations of interleukins and also, for that matter, the formation of platelet activating factor. I would say that you should recognize, and we'll talk about it later, but whenever we use glucocorticoids, you're going to get exacerbations limitations of the normal glucocorticoid action that is a hormonal action. So you're going to suppress the adrenal pituitary axis. You're going to inhibit pituitary function. You're going to get a state that is called cushingoid because that comes about from excessive glucocorticoid presence in the blood. You'll hurt the bone because you'll cause vertebral fractures particularly, and you'll have a lot of GI distress and ocular dysfunction. Now, there are 3 drugs that have come into medicine more recently which may have value. When we say may have value, we have to wait in many instances for several years to be able to fully determine that, but which are thought to have value in the management of rheumatoid arthritis. One of them is a drug called etanercept. This is a drug that is capable of binding tumor necrosis factor. Now, TNF, or tumor necrosis factor, is a very important inflammatory mediator. Certainly it may kill some tumor cells, but it has more than that role in biochemistry. It is a cytokine that actually can be involved in, for example, the inflammatory responses seen in rheumatoid arthritis. So etanercept is actually like the receptor for TNF. It's a rather clever ploy. TNF can't distinguish between etanercept and its natural receptors on immune cells, and therefore it tends to bind to etanercept, but it doesn't do anything because etanercept sort of takes it out of play. And in essence, then there's less available to activate the immune cells. So it's a sort of a clever type of approach to the management of rheumatoid arthritis. Unfortunately, TNF also plays a role, in decreasing the likelihood of infection. So if you take TNF out of the game, you also are going to likely increase the incidence of infections. Etanercept is a big molecule, protein-type molecule, can cause allergic reactions. You have to inject it, and it's very irritating at the injection site. So there are some limitations about etanercept. Infliximab is a monoclonal antibody. So this is prepared in the lab, and it's by design an antibody that once again is for proteins that are on part of the protein nature of tumor necrosis factor. So again, you're interacting with TNF and taking that out of action by using a monoclonal antibody. This drug has to be given by infusion, and infusion-related reactions can be problematic. And just like etanercept, by decreasing TNF, you are likely to increase the likelihood of infections because TNF usually combats infections. Remember, in chronic granulomatous disease, the reason you use interferons is to increase TNF. And both of these drugs, etanercept and infliximab, are decreasing TNF. Leflunomide was designed to inhibit the enzyme dihydroorotic acid dehydrogenase. Inhibiting that enzyme decreases UMP, uridine monophosphate, which in turn decreases the formation of ribonucleotides, and that leads to the arrest of lymphocytes in G1 phase of the cell cycle. And if you can't make lymphocytes, then you actually are having an immunosuppressive action there. And this can be useful in rheumatoid arthritis. Hair loss is one of the characteristics of the use of leflunomide. Rash, diarrhea are less distinctive, but alopecia certainly would be distinctive here. Now, what about the gout story then? Gout, obviously, is thought of in 2 ways, an acute inflammatory episode and chronic gout. And among the drugs that we have available for treatment of the inflammatory episode include non-steroidal anti-inflammatory drugs. Indomethacin has been used quite commonly, and most people consider to be that the drug of choice, although colchicine certainly is a drug that is effective in acute inflammatory episodes. There are a number of things you could do, really. I mean, if you haven't got indomethacin, you could use another non-steroidal anti-inflammatory drug, or you might even consider the injection of a glucocorticoid steroid into a joint where there's an acute reaction. Colchicine, however, we need to know a little bit about it. We know that it binds to tubulin and therefore can affect microtubular polymerization, but probably more related to its usefulness as an anti-inflammatory agent is its ability to decrease the formation of leukotriene B4. Remember, we said B4 is a very potent inflammatory mediator, and therefore if you decrease B4, you decrease the migration of granulocytes and leukocytes towards an inflammatory site, like an inflamed joint. And the idea then behind colchicine is that by decreasing leukotriene B4, then there would be less cells there joining the inflammatory party, as it were. You will have to put up with adverse effects, and this really is the primary reason why indomethacin is often preferred, at least initially, because of the GI distress. Many as 70 or 80% of patients get rather severe GI distress and pain with colchicine. When you use the drug for a longer period of time, problems occur regarding hematuria and also, again, hair loss with respect to colchicine. Myelosuppression occurs. It's irritating to the gut, so you're not surprised that you get gastritis, I shouldn't think. But it also has been associated with peripheral neuropathy, paresthesias, and sometimes pain, peripheral pain that can occur with colchicine. So although you can see on this slide I'm putting most of our emphasis in terms of quantity on colchicine, I think you know enough about indomethacin to be able to sort of handle that in terms of its mechanism and its properties, and I would like you to consider that as probably the drug of choice here. In chronic gout, there are two strategies that one can do here, or one can utilize. One would be to actually inhibit the formation of uric acid, and thus by inhibiting it, you will get this likelihood of uric acid crystals occurring in the joints. And the other is to actually try and get rid of uric acid out of the blood by promoting its elimination by the kidney. The drug that works at the level of inhibiting synthesis is allopurinol. Allopurinol is an interesting drug, really, because it's a drug that the enzyme, when it metabolizes it, xanthine oxidase, forms a compound that inhibits the enzyme. It's sometimes referred to as a suicide substrate. So xanthine oxidase forms, all right, it's obviously an enzyme involved in purine metabolism, forms uric acid. And if you can inhibit the activity of xanthine oxidase, you inhibit the formation of uric acid. So it's a drug that would be working, presumably, to decrease the elevated blood levels of urate that are associated with chronic gout. So in essence then, think of it as an inhibitor of xanthine oxidase and being a suicide substrate. This drug happens to be also used in cancer quite a lot, in treatments with both drugs and irradiation, because you see, when you kill a lot of cancer cells, what are you going to release from the cancer cell? You'll release calcium, and therefore hypercalcemia will occur, but you'll also release nucleic acids. And the purines that come from nucleic acids eventually form uric acid. So the idea here of been using allopurinol in that arena is to slow formation of uric acid, because you do not want to have a hyperuricemic state. So it's not just used in gout, it's also used in cancer, chemotherapy, and radiation treatment. Side effects, gastrointestinal, peripheral neuropathy would be fairly characteristic, I think. This is a drug that is associated with stone formation in the kidney, and it's also a drug that inhibits the metabolism of a fairly well-known anti-cancer drug called 6-mercaptopurine. 6-mercaptopurine is a purine antimetabolite, and it is a cytotoxic compound and causes hematotoxicity and also liver damage, by the way. And if you inhibit its metabolism, you enhance the toxicity of 6-mercaptopurine. So if a patient is using allopurinol, you should lower the dose of 6-MP very significantly, perhaps to a quarter of the normal dosage of 6-MP, because its metabolism is going to be via xanthine oxidase, and xanthine oxidase is being inhibited by allopurinol. I think you get the idea. Now, what about the drugs that will influence uric acid elimination from the kidney? These drugs are related to the sulfonamides. In fact, they were derived from sulfonamide pharmacology, probenecid and sulfin pyrazole. This is certainly shows you this is a sulfur-containing group. These drugs inhibit the tubular reabsorption of uric acid, but only over a certain range. Usually, if the GFR is greater than 50 milliliters per minute, they'll do the job for you. Anything below, it's uncertain whether or not you will actually inhibit reabsorption. However, they are used quite commonly in chronic gout. They also happen to inhibit the secretion, not reabsorption, the secretion of a number of acidic drugs. Some of those drugs are antibiotics, like beta-lactams, penicillins, and cephalosporins. They also include the fluoroquinolone family. So if you wanted to prolong the action of such an antibiotic, the co-administration of, say, probenecid should increase the plasma half-life of those drugs and make them more active for a longer period of time. As sulfur drugs, you might predict that they would cause GI distress and rashes. That's very, very common. But they can also cause damage to the kidney and nephrotic syndrome and cause crystallization if you have high uric acid content, because you're promoting the movement of uric acid into the urine by blocking reabsorption. And if it's too high, it'll crystallize out. Interestingly, aspirin, which is sometimes used in gout, will antagonize the action of these drugs which inhibit the reabsorption of uric acid. So that would not be a good idea. And anti-inflammatory steroids. I promise I'd say a little bit more about these for you. There are so many different indications for anti-inflammatory steroids that I don't think we want to put a list down of them all. Most of you will already have seen the use in terms of medicine and probably have used the steroids yourselves, perhaps, in some conditions. The primary steroid of the glucocorticoid family is cortisol, or hydrocortisone is another name for it. And this compound, although it is available for topical use, would not have any real use in terms of systemic inflammatory dysfunction because of its very short half-life. If you take cortisol by the oral route, it has a half-life of just a few minutes and it undergoes first-pass metabolism. So people have synthesized various synthetic glucocorticoids that have either longer durations of action, better stability by the oral route. In some instances, they also have greater activity when applied topically. And I would suggest out of the 30 or so that are in medicine, that you know the names of one or two of them. I mean, prednisone is fairly commonly used in cancer regimens, for example. Triamcinolone and dexamethasone would be longer acting types of drug, and perhaps you could identify those types of compound just as the idea of what glucocorticoids are like. At the cellular level, in terms of their anti-inflammatory action, we know that you can decrease the migration of leukocytes and increase the stability of the lysosomal membranes. That ought to have a useful anti-inflammatory result. You decrease phagocytosis by phagocytes, and you decrease capillary permeability. Increases in capillary permeability are one of the typical symptoms of an inflammatory response. So it seems reasonable that you're doing the opposite to inflammation with a glucocorticoid. How do you bring these actions about? Well, we know 4 biochemical mechanisms that might help these actual cellular events which are useful anti-inflammatory properties. One is to induce the synthesis of a protein called lipocortin that can actually inhibit the enzyme phospholipase A2. So this is an induced effect, and if you inhibit phospholipase A2, then you do not form arachidonic acid, as we described a little earlier. And if you can't make arachidonate, you can't make either the leukotrienes, which are inflammatory, or prostaglandins. So you can see that this would be an action that could have a large part of the anti-inflammatory property of a steroid as its underpinning. You decrease prostaglandins and leukotrienes, but you also affect cyclooxygenase 2 by decreasing the formation of messenger RNA for cyclooxygenase 2. And that then would obviously be particularly relevant to inflammatory cells. So decreasing prostaglandins in inflammatory cells would also be rather useful. You decrease the formation of platelet activating factor. That's an inflammatory mediator. You decrease the formation of the interleukins, particularly interleukin 2, but others as well. They're inflammatory mediators as well. So I like you to think of 4 biochemical mechanisms that underlie the anti-inflammatory properties of the glucocorticoids. And these then would be reflected in cellular events, and as we've described. The trouble with glucocorticoids is fairly obvious. One usually has to use quite high doses to get anti-inflammatory action. And since this is a naturally occurring hormone, at least cortisol is, then you're going to see side effects that often are expressions of the typical biochemical actions of cortisol in our body. And when you magnify them, then these typical biochemical actions become side effects, and sometimes very severe side effects. You see, cortisol normally goes back to the pituitary and says, don't release ACTH. I don't need it. We got plenty in the blood. Well, you put dexamethasone in the blood as an anti-inflammatory action, it suppresses ACTH, and that is going to lead to atrophy of the adrenal cortex. Myalgia, arthralgia, etc., malaise are all symptoms of suppression of the adrenal pituitary axis. High body temperature occurs as well. A cushingoid state, well, that's the fat deposition on the back of the neck, etc. Muscle weakness, bruising, acne are all features of excessive glucocorticoid activity. Hyperglycemia, well, certainly you anticipate that because glucocorticoids do increase insulin demand, and that then would be a side effect. Vertebral fractures, osteoporosis, aseptic hip necrosis, characteristics of glucocorticoids when used either as anti-inflammatory or immunosuppressive drugs. Here's another drug group that stimulates acid production. Also some of the enzymes, like pepsin as well. So for workups of patients who have the symptoms of acid peptic disease or ulcers, you are concerned that the patient might be taking a glucocorticoid, and this is the culprit, as it were. As far as mineralocorticoid activity is concerned, most of the actual longer-acting glucocorticoids have very little of that activity. Prednisone has some, and certainly cortisol would have some, because that's well known to have mineralocorticoid activity. There are certainly effects on electrolytes. Hypokalemia occurs, and hypocalcemia. In children, skeletal growth can be decreased. In fact, children using inhalational steroids for asthma, you may see a decrease in skeletal growth. Difficult for wounds to heal, that's certainly a problem. Viral infections may be exacerbated by glucocorticoids. An example, a herpes infection of the eye. Putting a glucocorticoid on that to decrease inflammation tends to spread the infection through the eye into the inside of the eye. That would be obviously a big disadvantage. Disturbing the flora in the gut leads to the elaboration of fungal infections in the gut, such as those caused by Candida species, leading to thrush. Eye, increased intraocular pressure can exacerbate and lead to glaucoma, and steroids used chronically are among the most common drugs to be associated with cataract formation. They increase the content of sorbitol. And we also have behavioral effects associated with high doses of glucocorticoids, been referred to as roid rage, meaning, related to the steroids. And it can actually present, in the extreme case, as something that looks like schizophrenia. In other words, a psychotic disorder. So these are some, to varying degrees, of the penalties that you will have to face using glucocorticoids, particularly at high doses by the systemic route. Now, the last group of drugs that we're going to talk about under this general area of drugs for inflammatory conditions concerns the drugs used in the treatment of asthma. Asthma is an inflammatory disorder. It's characterized by bronchiolar hyperreactivity, sometimes abbreviated to BHR, bronchospasm, an increase in the secretion of mucus, edema in the bronchial tree, cellular infiltration there. Early asthmatic responses, sometimes abbreviated to EAR, are associated with bronchospasm from the release of histamine and the leukotrienes. So, some of our drug actions may be exerted to prevent the effects of leukotrienes, such as the drugs that inhibit lipoxygenase, like xylutin, or the drugs that inhibit leukotriene receptors, like zafirlukast. The late responses to asthma, or late asthmatic responses, include cellular events like infiltration of eosinophils and lymphocytes, possibility of more protracted bronchoconstriction than simply bronchospasm. A lot of mucus is formed, and there's a big increase in BHR. So the management involves like a two-pronged attack. One would be to use bronchodilators to provide short-term relief of an acute type of situation, and the other would be to use anti-inflammatory agents that will decrease bronchiolar hyperreactivity and hopefully protect against the cellular infiltration that occurs as part of the late responses. And among the drugs that we have available there are, of course, drugs that are very potent bronchodilators. In the last decade or so, bronchodilation by the use of beta-2 selective drugs that activate beta-2 receptors in the bronchiolar smooth muscle has become almost the paradigm for treatment of asthma. I would like you to remind yourself about some of those drugs. They were mentioned earlier under autonomic pharmacology. One way you might do it actually is if you thought of the word MAT, M-A-T. That would give you the first letters of metoprolol, albuterol, and terbutaline. That could be one way to remember that type of beta-2 selective drug. But there are plenty of them available for management of asthma. The shorter acting forms in terms of inhalation are used for acute attacks, and usually those that are longer acting are more prophylactic. For example, salmeterol, salbuterol are used, and they have actions that go for perhaps 12 hours and therefore tend to decrease the likelihood of a patient waking up in the middle of the night with an attack of asthma. Also, the longer-acting ones allow you to use less of other drugs. If you need more than a single drug, then they may decrease the requirement for other drugs that are anti-asthmatic. Mostly these drugs are used by aerosolic form. That does decrease systemic effects because you're breathing it in and breathing it out, etc. However, some gets into the blood. And the concerns you have there really depend on the extent of overuse of beta-2 agonists. Even with the usual precautions, including spacers, etc., people sometimes overdo it with a beta-2 agonist in terms of inhalation. That means then that you might start to get effects outside of the lungs. And when you do, you begin to get effects that actually would be very dangerous to the heart. See, the actions of beta-2 drugs theoretically should not affect the heart, but they're not pure. They also have activity on beta-1 receptors, and if enough of the drug gets into the blood, they then will become stimulatory of the heart. And there have been occasions where people have had severe cardiac problems because of that, including actually death from such stimulation. One of the early signs of systemic toxicity that's going to occur with inhalation of beta-2 agonists is a tremor, a slight tremor, because remember, beta-2 receptors at the skeletal muscle are activated by norepinephrine, and they'd be activated by a beta-2 agonist for that matter. So recognize that muscle tremors would certainly be part of the expression of systemic toxicity. Patients often become a bit anxious, you see, because as soon as you start getting effects on the heart, you think, what's gone wrong? I can feel my heart beating. So they might get anxious as well. Now, the diagram here shows you what happens with respect to drugs that can influence bronchoconstriction. What we have here is, for example, the action of a beta agonist, which is through its beta-2 receptors coupled by a GS protein to adenylyl cyclase, and one then increases cyclic AMP, and it's the cyclic AMP that it leads to bronchodilation. Now, you might also see here that on this side of the figure, or on this bottom half of the figure, that if you were to interfere with the metabolism of cyclic AMP, and we certainly have drugs that can do that, theophylline is a good example, you can inhibit phosphodiesterase. That's the enzyme that metabolizes cyclic AMP, converting it to adenosine monophosphate. So part of our useful action of theophylline in asthma is due to increasing cyclic AMP, not directly, but by inhibiting its metabolism. The mechanisms of bronchoconstriction, of course, concern 3 different types of endogenous compound. Acetylcholine through muscarinic receptors, well, that's what you get when you have excessive parasympathetic stimulation. That's what you get when you increase acetylcholine by a cholinesterase inhibitor. You actually bring about bronchoconstriction. Remember, in terms of the identity of the drugs that act by cholinesterase inhibitors by the little term dumbbells. Dumbbells, as we've said already, actually stands for diarrhea, urination, meiosis, B for bronchoconstriction. So you can pretty much guarantee that that's what's going to happen. As far as adenosine is concerned, adenosine is also a bronchoconstrictor through adenosine receptors. And this then, of course, is part of our mechanism of action of theophylline. Theophylline blocks adenosine receptors and therefore would have an inhibitory action on adenosine's stimulation of bronchiolar constriction. Lastly, the leukotrienes. The leukotrienes activate receptors leading to bronchoconstriction, and the leucast family, like, for example, Zafir leucast, will have an inhibitory action there. So the diagram actually shows us all of our drugs that actually lead to the acute, if you like, bronchodilation that is important in an acute asthmatic attack. Muscarinic blockers already have been described very extensively under autonomic pharmacology, although one has not said specifically which types of drugs are used in asthma. If you were to sort of pick one of the several that are available, I think ipratropium would be a fairly good example there. There certainly are others available. Remember that they're going to cause a bronchodilation in acute asthma, and they appear clinically to be very good drugs in patients who have chronic obstructive pulmonary disease, COPD. Some people recommend this class of drugs over the beta-2 agonists in patients who are at risk for cardiovascular stimulation because they appear to be safer in patients who have cardiovascular dysfunction. In beta blocker overdose, where you might get a bronchospasm, you can't reverse that with a beta-2 agonist. Beta blockers always win the battle. If they're on the receptor, you can't get them off. So what you do in a bronchospasm caused by a beta blocker is give a muscarinic receptor blocker. This is an example of physiological antagonism. You're working on different receptors, and this is then puts this category of drugs into drug of choice for that situation. Do they cause atropine-like side effects? Well, if they do, they're very, very minor. It's not something to specifically worry about. You may get some dry mouth types of effects because obviously you inhale through that mechanism. Theophylline is an old drug. It's a methylxanthine, goes back a long way. It's a drug that for many years was a standard drug to use in the treatment of asthma, but has declined in use in a sort of inverse way to the increased use of the beta-2 agonists and the inhaled steroids. It's an inhibitor of phosphodiesterase and therefore should increase cyclic AMP by that mechanism. It also blocks adenosine receptors in bronchiolar smooth muscle. Remember, adenosine is a bronchoconstrictor. These days, I would say it's mainly adjunctive. It's got a narrow therapeutic window. Twice the effective dose or twice the effective plasma level gets you almost into the toxic range. So, that's a fairly narrow window, and it has cardiovascular and central nervous system effects, both of them being stimulatory. So look towards an increased heart rate and look towards arrhythmias as far as the cardiac effects are concerned, and look towards behavioral excitation up to and including seizures, with toxicity that is a CNS toxicity. More commonly, of course, and hopefully, GI distress might be one of the problems that people suffer here. Quite a few drug interactions with the compound theophylline. Many drugs inhibit its metabolism. For example, antibiotics like erythromycin and fluoroquinolones will do that. Cimetidine, the H2 blocker, is a very good inhibitor of theophylline metabolism as well. There is a form of theophylline called aminophylline, which you might have seen in the emergency room. It's an intravenous form that's sometimes used for bronchospasm. Now, what about some of the drugs that actually are more in the category of prophylactic or decreasing the bronchiolar reactivity? We have several mast cell stabilizers here that can prevent degranulation of the pulmonary mast cells, and that will then decrease the release of inflammatory mediators. Immediately you know that mast cells contain histamine. You may not remember that they also contain platelet activating factor and various leukotrienes, all of which are inflammatory mediators. So if you can prevent that release, you've got yourself something that could be anti-inflammatory. For the most part, we think of this type of compound, like cromolyn, as being prophylactic. You see, they're probably best in situations of either allergen-induced asthma, because of the effects on the mast cell, and to some extent exercise-induced asthma, but they really should be taken before you're exposed to the allergen, for example, because it takes time for them to work. If you've already been exposed, you already released these mediators from the mast cell, and you're not expecting to get too much of a response there. Overall, they're not particularly toxic. They may cause a repetitive cough in some patients, an irritation of the throat. Sometimes you can relieve that by a beta-2 agonist. A little bit of a beta-2 agonist, use a puff here and a puff there, may relieve that type of symptomology. The adrenal steroids as anti-inflammatory drugs have been discussed just in the past session, and therefore I don't need to go through in detail how they bring about their anti-inflammatory action in asthma, except to remind you that they will decrease the synthesis of prostaglandins, leukotrienes, and interleukins, as well as platelet activating factor, but I see prostaglandins, leukotrienes, and interleukins as being most relevant to the inflammation in asthma. And by blocking the release and synthesis of these things, they're going to have an anti-inflammatory action. Now, mostly we use glucocorticoids now by the inhalational route, and so we have what we call surface-active glucocorticoids. Beclomethasone is an example. Flunocilide is another example. I don't have a great preference for one over the other for your remembering about them, as long as you know that, of course, we do use inhaled glucocorticoids very commonly in asthma. They can be used in acute and chronic situations, and one can use these drugs both orally and intravenously in an emergency situation. Which drug would you use orally? Probably prednisone, actually. Prednisone tablets work very quickly in an acute asthmatic attack, and actually would be something that many people would use independently of a physician's help to ease a problem in a child, for example, who has an acute asthmatic attack. Remember that if you use steroids, you usually have to taper dose after using them. In an emergency room situation, you probably would use intravenous steroids in an emergency situation, and not inhaled steroids. Inhaled steroids tend to cause bronchospasm, but either oral or intravenous do appear to be appropriate. Steroids affect, the flora in your upper GI tract and oropharyngeal cavity, and can cause the elaboration of fungal infections like candida. And if you overuse them, you will get systemic effects. The best illustration I can give you for that is the one seen in children, where you can interfere with the development of their bone by overdoing it with an inhaled steroid. So they obviously do get in, and they can cause a slowing of bone formation. The last group, then, of the drugs that are working at the level of the inflammatory responses would be the leukotriene antagonists. We already have mentioned these drugs to you, and zafirlukast and its other its family members are antagonists at leukotriene receptors, most notably the D4 receptor. They have prophylactic value in that regard, not only against antigen, but also exercise and even drug-induced asthma, like NSAID-induced asthma. They have side effects, diarrhea, headache, etc. is quite common with the Lucas family, and they have also been associated with an increased infection rate, upper respiratory tract infections. Xyluton is the only example at the present time of a selective lipoxygenase inhibitor that's been brought into medicine, and so this one will inhibit all the leukotrienes. It's not selective in the sense of leukotrienes, but it is selective in sense of affecting a cosanoid enzyme. So it inhibits lipoxygenase, but actually interferes with the synthesis of all of the leukotrienes. Rapid onset is sometimes used adjunctively to steroids. The problem with it, if it is actually shown to be a serious problem in the long run, might be the liver toxicity. It has been associated with an increase in liver function transaminases. That, I would say, would be the most distinctive property about it. Lastly then, as far as acute asthma is concerned in the emergency room, don't forget oxygen as the major requirement in patients that can't breathe. Aerosolic beta-2 agonist would be certainly on demand, as it were, and you'll be making that decision. Steroids intravenously, usually. I would say in that order, as soon as possible. Aminophylline is around intravenously for bronchospasm or in status. I would think if you could just remember the general sequence here in the drugs, I think you'd be in reasonable shape. One of the important areas of pharmacology, which is a high yield area in terms of examinations, concerns the actions of drugs that can be called anticoagulants. This includes drugs that are of the coumarin family, the so-called coumarin anticoagulants, and the drugs that are related to heparin, the heparins. In discussing the pharmacology of these drug groups and the individual drugs, we'll be discussing really a very important clinical application of drugs to thin the blood and prevent coagulation. The first group of drugs that we're going to look at are the coumarin anticoagulants. Coumarins are structural derivatives of vitamin K. They structurally resemble vitamin K, but instead of doing what vitamin K will do in terms of its biochemistry, they actually interfere with the reactions of vitamin K to promote gamma carboxylation. Now, in the liver, gamma carboxylation is critical to the synthesis of various coagulation factors, particularly factor 2, which is prothrombin, and factors 7, 9, and 10. Coumarins inhibit those reactions specifically, and in doing so, of course, will gradually deplete the availability of those factors in the liver. They will not have any effect on factors that are already present in our bodies and in the blood, and therefore their onset of action is going to be slow. It will depend on how long it takes for the drugs to inhibit significantly the liver concentration and therefore the production of these various coagulation factors. And it also implies that since this action is taking place in the liver, that this type of anticoagulant will not have actions outside of the body. So this is like thought of in vivo only. The way we monitor the action of coumarin anticoagulants is to measure the prothrombin time, sometimes called the pro time. And this is actually to be prolonged if the drug is going to be effective. For example, if we have a prothrombin time normally of perhaps 12 or 14 seconds, one might achieve satisfactory anticoagulation if the prothrombin time was increased by 50%. So perhaps 20 or 22 seconds would represent a 1.5 times the normal prothrombin time. Prothrombin data is sometimes adjusted into what's called international normalized ratio. I think as long as you understand which direction the INR is going to go with respect to anticoagulation, up obviously, the same as prothrombin time, that would be adequate for our purposes here. If one's got too much of an anticoagulant on board, obviously one would probably consider lowering the dose. But vitamin K is an antidote. There is no argument about that because these are structural congeners of vitamin K. But you will have to wait some time before vitamin K will increase the synthesis of the cofactors. It takes time to do that. So the slow onset there really means that while vitamin K can be certainly used in cases of vitamin K deficiency, in terms of reversing an excessive anticoagulation action of a coumarin, it probably is more reasonable to consider using fresh frozen plasma to obtain a rapid response. The coumarin anticoagulants are extensively used. I can't really estimate how many millions of patients in the United States would be on a coumarin anticoagulant for protracted periods, but if I were to make a guess at how many people have had a myocardial infarct, it would be in the several millions, and certainly a very high fraction of those would be using coumarin anticoagulants. I think there are at least 1.5 million to 2 million patients who suffer from atrial fibrillation, and most of these patients are using a coumarin anticoagulant to prevent the likelihood of clot formation. So perhaps we could sort of like conservatively imagine that at any given time, perhaps 5 or 8 or 10 million people might be on a drug like warfarin. Warfarin is certainly the most commonly used of the coumarins in the United States, so I sometimes use that term warfarin interchangeably with coumarin anticoagulant. So what have we got? We've got the management of both arterial and venous thrombi, thromboses of various sorts, emboli of various sorts. Post-myocardial infarct, for example, is a clear indication for the use of the coumarins. Patients who suffer from heart valve damage to prevent clot formation, and certainly patients who have various atrial arrhythmias. Problems that occur with the coumarin anticoagulants, well, certainly you'd put bleeding probably at the top of your list. After all, these are anticoagulants. Sometimes the bleeding may lead to severe hemorrhage, and on occasion cerebral hemorrhage, although not commonly. One may see early in treatment the possibility of necrosis or reactions in the skin due to a low protein C content. We'll see in a moment that low protein C can occur early in treatment with a coumarin anticoagulant. The purple toe syndrome suggests vascular effects that are brought about by anticoagulation, and in the long term one may also see some evidence of bone dysmorphogenesis if provided to a patient who is pregnant. This type of drug is small enough to cross the placental barrier, small in molecular weight, and therefore should not really be used in a patient who is pregnant at all, let alone for any protracted time. The anticoagulant action of coumarins is shown in this little cartoon here. If we were to look at, for example, which cofactors or coagulation factors have their synthesis inhibited by coumarins, that would be coagulation factor 2, which is prothrombin, coagulation factor 7, 9, and 10. So the arrows point to the particular targets. While we're on the subject, let us just also look at what happens with another class of anticoagulants, the heparins. Heparins have a major action on factors 2A, which is thrombin, and of course thrombin converts fibrinogen to the fibrin clot, and inhibition of thrombin actually will prevent clot formation, and also on factor 10A. There are other factors influenced, including 11 and 12A, but I would say the primary actions are on 2A, the activated form of thrombin, and 10A. So the diagram actually lets us see in a very simple-minded way where the different types of anticoagulant, whether they be coumarins or heparins, are exerting their actions. Warfarin, as I say, is the dominant drug. It gets its name from the first letters of the Wisconsin Alumni Research Foundation, WARF, where it was actually developed at the University of Wisconsin as a rat poison. As it happens, of course, it does the same thing in rats as it does to us, acts as an anticoagulant. All the coumarins are acidic molecules, and warfarin's in that category. Its oral absorption can be decreased by some drugs. As an illustration, you may think back at the idea of the bile acid sequestration agents like cholestyramine and cholecystipol. They attach themselves to acidic drugs, and they sequester them, and that means you won't absorb them. So warfarin's activity is going to be diminished by bile acid sequestrants. They'll cross the placental barrier, as we've just described. They bind very extensively, warfarin particularly, to plasma protein binding sites, but rather weakly. So they have something better than 98, perhaps even 90% plasma protein binding, so that the free fraction is only 1 or so % of the blood level. And it's that free fraction, of course, that determines the pharmacological action, because only the free drugs can cross into the liver cell and therefore decrease formation of the coagulation factors. So if you have displacement of some of the bound drug to increase the free fraction, as we do with a number of drugs, then you tend to enhance the anticoagulant effects of warfarin. The compound, because it is lipid soluble, requires metabolism by the liver. It's a relatively slow rate of liver metabolism, but it can be made even slower by some inhibitors, drugs that inhibit metabolism, and certainly it can be made faster by inducers of drug metabolism. So you can see the stage is set with plasma protein binding being so extensive and weak, and the need for metabolism for a lot of drug interactions with warfarin. The actions can be enhanced by aspirin. That's partly through an antiplatelet of action of aspirin, which certainly will decrease the likelihood of a coagulation event, and also by aspirin displacing warfarin from plasma protein binding sites. Cimetidine, the H2 blocker, inhibits metabolism, therefore increases the actions of warfarin, as does metronidazole. And phenytoin can also displace the drug from plasma protein binding sites, as can the antibacterial sulfonamides. Now, the actions of warfarin would be decreased by enzyme inducers. And our most well-known enzyme inducers as far as drug metabolism is concerned are barbiturates, like phenobarbital, used as an anticonvulsant, and carbamazepine, used as an anticonvulsant. Phenytoin also actually can induce metabolism, but actually is more likely to be associated with an increase in action when used on an acute basis. Cholestyramine sequesters warfarin, doesn't allow it to be absorbed. Rifampin is an enzyme inducer and will decrease the actions by increasing the rate of metabolism. And vitamin K, as you would predict, is a drug that works as an antidote to warfarin and therefore should oppose the action of warfarin. Now, protein C deficiency can occur in a transient way, based really on the fact that protein C and also factor VII have shorter half-lives than the other coagulation factors. So what happens when you use warfarin initially is that you have the extrinsic pathway and the protein kinase C system inactivated, but the intrinsic pathway still remains active for several days. Because of that, a condition of hypercoagulability can occur, which, although it is temporary in terms of that condition, it actually can cause a rather longer lasting effect by bringing about a vascular thrombosis in the skin. And this can lead then to a skin necrosis situation. So this is equated with protein C deficiency and might occur earlier in therapy with any of the coumarin anticoagulants based on the differences between the individual coagulation factors in terms of their half-lives. The half-life of protein C, I believe, is in the area of about 6 or 8 hours. You can see these numbers actually listed for you in table 7-1 in the text, and you might like to refer to that. Now, what about the drugs that are heparins? Well, heparin itself, as an individual drug, actually is a very large molecule. Its molecular weight is about, I think, 15 or 20,000 Daltons, and it's a sulfated mucopolysaccharide. We often use the word heparin interchangeably when we're also talking about drugs structurally related, the low molecular weight heparins. So heparin and heparins is sort of like the same thing, interchangeable in a way. Heparin and heparins are able to increase the activity of antithrombin 3. Antithrombin 3 is an enzyme, a serine protease, that inactivates factors 2A and 10A particularly. And inactivation of thrombin and 10A obviously interferes with coagulation. The other factors, as I mentioned, that could be affected are 9A, 11A, and 12A, but basically, if you could remember 2A and 10A, I think you're in reasonable business there. The actions can take place in vivo and in vitro. See, these actions are in the blood. And so if the blood happens to be in a test tube, you can prevent its coagulation in a test tube by the use of heparinization. So this is a bit different, obviously, isn't it, from the standpoint of the coumarin anticoagulants. You probably already got at the back of your mind another difference. We've said this is a big molecular structure, and that should imply for you, therefore, that it doesn't cross membranes very well, whereas, of course, coumarin anticoagulants do cross membranes fairly well. Another difference between the coumarins and the heparin type of drug is how you monitor the actual enzyme activity, and that's done by partial thromboplastin time, actually activated partial thromboplastin time, APTT, and this is different, obviously, from monitoring prothrombin time. How do you stop the action of a heparin? Well, usually stopping administration is adequate. But if you were pushed into a corner and wanted to use something, you could use protamine, which makes a chemical complex with heparins, and therefore is an example of chemical antagonism. Clinical uses, well, in a strict sense, they're very similar to the uses of the coumarin anticoagulants in terms of the actual principles of use. For example, thromboses, emboli, etc. But because these drugs have to be administered parenterally, either intravenously or subcutaneously, they're not usually desirable for long-term use. And in general, we think of them for rapid and short-term anticoagulation. So in, for example, thromboses or emboli, they may be used with other drugs to prevent coagulation. Certainly DIC, disseminated intravascular coagulation, which is quite common in hospitalized patients, would be an indication. Total parenteral nutrition, you might imagine that the drugs could be given as part of the management of such patients. Various coronary syndromes, acute coronary syndromes like unstable angina would also be an indication, and to protect against thrombus formation following cardiac surgery would be another indication for heparin family. The characteristics of heparin, as I say, is a very large molecule. You don't give it IM, by the way. Intramuscular administration causes hematomas, but you can give it subcutaneously as well as intravenously. It is very low volume of distribution. It really doesn't penetrate tissues very well at all. Its volume of distribution is not much different from blood volume in the adult patient. But it gets metabolized, or perhaps is eliminated in part by absorption into the reticuloendothelial system. It's got a short half-life, too big a molecule to get into the fetal circulation, and in fact that leads to an important point, doesn't it? If you have a patient that needs anticoagulation who is pregnant, then you do not want the bone dysmorphogenesis that you see with warfarin or coumarins, so you put the patient on heparin or a heparin-like compound. What goes wrong here? Well, bleeding, certainly, that would certainly be part of the characteristic. Long-term use has been associated with osteoporosis. Many people actually get a transient and mild thrombocytopenia, decreased platelets. In some patients, however, perhaps because of their immune stasis, they may get a more severe and protracted thrombocytopenia, which would be referred to as heparin-induced thrombocytopenia of a particular type, type 2, for example. Big molecules tend to cause allergic reactions, and that certainly you will be seen in some patients, some form of hypersensitivity response to heparin. And what about the other drugs that are available? Well, partly because of hypersensitivity and partly because of the possibility of thrombocytopenia, people have tried to bring into medicine smaller molecules. These are referred to as low molecular weight heparins. Enoxaparin is a good example of it. The potential advantage of these drugs is actually that they should have a longer half-life and perhaps a less thrombocytopenic action. What seems to happen with them is that they have increased activity against factor 10A and actually diminished activity against thrombin. Actually, you can't use the activated partial thromboplastin time for monitoring the activity of these low molecular weight heparins with any reliability at all. So this can be a problem, actually, because you don't really quite know where you are in terms of the effectiveness of these agents. Usually you like, with any anticoagulant, to be able to say, well, I know where I stand in terms of either thrombin time or partial thromboplastin time. You can't do that with the low molecular weight heparins, and it's thought that a large part of that is due to the fact that a large fraction of the action happens to be on 10A rather than 2A. So that's worth keeping at the back of your mind. Now, low molecular weight heparins have the same molecular structures present in them as would heparin. Therefore, they may not be of great value in a patient who is allergic to heparin. And therefore, we have another drug which is not really a heparin, it's actually a heparan. It's called danaporoid, which can sometimes be used in patients who have had heparin and shown a hypersensitivity response to heparin. Whether you're a low molecular weight heparin or danaporoid, the general mechanism of action is more or less the same. Now, we need to take a look at thrombolytics. Thrombolytics are drugs, sometimes called, by the way, fibrinolytics, that lyse thrombi, or clots, right? And what they do is catalyze the formation of plasmin. Now, plasmin is a fibrinolytic enzyme. It's a serine protease. It's made from plasminogen. And thrombolytics then happen to be clot breakers or clot busters, if that's the phraseology you like. So what you're going to do then is promote the formation of plasmin from plasminogen. Now, the one that is perhaps most well known to us would probably be tissue plasminogen activator, which is a recombinant form, a recombinant DNA form of the natural activator. And so this compound is very, very like the real thing, as it were. Because it is a protein that is like the one in our body, or identical to the one in our body, you're not expecting to see any allergic reactions from TPA. The other term for it is alteplase. It appears to work on fibrin-bound plasminogen rather than plasminogen that's just running around in the blood. And this then has been referred to as clot specificity. That's true, it probably is clot specific, but what is not really have been shown, at least at the clinical level, is that clot specificity makes the drug any better than drugs that are not clot specific when it comes to activating plasminogen. And so we talk about it as clot specific, but the clinical significance of that is sort of marginal. The other drug that you see in the slide is streptokinase. Now, streptokinase is actually not an enzyme. It's a bacterial protein made from strains of Streptococcus. It is not clot specific. It doesn't work on fibrin-bound plasminogen specifically. But what it does is interact with plasminogen and bring about a conformational change in the plasminogen so that it gets converted more readily to plasmin. And that then obviously leads to a decrease in fibrinogen and factors 5 and 8. So this is a compound that is a foreign compound, a bacterial protein. And there is some evidence of hypersensitivity occurring when you use this drug, even though it does a sort of very similar clinical job to tissue plasminogen activator. It is more likely to cause allergic reactions, and there are more strictures on what patients might be suitable candidates for the use of streptokinase. A patient, for example, that has had a history of strep infection fairly recently may well have antibodies setting up a reaction to streptokinase, or a patient that perhaps had been treated with streptokinase earlier on retreatment with streptokinase may actually develop an allergic reaction. The therapeutic uses of the thrombolytics then include thromboses, coronary thromboses, particularly those associated with both myocardial infarcts, deep venous thrombi, pulmonary embolism, and one of the drugs, tissue plasminogen activator, is proven to have effectiveness in ischemic stroke. I think you might predict the adverse effects here. Bleeding, intracerebral hemorrhage would be possible problems that can occur with the thrombolytics. You do have antidotes. We have a number of compounds. Aminocaproic acid and tranexamic acid are two such compounds that might be useful in reversing the action of the thrombolytics. The diagram here is, again, another cartoon just introducing for you the situation regarding the activation of plasminogen by tissue plasminogen activator. The activation plasminogen to plasmin actually occurs at the level of the clot, and therefore it's on the fibrin-bound plasminogen, and this then, of course, leads to formation of plasmin, and the plasmin then works on fibrin to bring about a degradation of fibrin and therefore a dissolution of the clot. Streptokinase is somewhat different. Streptokinase complexes with plasminogen that is not bound, bringing about a conformational change in the plasminogen that facilitates its conversion to plasmin. And then, of course, plasmin does what it's supposed to do as far as fibrin is concerned. We've reviewed the pharmacology of many of the drugs that act as anticoagulants. So we've looked at the coumarin anticoagulants such as warfarin, and I want to remind you again that warfarin is a very important drug for you to know the pharmacology of. It's one of our top 10 in terms of being asked about. We looked at heparins, including heparin itself, the low molecular weight heparins, and the newer drug, danoperoid, heparan. We also examined the thrombolytic or fibrinolytic drugs, including tissue plasminogen activator and streptokinase. Now we have to discuss some of those drugs that work as antiplatelet drugs, therefore interfering with platelet aggregation. In order to understand their actions, remember that the formation of a clot, or the formation of a thrombus, involves initially the adhesion of platelets to some part of the vasculature that has been injured. Having adhered, there is activation of the platelets by many different types of endogenous compound, also by some exogenous compounds. And among the endogenous ones, of course, that come to mind immediately would be thromboxane A2, adenosine diphosphate, 5-HT, thrombin itself. Collagen also is an activator. The drugs that act as antiplatelet drugs, of course, in large part fit into the category of working to inhibit the formation of thromboxane A2 or to oppose the actions of adenosine diphosphate. Following activation of the platelets, there is an increased expression of the receptors that are involved in the final step in cross-linking of platelets. They're referred to as the glycoprotein 2B 3A receptors. The cross-linking reaction that takes place is a cross-linking facilitated by fibrinogen binding to the glycoprotein 2B 3A receptors, and that is the final step in formation of the thrombus or clot. Among the drugs that are antiplatelet, of course, we've already described aspirin as being in that category. I'd like to remind you, of course, about the mechanism here. Aspirin is an irreversible inhibitor of cyclooxygenases in platelets and therefore decreases the formation of thromboxane A2, which is a platelet activator. Remember that in platelets, since they cannot produce their own protein, they've already done so, and they're now, for the rest of their life, are unable to synthesize protein, then this inhibition of cyclooxygenase is permanent. Low doses, a quarter to a half of an aspirin tablet on a daily basis, decreases the likelihood of recurrence of a myocardial infarct, and that was demonstrated quite a few years ago. It also is now known to prevent a myocardial infarct or pre-infarct situation. We use the aspirin in atrial arrhythmias and in transient ischemic attacks. And one use of aspirin that actually is becoming rather important is its use along with agents that are capable of acting as thrombolytics. For example, tissue plasminogen activator has an efficacy that, if you get it into the patient quickly enough, is at least 50% survival. If you also use aspirin at the same time, you can improve that by a factor of about 10%, so that it becomes a 60% survival. So that's another indication for aspirin in an acute situation. The drugs ticlopidine and clopidogrel are blockers of ADP receptors that are present on platelets. So they're going to prevent the activation brought out by adenosine diphosphate. They've generally been looked on as backup drugs to aspirin, certainly in patients who suffer from transient ischemic attacks. That would be a potential indication, post-myocardial infarct, and also particularly in a hospital setting, these drugs have been used quite extensively in acute coronary syndromes, which include unstable angina. Their adverse effects are rather like the adverse effect of aspirin, actually. They can cause problems regarding bleeding. That's a possibility. Leukopenia has been reported in a few patients, and fairly recently, it's been established that both ticlopidine and clopidogrel are associated with the development of thrombocytopenic purpura. I'm not suggesting that particularly will limit their use in a hospital setting, but it certainly is an adverse effect that you might want to use to characterize this class of drugs. We have three newish drugs that have come into medicine in the last perhaps 3 or 4 years, which are antagonists to the glycoprotein 2B A3 receptor, 3A receptor, and this category of drugs is really very novel. One of them is a monoclonal antibody, and that's called abciximab. Another is a snake venom product called eptifibatide, and a third one is called tirofiban. These drugs will prevent aggregation by interfering with the cross-linking reaction. So they have been used in acute coronary syndromes and also in patients undergoing angioplasty to prevent clot formation, as you would predict. They are drugs that usually you think of in a hospital sense. They're drugs that are given parenterally, and they are often used in conjunction with other drugs that might prevent clotting. So we can actually, when we think about our antiplatelet mechanisms, 2 of our sets of drugs oppose activators. For example, aspirin opposes the action of thromboxane A2, and ticlopidine and clopidogrel oppose the action of adenosine diphosphate. And one class of drugs, these drugs that can bind to the receptor, prevent the final step in cross-linking of platelets. Now, I'm going to move from this point into an area that concerns drugs that either resemble hormones or can do things to hormones. In the preparation for an examination and step 2, you get material on endocrines from physiology. You get material to some extent from pathology. I'm going to actually play the role of fitting in the pharmacology, which might not have been brought into play in terms of the physiology component of a review or the pathology component. I don't intend to review all of endocrinology. In exams for step 1 regarding specific questions on drugs related to endocrinology, they represent probably no more than 6 or 7% of a total exam, and many of those actually can be handled quite well by a good fundamental knowledge of endocrinology. However, some aspects of endocrine pharmacology do deserve actual special consideration. I'm going to emphasize those. I start with the hypothalamus because that's where many of our endocrine functions start. And in looking at the hypothalamic principles, several of these have been turned into drugs, as it were. For example, somatrem and somatropin are analogues of somatotropin, the growth hormone, and these drugs are used in pituitary dwarfism and in the management of osteoporosis. Octreotide is an analog of the hypothalamic principle, somatostatin. This is a drug that actually opposes the action of growth hormone or somatotropin, and this then would be useful in patients who suffer from excessive growth hormone with the clinical condition of acromegaly. Somatostatin is also important in the GI tract, acts to inhibit the release of products from various cells that are important in terms of GI function. And in excessive production, for example, of in the case of tumors or in carcinoid of a variety of products that are detrimental to the patient, you can oppose those actions by the use of octreotide. So when we have tumors in the GI tract, including carcinoid, various secretory tumors, you can actually oppose their actions by administration of this analog of a hypothalamic hormone called octreotide. Gonadotropin hormone-releasing hormone from the hypothalamus also has an application, at least in terms of compounds that are derivatives of that particular hypothalamic principle. Probably the most famous one of these would be luprolide. Luprolide and the naphthalines resemble naturally occurring hypothalamic principles, and therefore you might have predicted that since they resemble growth hormone releasing hormone, they should actually cause production of FSH and luteinizing hormone, LH. In actual fact, if you were to administer them in what would amount to a physiological way by small doses intermittently, you will actually increase the levels of those particular gonadotropins, FSH and LH. But perhaps more important than that is the fact that they will work differently if you don't give them in a physiological fashion. If you give them in what is more, I suppose, a pharmacological fashion by injecting them in a repository form, and this is certainly done with luprolide, instead of FSH and LH increasing and therefore enhancing their activity, the opposite occurs. So luteinizing hormone and FSH go down when one uses luprolide in a repository form. This is an anomaly, I suppose, and therefore anomalies are often asked about. I would certainly keep in mind that luprolide does opposite things to what you might have anticipated of an analog of gonadotropin-releasing hormone. That's worth keeping at the back of your mind. As far as the actual gonadotropins themselves in the anterior pituitary, FSH, LH, we don't actually make these compounds from, say, recombinant DNA technology, although I suppose one could. One usually extracts them from various products. The urine, for example, of the postmenopausal patient contains high concentrations of FSH and LH. The extracts of those are referred to as menotropins because they're obtained from a postmenopausal urine. And these products, whether they're from urine or whether from the placenta, as human chorionic gonadotropin is, are used in the treatment of hypogonadal states. They're replacing or supporting endogenous FSH and LH. there is one hypothalamic hormone that is not a peptide, and that is the compound dopamine released from the nerve endings of the dopaminergic nerves of the tuberoinfundibular pathway. Dopamine acts on dopamine receptors in the anterior lobe of the pituitary to inhibit the release of prolactin. And in patients who suffer from hyperprolactinemia, activation of dopamine receptors is one management. And pergolide, a dopamine receptor agonist drug, is the drug of choice currently for the treatment of hyperprolactinemia. Now, insulin release then, we need to know about the steps in this to try and understand some of the actions of the drugs that can promote release. What happens in the pancreatic beta cell is, like many cells in our body, potassium is actually always diffusing outward. See, it's got a high concentration inside because the sodium-potassium ATPase is constantly bringing it in, but it's always constantly running out. You know, cell membranes are more permeable to potassium ions than any other of the ions. So it's always dribbling out, and because of that, it's leaving behind a negative charge, which affords a membrane hyperpolarization. Now, insulin can be released from these cells when you depolarize the membrane. And this is what happens with glucose. Glucose is an insulinogen. What it does is increase intracellular ATP. This increases calcium influx, and the little bit of calcium comes in, a positive charge, depolarizes the membrane, and this leads to the release of insulin. Now, if you can follow that, you can pretty much easily follow what happens when you give a sulfonylurea. The sulfonylurea drugs represent, probably still to the present day, the most frequently used of any of the oral hypoglycemic drugs in diabetes mellitus. It's been estimated, by the way, that about 12 to 15 million patients in the United States suffer from type 2 diabetes. Perhaps 2 million suffer from type 1, by the way. And because of that, about half of them are needing drugs. So if you say, well, somewhere between 6 and 7 million patients need drugs in the United States in at least a semi-chronic way, then I would say that about 2/3 of all those are using sulfonylurea hypoglycemics. So it behooves us to know what the mechanisms are involved in the action. Well, sulfonylureas do release insulin from a partially functioning B cell in the pancreas. And the way they do that is to block potassium channels. So if potassium can't leak out, it stays on the inside of the membrane and ultimately leads to a membrane depolarization. And the membrane depolarization causes insulin release. Now, that's the most acute action of a sulfonylurea. However, the insulin released actually goes over to the A cell in the pancreas, where there are receptors for that insulin, and the activation of those receptors decreases the release of glucagon. Elevated blood glucagon is one of the characteristics of the type 2 diabetic patient. And so what's happening here is by getting more insulin released, you are offsetting the elevated glucagon level that you see in type 2 diabetes by virtue of the insulin working on a receptor that can ultimately then decrease the release of glucagon. Now, these events that we've described take place fairly rapidly. When you continue to treat the patient with a sulfonylurea, there are actually some effects that have a longer latency of onset. With time, perhaps weeks, we see a beginning to increase in tissue responses to insulin, especially the muscle and liver cells. Remember, the three major targets for insulin are muscle, tissue, liver tissue, and fat tissue. 2 out of 3 types of tissue, the insulin receptors appear to be more responsive to the action of insulin that's present in the blood. Now, we're not sure the mechanism of this, but we still like it because this then leads to a lower demand on our bodies for the insulin that we've already got there. And so if we can increase responsivity then that's a very useful property. So it's slower in onset than what we've described under the release of insulin or the effect on glucagon, but it is a valuable property that I would want you to know about. So don't just stop when you say release of insulin. Keep going and try and remember what happens pursuant to that release of insulin. Here's a diagram that shows you the normal situation. Here we have glucose interacting with a receptor on the pancreatic B cell, and what it's going to do is to increase is going to increase ATP. ATP has an action to lead to a closing of the potassium channels, and this is a membrane depolarization, which in turn opens calcium channels. Calcium runs down its concentration gradient from the outside to the inside and causes fusion of the insulin granules with the membrane of the cell, releasing insulin into the blood. Sulfonylureas don't need to go through all that, but sulfonylureas simply block this potassium ion channel, and if you block it, of course, you'll increase potassium intracellularly. So this again leads to an increased insulin release, which in turn on the B cell inhibits glucagon release, and with time, you'll increase insulin receptor sensitivity in both liver and muscle tissues. What about the characteristics of the sulfonylureas? We've had them for over 40 years, and we generally these days talk about first and second generation. We still see use of the first generation drugs. They are less expensive than the second generation. I'm not convinced that you need to know the names of everyone or every property, but certainly acetohexamide, tolbutamide, and chlorpropamide have been used for many years as oral hyperglycemics in the management of type 2 diabetes. Some of the problems with them, of course, include a lot of drug interactions and weight gain, but we'll come to that in a moment. About 15 years ago, they introduced some very highly potent sulfonylureas, which you can usually identify by sort of looking at the first letters in their name. They usually have GLI or GLY as part of their nomenclature. So glipizide and gliburide, etc., are these second generation sulfonylureas. These compounds are much more potent, and therefore when you think about them, they probably have a greater ability to lower blood sugar than would the older sulfonylureas. I would say that if you had a sort of a sense of how they work, that's more important overall than trying to remember the individual details of one that might be useful in terms of modifying dosage if the kidneys are not working, and another one if the liver is not working. You do have that choice between acetohexamide, for example, and tolbutamide. The key feature of chlorpropamide is its long duration of action, which sounds good, except that it's longer than a day. And if it's longer than a day, then it tends to be cumulative in terms of giving daily doses. It also has been associated, particularly this one, with disulfiram-like reactions in the presence of alcohol. Diabetics can, of course, be quite sensitive to alcohol, and a lot of people suggest that they should not consume alcohol. It doesn't seem to stop people much, and this particular drug is likely to cause a severe reaction. As far as the drugs that are the second generation type, I would say that one of them, glipizide, would not be appropriate if you had a patient with poor liver function, and the other one less appropriate in a patient with renal dysfunction. That would be the only distinction between them, I think. You know, if you're looking for a patient subset where one drug would be favored over another one. The problems, well, hypoglycemia. These drugs do lower blood sugar below the norm. They tend to cause weight gain. Of course, any drug can cause weight gain if you're not careful, because, you know, the tendency is that if you've been holding your diabetes by keeping your weight down, now somebody prescribes a drug for you, you get the feeling that maybe it doesn't matter that you keep your weight down so much. And so there is a bit of that goes on in terms of weight gain, but certainly other drugs are not as bad as sulfonylureas in this regard. They're related to the sulfonamides, so they can cause hypersensitivity reactions, and interestingly, we've seen actually some cross-allergenicity between sulfurs and sulfonylureas. quite a few interactions with the first-generation drugs. You know, these first-generation drugs seem to be more sensitive to inhibition of metabolism by drugs like cimetidine, and more easily displaced from plasma proteins by drugs like aspirin or salicylates, or for that matter by sulfonamide antibacterial drugs. And what do you do when you either inhibit metabolism or displace these drugs from the plasma? You enhance the effects, right? And sometimes that effect is enough to make the blood sugar drop so far down that you're suffering from hypoglycemia. Incidentally, always a good idea, though not pharmacology, to know the symptoms of hypoglycemia as well as the symptoms of diabetic ketoacidosis, and know what to do about management of patients there. That's really not pharmacology, but I can tell you that it is often asked about. Okay, next step then is to look at other oral hypoglycemics. A drug called metformin has been around for some period of time. It had a forebear in a drug called fenformin that was taken off the market 20 years ago because of problems of lactic acidosis. Metformin is not a hypoglycemic in the true sense of the word. I think a lot of people like to call it a euglycemic drug. I don't mind what you call it, but let me just tell you that while it will lower blood sugar levels that are elevated towards the normal, it very rarely lowers blood sugar levels below the normal. So I think we can fairly categorically say that hypoglycemia is very unlikely with metformin. That doesn't seem to happen. It's been around for a while, as was fenformin, and we still don't have a very good idea of how it works. We know how it doesn't work. This is one of these negative things. We know that it does not release insulin from a pancreatic B cell, like the sulfonylurea is. That's for sure. It doesn't do that. What it does do, probably, is both sensitize target tissues to the action of insulin and probably inhibit the formation of glucose by inhibiting liver gluconeogenesis. That may be the action of it, but it's not at all clear really how this type of drug works. Suffice it to say, it brings blood sugar that's up down to the normal range. We like that. It does it without hypoglycemia, and in fact without too much weight gain for that matter. So it's been used either by itself or sometimes with sulfonylureas in combination. And the only thing I would draw your attention to is the reminder that one drug very like this called fenformin was taken off the market for lactic acidosis, and this may be a possible side effect of metformin. If it is, it's not common because the drug's been around long enough, but I would keep my eye on things in patients who have, I say, predisposition to lactic acidosis, which would include, by the way, the alcoholic patient. Other oral hypoglycemics, acarbose, I suppose, would fit into that category. Again, it tends to be more of a drug that lowers postprandial sugar levels. This drug actually prevents sugar getting into you at all. So it's working in the gut. It's inhibiting an enzyme that normally breaks down carbohydrates to forms that can be absorbed, alpha-glucosidase. And so you have your meal, and instead of getting absorbable carbohydrate, the meal passes on, and you get only a fraction of the carbohydrate that was present in that meal. So this drug happens to be really very valuable in people who have a high postprandial, post-meal hyperglycemia. If you can decrease the blood sugar following a meal, then really you should help out the pancreas, because you don't really need as much insulin. So you don't get the push, the demand on insulin that you would normally get with an elevated blood sugar. As I said, very unlikely to lower blood sugar below normal level. Can do it, but it's unlikely. What's the penalty you pay for using acarbose? Well, a lot of GI discomfort, including flatulence, diarrhea, and there is evidence of effects on liver dysfunction. Increase in liver function transaminases have been observed, and I would put this down as a drug that you might want to avoid in a patient who is at risk for liver dysfunction. The thiazolidinediones have been very much in the public eye as well as the scientific eye in the last 4 or 5 years. the initial drug to be brought in that was a thiazolidinedione was a drug called troglitazone. And I think in terms of remembering the names, the glitazone family seems to be the way to do it now. We have PO and Rosie, and we had Trog. Trog is gone now. It's been taken off the market. Now, these drugs have been interesting to people because they have an unusual mechanism of action. They bind to PPARs, that's peroxisome proliferator activating receptors. And these receptors are involved in the transcription of insulin-responsive genes. So use of the agents actually sensitizes the tissues to insulin, and it decreases liver gluconeogenesis and also happens to increase insulin receptor numbers. Now, all of these things are in favor of an anti-diabetic action. And in theory, of course, when you've got something that is mechanistically so intriguing, you would like it if the drugs were really good. Well, as it turns out, they are fairly effective in type 2 diabetes. They're less likely to cause hypoglycemia than the sulfonylureas, but they'll still give you weight gain, and there's still some fluid retention, etc. And the most alarming thing about the family, which culminated in the withdrawal of troglitazone in early 1999, was the liver toxicity. This was a voluntary withdrawal because of a large number of patients, well, not large, but a significant number of patients developed liver dysfunction. And I would say that in terms of the thiazolidinediones, pioglitazone and rosiglitazone have not yet demonstrated such liver toxicity. But, I would say that I'd be a bit concerned that they may too resemble the original drug in this regard. Ripaglinide is also a fairly new drug which seems to work very like sulfonylureas. It appears to release insulin from a pancreatic B cell, and it seems to do the same sort of job as the sulfonylureas. This drug has a very short half-life and is largely used adjunctively to actually lower post-meal blood sugar increases. That's the primary use of ripaglinide. Okay, here's a schema showing some of the targets for agents which are used as oral hyperglycemics. Here outside in the GI tract, we have acarbose inhibiting alpha-glucosidase, and therefore we're not producing the glucose that gets into the blood. And then at the level of both the liver and the muscle, we think that the glidazones are working there, and also metformin to do things regarding glucose production. The oral sulfonylureas and the drug we just mentioned, ripaglinide, increase the release of insulin from the pancreas. And all of these things here then will impact in terms of insulin's ability to reduce blood sugar by facilitating the entry of glucose into the target cells. The last bit of what we might call hormone pharmacology that I want to draw your attention to concerns bone and mineral disorders and the use of bisphosphonates in this regard. Vitamin D, of course, has a great deal of value in terms of calcium and phosphate metabolism disorders. I think that's a biochemical aspect of things, and don't see any reason for us to want to review that in terms of our time that we have available. But most people would want to know a little bit more about bisphosphonates because they've become really important, particularly in situations of osteoporosis. A number of drugs have been available for dealing with, for example, Paget's disease. We've had drugs like calcitonin, which has been used in that fashion, that can actually decrease high blood levels of calcium. We have, of course, the use of the loop diuretic furosemide in terms of getting rid of calcium from the blood, very commonly used in hypercalcemic states. But what about the bone? What have you got that helps out in terms of osteoporosis? Well, you've got the estrogens. I mean, we've described that earlier, and we said, yes, estrogens are part of hormone replacement therapy, and these actually do increase bone formation and presumably slow osteoporosis. Well, the bisphosphonates we've known about for at least 30 years. We know that they interact with the hydroxyapatite structure of the bone, and I think we used to think that they were stabilizers, and that was about it. They didn't actually sort of do much to help bone grow, but at least they got in the way of osteoporosis, so they stopped bone degeneration. But that's not particularly the only action. Certainly, we know that you can decrease bone resorption. That's certainly the case. So that actually decreases osteoporosis. But the earlier drugs that were used in this fashion, even though they were shown to have at least a partial effect to delay osteoporosis, did not work for more than about a year, and they actually caused bone mineralization defects. So they really were not that satisfactory. And although we had used them in Paget's, etc., but alendronate came along, which you might know because it's so heavily advertised as Fosamax. Alendronate actually can cause an increase in bone formation, and indeed is a very useful drug in that regard. When used with hormone replacement therapy, alendronate can actually increase more bone to be formed, at least as measured by bone mineral density, BMD measurements. Now that's a sort of an important feature. When you can get something that not only stabilizes and slows osteoporosis, but actually might even reverse it by increasing bone formation, I think that's an intriguing property. It's not necessarily extended to every bisphosphonate, but alendronate seems to be capable of doing that. It's also become the drug of choice for steroid-induced osteoporosis, and that certainly would be, I think, a keeper in your mind in case you should be asked about what to use in that sort of situation other than stopping the use of the steroid. Etidronate, pamidronate, these are the ones that cause bone mineralization defects. There is a problem with alendronate. It's quite irritating to the GI tract, including the esophagus, and has caused ulcers in the esophagus. This is a drug that one tells one's patient when they're using it not to lie down after taking alendronate. In fact, don't even lean back in a recliner because the thing will pull and it will cause irritation of your esophagus. So stay vertical following the oral administration of alendronate. This review of pharmacology for step 1 would not be complete without at least some description of what might be anticipated regarding toxicology. The items that we've discussed regarding the individual drugs, of course, have always had at least one component that concerns adverse effects and toxicity. So one has to be aware that, we've already talked an awful lot about toxicology by virtue of talking about adverse effects or overdoses, these types of things. We have not really talked about, metal poisoning and antidotes in a specific way. And I thought one way of actually providing you with some rather quick way to scan toxicology would be to put together some of the signs and symptoms of toxicity for specific drug groups, and also include with those signs and symptoms the idea of what might be the key interventions that one would apply. I call these little, if you like, summaries, toxic syndromes. And so I'd like to discuss some of those or review some of those with you, and then perhaps a little bit on heavy metal poisoning, and perhaps a little bit on the use of antidotes in toxicology. Overall, on an exam in terms of pharmacology questions, perhaps just 1, 2, 3, 4% would concern toxicological items. It varies a little bit. If you also include adverse of drugs, of course, you can expand that quite a lot. So I'm expecting that you would want to have reviewed our adverse effects as we've been going through the different drug groups. So here goes with our first toxic syndrome. You're very familiar with this. This is a toxic syndrome that I'm repeating for the very simple reason that it's worth it. And I want you to know about the cholinesterase inhibitors like neostigmine and physostigmine and pyridostigmine, and what might happen with overdose of those, which I use clinically. Most cases of overdoses with ACHE inhibitors are not usually with the clinical application of these agents, but with the commercial application of these agents in terms of their use as insecticides. We use both carbamates and organophosphates as insecticides very, very freely in the North American countries, and on occasion you'll see a patient who has been exposed to these insecticides and shows the classical symptoms of acetylcholinesterase poisoning. It's asked about quite frequently on these examinations. So I'm expecting you to know some of the symptoms that you would get by increasing acetylcholine at all sites where it's a neurotransmitter, both in the periphery and the central nervous system. So all you have to say to yourself, of course, is our usual word here in terms of our features of dumbbells. So cholinesterase inhibition goes along with dumbbells, the diarrhea, the urination, the meiosis, the bronchoconstriction, the excitation both in the brain and at the skeletal muscle, the lacrimation, the salivation, and of course the sweating. So dumbbells it is, and I'm hoping you can pick that up in a clinical vignette. What are you going to do about it? Provide respiratory support, and you're going to use atropine in terms of the offsetting the muscarinic receptor stimulation, and you're going to use the regenerator of the enzyme pralidoxime or 2-PAM to see if you can't push the organophosphate off acetylcholinesterase. The second toxic symptom, again, relates back to autonomic pharmacology. What happens when you block muscarinic receptors? How's that going to come about? Well, it can come about from any of the clinically useful muscarinic blocking agents in excess, from atropine through to benztropine, etc. It can also come about because many drugs that are not conventionally categorized as a muscarinic blocking drug happen to have such properties. Let me illustrate. Diphenhydramine, the antihistamine, in overdose causes marked muscarinic receptor blocking action. Diphenhydramine is an over-the-counter drug. Many muscarinic blocking drugs are present over-the-counter, or at least let me change that. Many drugs that have muscarinic blocking activity are available over-the-counter. You know tricyclic antidepressants have muscarinic receptor blocking action, and that can be contributory to their adverse effects well. And I mentioned to you that plant products often contain muscarinic blocking activity. In fact, the very plant belladonna gave the name, of course, originally to this whole class of drugs in terms of atropine. Atropa belladonna. And also the seeds of Jimson weed. So look for increases in heart rate and blood pressure because you're blocking muscarinic receptors. You can't sweat. Now remember that the sweating is a muscarinic receptor activation, but it is through the sympathetic nervous system. This is that one big exception where we said it's sympathetic in terms of innervation, but cholinergic in terms of the interaction with receptor. So you're going to have a hot, dry skin. You're almost certainly to be delirious and throwing hallucinations, and what you're going to do about it is largely symptomatic in terms of controlling cardiovascular symptoms, the hypothermia, bring the body temperature down, and possibly the use of the cholinesterase inhibitor physostigmine. Why physostigmine and not neostigmine? Neostigmine won't cross the blood-brain barrier. See, it's a quaternary amine. Physostigmine will. It's a tertiary amine. So that would be the more appropriate drug in this instance. CNS stimulants, well, we tend to expect anxiety and agitation with such drugs. They're often very likely to cause a warm and sweaty skin. Hypothermia can sort of occur. I told you to look in the patient's eyes. Mydriasis is very characteristic of overdose with a CNS stimulant, as would be sympathetic stimulation, increased heart rate, increased blood pressure. And central nervous system effects, well, very bizarre behavior on many instances, and in real gross overdose, quite likely to see seizures. So you're going to control the cardiovascular symptoms, bring the body temperature down, use anticonvulsants if they are needed, quieten the patient with probably parenteral benzodiazepines or possibly even antipsychotic drugs. So this is what you can anticipate with CNS stimulants like amphetamine and overdoses of methylphenidate, a number of drugs that would fit into that category. Opioids, remember, these are downers. They cause sedation and lethargy. They'll lower blood pressure and decrease heart rate. Hypoventilation occurs, and this is what ultimately leads to death in terms of respiratory failure. They all, with the exception of meperidine, cause meiosis and will put you into a comatose state. Ventilatory support is very important here. And of course you have naloxone. Naloxone's the opioid receptor antagonist, has a short duration of action, IV, and therefore you have to give it more than once. SSRIs, the serotonin syndrome, agitation, confusion, hallucinations, muscle rigidity and hypothermia. Heart rate goes up, blood pressure goes up, and you throw a seizure. What causes the serotonin syndrome? Well, in general, you have to have as one component an SSRI. Obviously, that's the type of drug that blocks the reuptake of serotonin. But many other drugs can be contributory to that. The first that was demonstrated clinically was an MAO inhibitor, phenolzine. I would take it that most MAO inhibitors would do that. Subsequently, tricyclic antidepressants were shown to cause the serotonin syndrome when used with an SSRI. We've seen it with meperidine. We've seen it with diphenoxylate. We've seen it with MDMA, ecstasy, etc. So there's quite a lot of drugs there that can do that. How are you going to handle it? Well, again, symptomatically in terms of the hypothermia, anticonvulsants if you're throwing a seizure. Cyproheptadine, a serotonin antagonist, has also been used here because obviously you're getting excessive serotonergic activity. And other drugs that might quieten the patient, the antipsychotics or the benzodiazepines, would possibly be alternatives here. Aspirin we've dealt with hitherto in terms of the symptoms of overdose toxicity. We have this rather bizarre set of circumstances which include, a metabolic and respiratory types of effects on acid-base balance and electrolytes, and really one has to look at the individual patient to know precisely what it is that you will do in that regard. One thing you will do is make sure that you have good ventilation and that the patient does not get so hot. You'll bring the temperature down. You'll readjust electrolytes. You'll readjust the pH in the blood. And if you can, you will try to get rid of salicylates. And you can do that by changing the pH in the urine. If all else fails, you can use hemodialysis, and that pulls out salicylates as well. But certainly this can be life-threatening because of the very marked effects on acid-base balance. Tricyclic antidepressants, I mentioned earlier that we get the symptoms of the 3 C's, the cardiotoxicity, the coma, and the convulsions. These are tough drugs in overdose because they've got so many different pharmacological actions. They block alpha receptors, they block muscarinic receptors, they lower the seizure threshold, they are cardiotoxic, prolonging the QT interval, quinidine-like action on the heart, and the outcome with overdose is not always predictable here. So once again, we're really dealing with symptomatic management. The hypothermia that comes from muscarinic blockade has to be handled, the seizures have to be handled, and of course any changes, for example, in cardiac function may need to be handled, including possible antiarrhythmic drug use. The summary of toxic syndromes is shown in the text under item section 8-6, and you can review that at your leisure. Now, what about heavy metal poisoning? As a general rule, there are sort of 4 heavy metal poisons that people want you to know about. Arsenic sometimes and mercury sometimes. I'm going to suggest actually put most of your effort on iron and lead poisoning. Lead is always a very likely thing to come up. Iron comes up, not commonly, but when it does come up, it's most frequently seen in children. Children get into mum's supplementary iron tablets, And when they ingest just a few of them, they can have very marked effects on the GI tract. You may be up to actually even make the diagnosis by seeing what's happening in terms of what's coming out of their mouth. If something blue is coming out of their mouth, tinged with red, perhaps blood, and perhaps even coming out the other end of the body, then you could make a pretty good presumptive guess that the kid had been swallowing iron tablets. Get them out if you can get them out, obviously. We have clearly a life-threatening situation here, depending on how much iron has come in, because this necrotizing, bloody diarrhea with hematemesis, which is throwing up blood, etc., shock-like state, dyspnea, etc., coma is life-threatening. So again, try to get the drug out, try to do what you can in terms of symptomatic management, and your antidote is deferoxamine, known commercially as Desferal, a chelating agent that can bind to iron and hopefully prevent iron from inhibiting the multiple enzymes in our cells that it can interact with. Lead is a good one to keep your eye on. Lead poisoning is quite common, much more common actually than iron poisoning. And the reason I think it's of interest for examinations is because it has multi-system effects. Here you've got your chance to see changes in heme synthesis, because iron certainly can do that. It inhibits there. Here you've got your chance for patients who have wrist or foot drop because of the peripheral neuropathy that lead poisoning leads to. Renal damage, the proteinuria, the failure, etc., liver damage, hepatitis, and of course in children that are exposed to lead during their development, we see the problems of mental retardation. The term pica, you may recall, is often associated with lead poisoning. Its actual literal meaning is the ingestion of non-food substances, and it's usually applied to the idea of a child, picking paint off a window, painted window, and putting it in their mouth. And although we've not used lead-based paints in the United States for 40 years, there are plenty of our buildings that still have lead-based paints at the bottom of a series of paint coats, and they can pick that off and swallow it, and lead gets into the body and can cause very marked effects on mental development. Also, lead, especially lead that turns up in the water supplies, is dangerous from the standpoint of decreasing fertility, and when you do get pregnant, there may be a greater incidence of stillbirths. So I think this is a nice test item, lead poisoning. So refresh your memory about that. What are you going to do about it? Well, at least in children, you're probably going to consider Suxima. Suxima is a form of dimercaprol, or BAL, that actually is orally bioavailable, and that's a reasonable thing to give to a child who's suffering from lead poisoning. Dimercaprol will probably be used in the adult patient who suffers from lead poisoning. And so what I would suggest you do is check out items 8-7 in the text, because I've summarized the features of lead poisoning and other heavy metal poison for you there. The last section of which we intend to do are antidotes. There are a number of situations where you might just get one question and all of a sudden they ask you the antidote for a particular type of situation. So I always suggest to people that they actually know this by rote. And I start with activated charcoal. You could almost guess that activated charcoal would be very good for nearly all oral poisonings. And that's true. But the things that it won't work on, number one, is iron. It doesn't work in iron poisoning. It doesn't work in cyanide poisoning. Now, if you refer back to where we were discussing nitrates, by the way, you'll see what it is we do in cyanide poisoning. Do you remember? We looked at nitrates and the use of nitrates to form methemoglobin, which binds cyanide. So I have no intention of going over cyanide again. I'm just pointing you backwards to, if you want to look at cyanide poisoning and its management, there it is under the cardiovascular drugs, under nitrates. Lithium won't be taken out by activated charcoal, and nor will acids or alkalis or corrosives, etc. But that leaves an awful lot of drugs, doesn't it, that might be bound by activated charcoal. Well worthwhile considering. Well, acetaminophen, That's acetylcysteine or mucomyst. That's the antidote for poisoning to prevent or to offset the liver toxicity. Deferoxamine, iron or iron salts, that's a fairly standard thing. Dimercaprol would be used in lead poisoning, but also if you were thinking of using guesswork here, you could add a few other things in there like mercury, arsenic and gold. Succimer for mild lead poisoning, and usually in children, that's the agent that you would use. The use of EDTA is quite common in metal poisoning. Actually, I would say that this is more active in terms of a range of metal poisons than any other type of chelating agent. This is ethylene diamino tetraacetic acid, EDTA, and has to be used parenterally. And I suppose if you were into the guessing game and couldn't remember a chelating agent, you'd have a better chance, really, of saying, well, I'll use EDTA than perhaps, if you didn't know at all. Oxygen, well, that's an antidote for carbon monoxide, isn't it? Carbon monoxide poisoning from heaters in winter months, etc., is quite common, or from the back of exhaust of a car is quite common, and forms carboxyhemoglobin, and it behooves us to get oxygen in, even at positive pressures, to actually change that situation and revert to the oxygenated form of hemoglobin. Penicillamine, we mentioned that drug under the area of drugs that might be useful in rheumatoid arthritis, but its famous position, of course, is as cupramine. Cupramine chelates copper, and it would be used in copper poisoning and in Wilson's disease with elevated copper. It doesn't restrict itself to that particular iron or metal, but certainly that would be the one I'd pick out first. So once again, if you want to see a summary of these things, they're in Table 8.8 in the text. Now, we're going to cover very briefly, but still importantly, some of the drugs used in the management of the hyperlipidemias. As you probably remember, if we have unusual levels of certain lipids in our blood, this tends to predispose towards atherosclerosis and coronary heart disease. And in particular, if we have elevations in low-density lipoprotein cholesterol, very low-density lipoprotein cholesterol, triglycerides, these are all associated in the long term with atherosclerotic disease and its consequences, and also reductions in high-density lipoprotein cholesterol, the so-called good cholesterol, is also associated with atherosclerotic disease. And you would predict then that if you're managing a patient who has unusual lipid patterns in their blood, that what you're trying to do is to bring things back into a more normal state, if you can, by dietary modifications. But in many cases, of course, we now resort to drugs to be able to do that. The principle behind drug treatment of hyperlipidemias is, of course, to decrease mortality, because just running around with high blood lipids in your body under normal circumstances is not really particularly noticeable. But you should recognize that if you start drug management of patients who have hyperlipidemias, it may be very difficult to discontinue such drug treatment. What we found, in the area of using such drugs is that it might be not only indefinite, but perhaps even a lifetime commitment to pharmacology if one's going to do that. The types of drug that we're going to look at include drugs that work at the level of the GI tract. These are generally called bile acid sequestrants. I'm thinking here of cholestyramine and cholecystipol, etc. Drugs that work at the level of the liver, particularly, and this includes drugs that inhibit the synthesis of cholesterol, the Hmge-CoA reductase inhibitors, and drugs like niacin or nicotinic acid, which can also interfere with lipid biochemistry in the liver, and then drugs that work out in the periphery, most notably those that actually activate lipoprotein lipases. And the best example of that one, and the one I want you to remember the name of, would be gemfibrozil. Now, the next slide shows a listing of lipid disorders with some of their characteristics. We class the different lipid disorders 1 through 5 with some subdivisions, and what I've done in the table here is sort of point out what the names are and what the laboratory findings are with respect to individual lipid disorders. As far as the right-hand column is concerned, which is the primary pharmacological interest here, recognize that in many cases more than a single drug has value in the management of hyperlipidemias. And there is not, in most cases, a clear-cut situation where we would say such and such a drug is the drug of choice for that particular lipid disorder. I would say that if you look at the different drugs that are in that column there, that you should say to yourself, well, I'm perhaps more interested in which drugs might not work rather than which drugs do work. Remember this, that in this arena, simply showing that you have the appropriate changes in blood lipids does not always correlate well with the actual outcome of changing those lipids in the sense of morbidity and mortality. It takes a lot more study before you're fully convinced that it's worthwhile to change blood lipids, and in fact it's only in the 1990s that we've actually got very good evidence that some of these drugs, perhaps most notably the statin family, actually has value in that regard. Bile acid sequestrants, like cholestyramine, for example, prevent the reabsorption of bile acids. Now, normally, you see, we reabsorb 95% of our bile acids, and as it's reabsorbed and gets back into the liver cell, the bile acid inhibits its own synthesis. It's a feedback inhibition at the level of an enzyme called 7-alpha hydroxylase. So you don't need to keep making it, you can keep using it again under normal circumstances. But what if you stop its reabsorption, as you do by these sequestration agents? Well, that means that the enzyme 7-alpha hydroxylase starts to work faster. And when it starts to work faster, it makes new bile acids from cholesterol. So the level of cholesterol in the liver goes down. And that nearly always precipitates an increased formation of high affinity, low density lipoprotein receptors that bring lipoproteins back into the liver from the blood. So this decreases LDL in the plasma, which is a favorable event because high LDLs are associated with atherosclerosis. So this is the basic biochemical mechanism of the bile acid sequestrants, and they're very, I suppose, effective in the sense that they work in many of the lipid disorders, but they would not be a drug of choice for hypertriglyceridemias because, you see, they tend to increase VLDL and triglycerides. This is certainly a limitation to the use of these agents. There are some practical limitations as well as theoretical ones regarding gastrointestinal problems, a feeling of bloating and constipation, for example, which on a day-to-day basis is not something that you like to continuously have. And there are quite a few drug interactions because bile acid sequestrants can also sequester drugs, particularly acidic drugs. Among the drugs that we've already sort of mentioned, digoxin and thiazides have been mentioned as far as important drugs that might be used in patients, for example, have cardiovascular dysfunction. Warfarin has been mentioned as a drug that's needed because of its anticoagulant properties. Clearly then, these would be drugs which have their effects diminished by inhibition of their absorption if they're sequestered by drugs like cholestyramine. Hmge-CoA reductase inhibitors work at the level of inhibiting the synthesis of cholesterol, and as such then, they too would lower cholesterol levels in the liver. That leads to, again, increase in LDL receptors and therefore a decrease in plasma lipids, particularly LDL. We also know that they inhibit the synthesis of VLDL and apoprotein B. They can also cause small increases in HDL, and most of them actually cause only small decreases in triglycerides. But one of them, atorvastatin, is actually the most potent at lowering plasma triglycerides. in the sense of this biochemistry of these drugs, I think we need to know what happens to the lipids, but you should also recognize that possibly part of their efficacy in the long term might also relate to vasodilation, because they increase nitric oxide and they also inhibit the formation of endothelin-1. They decrease its messenger RNA, and endothelin-1 is a very potent vasoconstrictor. I would say identify statin family, know that they can cause GI effects, but perhaps the most distinctive toxicity concerns the muscle, the myalgia or myopathy, which can be monitored by looking at creatine kinase levels, for example, fairly characteristic here. Rhabdomyolysis might be an extreme, if you like, example of muscle toxicity, and recognize that's more likely to occur in the presence of other drugs that might also be used for hyperlipidemias. Gemfibrozil is an example, and niacin is an example. There is some liver toxic potential. Might be worthwhile looking at liver function transaminases, and if you see any elevation of the LFTs, that might be a reason for discontinuance. Patients who already have pre-existing liver disease perhaps are not ideal candidates for the statins. And recognize that inhibitors of the metabolism of the statins, including P450 inhibitors, and even constituents of grapefruit juice, by the way, can actually sometimes enhance the effects of the statins by inhibiting metabolism of those drugs. A few patients have reported, or there has been reported for a few patients, a lupus-like syndrome occurring with certain of the statins. Nicotinic acid, or niacin, is an interesting compound because it is available, of course, without a prescription. This is a drug that inhibits the synthesis of VLDL and its apoprotein in the liver, and once again then is going to decrease plasma lipids by that mechanism. In particular, it's really very good at decreasing VLDL, but it will also work on most of the other plasma lipids, including triglycerides. It's actually the best drug for increasing HDL cholesterol. So if you had a clinical vignette where a patient's only problem really is a low HDL, this might be the drug of choice under those circumstances. Patients will complain about the flushing and itching sensation they get. Sometimes you can relieve that by aspirin or NSAIDs. Gouty patients might not fare well because of hyperuricemia. Hyperglycemia can occur, which is a rather distinctive feature and might predispose towards the idea that the patient has diabetes. Liver toxicity has occurred, including necrosis of the liver, and this is one of the drugs that you'd keep your eye on in terms of people complaining about GI problems, acidity, because it does cause GI ulcers. Lastly, gemfibrozil. Gemfibrozil is an activator of lipoprotein lipase. It increases metabolism of VLDL and intermediate density lipoprotein, so your blood levels of the lipids go generally in the right direction. In particular, this is a drug that we think of in the hypertriglyceridemias. It does a pretty good job on bringing down triglycerides. It's not without its adverse effects, however. GI distress is quite common. Rashes are not uncommon either, and gallstones occur with use of gemfibrozil. Hypokalemia and other electrolyte disturbances have been described, and there have been a few drug interactions. Warfarin and the drugs used orally in diabetes, the sulfonylureas, may have their actions potentiated when used in conjunction with gemfibrozil. This figure then describes the basic targets, if you like, for the different drugs that can influence lipid synthesis. For example, you can interfere with the absorption of the bile acids by using cholestyramine and other bile acid sequestrants. You can interfere with the formation of mevalonic acid and hence cholesterol by Hmge-CoA reductase inhibitors. These are the so-called statins, of which I believe there are 9 clinically available. Niacin interferes with VLDL formation particularly, and gemfibrozil activates lipoprotein lipases, which will reduce the level of VLDL. So mechanistically, I think the diagram is a good review point for you. In reviewing the drugs that have actions on the central nervous system, we consider that in most step 1 examinations, about every 6th or 7th question in pharmacology would probably be something to do with CNS drugs. Not all of the areas of central nervous system pharmacology have equal importance for us, and I'll do my best to point out to you during our review of which areas I think are of the greatest yield in terms of your preparing for the exam, and which perhaps are much less important. We're going to start by considering aspects of neuronal excitation. This is sort of a bit physiological, but I think it will be helpful for us. If you're imagining how we change neuronal activity, I'm sure we all have to say, well, it's because we change ion flux. And ion channels obviously are very important in terms of neuronal activity, and many of such ion channels actually can be regulated by neurotransmitters. For example, if you imagined how you would bring about a membrane depolarization, which is going to be an excitatory event as far as a neuron is concerned, one of the ways you could do that would be to open ion channels to sodium, so that sodium runs down its concentration gradient, taking a positive charge with it, and that opening of the sodium ion channel, allowing such influx, is quite excitatory. On the other hand, you could also imagine that since potassium is flowing out of cells all the time, if you prevented the efflux of potassium, then a positive charge would also appear on the inside of the membrane, and that again is tantamount to a membrane depolarization. What about inhibition of neurons? Certainly opening a chloride ion channel, allowing chloride to run down its concentration gradient into the cell, carrying a negative charge, would be inhibitory, and that would lead to membrane hyperpolarization. Likewise, enhancing the efflux of potassium, it's always going out, remember, but if you made it go out faster, then that would also be an inhibitory action through membrane hyperpolarization. Now, if we then turn around and say that such ion channels can either be regulated by voltages, and certainly we've described before some of the voltage-regulated sodium channels that occur in excitable tissues, such as the heart, or it could be regulated by neurotransmitters. And in thinking about transmitter compounds, we would say that in some cases, transmitters, when they interact with their receptors, have a direct coupling to an ion channel. And in other cases, when receptors are activated by a transmitter, they actually go through mechanisms that involve second messengers, which in turn then, via phosphorylation events, will change ion flux. The figure that you see has two of the examples of ion channels that can be molecular targets for central nervous system drugs. The top part of the figure represents an ion channel that is perhaps controlled simply by changes in voltage on the membrane. A good example would be the sodium ion channel responsible for axonal conduction. When we conduct a nerve impulse along an axon, you may recall that changes in membrane potential sequentially allow for the opening of sodium ion channels, and sodium can run down its concentration gradient, taking a positive charge into the cell, and that is a depolarizing event. Likewise, we can imagine such situations where calcium ions can also go through voltage-dependent ion channels, and this would be very true of many presynaptic membranes, where the voltage change at a presynaptic membrane, permitting calcium to run down its gradient from the outside of the cell to the inside, would actually bring about a fusion of vesicles with the presynaptic membrane, allowing for the release of neurotransmitter. Now, among the drugs that we think of most importantly in the area of agents that will work on this type of target would be a number of the anesthetic molecules and certainly some of the anticonvulsant drugs. So in thinking about voltage-regulated ion channels, as far as neuropharmacology is concerned, we generally think about anesthetics and anticonvulsants. Now, we also said that we can open ion channels by neurotransmitters that are directly coupled to the ion channel via their receptors, And so we have a little diagram here showing a neurotransmitter interacting with a macromolecule in the membrane, which is coupled directly to an ion channel, allowing for movement of ions across this type of system. Now, among the different neurotransmitters that are directly coupled, we have to consider gamma-aminobutyric acid. We have to consider the excitatory transmitter glutamic acid, the inhibitory transmitter glycine, and certainly many targets for acetylcholine, of which nicotinic receptors would be a very good example. So when you then turn around and say, well, what drugs seem to work on these systems? Once again, anesthetic molecules would be a possibility, as would certain of the anticonvulsant drugs. Thinking of nicotine and other cholinergic drugs, which are presumably working through this type of receptor, and certain of the sedative hypnotics and anticonvulsants will also work on such systems, most notably those coupled to gamma-aminobutyric acid. Now, ion channels and receptors can also involve G proteins and second messengers. And so this next slide demonstrates a model for this, where we have a receptor to a neurotransmitter that is coupled through a G protein, which can change second messengers. Now, our most well-known second messengers from autonomic pharmacology are well represented here again, cyclic AMP and inositol triphosphate and diacylglycerol, and also calcium can be thought of as a second messenger as well. And these types of second messengers are responsible for protein phosphorylation, and it's the protein phosphorylation, presumably of proteins intimately connected with the ion channel, either activate or inhibit the ion channel function. And these actions then are brought about through biochemical second mechanisms, and there is even some evidence of long-term effects as well as the more rapid onset effects. What transmitters seem to go through this type of system in the central nervous system? Well, many of them. Certainly acetylcholine, dopamine, norepinephrine, serotonin, the opioid peptides and possibly other peptides. These are all going through receptors that are coupled to second messengers. And as such, then these systems, these neurotransmitter systems, become targets for many different drugs. I'm thinking here of the analgesic drugs like the opioid analgesics, morphine, meperidine, codeine, etc. I'm thinking about drugs useful in the treatment of major depressive disorder, drugs useful in the treatment of psychoses such as schizophrenia, and drugs that are useful for the alleviation of anxiety states. So these three sorts of system are the systems that we're going to be talking about when it comes to individual drug actions on the central nervous system. Now, before we can talk about the individual drugs, though, I think it might be worthwhile to remind you about the different types of neurotransmitter present in the central nervous system and what their functions might be. I start with amino acids in large part because these are actually, in terms of quantity, in the sense of regions of the brain, quantitatively, most neurons in the brain seem to have receptors for glutamic acid. Well over half of our neurons can be responsive to glutamate. Now, glutamate, in the biochemical terms, of course, is an amino acid that can be used for protein synthesis and can be oxidizable for energy, etc. That's probably true in the brain as well. But in the brain, glutamate has a very special role. It is a very commonly used excitatory neurotransmitter, and in actual fact can increase the influx of cations, like sodium, for example, by a direct coupling mechanism. There are a number of different receptor subtypes for glutamic acid. The one that I usually advise people to have heard of is a receptor subtype called the NMDA receptor. That stands for N-methyl D-aspartic acid. Now, we don't have any D amino acids in our bodies, so you can immediately then say, this must be a tool that neuroscientists use to characterize receptors. And you'd be quite right. That's in fact the case. But the NMDA NMDA receptor seems to be rather important for us in pharmacology. It probably is also important in neuroscience because a lot of people believe that's related to consolidation of long-term memory, for example. A lot of people believe that the glutamate NMDA receptor is responsible for damage to neurons when you have a stroke or ischemic damage in the brain. But in pharmacology, not that we have very many drugs, but we have two rather interesting drugs that appear to be blockers of the NMDA receptor. One of them is an anesthetic called ketamine, a very unusual anesthetic drug, and we'll deal with that a little later. The other is the psychotomimetic drug, phencyclidine, or PCP. Both of these drugs happen to be capable of blocking NMDA receptors, and at least a part of their neuropharmacology seems to be expressed in that way. Now, like glutamate is an excitatory transmitter, gamma-aminobutyric acid, or GABA, is an inhibitory neurotransmitter. And it can inhibit neurons by one of two ionic mechanisms. It happens to have more than a single receptor subtype. The subtype GABA-A receptor is coupled to a chloride ion channel, and activation leads to chloride running into the cell, which leads to hyperpolarization. And the GABA-B receptor is coupled to a potassium ion channel, whereby activation leads to an increased efflux of potassium, which again would be tantamount to hyperpolarization. Now, in the context of GABA-A receptors particularly, we know that many anticonvulsants can work to facilitate the actions of GABA. Certainly sedative drugs can do that. Many sleeping pills or hypnotic drugs can do that, and so can muscle relaxants. So we have an awful lot of drugs here that seem to help out GABA, facilitate the inhibitory actions of GABA in the brain. Acetylcholine is, of course, not an amino acid, but an amine, a quaternary amine, and we've described acetylcholine certainly at some length in terms of autonomic pharmacology. In the brain, the dominant type of receptor for acetylcholine is an M1 receptor. You may recall that M1s are not very common in the periphery. They are in the GI tract, but usually we think of M2 receptors in the heart and M3 receptors in most peripheral tissues. But here we've got M1 receptors as the most dominant type of receptor. This is a receptor which, upon activation, excites neurons, and it can do so by decreasing the efflux of potassium, allowing potassium to accumulate on the inside of the cell, and this is a coupled system because it involves changes in phospholipase C activity, leading to an increase in diacylglycerol. M2 receptors, see, they're not only in the heart, M2 receptors in the brain are inhibitory. And these inhibitory actions are brought about by increasing potassium efflux. But it's a different second messenger. This second messenger is a second messenger coupled negatively to cyclic AMP, and this then is a mechanism that is quite distinctive from the mechanism involving phospholipase C. So we have muscarinic receptors that are coupled through G proteins of opposite sorts, and we have nicotinic receptors that are not coupled because they're directly linked to cation channels, most notably sodium channels, and therefore sodium influx occurs, which is going to be excitatory. Now, in thinking about drugs that can affect these channels, well, by definition, nicotine must be affecting nicotinic receptors in the central nervous system. But our acetylcholinesterase inhibitors are also going to influence cholinergic function in the brain, and certainly that would be one of the reasons why we use acetylcholinesterase inhibitors in Alzheimer's dementia, Alzheimer's disease, because it appears to increase acetylcholine, and that is a deficiency, particularly in Meinert's nucleus. As far as the usefulness in Parkinson's disease is concerned, muscarinic blockers are used there, drugs like benztropine, because you want to offset the imbalance that's brought about in Parkinson's disease by a loss of dopamine leading to an excessive amount of acetylcholine. And if you can decrease the actions of acetylcholine at muscarinic receptors, you have a potential therapeutic strategy. Dopamine and norepinephrine are catecholamines. We've mentioned both of these compounds under autonomic pharmacology. In the brain, dopamine is inhibitory. There are multiple subtypes. The subtypes are generally considered to be G protein linked to cyclic AMP. Only one of them, by the way, is an excitatory, I'll put it this way, only one of them involves an increase in cyclic AMP. Most of them seem to involve decreases in cyclic AMP. And these are targets, the systems that involve dopamine, for a variety of drugs that are CNS stimulants. Amphetamine, for example, can act to cause release of dopamine, and as you would predict then, some of the actions of amphetamine, as well as concerning norepinephrine, actually do concern dopaminergic function. The use of levodopa in Parkinson's disease is an obvious clinical application of knowing about dopamine in the brain, and you should also know that there are many effects of antipsychotic drugs that seem to be expressions of their ability to block dopamine receptors. So you are decreasing dopaminergic transmission when you think about drugs like haloperidol or chlorpromazine in terms of their use as antipsychotic agents. Norepinephrine is distinctive in the sense of the central nervous system. The tracks for norepinephrine are quite different from the tracks for dopamine. Even though dopamine is a precursor of norepinephrine, they have very different neuronal pathways in the brain. Most of the cell bodies for norepinephrine neurons are present in the locus ceruleus or the lateral tegmentum. And again, there are differences in terms of the role of norepinephrine in the brain. Norepinephrine can be either excitatory or inhibitory. Alpha-1 and beta-1 receptors in the brain lead to excitation, and alpha-2 and beta-2 receptors in the brain lead to inhibition. And most of these actions are coupled to second messengers. Why are we interested in norepinephrine in the brain? Once again, because of the actions of central nervous system stimulants. So if we're thinking about drugs for attention deficit disorder, for example, like methylphenidate, or you're thinking about amphetamine, you're thinking about cocaine on occasion, then you would say, yes, this is a group of drugs that might influence norepinephrine function, largely by increasing the activity of norepinephrine in the brain. Likewise, the use of antidepressant drugs, like tricyclic antidepressants such as amitriptyline, is thought to, at least in part, involve an increased functional activity of norepinephrine in the central nervous system. A number of anxiolytic agents also fit into this category. Serotonin is not a catecholamine. Serotonin is an indole alkylamine, 5-hydroxytryptamine, 5-HT. This too can be excitatory or inhibitory. It reminds you a little bit of norepinephrine. And also, by the way, it's got very discrete pathways in the central nervous system in terms of where the cell bodies are. Most of the cell bodies for serotonin are in the RAF nuclei. But interestingly, one neuronal cell body can make as many as 1 million connections with other neurons. So if a neuron gets excited at all, then a lot of other neurons hear about it. There are at least 15 different subtypes of receptor for serotonin. I'm going to describe some of these for you a little later outside of the realm of CNS pharmacology because this is an important drug group of drugs that work on serotonin. This is sort of high yield. But as far as the central nervous system is concerned, most of the types of receptor for serotonin are coupled to second messengers, other than one. And you might as well distinguish that now. It's called the 5-HT3 receptor subtypes. What drugs work here? CNS stimulants, antidepressants, anxiolytics, etc. So clearly we need to know a little bit about serotonin in the brain to really try to understand some of our CNS drugs that are very important. Opioid peptides. Well, there are a lot of different peptides in the brain that appear to play either transmitter or neuroregulatory roles, but for pharmacology, our most interesting ones are the ones that are appeared to be classified as opioid peptides. I'm thinking here of met and leuenkephalin, dynorphin, and of course beta endorphin. The peptides of this class tend to be inhibitory to neurons. Once again, there are several receptor subtypes. We'll need to describe those for you because different opioid analgesics have different actions on these subtypes, and they're coupled to second messengers. And our most important drug group in this arena, of course, are the drugs that we would call, by definition, opioid analgesics, and this is the morphine family. All right, so that allows me then to move to another pharmacological drug group, the anticonvulsants. Now, there are overlaps between different CNS drug groups. We already can see that because you've just been talking about, or we've just been talking about, GABA, and therefore the actions of drugs that work through GABA, which do include benzodiazepines and barbiturates. And certainly this is a mechanism of action that has great relevance to decrease in neuronal activity. I mean, if you can increase inhibition by helping out GABA, then obviously it's more difficult for neurons to fire spontaneously or to, generate a pattern of excessive neuronal activity. That's certainly one way to do it. If you were to block sodium channels involved in axonal conduction, that would be another mechanism of an anticonvulsant drug action, and we have several of our very important anticonvulsants that are very good at doing that. I'm thinking particularly of drugs like phenytoin and carbamazepine in that arena, but other drugs can do that as well. Remember, we just said that the barbiturates, higher doses, probably block sodium channels as well. So, there's clearly the possibility of that as a mechanism of anticonvulsant action. And of course, we also have the possibility selectively of effects on calcium ion channels. Two of our most important drugs used in absence seizures, valproic acid and ethosuximide, appear to decrease the voltage-dependent passage of calcium into neurons present in our thalami. They're actually working on type T channels, which are fairly rare in the periphery, but certainly fairly well known in thalamic neurons. The T is not for thalamus, but it might help you remember it anyway. The T is really for the kinetics, transient kinetics of opening of that calcium channel. So we've got three mechanisms that seem to involve, movement of ions. If you can help out chloride going in, that's not a bad idea, and benzodiazepines and barbiturates do that. If you can stop sodium going in, that sounds right too. And if you can stop calcium going in presynaptically, that seems to be a useful property as well. Another way we can think about things is, what about if we got in the way of an excitatory transmitter? Would that have any value? Yes, it ought to. In fact, we know that some newer anticonvulsant drugs, most notably lamotrigine and topiramate, and to some extent felbamate, seem to get in the way of the excitatory transmitter glutamic acid. This is going to become more important, obviously, but the trouble with glutamate in terms of it being a target for drugs is that I said over half of our neurons have receptors for glutamic acid. That makes life a little bit difficult in getting selective actions. However, most anticonvulsant drugs are not very selective. I mean, they'll work pretty much anywhere where there's an ion channel there, and that you may have to put up with. All right, now, having some idea of the mechanism of action, I'll tell you that that's sort of important. I think it is important, but it's nowhere near as important as knowing which drug for which seizure disorder. This is an area, by the way, where one would be expected to know which drug would be perhaps a drug of choice and which drug might be a backup drug in terms of individual seizure states. So the table here shows us a reasonable classification of seizure types, although seizure types, as you may be aware, often have components of more than one of these different types, and the drugs of choice are listed, and the backup drugs are listed as well. We can go through this very, very quickly. Partial seizures, whether they're simple or complex, there are three drugs that come to the fore: valproate, phenytoin, and carbamazepine. And those three drugs are fairly interchangeable as drugs of choice. Sometimes more than one of them may be used. About 3 or 4 years ago, phenobarbital was demoted from being a drug of choice. I don't know whether the word demoted is correct, but anyway, is no longer a drug of first choice in terms of those types of seizures, but it would be perhaps the first drug to consider as a backup drug, and probably the first drug to consider for such seizures if the patient was pregnant. And the reason for that is that valproic acid, phenytoin, and carbamazepine are teratogenic. So they cannot be used or should not be used in a pregnant patient. So if you have a pregnant patient who's got a partial seizure, phenobarb has to be the number one drug, right? Even though it's traditionally now thought, well, not traditionally, it's now categorized as an important backup drug. Put it in that category. Now, most of the newer drugs that have come into medicine in the past 5 or 6 years for the treatment of seizure disorders also seem to be effective in partial, simple or complex seizures. That's not necessary to say that you would immediately jump into using them. Most newer drugs you've got to be very circumspect about, because you find as time goes by that there's something wrong with them. And so you don't want to be the first on your block, as it were, to be responsible for an adverse effect. And I would say that they would be backup drugs. What about general tonic-clonic seizures? This was the old grand mal. Now, you don't have to worry too much there, because you got the same drug groups here, the first choice, as you had for the partial seizures. Valproic acid, phenytoin, and carbamazepine. That's nice, because it's easier in terms of memory. It's nice to know that phenobarb is the first backup drug in this regard, and some of the newer drugs also can be effective in tonic-clonic seizures. Things get a little bit simpler from here on out. Absence seizures. Now, absence seizures, of course, are the seizures that we generally think of in childhood or early adulthood, where we have these rather transient, generally, seizures that, take people away from, their conscious surroundings, maybe as many as 50, 60, 100 times a day. They certainly cause dysfunction, and one of the big problems in children, of course, is it interferes with their attention, it interferes with their ability to learn, etc. As far as the drug of choice, the drug of choice really varies between valproic acid and ethosuximide. It's been interchangeable lately because a lot of young people, or anybody for that matter, get gastrointestinal distress from ethosuximide. It's an incidence of somewhere over 40% of quite severe GI distress. So a lot of people now think that valproic acid is the best bet there. But either of them are fairly suitable for treatment of this type of disorder. The trouble with valproate, of course, is twofold, as we'll see in a moment. One, you already know it is teratogenic, and the other is it's liver toxic. So, it's a bit of a balance job here as to which would be the best drug. Clonazepam is not the best drug, although it's listed as a drug of choice. The clonazepam is usually too sedating. All right, and if you're sedating the patient, then that's not very appropriate when they're trying to sort of function on a day-to-day basis. One of the newer drugs, lamotrigine, has been approved for use in absence seizures. The trouble with lamotrigine is it causes quite marked hypersensitivity-based skin reactions in a small but significant percentage of children, and like 1 to 2%. And these can be life-threatening. It's not just like, oh, I've got a rash. This is life-threatening skin reactions. And so that's a limitation to lamotrigine, a newer drug. Myoclonus, no argument. At least we finally come down to one drug of choice. Myoclonic seizures, valproic acid. Backup, well, clonazepam, but it's very sedating, as I've said. Felbamate, maybe, but what does felbamate do? It causes liver damage and blood damage. We don't like that too much, actually. It was taken off the market in 1995 because of those side effects. It's back because sometimes you might need it. But clearly, newer drugs, sometimes it takes a little while to sort out, just where they're going to fit into the scheme of things. Status epilepticus, a continuous seizure disorder. Intravenous drugs are needed here. The usual drugs of choice, there's not an awful lot to choose between them, but most authorities now say that lorazepam would be perhaps first, or diazepam. There's not an awful distinction there. And then possibly phenytoin, or a water-soluble variant of that called fosphenytoin. And then maybe in a long-term application, perhaps phenobarbital. I know this is sort of rather difficult for people to remember all these intimate details about drugs of choice, but I'm suggesting that it might be worth it in this instance, because of history tells us that people have been interested in you knowing this information. Now, I need you to know also some specific information about individual drugs. Phenytoin, if I may use my term once again, top 10, where I've told you that there are a listing of drugs that come up very, very frequently. Phenytoin is on that list. So you already know something about phenytoin. We said that its mechanism of action is as a sodium channel blocker. That's fairly straightforward. You might know that phenytoin is also an antiarrhythmic. It's a type 1B drug similar to lidocaine. And you may not know this, but it is a drug that we now consider to be a backup drug in bipolar affective disorder. The main drug we think of for manic depressive disorder is lithium, but if you can't use lithium or it doesn't work well, then you may consider phenytoin in that regard. The features that make this drug a top 10 drug actually not only include, what its mechanism is or what it's used for, but an awful lot of interest in both its biodisposition and also its side effect profile. This drug is very variable in its oral absorption. For example, if a group of patients, say 100 patients, took the same dose of phenytoin orally, you would find as much as a 20-fold variation in plasma level, which is really very, very variable oral absorption. In addition, the drug undergoes first-pass metabolism. It binds extensively to plasma proteins, particularly albumin, and sometimes can displace other drugs, and it itself can be displaced by drugs. And remember, if you increase the free fraction of a drug, you tend to enhance its pharmacological actions. It's an inducer of cytochromes P450 in our liver, and that can lead to drug interactions. All of these properties, you see, really make the drug sort of interesting. Now, under the adverse effect category, I'd like you to recognize that phenytoin does have CNS depressant properties. It's a sedator, and it may cause in some patients, visual dysfunction, double vision, or perhaps even in some patients ataxia. Of course, there's a lot of acne. If you're prone to acne, it seems to be exacerbated by the use of the drug phenytoin. It also causes growth of one's gum tissue, gingiva, and so gingival hyperplasia or gingival overgrowths are not uncommon with phenytoin, sometimes to the point that you actually have the gums going over the incisors, which is really, it's not just a cosmetic matter, it's more than that. But that's a rather unusual property, but it's associated with phenytoin. Likewise, hirsutism, excessive hair, usually where you don't want it actually. Osteomalacia can occur, and that's another feature that's rather characteristic of phenytoin, and it is hematotoxic, although not to the extent of carbamazepine, as you'll see in a moment. Teratogenesis, yes, don't use in pregnancy because of the fetal hydantoin syndrome. That often presents as structural abnormalities, craniofacial, including cleft palate and cleft lip. So this one is out when it comes to pregnancy. Carbamazepine, you might know it as Tegretol, has a mechanism similar to phenytoin. It's got also some other properties that I want you to recall. It's the drug of choice for trigeminal neuralgia, a very painful condition, and I would say that there isn't any drug better than carbamazepine in most patients in that regard. Like phenytoin, it can be used as a backup drug to lithium in bipolar affective disorder. Like phenytoin, it's an inducer of P450, so can actually cause drug interactions by that mechanism, happens to increase its own metabolism by virtue of inducing an enzyme that metabolizes it. So actually that also impacts on dosing considerations. It's a downer in the sense of sedation or ataxia or double vision, etc. Like phenytoin, causes osteomalacia. Like phenytoin, causes hematotoxicity, except it's worse. The granulocytopenia is fairly common, but the anemia, particularly the aplastic anemia, though not common, is is not easily reversible. You get water retention because you promote the formation and secretion of antidiuretic hormone, and in some patients we've seen quite marked skin reactions, exfoliative dermatitis, for example. Teratogenicity, mainly craniofacial abnormalities. There's been recent reports of spina bifida occurring with carbamazepine, but if you were to choose which of the anticonvulsants causes spina bifida, I'm hoping you will choose valproic acid. Valproate has lots of actions. I mean, it's a blocker of T-type calcium channels in the thalamus. It inhibits the enzyme GABA transaminase, and what would that do? That should increase GABA levels, shouldn't it? It also happens to block sodium channels in axons. So we're really not quite sure, which fits with which particular seizure disorder. Suffice it to say, we've already described that valproic acid can be used for most seizure disorders. And if you were put into a position of having to say which drug could I use for any seizure disorder, it would probably be valproic acid, right? The only consideration I would have there was that you're probably not going to use valproate for status epilepticus, but you could use it for pretty much anything else. It's a backup in bipolar disorder. That's a useful property. It's also used in migraine, as are many drugs, which tells us, of course, that we don't have any really selective drugs for migraine that we can guarantee will work. It's an inhibitor of P450. Remember, we just said that carbamazepine and phenytoin are inducers. Well, this drug inhibits metabolism of other drugs, in fact, including the metabolism of phenytoin and carbamazepine. The primary adverse effect, I would say, is going to concern the GI tract, and in fact, liver toxicity is the crucial issue here. There is a dose-dependent formation of a potentially toxic metabolite which binds to the hepatocyte and ultimately leads to a necrosis of the liver. The centrilobular necrosis, meaning, of course, that you haven't got a liver. And this means, of course, that you either get a new one or you don't survive. Now, that's a very unfortunate thing, especially since when valproic acid, when first introduced into medicine, was introduced with only one indication, absence seizures. And absence seizures are things that we think of in children and youngsters. And basically, a large number of kids were overdosed, and that meant that they lost their livers. We also see evidence of pancreatitis with valproic acid. There are a number of drugs that we associate with pancreatitis. Here's one of them for you. You lose your hair, alopecia, and you may see evidence of, when exposed to UV light, of very marked skin reactions that represent sensitivity to UV light. This is a teratogen, not to be used in pregnancy. This is your drug that causes neural tube defects, spina bifida, and I can't imagine one that would be more likely to do that is commonly used. There are other drugs that do that, and of course spina bifida is associated with folate deficiency. Ethosuximide is the fourth of the drugs that I formally want to say a few words about. What have we had? We've had phenytoin, carbamazepine, and valproic acid. Ethosuximide, we think, blocks the T-type calcium channels in the thalamus. It has only one use, and that would be absence seizures. Its biggest problem is gastrointestinal distress, and that's usually been the reason why you might consider valproic acid perhaps as a first-choice drug. Current diagnosis and treatment of 2000 suggests that perhaps you start with valproic acid, but it's largely based on side effect rather than efficacy. Other things that you might consider would be lethargy or fatigue. Again, you may have evidence of skin reactions or dermatitis, and there's even been a few reports of dysfunction of the extrapyramidal system that's been seen with ethosuximide. But overall, at least it doesn't have teratogenic potential. At least it's safe in pregnancy, and we do like that feature of it, although, as I say, it's mainly used for younger people, many of them not in the category of pregnancy. Barbiturates and benzodiazepines you already know an awful lot about. I want you to pick out phenobarb as the dominant barbiturate used as an anti-seizure drug. And that would certainly be important. And pick out clonazepam as a rather specific benzodiazepine that's had a long history as an anticonvulsant drug. It doesn't have that many uses, and it usually is considered second to other drugs because of its marked sedative properties, but would be a drug in absence seizures or in myoclonus as a possibility. Recently, we've been seeing clonazepam actually having efficacy as an anti-anxiety drug, so you might want to sort of keep that at your back of your mind. It is, after all, a benzodiazepine. So is lorazepam and diazepam, and I emphasize lorazepam for you here because a fairly recent consensus of neurologists suggested that lorazepam might be the first drug to consider intravenously in the management of status epilepticus. Newer anticonvulsants, one of the most surprising things, I think, to us in pharmacology over the past 5 or 6 years has been that we have doubled the number of anticonvulsant drugs that we now have available for treatment of seizure disorders. The first drug to be introduced was in 1994. That was felbamate. It was taken off in 1995 because of hemato and hepatotoxicity, but it came back again as an adjunctive drug. This had been followed by 4 or 5 other drugs. Gabapentin. Well, that one should be easy for us. We could say, well, gabapentin probably works like GABA. It certainly works to help out GABA, and that's true. And it is useful in partial seizures, no argument about that. But notice that gabapentin has been expanding its clinical utility since it got in. One of its useful properties is pain of neuropathic origin. Now, what am I talking about here? Pain that occurs in the diabetic patient because of damage to the neurons. Pain that occurs in the HIV patient because of treatment of drugs like AZT, which actually cause damage and severe pain. So these are indications that are improvements on the role of gabapentin in medicine. Likewise, it's a drug that seems to be valuable in bipolar disorder, and it's even being used in migraine. So there's more to gabapentin than meets the eye. I mentioned to you earlier that lamotrigine actually causes very severe skin reactions. They resemble the Stevens-Johnson syndrome, and since lamotrigine was initially approved for use in absence seizure, it was children that really had these severe reactions. The other drugs that you see here, I would just say to you that if you want more details about them, I did put something together in a little tabular form, and that will be in the text, all right? General features of anticonvulsants. First, think about additive CNS depression. Certainly that would occur with antihistamines, ethanol, sedative hypnotics, and opioids. You should be careful not to abruptly withdraw the patient from use of anticonvulsants because you can precipitate a seizure state. That's an important consideration. You should taper dose and warn them not to take it into their own heads to stop taking a drug. That may put them into a severe seizure. And anticonvulsant drugs are commonly drugs that interfere with the activity of oral contraceptives. I think we can understand how some of them do that, like for example, phenytoin or carbamazepine and phenobarbital or any barbiturate, because you see they increase the activity of drug metabolizing enzymes, and oral contraceptives are drugs. You know, they're estrogens and progestins, and they need to be metabolized, and if you metabolize them more rapidly, their effectiveness may be reduced. So it's usually a good idea in patients who are being treated with anticonvulsants to convince that patient to use other modes of contraception. They don't have to stop taking the oral contraceptive, but they should also have some backup there in that regard. Literally speaking, an analgesic drug is one that can relieve pain. We've discussed the anesthetic molecules, which certainly can relieve pain, whether they be intravenous, inhalational, or local anesthetics. But generally, when we think about analgesics, we think about drugs that perhaps we take largely by the oral route, and among the drugs that are valuable in that regard are the opioid analgesics. So-called opioid because we think that they are all very similar to the extracts of the opium poppy, from which we obtain, of course, morphine, codeine, and some other drugs. So we use the word opioid to at least denote that these drugs were related, at least in the original concept, to opium poppy products. Now, most of the actions, but not all of the actions of opioid analgesics, are exerted through receptors for endogenous peptides, the so-called opioidopeptides. And these peptides, which include compounds that contain 5 amino acids, pentapeptides, that's met and leuenkephalin, compounds that contain 17 amino acids, which includes dynorphine, and of course the very well-known beta endorphin, which has 31 amino acids in it, are endogenous compounds found in various regions of the body. They're certainly present in the brain in many areas, the pituitary, and certainly in parts of the innervation of the GI tract. And much of the action of opioid analgesics would be exerted through receptors for these endogenous opioid peptides. Now, there are many different types of receptor, but I would suggest that we know at least 3 of them: the mu receptor, the kappa receptor, and the delta receptor. If we can know those 3, I think we can describe most of the pharmacology of opioid analgesics from our understanding of those receptors. Now, in thinking about how drugs work on those receptors, we could say, well, if there are activators of these receptors, then there will be agonist drugs. And here's an example of a drug group where we have both full agonists and partial agonists. And from basic principles, a full agonist can give you the maximum effect, in this case, maximal analgesia possible, and a partial agonist would give you something less than that. In fact, it cannot reach a full analgesic effect. If you have agonist drugs, you can certainly have antagonist drugs. And so these 3 categories, full agonist, partial agonist, and antagonist drug, we need to know some of the representatives of each of those categories. Now, there's also another category seen particularly here among the opioid analgesics, which is referred to as mixed agonist-antagonist. Don't be worried by that. All it really implies is that there are certain drug molecules that might activate one receptor and therefore act as an agonist, but perhaps block another receptor subtype and therefore perhaps act as an antagonist against drugs that are more active on that receptor. Remember, partial agonists can do that too, but a partial agonist does it by interfering with the actions of a full agonist on the same receptor. A mixed agonist-antagonist drug can do it by perhaps interfering with the actions of a drug on a receptor that it itself does not activate. So there is a distinction there. The activation of receptors that are of the opioid subtype actually can have different mechanisms involved. For example, when you activate receptors that are presynaptic, as a general rule, you decrease the entry of calcium into the presynaptic region, and this is usually via a voltage-dependent ion channel mechanism. This entry really brings about a decreased release of neurotransmitter if the calcium channels are blocked. So activation of a presynaptic opioid receptor can lead to a slowing down of calcium influx. And since calcium influx is needed for the fusion of vesicles with the presynaptic membrane to release neurotransmitter, then activation of the receptors will decrease that release, therefore decrease the effectiveness of the neurotransmission. The other type of mechanism is the activation of receptors that are post-junction or postsynaptic. Here we know that if we activate opioid receptors that are localized on the postsynaptic membrane, we actually increase potassium efflux. Now, you may recall from our original discussion about ion flux and excitation of neurons that an increase in potassium efflux means that a positive charge is moving out of the cell, leaving behind a negative charge. And that leads to membrane hyperpolarization. And membrane hyperpolarization is the same thing as saying inhibition of neuronal activity. So what have we said here? We've said we can get inhibition by both presynaptic and postsynaptic mechanisms, but the ions involved are different. Calcium in the case of presynaptic and potassium ions in the case of postsynaptic inhibition. The diagram that we're looking at now happens to be a sort of a schematic of where in the central nervous system we might expect that activation of opioid receptors might influence pain pathways. Pain pathways come into the spinal cord by virtue of the primary afferents, and they often involve type C or type A delta fibers, and we see that the message is coming into the spinal cord at the level of the dorsal horn and would be sent upwards, further up the spinal cord towards the medulla, and from the medulla possibly into the midbrain region, particularly an area called the periaqueductal gray, and then ultimately higher still to various parts of the brain, so that you see the reaction and perception of pain, and also you might well see autonomic responses to pain as well. Well, what are we talking about in terms of modulating these pain pathways? Well, for example, if we were able to act at a presynaptic level here in the dorsal horn where the primary afferents are coming into the spinal cord, then we might be able to interfere with the message ever getting upstairs, as it were, to the higher centers of the brain. And we know that there are opioid receptors presynaptically here on these primary afferents that release substance P. Now, substance P is a peptide, but not an opioid peptide, a peptide that is known to be involved in nociceptive pathways, so that when you're hurt or when pain receptors are stimulated, we will see a release of substance P here in the spinal cord, which will then send the message further up to the higher centers. Well, if you inhibit the release of substance P here by activation of an opioid receptor subtype, then you're decreasing the message, and the message never gets in. Now, another type of mechanism, which is thought to involve postsynaptic inhibition, concerns certain neurons present in the periaqueductal gray region of the brain, which actually send messages retrogradally back down the spinal cord to modify the message coming upwards through the central nervous system towards the higher centers. We know that opioid receptor activation can actually impact on these in a descending fashion on these pathways, causing inhibition of pain transmission. So if you wanted to put this into the context of ionic events, we'd probably say that actions in the spinal cord seem to be pre-junction or presynaptic and have an impact on the entry of calcium ions, while those of them at higher centers seem to be largely postsynaptic and seem to have an impact on potassium ion flux. So the model is really a very simplified version of what is taking place, but it gives you the feeling for where our drugs may be acting. Our opioid analgesic drugs probably have both spinal cord actions and also actions at higher centers of the central nervous system. Sometimes we call these spinal cord actions spinal analgesia, whereas what would you call things that are higher up? Supraspinal analgesia. So those two terms have at least their origins in the context of anatomical sites of action of opioid analgesics. When we look at, for example, the ability to act on receptors in the periaqueductal gray, what we're thinking there is we activate descending pathways to the Rafe nuclei. This has more than a single effect. It might well interfere with pain transmission, and that would be an example of supraspinal analgesia, but it probably has impacts on other serotonergic functions that are related to pain transmission in addition. And then if we were to look at the action at the level of the spinal cord, remember these primary afferents involved in pain are largely type C unmyelinated fibers and type A delta myelinated fibers. In the dorsal horn, they release substance P, and that's an excitatory transmitter that would actually be involved in transmitting pain into the spinal cord. So if a drug inhibits substance P, then that would be providing you with spinal analgesia. So there's where the two terms come in. Now, what about the pharmacology descriptively of opioid analgesics? We will need to know the names of some of the opioid analgesics because they do vary not only in the intensity of their actions, but also to a reasonable extent in terms of the nature of their actions. If we start with analgesia, we will say that opioid analgesics will actually increase one's tolerance to pain and decrease both the perception of and the reaction to pain. I can still feel the pain, but it doesn't matter is one of the things that we talk about in terms of reaction to pain. The impulse may be there, but it doesn't do what it used to do in terms of setting up autonomic dysfunction or the pain perception, etc. We have variable levels of effectiveness among the opioid analgesics. If we were comparing opioid analgesics with automobiles, we would say that we have Rolls Royces. And Rolls Royces would include morphine, meperidine, methadone. If you like the idea of a Ferrari as a car that you might like to drive, that could be heroin. Heroin is a very effective analgesic, but it's got a sort of a glamour aspect to it as well. So Rolls-Royce or Ferrari, whichever you like. You'll have to step down, however, when you get to many of the other types of drug. Now, bufene, which is a mixed agonist-antagonist drug, is like a Jaguar or a Mercedes or something of that sort. Hydrocodone is a step below that, so I think we're getting into the territory of Ford. Codeine is in the Volkswagen arena, perhaps, and then propoxyphene would be a horse and buggy, right, in terms of analgesia. So get the sense that drugs... All right, now we then have to get to the point of looking at the different neurotransmitters in terms of their characteristics. And what we're going to do is first concentrate on cholinergic transmission, and this means then transmission that involves acetylcholine. Now, it doesn't matter whether you're talking about an autonomic ganglion, either sympathetic or parasympathetic, or the postganglionic parasympathetic neuroeffector junction, or the skeletal muscle junction, or really, actually, cholinergic systems in the brain. They've all got these same components to them that you see in the diagram. So learn this and you've got it made for an awful lot of pharmacology if you know what the system components are. You make acetylcholine in nerve endings by taking choline in by an uptake mechanism and combining it with acetyl-CoA via the enzyme choline acetyltransferase. That's not particularly of interest to pharmacology because we don't have drugs that affect that enzyme system, but you need to know it for physiology anyway. And you make acetylcholine from that enzyme, and acetylcholine gets stored in these little vesicles or granules that are near the nerve ending. So you see these little circles where we're showing acetylcholine getting incorporated into these vesicles and actually staying there until something happens. What's going to happen? Well, you see, the nerve, for which this is a nerve ending, actually is going to get activated by something, and you're going to have an impulse come down to this part of the nerve ending at the level of the membrane. And you're going to change membrane voltage down at this end, opening a calcium ion channel. So calcium is going to run down its concentration gradient, it's going to flow into the nerve ending and cause fusion of the vesicles of acetylcholine with the presynaptic membrane. And that's going to allow for acetylcholine to be released into the junction between this nerve ending and whatever the effector cell is that this nerve ending is feeding. It could be another nerve, as it would be in autonomic ganglia. But it also could be a cell, like a gland cell or a smooth muscle cell or what have you. So I'm not specifying that this is another neuron, although it could be, but it could be any cell that has receptors on it that will respond to acetylcholine. So what receptors are we going to need? We're either going to need a nicotinic receptor or a muscarinic receptor. So acetylcholine goes across the junction, and I've widened it so as I can get a few more things in there. But you know, in terms of the actual dimensions, the nerve ending is very close to the target effector cell. And on the effector cell, we've got the receptors there, which can be activated by acetylcholine. So, for example, if the effector cell was the heart, we're expecting muscarinic receptors there to be activated and a slowing of heart rate to take place. If the receptor happened to be on the skeletal muscle junction, you might expect a depolarization event to occur, leading to a twitch. So, you know, a muscle twitch. So, you know, in essence, it depends on the target, you know, organ or cell, what the response is going to be. But in all cases, acetylcholine is going to activate a receptor. Now, this type of action can occur quite quickly. Acetylcholine can have an effect within, you know, much less than a second on a target tissue. If it took more than a second for me to tell my hand to be waving around like this, you know, that would be ridiculous. It takes just, you know, some very small amount of time for acetylcholine to be released, in this case from somatic nerves. Now, how do you stop the effect? Well, the primary way you stop the effect of acetylcholine is to metabolize it, because on the effector cells there is the enzyme acetylcholine esterase. And if you were to then say, well, what does this do? It breaks down acetylcholine. To what? Well, to acetate and choline. And the choline is taken back up into the nerve ending and used again by combining it with acetyl-CoA. So you see, this goes right through a cycle of events in terms of cholinergic function. You get your choline back, and you make new acetylcholine, and you do the same thing over and over and over. Now, just looking at this system, I've told you already that really there is no drug that works on acetyl-CoA that has clinical significance. There really isn't any drug that works on choline that has clinical significance, to be honest with you. There are some tools that they've used to study cholinergic function, but we don't have any drugs really in the strict sense of the word. What about a drug that might affect the release of acetylcholine? Well, you know, botulinus toxin is a drug. It is approved as a drug for very selective purposes, not to be running around in our body, but we might be able to use it, for example, to get rid of wrinkles under our eyes by injecting Botox, it's called, botulinus toxin. How does it work? It inhibits the release of acetylcholine. Now, it's of most interest, of course, in botulinism. Botulinism is food poisoning, a type of food poisoning, isn't it? It's produced by a Clostridium organism to produce this toxin. How does botulinus work? It prevents the release of acetylcholine from these nerve endings by interacting with various proteins, including one called synaptobrevin, that is involved in the release of acetylcholine. So at least we do have a drug there that can prevent release, but obviously not of right primary clinical significance, but it is at least a drug, but it's more interest really in the context of poisoning, food poisoning, and botulinism. So when it comes to drugs, what have we got? Well, really, we've got drugs that can either activate a muscarinic or nicotinic receptor. You know one of them already, don't you? You know nicotine. Nicotine will activate a nicotinic receptor, and we've got drugs that will also activate muscarinic receptors. You don't really have acetylcholine as a drug, and you know why? Because within just a second or so, it's metabolized by acetylcholine esterase. So you can't use it pharmacologically, all right? And it does remind you then of how rapid this inactivation event takes place. And it's a very important type of property to know. Why? Well, because we're going to use drugs to inhibit that enzyme. And they're going to be called, obviously, acetylcholine esterase inhibitors. And this is a very prominent target for influencing cholinergic function. Anywhere that acetylcholine is a transmitter, a drug that inhibits its metabolism will potentiate its effect. Right? It doesn't matter whether it's in the ganglia, whether it's at the skeletal muscle, whether it's at the parasympathetic neuroeffector junction, wherever acetylcholine is released from a nerve to activate a receptor, it's inactivated by this enzyme. And if you inhibit this enzyme with drugs, then you will enhance the activity of acetylcholine at all those sites. Do you understand? That's the important feature. It has to be an innervated site. It will not happen if you don't have nerves. You see, because this is enhancing an endogenous neurotransmitter. You need the endogenous transmitter to get anywhere with a cholinesterase inhibitor. So really, pharmacologically speaking, when we look at this diagram here, we can say the most interest is in two arenas. We can either activate or block receptors, or we can inhibit acetylcholinesterase. That's a simplification of it, but I think it's good enough for us, and it certainly is very good in comparing with the complexities of adrenergic transmission, which we will get to later. So here we go, the summary. Acetylcholine synthesized via cholinesterase accumulated. Calcium runs in when we have a voltage-dependent opening of the channels. Fusion of the vesicle allows acetylcholine to be released, and you can block that with botulinum toxin. Inactivation by acetylcholinesterase, ACHE, and this is the major mechanism of termination, and it's a target for inhibitors, indirect acting cholinomimetics. All right, why do we call them cholinomimetic? Because they mimic the action of acetylcholine. So that terminology is very commonly used. You should know what it means. Why do we say indirect acting? Because cholinesterase inhibitors do not work on receptors directly. They merely allow acetylcholine to have a greater action by virtue of inhibiting metabolism of acetylcholine. That's the important thing, and you need innovation for those drugs to work. Post-junctional cholinergic receptors are targets for both activating drugs and for blockers. Now, depending on the receptor subtype, different drugs can be activators. We already have discussed now, or mentioned now, nicotine as an activator of nicotinic receptors. Well, the other type of receptor that is of interest to us is a muscarinic receptor, which are those that are present at the parasympathetic postganglionic neuroeffector junction, and also present at the thermoregulatory sweat glands. Now, muscarinic receptors are activated by different drugs. One of the drugs that we use quite a lot clinically is an analog of acetylcholine called bethanacol. Bethanacol activates muscarinic receptors without doing anything to nicotinic receptors. Methacholine actually will work on both types of receptor, both nicotinic and muscarinic. Pilocarpine is a plant product that happens to work only on muscarinic receptors. So really, you've got two plant products here. You've got nicotine working on nicotinic receptors, which comes from the nicotine plant, the tobacco plant, and you've got pilocarpine, which works, a plant product, only on muscarinic receptors. Now, what about the antagonist drugs? Well, the antagonist drugs, again, are selective in terms of the receptors. They, again, are going to be active depending on which receptor that you look at. Nicotinic receptors, as I said before, fit into two categories. Nicotinic NN, which is in all ganglia of the autonomic nervous system, and we have drugs that block those receptors, which have very little clinical use, if any. Hexamethonium is one of them. Mecamylamine is another one of them. And you need to know these names. Hexamethonium is a very good example of a drug that has been mentioned on examinations, although it has never been used clinically in the United States. Why has it been mentioned? Because they want you to know it's a ganglionic blocking drug, and you'll see a little later why that becomes very important. Nicotinic receptors at the skeletal muscle are called NM, and we've got drugs that block that receptor without necessarily affecting the other nicotinic receptor. Tubulocurarine, that comes from the curare, the arrow poison, is a skeletal muscle relaxant. Atracurium is a synthetic version of that. Succinylcholine is also a skeletal muscle relaxant. So these are antagonists of acetylcholine at the nicotinic NM receptor. And then you have antagonists at muscarinic receptors. Muscarine, by the way, is a plant product. It gave its name to this receptor subtype, but the only time you're going to see muscarine is in toxicology, if you happen to eat the wrong type of mushrooms, and you'll see muscarine poisoning. We don't use it as a drug, but we use the name muscarinic to denote distinction from nicotinic, and we have different drugs that act as antagonists as muscarinic receptors. Atropine is the prototype, a plant product coming from the belladonna plant. but we've got plenty of others that are made synthetically or that are derived from other products. Scopolamine is a naturally occurring compound, but benztropine and glycopyrrolate, which will be mentioned later to you in terms of their clinical uses and pharmacological properties, are example of muscarinic blocking agents. Very common clinical applications. The first signaling mechanism that I wish to review for you are those that involve intracellular receptors. Intracellular receptors, of course, are the targets for a number of hormones. I'm thinking of glucocorticoids, I'm thinking of aldosterone, the sex hormones, thyroid hormone interacts with intracellular receptors, etc. The binding of these hormones happens to bring about the release of various regulatory proteins. For example, binding of glucocorticoid to receptors in cells can displace various proteins that have heat sensitivity, and this then allows for dimerization of the hormone receptor complex and the ability of the complex to cross the nuclear membrane and interact with response elements on nucleic acid, which can change gene expression and thus change protein synthesis by that mechanism. By way of illustration, let me remind you that most of the time we use glucocorticoids in medicine, it is not for hormonal purposes in terms of replacement therapy, but it's because these drugs are very effective anti-inflammatory and immunosuppressant agents. So, for example, if we use dexamethasone as an anti-inflammatory agent, it's probably going to work just like hydrocortisone would have worked as a glucocorticoid, going through the steps that we've just described and changing protein synthesis, leading, for example, to the synthesis of a protein that can interfere with the enzyme phospholipase 2. Now, what does phospholipase A2 do? It's the enzyme that releases arachidonic acid from cell membranes, and arachidonic acid is the precursor of leukotrienes. Leukotrienes are very inflammatory mediators, and therefore if you can interfere with their synthesis, you have a very effective anti-inflammatory action. So I like you to think of these hormone receptors as also being drug receptors, because as I say, most of the time you use glucocorticoids, it's for their drug action. Likewise, most of the time we use gonadosteroids. I mean, what's most of the time we're going to use an estrogen? It's not for specifically only for replacement therapy in menopause. A lot of the use of estrogens, of course, is as contraceptive agents. Once again, you're interacting with receptors, you're changing, obviously, gene expression and the synthesis of proteins. And this is a sort of mechanistic action that's relevant to pharmacology. As a rule, when you modify the gene expression leading to protein synthesis, you have slow responses. They may take hours and sometimes days before they peak, and you usually have a relatively protracted duration of action that is commensurate with the life of the protein that has been synthesized. Now, in contrast to that type of signaling mechanism, we have some signaling mechanisms where the receptors are directly coupled to ion channels. These are particularly important in, for example, neurons. The nicotinic receptor, for example, in the sympathetic ganglia and the parasympathetic ganglia is responsible for transmission of all autonomic messages. And it's the actual target, if you like, for nicotine itself and for drugs that can activate such types of acetylcholine receptor and block that receptor. Likewise, nicotine receptors are at the skeletal muscle junction. So every physical movement we make in terms of our skeletal muscle involves activation of a nicotinic receptor. Well, what does a nicotinic receptor look like? Well, actually, it looks like a receptor that can identify acetylcholine and other types of chemical related to nicotine, but also is an ion channel. And the ion channel in this context is for sodium and to some extent potassium, allowing sodium to run down its concentration gradient. So every muscle move we make involves sodium running down its concentration gradient, bringing about a depolarization at a skeletal muscle end plate. So you can see how obviously this relates to pharmacology. Similarly, GABA receptors are coupled to ion channels. One type of GABA receptor, GABA is, of course, gamma-aminobutyric acid, present in the brain, is very important in the context of anti-anxiety and anti-epileptic drugs. This is the GABA-A receptor that is coupled directly to a chloride ion channel. Now, remember that when sodium runs down its gradient, you depolarize a membrane. When chloride runs down its gradient in the same direction from the outside to the inside, you don't depolarize, you do the opposite. You hyperpolarize the membrane. And hyperpolarization is inhibitory. So GABA is one of our important inhibitory transmitters in the central nervous system and a target for many benzodiazepines and many anticonvulsant drugs and some hypnotic drugs, sleeping pills, etc. So this obviously are very important signaling mechanisms that are relevant to pharmacological action. It doesn't restrict our thinking only to GABA or to nicotinic receptors. There are a number of other systems that also use ion channels directly coupled to the receptor. And by directly coupled, what we're referring to is no other biochemistry is needed in the response. You don't need to go through phosphorylation to get the response, put it that way. These responses are rapid. They may occur over the duration of a few milliseconds, and they're usually quite short in duration. Now, when I say direct coupling, I'm using that in contrast to receptor systems that might also involve ion channels, but are not directly coupled, but are linked via coupling proteins to enzymes. The classic example of that is, of course, those receptors that are linked to adenyl cyclase by GTP binding proteins. The receptors here usually are of the serpentine type. They look like a snake, and they have 7 transmembrane spanning domains. One of the domains on the outside of the cell recognizes the drug, the hormone, the transmitter, and the third loop going into the cell happens to be that which is coupled via a G protein to either activation of or inhibition of cyclic AMP. Now, what does cyclic AMP do? It activates protein kinase A, and this in turn leads to phosphorylation of multiple types of proteins which are tissue specific, and thus the responses that we see depend on the tissue and depend on the nature of the proteins that are phosphorylated. We have 2 types of G protein family linked to adenyl cyclase, GS and GI. GS, S for stimulation, is coupled in terms of receptors to catecholamines that activate beta receptors. For many years, we thought that cyclic AMP was the most important and perhaps the only real well-identified, quote, second messenger substance. A second messenger being, the messenger that is downstream from the first messenger, which could be acetylcholine or norepinephrine or what have you. So this was a second messenger compound. About a decade ago or so, people identified another type of mechanism where we use GTP binding proteins, but they don't have coupling to adenyl cyclase. Instead, they have coupling to an enzyme present in cell membranes called phospholipase C. Now, these types of G protein, to distinguish them from GS and GI, which modify adenyl cyclase, are referred to generally as a family as GQ proteins. When we have activation of receptors linked to GQ proteins, we actually activate phospholipase C, which is an enzyme that can hydrolyze a phospholipid present in cell membranes. The name of that phospholipid is phosphatidyl inositol bisphosphate, usually abbreviated as PIP2. And from this phosphate, 2 second messengers are released. One is called inositol triphosphate, or IP3, and the other is called diacylglycerol, or DAG. IP3 releases calcium from the sarcoplasmic reticulum in the cell, and together with diacylglycerol activates protein kinase C. Not phospholipase C here, don't get confused, right? Protein kinase C. This in turn results in phosphorylation of specific proteins in tissues and obviously ultimately leads to pharmacological responses. Well, what receptors are of interest to us here when it comes to drugs? Quite a few. Acetylcholine receptors that are not in the heart but in other tissues in our body, for example, those in our salivary glands that make saliva, etc., those in our GI tract, those that are present at other tissues other than the heart, happen to be linked via GQ proteins to the activation of phospholipase C. And many of the drugs that we use, such as, for example, atropine to dry up my oral secretions, which I could use it for, would be working through this messenger system. Norepinephrine is a transmitter at sympathetic nerve terminals that actually are innervating vascular smooth muscle. Alpha-1 receptors are involved there, and this is a GQ-linked system. So, what happens when norepinephrine interacts with this receptor? You get vasoconstriction. Is that of any use to us clinically? You bet. You bet it is. When every time you use a decongestant and you drop something into your nose, why are you getting decongestion? Because you brought about a vasoconstriction. What did you do? You used a drug that activated an alpha-1 receptor. What did that do? That stimulated phospholipase C. What did that do? It released diacylglycerol and IP3, and you phosphorylated a few proteins, and the next thing you knew was you had vasoconstriction. You can breathe again. And that's a mechanism of action that is very, very well described. Angiotensin II, a bad actor when it comes to hypertension in patients, right? Part of the time what we want to do is try and prevent formation of angiotensin II. Why? Because one of the actions of angiotensin II is to increase the release of the mineralocorticoid aldosterone. And what's that going to do? Well, downstream that's going to cause water and sodium retention. It's going to increase blood volume, and it's going to increase blood pressure. So angiotensin II, when we use drugs that are called ACE inhibitors, what are they going to do? They're going to inhibit ultimately angiotensin II formation and therefore interfere with this GQ protein linked system that involves hydrolysis through phospholipase C. So these are the features I think that you need to know about those coupling proteins. So we like to see both adenyl cyclase and phospholipase C represented in a single diagram. And the diagram shows us that we can either activate adenyl cyclase, for example, by beta-1 receptor activity, increasing the formation of cyclic AMP, or we could actually inhibit the formation of adenyl cyclase through a GI protein, as we do when acetylcholine activates a muscarinic receptor in the heart. We can see in the diagram that activation of an alpha-1 receptor at the blood vessel level activates a phospholipase that will release inositol triphosphate and diacylglycerol. This is a GQ protein-linked system. So the diagram puts it all together, and I think would be a good summary diagram for you in reviewing your messenger systems or your effector systems that are modified by drugs that use second messengers. Now, there is one aspect of a second messenger that is specific really to us in pharmacology that has to be talked about separately from, say, cyclic AMP or IP3 or DAG, and that is cyclic GMP. Cyclic GMP is important for us in appreciating the role of nitric oxide as a signaling mechanism in vascular smooth muscle. Cyclic GMP is a second messenger, just like cyclic AMP, I suppose, and its action in the vasculature is to stimulate the loss of a phosphate group from myosin light chains. It actually activates enzymes that bring about dephosphorylation. Now, myosin light chains, normally when they're phosphorylated, can bind to actin, the other contractile protein, and it's the phosphorylated form that can bind such that you can bring about an event leading to contraction of the smooth muscle. Now, if you've dephosphorylated myosin light chains, then the myosin light chains in the non-phosphorylated or dephosphorylated form can't interact with actin. If it can't interact with actin, you can't get a contraction of the smooth muscle. And if you can't get a contraction of the smooth muscle, you can't constrict. And if you can't constrict, what do? You vasodilate. So cyclic GMP brings about vasodilation. Where does nitric oxide come in then? Well, nitric oxide is a natural endogenous compound, that's for sure. For example, it's present in endothelial cells that line the blood vessels, and presumably when you activate certain receptors that can release nitric oxide, the nitric oxide can bring about this vasodilation through the steps that we just described. What can release nitric oxide? Well, activation of muscarinic receptors can do it. That's one possibility. But you know, one compound that does it very, very easily is histamine. When you're stung by a bee, right, you're going to release histamine from mast cells. You're going to lower blood pressure. Why are you going to lower blood pressure? You're going to lower blood pressure because that histamine is going to release nitric oxide via its interaction with H1 receptors on the endothelial cell. And that nitric oxide is going to bring about a vasodilation. No wonder your blood pressure drops down when you've been hit by a bee in terms of the venom releasing the release of histamine. It goes through this mechanism of nitric oxide. We also use many drugs that can actually break down to form nitric oxide, nitroprusside, nitroglycerine, isosorbide dinitrate. All of these drugs are very good vasodilators. Why are they good vasodilators? Because they release nitric oxide from their chemical structure, and nitric oxide then activates guanyl cyclase. And what does guanyl cyclase do? Guanyl cyclase forms cyclic GMP. And what does cyclic GMP do? It causes dephosphorylation of myosin light chains, and that means you can't get a contraction. So you can see that in this slide here, I'm emphasizing this very strongly as a mechanism distinctive from cyclic AMP. This is cyclic GMP, and it's a very important from the standpoint of pharmacology. Now, when I first started in pharmacology, we had a couple of drugs that worked as enzyme inhibitors. We had cholinesterase inhibitors, for example, and we had inhibitors of carbonic anhydrase. As time has gone by, of course, we have multiple drug actions that are thought to be exerted at the level of inhibition of enzyme activity. The more we find out about the enzymes and how they may be important in cellular functioning, the more we find out drugs that can modify that cellular functioning. In the sense of the importance of knowing every individual one of these enzymes that can be inhibited by drugs, I don't think that's the critical issue at this particular stage. But I thought it would be of interest to give you at least a selection of different drugs that are important regarding their ability to inhibit various enzymes in our body. And let me just illustrate that for you. There are many drugs that are inhibitors of acetylcholinesterase, and these have multiple uses ranging from myasthenia to glaucoma, the management of glaucoma. That's a very high-yield enzyme as examinations go, let me tell you. Acetylcholinesterase is an enzyme that I look at as a keeper for preparation for exams. Angiotensin-converting enzyme, the so-called ACE. Well, ACE inhibitors are all over the place. We must have a dozen now ACE inhibitors that are in medicine. What for? What are they used for? They're used for hypertension. I don't know how many millions of our patients in North America are actually using ACE inhibitors, but it must be many, many millions. Aspartate protease. Oh, I like that one. You know the PIs that are used in the management of patients who have HIV? These are aspartate protease inhibitors. So protease inhibitors, or PIs, are working by preventing the formation of a protein from a precursor molecule and are active against human immunodeficiency virus. Dihydrofolate reductase, an example, methotrexate, anti-cancer drug and a drug widely used in rheumatoid arthritis. How does it work? It interferes with the synthesis of tetrahydrofolic acid, a very important coenzyme in the production of purines and of certain proteins in terms of methionine. DNA and RNA polymerases. So many drugs work on these enzymes. Antiviral drugs work there. Acyclovir is a good example, used in herpes. All sorts of drugs work there. This is an illustration, as it were, for you of some of the enzymes that are critical to you in trying to identify how drugs work. And some of them concern our own enzymes. Many of them concern enzymes present in infecting organisms like viruses, bacteria, etc. And you can see it's a huge area of pharmacology. What about drugs that work on transporter molecules? We have drugs that can influence the uptake of dopamine, GABA, norepinephrine, and serotonin. Perhaps just by illustration, I'll give you one little subgroup there just to show you the extent of the interest here. The drug Prozac, fluoxetine. Fluoxetine was the parent drug of a family of drugs now that we call SSRIs. And what does that stand for? Serotonin selective reuptake inhibitors. Serotonin being, of course, 5-HT, or 5-hydroxytryptamine. And how many drugs are out there now? 6, I think it is, that are all used, very importantly for various psychiatric and emotional conditions, right, including major depressive disorder, but not restricted to that indication. So if you wanted an example of drugs working by influencing transporters, that would be a very good example for you. Now, lately we've been seeing things in terms of transmembrane functioning enzymes. We've known for a long time that insulin, and you can call that a drug if you want to, but we've known for a long time that insulin interacts with a receptor that can span the membrane. The outside of the cell recognizes insulin, and when insulin binds to it, the receptor dimerizes and increases the activity of a tyrosine kinase, which is the sort of back end of the receptor, but this one is inside the cell. And that tyrosine kinase leads to phosphorylation of proteins. Now, we also know now that many other systems do use that, including epidermal growth factor, EGF, atrial natriuretic factor, ANF. A number of things other than insulin work in a very similar mechanism to insulin. Now, the reason that we want you to know about insulin, of course, is that sort of everybody wants you to know about insulin, really, don't they? Biochemists do, pathologists do. Well, insulin in the sense of the management of type 1 diabetes is a drug, and so we certainly need you to know that much about it in terms of a mechanism of action. What about other systems that I've already mentioned this aspect of where we see a dimerization and an activation of tyrosine kinases? What about some of the newer drugs that are coming into medicine that we used to identify in the past as sort of biochemical entities that were just out there? We called them cytokines or sometimes lymphokines when they affected lymphocyte function. The receptors for big molecules like erythropoietin, growth hormone, alpha, beta, and gamma interferons. How do they work? What are they doing in terms of signaling mechanism? The receptors for these molecules are again membrane spanning and again can affect kinase activity. But they are not actually one molecule that has both the role of identifying the cytokine and functioning as a tyrosine kinase. No, these molecules identify the cytokine and then by virtue of interactions intracellularly modify specific kinases that are referred to as JAKs or JAKs. And this stands for Janus activating kinases, and these then phosphorylate specific proteins inside the cell. And the specific proteins are called STATs, which stands for signal transducer and activators of transcription. What do the STATs do? The STATs then dimerize, cross the nuclear membrane, interact with nucleic acid, and modify gene transcription. So these cytokines, you know, are like a mixture, mechanistically, of an insulin receptor and a steroid receptor, because they both affect phosphorylation and then subsequently affect gene transcription. These are becoming more and more important to us in pharmacology as we make more and more of these molecules for clinical use by recombinant DNA technology. There I think you have our signaling mechanisms.
This image shows you a skin infection with Mycobacterium. This happens to be Mycobacterium marium, and this is occurs lots of times in scuba divers. It occurs in tropical fish enthusiasts, and you can see some of the lesions from this particular organism. In finishing up on Mycobacterium tuberculosis, let's make sure that we understand two of the major virulence factors in this organism is the phosphatides that is found in the cell envelope. These chemicals inhibit phagosome-lysosome fusion, and that enables this organism to live intracellular. Cord factor is a mycolic acid polymer, and it certainly is a virulence factor, as it also allows for the organism to live intracellular. High-yield materials. You should know that the screen of the sputum is called the auramine-rhodamine screen. If this is positive, then you're going to do an acid fast. You're going to culture on Lowenstein-Jensen media. You're going to do a PPD skin test. And then if these occur, if you grow this organism, and it's in a patient that has clinical tuberculosis, then you're going to have to go through a regime of treatment. This treatment usually consists of multiple drugs. It may consist of isoniazid, rifampin, and maybe even 2 other drugs. This material will be given for a long period of time until the organism is no longer cultured. For instance, if a medical student is on service and that person is exposed to tuberculosis, they don't have clinical tuberculosis, but they're exposed, they may have to take isoniazid for 6 months to 9 months to 1 year. There are other Mycobacterium that are very, very important. Mycobacterium avium intracellulare is an organism that's found in the soil. This organism is extremely dangerous in HIV patients. It is the #1 Mycobacterium that causes death in HIV patients, Mycobacterium tuberculosis being #2. There is one other Mycobacterium that we need to spend a little bit of time on. Mycobacterium leprae causing leprosy. This organism is an acid-fast rod. However, you cannot grow this organism in culture. You usually take a punch skin biopsy of this organism in order to identify it. The organism is located in the skin, it's located in the nerves, and one of the main things that it does is it destroys sensations. So the individual is no longer able to feel, to touch, etc. The next image shows an individual with leprosy, and you can see that there is a hypopigmented area on the chest. You can also see that that person has no more nasal cartilage left. All the cartilage is gone. The next image shows an individual with leprosy. That particular individual, you'll see, has a very rough, wrinkled skin in the face. This is called Leonian facies. It's lion-like facies. You will also note that that individual, on the tips of their fingers, they have no tissue left. This person, during the nighttime, was bitten by rats or mice, and the person had no sensation, so they did not know that they were being bitten. In your chart on page, on table 2-22 is the two different forms of leprosy. One of those forms is much milder than the other. The mildest form of leprosy is called the tuberculoid form. This particular form, the individual maintains a strong cell-mediated immunity. They have a skin test, the Leproman skin test, which is positive, and you actually can find very low numbers of organisms in that skin lesion, and there are fewer lesions. In the lepromatous type, that's the bad kind. The cell-mediated immune system has just completely been destroyed. The leproman is negative because you have no cell-mediated immune system, so the delayed type hypersensitivity test is negative. You have lots of numbers of organisms in the lesions, and you have a large number of lesions. Again, you cannot culture the organism. You have to take a skin biopsy, do an acid-fast stain, and treatment. Treatment, again, just like tuberculosis, is multiple drug treatment for this organism. We are now going back, and we're going to talk about our sixth organism that is a gram-positive rod. Remember, we had already talked about 5 of those, and we digressed just for a little bit to talk about the acid-fast Mycobacterium. Our sixth gram-positive organism that we want to discuss is the genus Clostridium. Clostridium is a gram-positive organism. This organism forms spores. All Clostridia form spores. These spores are to resist adverse conditions. They aren't for reproduction. The first Clostridium that we want to discuss is the tetanus organism, Clostridium tetani. In this image, you will see this organism, and you will also see these spores. It makes the organism almost look like a tennis racket. So this organism is a large gram-positive rod with spores that are terminal on the end of the organism. This particular organism is acquired as the result of a wound. You step on a nail, you cut yourself, you get it into an area, you cut off the blood supply, anaerobic conditions occur, and that organism starts growing. Earlier in the lecture, we talked about some very powerful toxins. Well, tetanus has a very powerful toxin. It is a neurotoxin. We get this organism into the wound, and that organism starts growing. The toxin starts being circulated. The toxin moves up the nerve tracts. And as a result, we end up with some very serious disease called tetanus. There are some clinical signs to this particular disease. This particular disease results in 2 clinical things pictured in the next image. This next image is called Ristus sardonicus. That particular individual in this image has a very distinct facial grimace. The muscles in the face are contracted. They will not relax. Remember that this tetanus leads to a spastic paralysis. This is an adult with that same condition. Ristus sardonicus. There is another clinical condition. This is called ophis tonus. In this individual, you'll see that the head is bent backwards, and you'll see that the ankles and the feet are going backwards towards the back. Here is an older girl that has tetanus. You'll see her ankles are bent backwards, her head is bent backwards. This is ophis tonus, and you'll see she's also on hyperbaric oxygen. Treatment for tetanus consists of a variety of things. The treatment consists of antibiotics to kill the organism. It consists of hyperimmune globulin. That's antibody against the tetanus toxin. That is of human origin, because if it is of animal origin, then that person may end up getting serum sickness out of it. You may have to give some antispasmodic drugs, such as benzodiazepine or diazepine, to inhibit spasms. And, of course, hyperbaric oxygen may be important. This particular disease you can immunize for. It's part of the DPT shot. That DPT shot is given at 2 months, 4 months, 6 months, 18 months, and 5 years of age. Everybody should have that, and as a result, should be fairly immune to tetanus for at least 10 years if it is a clean wound. They would be immune 5 years if it was a dirty wound. Neonatal tetanus is extremely dangerous in developing countries. In developing countries, the mother has not been immunized, so as a result, the baby has no antibody that the mother would have produced. So if that baby is born and they use soil or fecal material to cover up the umbilical bleeding, then that is just a good prescription for getting tetanus. So neonatal tetanus is extremely dangerous. Remember the mechanism of action of tetanus toxin. It is a neurotoxin, and it leads to release of inhibitory mediators, glycine and GABA. Your table on page 1123 is very important in treatment and wound management of tetanus. The things that you should remember is it a dirty wound or is it a clean wound? Has the person had the full series of vaccinations? You will notice in that if you have had the whole series of vaccinations and it has been less than 10 years and it is a clean wound, you would not have to have any vaccine. If it has been more than 10 years and it is a clean wound, you may want to have a tetanus toxoid shot. Let's suppose that it is a dirty wound. If that particular dirty wound, you don't know anything about your patient, if you are not familiar with the history of that patient, and it is a dirty wound, then you should give that patient two things. You should give them antitoxin in one arm, and you should give tetanus toxoid in the other arm. If you know that this person had a completed series, and it's been more than 5 years, and it is a dirty wound, then you should give this individual tetanus toxoid. That chart, table 223, is very important, and you should be familiar with management of tetanus. The second organism that we want to talk about in the Clostridia is the botulism organism. This is sometimes called fatal food poisoning. This is Clostridium botulinum, and you can see this organism in the image. It is a gram-positive rod. The organism produces spores. These spores get into food that has been home-canned primarily. This might be some home-canned green beans that your grandma did. And as a result of that, when she pressure cookered it, she did not get the spores killed. And as a result, that toxin was produced. This is a very dangerous toxin. This particular toxin, the mechanism of action is it blocks the release of acetylcholine. This leads to a flaccid paralysis. The nerve to the diaphragm actually quits, and you die of respiratory failure. This organism is in the soil. It gets into the food, the spores germinate, and the toxin is produced. Some of the clinical signs of this particular organism is double vision, difficulty in swallowing, difficulty in speaking, and you have fixed pupils. Table 2-24. In the adult, this is primarily a foodborne disease. We get it from home canned foods. If you actually boil those foods, that toxin is destroyed. So making sure that the food is boiled will kill this particular toxin. Now there is also infant botulism. In infant botulism, you really don't want to give a young child honey before they're 1 year old, 1 year of age, because this could have spores in it, and these spores will germinate in the baby's digestive system, producing toxin, and they may end up getting botulinum. So we have Clostridium tetani, we have Clostridium botulinum. Our third clostridial organism is Clostridium perfringens. This is the gangrene organism. In the image is a gangrene organism. It is a gram-positive rod. This organism is the result of a wound infection. You get the organism in there, the spores germinate, and they start producing gangrene toxin. This toxin we had discussed earlier is a cell-lysing enzymatic toxin. It lyses every cell that it comes to. This toxin is called an alpha toxin. The gangrene organism also is a food intoxication. If you get the gangrene organism into some meat products or some stew or some sort of soup that has meat in it that's left over, and you do not heat that properly and you eat it, then you may get an enterotoxin from Clostridium perfringens. So Clostridium perfringens has two very powerful toxins, the alpha toxin, which is the cell-lysing toxin, and the enterotoxin, which is a diarrhea vomiting type toxin. Clostridium perfringens grows in different kinds of media anaerobically, and this particular organism growing in milk, litmus milk, will give the image that you see in the next slide. Here is a blister from Clostridium perfringens. This is the gangrene blisters. This is a very, very dangerous disease. If somebody gets this and it gets this far in them, treatment is you have to cut that tissue away. You have to administer antibiotic. You may have to give hyperbaric oxygen. So this is extremely dangerous. Again, it can also cause food poisoning. The fourth Clostridium that we want to talk about is Clostridium difficile. This organism is pictured in the next image. You even can see one of the spores of this organism. White area inside the bacteria, that's an endospore. Okay. This organism is called antibiotic-associated disease. Let's suppose that we have a 70-year-old individual, and that individual is in the hospital for some condition. He is getting much better, and they're getting ready to dismiss him. But that person had been treated with clindamycin to get rid of the previous infection. That clindamycin destroyed a lot of the organisms in the digestive tract, and it allowed this organism to overgrow. Clostridium difficile started growing. As a result of that, this image you can see, this is called pseudomembranous enterocolitis, and you can see some of these lesions in the colon. This particular person has these very powerful toxins being produced, and now you have to follow this up with an antibiotic that kills the organism. Remember, the results of this disease is previous clindamycin treatment. The antibiotic that can be used is either vancomycin or metronidazole. Both of them work successfully. However, vancomycin, we don't want antibiotic resistance developing to it. So metronidazole is a good antibiotic of choice for pseudomembranous enterocolitis caused by Clostridium difficile. That completes the 6 gram-positive rods that we were going to talk about. Now, so far in the course, we have now discussed the gram-positive cocci, Staphylococcus, and Streptococcus. We have now discussed 6 different gram-positive rods. Also, the acid-fast Mycobacterium group. The next group of organisms that we're going to discuss will be the gram-negative cocci. Now, this is not a large number of organisms, but there are 2 very serious diseases that result from these organisms. The first disease that results is meningitis, and the second disease is gonorrhea. On the image, you will see the gram-negative paired diplococci Neisseria. This is actually Neisseria meningitidis right here. It is a gram-negative paired cocci. Growing on chocolate agar, it is oxidase positive. So those are 2 very important features that you need to know about this organism. It will not grow on nutrient agar. It's very fastidious. It requires chocolate agar. It is a gram-negative paired diplococci, and the biochemical test that's helpful in identification is the oxidase test. Here is a paper oxidase test. On this particular image, you can see by adding oxidase reagent and the organism, you get this purple color. That is a positive. Neisseria meningitidis, if you'll look at your table 225, it gives you the 2 important Neisseria. Neisseria meningitidis, Neisseria gonorrhea. Neisseria meningitidis has a capsule. In this next image, you will see the capsule of that organism. Earlier in the day, we talked about a vaccine. This vaccine is called YWCA. It consists of 4 serogroups. This is given to military. It's also now given to college age, medical students, etc. This organism enters by a respiratory route, and it causes meningitis. Here the organism is growing on chocolate agar. Again, it's a fastidious organism. Now, let's make sure we understand the differentiation of Neisseria meningitidis from Neisseria gonorrhea. Obviously, the specimen of choice usually helps you out on identification. But Neisseria meningitidis ferments glucose and maltose. You will notice that here is glucose, and it is fairly pink. Here is maltose, and it's fairly pink. Fermentation of glucose and maltose is characteristic of Neisseria meningitidis. We're going to be talking about Neisseria gonorrhea in a minute, but while we're on this 2-25 table, let's look at Neisseria gonorrhea. It does not have a capsule. There is no vaccine. This is the genital port of entry. Glucose is fermented, but maltose is not. So that's a very important biochemical differentiation. Now let's specifically talk about Neisseria meningitidis. It is a gram-negative paired diplococci. It has a capsule. If this organism is present in the cerebrospinal fluid, then you want to determine if that organism or you have a meningitis. What are the results of a cerebrospinal fluid with a bacterial meningitis? Number 1 that you should know is there is a decreased amount of glucose. There is an increased amount of protein, and there is an increase in bacterial or capsular antigens. You know that this organism has a large capsule. Here in this image are some petechial hemorrhages that you see in the roof of this person's mouth, and this person is a case of meningitis. Here is a person that has DIC. The DIC that results there is from overwhelming amounts of endotoxin that this organism released. Now, there are some things that you want to make sure that are very high yield for you to remember. What causes newborn meningitis? Newborn. Group B, strep. E. coli, and Listeria. Now, we have already talked about two of those before. Group B strep, E. coli we have not discussed yet, and Listeria. That is neonatal meningitis. What causes adult meningitis? There are two major causes for adult meningitis, and this is one of them. Neisseria meningitidis, and we've also talked about Streptococcus pneumoniae. This organism has a very powerful endotoxin. Neisseria has an IgA protease. Remember, an IgA protease digests IgA, and as a result, we don't have as much mucosal immunity. Be sure and remember that a lot of the normal population may carry this organism. They're a carrier, but they do not have the disease. Prevention. You got a great vaccine, YWCA. If somebody is exposed in your group to this, everybody in the group would have to take rifampin as a precautionary prophylaxis for this particular disease. The second gram-negative rod that we want to talk about is Neisseria gonorrhea. This is not the most common venereal disease, but it's way up there. The most common bacterial type venereal disease is chlamydia, and Neisseria gonorrhea is second. And this next image shows you gonorrhea. This organism is a paired gram-negative diplococci. You can see this organism inside of neutrophils in the next image. Here is this white blood cell. The pink area there is the nucleus of the white cell, and it's lobed. You can see here comes the lobes of that neutrophil. And inside of that neutrophil, you will see these paired organisms. That is diagnostic if it happens to be a male specimen. If that is a female specimen, it is not diagnostic. What would you do if this was a female specimen? Then you would take it and you would culture it. You would culture this organism on Thayer-Martin media. We talked about that media previously. This organism grows on Thayer-Martin because a lot of the other organisms are killed. Thayer-Martin has some antibiotics added to it. Not only that, this is an oxidase test. This oxidase test is positive for Neisseria gonorrhea. Gonorrhea only ferments glucose. You can see that this particular image is glucose fermentation only. This is yellowish. The rest of them stay pretty reddish pink. Neisseria gonorrhea has Fmge or pili. If it is a type 1 or 2 pilus, that organism is virulent. This image shows you those pili. Here is what that disease causes. It is a venereal disease. It is by sexual contact, or mother can also give it to the newborn baby as the baby passes through the birth canal. This organism in the male, it primarily causes a urethritis. You can see in this male that there is an exudate that has been being produced and it's coming out of the urethra. Here it is, the same exudate in the female. Okay. In the female, you would take that material and you would culture it on Thayer-Martin media. You would do an oxidase test. You would do a glucose fermentation test in order to identify the organism. Here the organism is growing in the cervix of the uterus. So that's gonorrhea in that female cervix. One of the bad things about this is females have it a lot worse than males do. This is an ascending infection in a female. It goes from the urethra, it goes into the cervix, it goes up the fallopian tubes, it stops up the fallopian tubes. You end up getting PID out of it. Not only that, but it becomes septicemic. It spreads by way of the bloodstream and it causes an arthritis. This is usually a monoarthritis. For instance, in this case right here, you'll see that this ankle is perfectly normal. But this particular ankle is swollen. There's only one joint involved in this particular case in this female. Here's a case of gonorrhea in the newborn. Neonatal gonorrhea. The mother had it, and as that baby passed through the birth canal, the mother gave it to the baby, and the baby got it in the eyes. You also can do a fluorescent antibody. This is a direct fluorescent antibody where you take the vaginal scraping. You have an antibody against Neisseria gonorrhea that has been labeled with a fluorescent dye, and you can see the results of this. It is very green. Fluorescence is kind of green. You used to be able to treat gonorrhea with penicillin without any trouble, but it now has a beta-lactamase, and as a result of that, you cannot use that antibiotic anymore. The antibiotic of choice is called ceftriaxone. A lot of times, individuals may have gonorrhea and chlamydia at the same time. They're usually in STD clinics, they will double treat. They will treat for chlamydia, which is doxycycline or tetracycline, and they will also give ceftriaxone for the gonorrhea, even though they may not know that they have both of them. If this is a person that says they have been very promiscuous, they have had 3 sexual partners in the last month, condoms were not used, then they will probably double treat this individual. This is a test that proves beta-lactamase production right here. This development of this pink color, this is called a cephinase test. Again, this is the organisms, in this image, this is the organisms inside of a white blood cell, and in a male, this would be diagnostic. That is our 2 different gram-negative rods, gram-negative cocci. We have one more that is important. It's called Moraxella. It is very similar to Neisseria. It generally does not cause any major problems, except it does cause otitis media, ear infections, even in adults. So ear infections can be caused by Streptococcus pneumoniae. It can be caused by non-typable Haemophilus influenza, and we have not done those yet. And it can be caused by Moraxella. Moraxella is not a major problem outside of maybe otitis media. So that finishes our gram-negative cocci: Neisseria, meningitis, Neisseria, gonorrhea, and Moraxella. We are now getting ready to start a whole group of organisms that are gram-negative rods. The problem with this is there are hundreds of them. You certainly aren't responsible for hundreds of these. We want to hit the highlights. We want to do the ones that are most important and most relevant for you to study for the boards. The first one we want to talk about is the genus Pseudomonas. On the image, you will see a large gram-negative rod. This organism is called Pseudomonas aeruginosa. It is a gram-negative rod. It has the unusual characteristic of producing some green-blue pigment on culture. This next image shows you some of that pigment that it produces. This particular organism is a lactose-negative organism. It does not ferment lactose, so as a result, on the negative media, McConkey's, it will be clear, and you can see that has happened here. This particular organism has a grape-like odor. You can walk into a hospital ward and you can almost tell if Pseudomonas is there. One of the major problems with Pseudomonas is it's found in water. It's found in flowers. People that take flowers into their friends that's in the hospital, that might be one of the worst things you can do. The water supply is contaminated. The catheters are contaminated. This is a horrible disease. Pseudomonas has a great big thick capsule. It causes abscesses in the lungs. It causes pneumonia. But one of the main things you want to remember, especially for high-level board type questions. Number one, it occurs in burn patients. Number two, it occurs in neutropenic patients, somebody that has a white cell count of less than 500. Number three, it occurs in catheterized patients. Number four, it occurs in cystic fibrosis patients. This is a very dangerous disease. This particular disease is found in contaminated water and anything that might be associated with that water. If this gets started in the hospital, they have to just sterilize everything that might be water associated. That's our first gram-negative rod. That causes a respiratory type infection primarily, although obviously it can go from the skin, it can go from a catheter, etc. Number two, the second organism we want to talk about is Legionella. On some of these gram-negative rods, there isn't a lot of detail we need to do because a lot of this is not that high level. Legionella is a gram-negative rod. This particular organism grows on a media in which there is lots of iron and there is lots of cysteine. This particular organism is also found in water. It's found in air conditioning units where they recirculate water. Where this first was really noticed in great detail was in Philadelphia at the Legion Convention several years ago, where the water supply was contaminated, and a lot of these old, smoking, alcoholic Legionnaires ended up getting this particular disease. So be sure and remember, older males, smokers, alcoholics, immunocompromised patients, very typical of this disease. Now, one of the main things about this disease, this is the first organism that we've talked about that leads to an atypical pneumonia. Strep pneumo was atypical pneumonia. Chills, fever, sputum, lots of productive, rusty, bloody sputum. This particular organism is an atypical pneumonia. It might be a dry cough and very little sputum produced. How do you know somebody has this? The next image you will look and you will see that this is a scraping from the lung. In this particular scraping, it is not these large cells you're looking at. It is these little cells right here. This is a direct fluorescent antibody test. You took a scraping from the lung and you stained it, and as a result, you will treat this individual. You can treat it with several different types of antibiotics. There's no one antibiotic of choice for this. There are several that could be used. Here is a case of Legionnaire's disease. You will see the phagocytic cells, and you'll see this gram-negative organism present. This could be a sputum. This could be a scraping from the lung. Here's a pneumonia from Legionella on this next image. So now we've done Pseudomonas, and we've done Legionella, gram-negative rods. Our third gram-negative rod is Bordetella. This is whooping cough. This is a very small gram-negative rod, as you can see from this image. This also gives you the same type of characteristic slide identification as whooping cough, as Legionnaire's disease did. Here is the phagocytic cells in this image, and here is a direct fluorescent antibody. Now remember, the antibody that is used in this is going to be different than the antibody that was used in Legionnaire's disease. This is an antibody against whooping cough. This is an individual with whooping cough. You can see the frenulum of the tongue is swollen. This almost looks like a person that has pink eye, but this is not pink eye. One of the classic things from this particular disease is that person coughs so hard that they almost vomit. They rupture the capillaries of their eyes. So this individual's capillaries are actually ruptured. Please remember, how do you know it is whooping cough? You do it by a direct fluorescent antibody test. This is a respiratory-borne disease. Now remember, there is a vaccination. This is called the DPT shot, or even better, it is now called the DPAT shot. If the A stands for an acellular component, it is not the dead organisms. It is the capsule, it is the toxoid, and it is the hemagglutinin that's in the vaccine. One of the classic things that you should remember, especially if they give you a board question that has an 80%, 70% leukocyte count, lymphocyte count, 70 to 80% lymphocyte count. Well, the first thing you're going to look at is you're going to say, oh my goodness, that person has a lymphoma. But they do not have a lymphoma. They have whooping cough. This is a classic clinical test for whooping cough and increased in lymphocytes. This toxin is a very powerful toxin. It does a variety of things. One thing that it does is it causes fluid production in the throat. This is an adenyl cyclase toxin. Now, it does not have the same mechanism of action as cholera does. Cholera stimulates adenyl cyclase. This inhibits the inhibitor center from working, thus the adenyl cyclase system stays turned on. What is whooping cough? Well, the first week you're going to have a runny nose. You're not going to feel good. You're going to have fever. You're very contagious. Finally, you start whooping so loud, coughing so hard, vomiting, and you're very, very toxic. Eventually, you will get over this. Now, let me caution you that currently the vaccine needs to be given to lots of people. I wonder how long it's been since I've had a whooping cough shot. Probably since I was 5 years old, and that was a long time ago. So people need to periodically be vaccinated because whooping cough is a current disease that can happen. You can see that immunity wanes within 5 to 7 to 10 years. We've got a couple of other gram-negative rods next in this discussion that are not major organisms. We want to mention them, and we want to mention the major parts about them. One of them is Francisella. Francisella tularensis causes tularemia. We're now going to start a discussion of a different group of gram-negative organisms. These are organisms that infect the intestinal tract. These are GI organisms. They cause a variety of diseases, and we really need to divide these diseases up into three major groups. An organism that is going to be found in the colon, producing a bloody type mucus, white blood cell infection, or an organism that is up in the small intestine that is going to produce a diarrhea or a watery, vomiting type infection. And then the third category is the organism that actually invades and goes into the reticuloendothelial system, such as the typhoid fever organism. We're going to start off and we're going to talk about the genus Campylobacter. Campylobacter is a gram-negative rod. This organism is microaerophilic. In the earlier discussions, we talked about that there are obligate aerobes, obligate anaerobes, and we said there were two organisms that were microaerophilic. Campylobacter is one and Helicobacter is another. Campylobacter causes gastroenteritis. Here this organism is, and in the image, and you will see that the organism has a very unique property in which two organisms, here's one and here's the other, they kind of gather together and they look like a pair of gull's wings. So that's how they're described. Gram-negative curved rods that are gull's wings. They grow on a very selective type media. They grow at 42 degrees. So what used to happen in diagnosis would be you do not grow the organism causing it because you're growing it at human body temperature or incubator temperature, and this organism does not grow. You have to grow it at 42. You grow it on a very special media called campi. How do we get this? We get this oral fecally. We get this from poultry. We get this from contaminated meat of some sort. All kinds of animals house this organism. It gets into us. It goes down into the colon. It causes a bloody, pussy, mucus diarrhea. This may be the most common infectious diarrhea worldwide, even more common than Salmonella and Shigella. The next image shows you the second organism that's microaerophilic, and that's Helicobacter. It wasn't thought much about Helicobacter for a long period of time until it was discovered that this organism is involved in a cause in gastritis, duodenal ulcers, and even stomach cancer. Here is this organism in this image growing in an ulcer. The reservoir is humans. It's passed from one human to the other oral fecally. And this particular organism is urease positive. You can see a urease positive test in this image. This pink tube is urease positive. Again, this is a very dangerous organism. It now is known to cause gastritis, duodenal ulcers, even stomach cancer. There is a special test for this in which the individual is fed radioactive carbon-13 urea. And then the urease from the organism breaks up that urea and produces carbon-13, carbon dioxide. And as a result, you can measure that and determine that that organism is present. Be sure and remember the treatment for this organism. For treating this organism, you give two different antibiotics. Metronidazole is usually one of them. You also give something that has bismuth in it, such as Pepto-Bismol. And the fourth thing that you give is a proton pump inhibitor. So you want to make sure that you know the 4 avenues of treatment that you need to use for Helicobacter. We're now going to talk about the large group of gram-negative organisms. We're going to talk about the ones that you normally think of as gram-negative, all of the Enterobacteriaceae. In the picture, you will see a gram-negative Enterobacteriaceae. This could be E. coli. In figure 2-11, it has a diagrammatical picture of a gram-negative organism. You should know the terminology for the antigens of this gram-negative organism. The H antigen is the flagellar antigen. The K antigen, or the VI antigen, is the capsular antigen. The VI antigen happens to be present in Salmonella typhi, and that's one of its virulence factors. The K antigen is an antigen that's in E. coli. We haven't talked about E. coli, but we talked about the K1 antigen being important in neonatal meningitis from E. coli. If that capsule K1 is there, the organism is more likely to cause it. And then the large circle O, that stands for the outer part of the outer membrane, the carbohydrate material. So in determining gram-negative enteric organisms, there are a lot of different serological tests that can be done for the capsule, for the O antigen, and for the flagella. All gram-negative organisms have endotoxin. Now, there are some interesting laboratory diagnoses that you can do for these organisms. There is a media that you always put gram-negative organisms on. It is called McConkey's. Earlier in the lecture, we talked about the fact that McConkey's was a selective media in which it selects out gram-negatives and does not allow gram-positives to grow. It is also a differential media in which it differentiates lactose fermenters from non-lactose fermenters. If the colony turns pink, such as in this image, then it is a lactose fermenter. So an example of the lactose fermenters would be Klebsiella, Enterobacter, E. coli. There's others. An example of a non-lactose fermenter in which there is no color that develops on McConkey's would be Salmonella, Shigella, Pseudomonas. Now, there are other biochemical tests, etc., that can be used to help identify these organisms. For instance, the organism may not have a flagella. A good example of a non-flagellated gram-negative organism is Shigella. He has no flagella. Shigella also produces no H2S. This is a TSI test, triple sugar iron agar test. And if H2S had been produced, that would be black. There would be a black area approximately in that area right there on that particular tube. Certain organisms are flagellated. Remember, that's the H antigen. And here's an example. This is Salmonella. Salmonella and Proteus have flagella. You'll notice that this has turned black. There is lots of black in this area right here. That is H2S positive. All that area there is black. So H2S production is important in helping identify some of these gram-negative rods. Now let's go into some of these major enteric negative rods. The first one we want to talk about is E. coli. It is a gram-negative rod. It is a lactose fermenter because it turned pink on this EMB. You will notice that this TSI is completely yellow. That means it fermented all of the sugars in there, and there's lots of acid produced, so we get a lot of change in the pH indicator. On TSI, this is called acid over gas, H2S negative, and that is helpful in identification of E. coli. E. coli causes a variety of infections in us. It's one of the common organisms that's found in our stool samples. It's in our colon. It is not the most common. Bacteroides is more abundant than E. coli. This organism can be used for crop fertilization. In a lot of undeveloped countries, human fertilizer is used. Well, of course, E. coli is in there. This particular organism can cause a variety of diseases. First of all, it is the most common cause of urinary tract infections in females. Number one, in females. It is a very common cause of neonatal meningitis in the newborn. Again, this is the K1 capsular type. We had already previously told you that strep group B, E. coli, and listeria are common causes of neonatal meningitis. This organism can get septicemic through a catheter, through an IV, and it is very, very pathogenic because of its endotoxin. Most of these diseases are spread oral fecal or UTIs. Now, in this first discussion of E. coli, this organism that we're talking about, I like to call old normal E. coli. But there are lots of other E. colis. There are E. colis that have unique capacities. The first one of these E. coli that has unique capacities is called E. coli ETEC. That stands for enterotoxigenic E. coli. Earlier, we talked about some different kinds of toxins. One of the categories of toxin was a cyclic AMP producer, meaning that organism is found in the small intestine. It produces massive amounts of toxin, which causes an increase in fluid, cyclic AMP fluid release. Well, this organism, ETEC, is one of those. This is called traveler's diarrhea. In the next image, you will see that organism. You will see the pili, Fmge, coming out from the organism. And you certainly will see that this organism does not invade. It has not invaded. It is just sitting out here in the intestine. It is producing its toxin. You're going to have lots of fluid produced from that particular organism. And you'll note that it is found up in the small intestine. So we have lots of fluid. The second unique type of E. coli is enteropathogenic E. coli, EPEC. This may be the most common cause of diarrhea following the rotavirus, and we will do viruses later on. This is a prolonged watery diarrhea, very much like ETEC. Here is a child with ETEC. In this next image, you can see that the child has very sunken eyes. It is dehydrated. If you pinch that child's skin, it would have lost its turgor. That means the child is very, very dehydrated, and you need to get fluids back in this child. ETEC. The third type of E. coli is the EIEC. That's enteroinvasive E. coli. This organism is not in the small intestine. It's down in the large bowel. It infects the colon. It's very much like bacillary dysentery. There's blood, there's pus, there's mucus in the stool sample. EIEC. The fourth type of E. coli is EHEC. This is enterohemorrhagic E. coli. This is the one that we find that is associated with hamburger meat. It is more characteristic to identify it as type 0157H7. Hamburger meat that's not properly cooked gets this organism, and this organism becomes extremely dangerous when it causes hemolytic uremia syndrome. This is, again, a foodborne infection. There is a very toxic response to this particular organism. 0157H7 is acquired from hamburger meat. So what we've just done is we've just discussed normal E. coli, urinary tract infections, neonatal meningitis, and we've discussed the unique E. coli's, EIEC, EPEC, ETEC, and EHEC. The next gram-negative organism that we want to talk about, that is an enteric organism. So we've had Campylobacter and we've had E. coli's that are enteric infections. Is Shigella. This is bacillary dysentery. Here is Shigella on the slide. You will see that it is a rod and it has no flagella. We discussed that when we started a minute ago. Non-motile, it is non-lactose fermenting, and it does not produce H2S. Shigella causes bacillary dysentery. This organism is only in humans. It's not anyplace else. It's only humans. There's no animal carriers. It is oral fecal from person to person. And what you should remember is this organism goes through daycare centers like crazy. One kid has it, passes it to the next kid. Mama comes in and gets the kid and takes him to another daycare center. He's already been infected, and now he goes over and infects another daycare center. You will look on this image and you will see red cells, red blood cells, and white blood cells. This is pus, and it's in a stool sample. You would grow this organism and identify it. Oral fecal. This is a very powerful toxin. This is called sugar toxin. It is enterotoxic. That means some fluid is going to be produced. It is cytotoxic. That means it's going to kill cells. It is neurotoxic. That means it's going to have some degree of effect on the nervous system. One of the main things about this organism is it only takes a few bugs to infect you. You don't have to have very many, 1 to 10. So you can see how this gets spread through daycare centers very, very quickly. You generally don't use antibiotics for this. Usually it's fairly self-limiting, but you certainly have to make sure the kids wash their hands, and you have to replace the electrolytes that are lost. So proper sanitation, sewage, washing hands, washing the diapers, etc., for treatment of this particular organism. The next gram-negative organism is Klebsiella. Here is Klebsiella. It is a gram-negative rod. And I want you to note the unique thing about Klebsiella. It's got a gigantic capsule on it. This next image shows this large Klebsiella capsule. Now remember this earlier when I talked about the virulence factors of these organisms? I told you that capsules were very important. We talked about strep pneumo. We talked about K1 from E. coli. We talked about YWCA from Neisseria meningitidis. Well, don't forget Klebsiella capsules. This is a major capsule organism. You can see that it is a lactose fermenting organism. It turns pink. In fact, it is very mucoid. This capsule is so thick and gummy that this is really what it looks like when you grow it up. It's very mucoid-like. Lots of times you will be able to differentiate an aspiration pneumonia from Klebsiella and strep pneumo by just some of the major types of characteristics. If that 50-year-old alcoholic is found, he's a smoker, he's found out behind the bar and it's cold in the morning, and he's found and taken into the hospital, and he has chills and rigors, he's producing a rusty sputum, he probably has strep pneumo. However, if that alcoholic is found and he is very clammy, that clammy characteristic would lead you towards Klebsiella because it is endotoxin shock that individual has. So you would culture on blood, you would culture on McConkey's, and you would do a gram stain. Gram-positive paired diplococci with a capsule is strep pneumo. You treat that with penicillin. A gram-negative rod with a big capsule could be Klebsiella. You would have to identify it, and this is one of the ways right here in this image to identify it by all that mucoid-looking material. Here is a case of pneumonia right here. You can see the white blood cells, and you can see Klebsiella inside of those white cells. Please remember, older, alcoholic, diabetic, abscesses, Klebsiella is more likely to form an abscess. This also can be hospital related. It could be catheters, it could be IV tubes, etc. Klebsiella looks very much like E. coli on identification. The TSI is going to be the same. You have to go to further means to identify it. The next organism is Salmonella. Again, we're still working on gram-negative organisms that primarily inhabit the gut area. Now, Klebsiella does not, as far as causing those abscesses in the lungs, but it started out in the digestive tract. Here is an image of Salmonella. a nice gram-negative rod. You can see that it's a non-lactose fermenter. And Salmonella has flagella. Remember, Shigella does not have flagella. That should make a good country western song. Shigella has no flagella, Salmonella has flagella. Salmonella produces H2S. You can see that H2S being produced. Now, we have to be very, very careful when we're talking about Salmonella because we have two entire different groups. We have an organism, Salmonella typhi, and the disease that it causes is called enteric fever. It's called typhoid fever. It is not like the other Salmonellas. This particular organism is a gram-negative organism. Again, it produces H2S. It is lactose negative, so it's going to be clear on McConkey's media. But I want you to especially note that it is humans only. So we have Shigella being humans only. We have Salmonella typhi being humans only. Now that's Salmonella typhi. This particular organism is oral fecal acquired. Here is ingestion of the organism. It enters the small intestine. It penetrates the small intestine, goes into Peyer's patches. It penetrates the small intestine and goes into the mesenteric lymph nodes. It spreads by way of the bloodstream, and it goes to the liver, to the spleen, and all the RES system. That is the reason that you get all of that fever. Even more important, it goes into the gallbladder. You certainly want to be familiar with cholecystitis. If you have cholecystitis, if you have fever, if you have an increased size of spleen, liver, etc., if you've been to an area where contaminated sewage from human origin is there, and you drank that water or ate that food, then you may have this particular disease. It is oral fecal, and remember, gallbladder. People that have sickle cell disease are very prone to Salmonella. Pathogenesis. In your notes, you will see what I just said as far as pathogenesis. The organisms enter, they go to Peyer's patches, they spread throughout the body, you get fever, they go into macrophages. One sign of this particular disease, clinically, is a rose spot. Here's some examples of rose spots on the belly of this person with typhoid fever. Okay? Typhoid vaccine. Earlier in the day, we talked about the fact that there are dead vaccines for typhoid. You take the shot 1 month and the next month and the next month, and you're immune for a while. But there is a brand new one that's much better. It's called Ty-21. It is oral, and it is a live vaccine. So if you are going to an area that has this particular disease, you certainly should be immunized for it. Now, I do want you to be aware that we have other salmonellas, not Salmonella typhi. That causes enteric fever or typhoid fever. We have lots of other salmonellas. They are gram-negative rods. On this image, you will see they have flagella. They are lactose negative on McConkey's. Those particular organisms are found in animals. They're found in the digestive tract of other animals. So as a result, we get gastroenteritis by eating the meat or the eggs or the milk, etc., from those animals. One of the notorious ones in this is from chickens. We all know that you need to cook chickens, you need to cook eggs. One of these organisms might be Salmonella enteritidis. there are at least 2,000 of these species. So obviously we're not going to discuss those today, but understand that there is a great difference between Salmonella typhi and Salmonella enteritidis. Typhi is human only. Enteritidis, the source, was another animal that occurred. This causes gastroenteritis. It can become septicemic. How do you prevent it? Well, you just make sure that what you eat is cooked properly. We have some other gram-negatives that aren't as high a yield. Yersinia pestis, that particular disease causes plague. That particular organism causes plague. That organism is primarily flea rodent. Actually, in my area of the world of Oklahoma, we actually have that disease, but it is found in prairie dogs. So fleas and prairie dogs have their own little deal going. They have their own little plague. But we do not have this in our population in humans. That material is not high yield. Obviously, if you got it, it's a very dangerous disease. It's highly contagious. If somebody breathes it, they're probably going to die because that's the pneumonic form of it. Another gram-negative organism causes urinary tract infections. This organism is called Proteus. Proteus looks very much like Salmonella. It is a flagellated organism, such as in your image. It is a non-lactose fermenter, and it produces urease. That is one of the real characteristics of that particular organism. Again, it causes urinary tract infections. It is urease positive, but one of the more characteristics of Proteus is when you put it on the media, it swarms. You can see that the inoculation started right here. And that organism has grown very rapidly, and he moved out here. Then he moved out here. Then he's continuing to move. That is called swarming colonies, and that's very characteristic of Proteus. Proteus is found in water, it's found in soil, it's found in our colon, etc. Now, there is one important thing that you should know. Here is another swarming colony of Proteus. There is one more very important thing that you should know about Proteus. Proteus vulgaris has some different serogroups. These different serogroups are used to identify rickettsial diseases. OX2, OX19, and OXK are some serological identifying groups of Proteus vulgaris that are used to identify rickettsial organisms. So that is going to be very important when we get to the rickettsia. Our next gram-negative enteric organism is the cholera organism. Vibrio is a small gram-negative rod. It's even curved. You will see by the next image, you can see that slight curve to this organism. The organism is Vibrio cholera. In this image, you will see the curved organism, and you can see that it has one polar flagella that arises from it. This particular organism is oral fecal spread in water. This particular organism is very dangerous worldwide. We don't have a whole lot of problem with cholera in the United States, but certainly worldwide there is a problem. Approximately 10 years ago, a pandemic started in Asia. It has spread throughout the world, and more recently it is in South America. Yes, the first place in South America was Peru. So we've got cholera. There are two major biotypes. One of them is called L. tor, and the other is cholerae. Within those biotypes are some subgroups. Without going into too much detail, I want you to know that the type that is the pandemic right now that is spreading in South America is O1 L-Tor Inaba. That involves the O1 antigen, the L-Tor biotype, and the Inaba subgroup. This particular organism grows on a very special media. This media is called TCBS media, and you can see in this image of where there is a bright yellow pigment produced by this organism. In a lot of board exam reviews, you will find a question about this organism, and it will be affiliated with dirty water. It will be affiliated with rice water stools. This particular organism produces a very powerful adenyl cyclase toxin. Large amounts of fluid are produced, large volumes. A person can literally lose liters of fluids every day. Proper handling of sewage, boiling of water in areas of where this organism is found is important. There are other vibrios. There is a Vibrio parahemolyticus. This particular organism also is an enteric organism. It is a food poisoning organism, and it's notoriously found in shellfish, oysters, etc. There's been several different clinical cases on board reviews and books, etc., about a group of college students going to New Orleans and getting in an oyster eating contest, and one of these college students ended up winning the contest, but he ended up getting Vibrio parahemolyticus from it. So this is a very, very dangerous disease. Although it is fairly limited in areas, it spreads very quickly. Fluid replacement is the major mechanism of treatment. In this next image, you will see this particular organism. This organism does not invade. You will see it just sits there. It produces the toxin. This organism produces the toxin, and the toxin causes all of this fluid loss to occur. The genus Pasteurella is a gram-negative organism. Probably the only one that you even want to think about remembering is Pasteurella multicida. Pasteurella multicida is in the mouth, around the teeth of dogs and cats. So on occasion, if you're bitten by a dog or a cat, you may get a lesion that works up the lymphatics and is very self-limiting usually, and this is caused by this particular organism. That certainly is not a high-yield test material. The next gram-negative rod is pictured in your images, and this particular organism is Haemophilus. Haemophilus is a gram-negative organism. Haemophilus is unique in the fact that it has this great capsule. Now remember, we've had several different organisms that have capsules that are important. Strep pneumo. The capsule of strep pneumo is used in the vaccine, Pneumovax, to inoculate, vaccinate elderly people, people with no spleens. Klebsiella has a big capsule, which makes it very mucoid when it grows. Neisseria meningitidis, YWCA, there's 4 serogroups of capsules. Well, this particular capsule in Haemophilus influenza is very important. This capsule is called type B, Haemophilus influenza type B. This used to be a major cause of meningitis, but due to the fact of this vaccine, again, the vaccine is given at 2 months, 4 months, 6 months, 18 months, and 5 years. So before you go to the first grade, you've already had 5 shots of this particular vaccine. So this organism has a great capsule. This organism requires 2 growth factors. These growth factors are called X and V. X is heme and V is NAD. Those growth factors can be supplied either in a disc. Here is a disc with these 2 growth factors, and here is Haemophilus growing around that particular disc. Or there is also another phenomenon called the satellite phenomenon. Haemophilus can grow if it is placed on blood and around, here's the Haemophilus growing, and here is Staphylococcus aureus. So Staph aureus and the blood furnish the X and V factors enabling Haemophilus influenza to grow, and that is the reason it's called a satellite phenomenon. This is another illustration of a satellite phenomenon. You can see the organism growing. Since Haemophilus influenza requires X and V factors, that means it's very fastidious. If you don't have that little disc, then you grow the organism on chocolate agar. So that supplies the X and V factors for the organism. Again, we do not have the problem we used to have with meningitis from this organism. But please note, there are many kinds of diseases that it can cause. It can cause epidemic epiglottitis. It can cause otitis media. Now, when it causes otitis media, it is usually non-typable Haemophilus influenza. That's N-T-H-I, non-typable Haemophilus influenza, meaning that one does not have a capsule. So today we have talked about 3 different organisms that cause otitis media or ear infections. We talked about strep pneumo, that's very common in little kids. We talked about Moraxella, and now non-typable Haemophilus influenza. Again, the vaccine is so good that most of us are vaccinated for this organism. Now, it is important that if somebody gets this, you cannot use penicillin anymore. This organism has also acquired a beta-lactamase by a plasmid. So Neisseria gonorrhea has acquired this, and Haemophilus influenza has acquired this. So you have to use something other than a beta-lactamase antibiotic. There is another Haemophilus. This is called Haemophilus ducreyi. This is a venereal disease. Now, so far today, we have talked about Neisseria gonorrhea. Now, here is the second venereal disease. This organism, you can see it's a gram-negative rod. It's called Haemophilus ducreyi. This particular disease is called chancroid. It is called soft chancroid. Now, please note, I did not say chancre. I said chancroid. Soft chancroid is caused by Haemophilus ducreyi. There is a lesion right there, and there is a lesion right there on the penis. These are very painful. They are soft lesions. The organism is present inside of these phagocytic cells. That is our second venereal disease. The next group of organisms that we're going to talk about is going to be Bacteroides. Now, earlier we told you that there were 3 organisms that you should know that have obligate anaerobic requirements. Actinomyces, which causes lumpy jaw. Clostridia. Clostridium causes tetanus, botulism, gangrene, pseudomembranous enterocolitis. Well, now we get to Bacteroides. Bacteroides is a gram-negative rod, and the organism that you should know is Bacteroides frugalis. This organism is the most common organism in our colon. Anytime we have surgery or we have some sort of cancer, colon cancer, etc., then we may have this organism spread. Here is an abscess. That abscess is due to Bacteroides. This probably was from some sort of surgery. Please note that this organism is endogenous. It's found in us all the time. This organism can cause a variety of conditions, but primarily it causes abscesses. How do you get rid of this particular organism? This organism is very sensitive to metronidazole. Here is a metronidazole disc. Here is Bacteroides. You see that it has been inhibited from growing around the disc. So metronidazole is an excellent antibiotic for Bacteroides. We also have another Bacteroides that's found up in the mouth area. This is Bacteroides melanogenicus. There is a new name for this, although the board hasn't started using it frequently yet. Who knows for sure when they're going to start it. But you certainly should keep in mind Prevotella. Prevotella melanogenica and Bacteroides melanogenica are the same organism. They happen to be bile sensitive, which means you're not going to have them down in the large intestine because bile will kill them. But you can have them in the mouth. So abscesses that are found in the mouth may be this organism, and you can see that it's a very black organism when it grows on culture media. That actually completes the discussion of gram-negative rods. I realize that that's very complicated. There are a lot of little small points that need to be made, but you need to study these in detail, especially the ones that I pointed out that you can get in different mechanisms. You can get from water, sewage, contaminated water, etc. The next group of organisms that we're going to talk about are going to be the spirochete organisms. These are spiral organisms. There are three of them that we're going to talk about. We're going to talk about treponema, which causes syphilis. We're going to talk about Borrelia, which causes Lyme disease. And we're going to talk about Leptospira, which causes Weil's disease. The first organism is going to be the treponemes. It's a spiral organism, and you can see the characteristics of this organism growing. Remember, this organism does not grow on artificial media. This is actually in growth inside of rabbit testis. You have to inoculate living tissue in order for this organism to grow. It cannot be cultured. It's a very thin spirochete, and it is a venereal disease. So far today, we've now talked about Neisseria gonorrhea as a venereal disease. We've talked about Haemophilus ducreyi as a venereal disease. And now we're going to talk about Treponema pallidum as a venereal disease. Syphilis has three major stages to its life cycle. The first stage to this life cycle is called a primary chancre. You will see that this male has two primary chancres on the penis. Here is a large primary chancre. This is called a hard chancre. It is not painful. Here is a female that has a chancre. This is another female with a chancre. Here is an individual in which the anus has a chancre. Here is an individual that has a chancre on the finger. This incubation of the organism can last 2 weeks, 3 weeks, 4 weeks, 5 weeks. The chancre appears. This is a hard chancre. That person is very, very contagious at that particular time. And that chancre will heal. Whether you treat it or don't treat it with penicillin, that chancre will heal. That doesn't mean that you got rid of the organism, because the organism may go into secondary syphilis. Here is a case of secondary syphilis. You can see these lesions all over the individual. Here's secondary syphilis in a female. Again, the female gets the worst part of these diseases, these venereal diseases. You'll see all of these lesions in that female. This is called condylomata lata. The mucous membranes are infected. This almost looks like warts virus, but it is not. Okay? This is condylomata lata. It is a secondary lesion in females. Syphilis will continue on if not treated in some cases, and it will go on to tertiary syphilis. This is a case of tertiary syphilis, and the lesion that you should remember is called a gumma. This is a gumma from tertiary syphilis, this gumma in the brain right there. This tertiary syphilis may affect liver, kidney, brain, heart, aorta, different areas of the body. Now, if that female has a primary lesion with syphilis, or if she has primary syphilis, it is possible for her to pass this to the baby. This is congenital syphilis. That female will pass that to the baby, and as a result of that baby having that particular organisms, there are many, many types of effects. Obviously, the worst effect is the baby be stillborn. But that baby may actually be born, and at later times, that baby will have varying types of things appear. This happens to be a perforated palate. This is from congenital syphilis. That individual may have Hutchinson's teeth. These teeth look like screwdrivers. That's from congenital syphilis. That baby, when it's born, it may have clear fluid running out of its nose. These are called snuffles. This clear fluid has organisms inside it. So you can very, very quickly diagnose and treat this baby if it's congenital syphilis. How do you identify syphilis? How do you diagnose it? If you'll recall, we talked about the primary stage just a minute ago. If you take that primary chancre and you take a scraping from that chancre and you put that scraping under a dark field microscope, you will actually see this organism in there. Then you will treat with penicillin. Early in the course of the disease, we start making antibody. We make an antibody that is positive in a VDRL test or an RPR test. This is a positive VDRL test right here. The antibody in that patient reacted with beef heart cardiolipin, and it agglutinated or clumped that particular beef heart material, and that is a positive RPR. That particular test will become negative after that person starts getting treated with penicillin, and that's an important point for you to remember. The VDRL does become negative following penicillin treatment. There are these screen tests for penicillin, for treponema. These screen tests for treponema are very cross-reactive. Somebody that has lupus may have a VDRL positive. So you don't always go by a screen test. You may want to run the true diagnostic test. The true diagnostic test is called the FTA antibody test. It is a fluorescent antibody test. The way you do this test is you put the syphilis organisms on a slide. You take serum from the patient and react it with the organisms. If that person has the antibody against the syphilis organism, you wash the slide and the antibody stays on the organism. Then you react that slide with an anti-human gamma globulin that has fluorescent dye. This is called an indirect FTA test. And here is a positive. This is greenish color. That is an FTA antibody. It is confirmation of syphilis. Syphilis continues to be easily treated with penicillin. So at any stage, the primary and secondary stage of the disease, you can treat with penicillin. The congenital stage of the disease, you can treat with penicillin. Our second treponeme is Borrelia. Borrelia is a large spirochete. You can see it in the next slide. Borrelia is a spirochete, and it causes a disease called Lyme disease. This organism is Borrelia burgdorferi. It is transferred to humans by the bite of a tick. This tick is the genus Ioxides. Normally this disease is in mice and the white-tailed deer. Ioxides keeps this little disease within that population. However, if humans are bitten by this tick, it develops into a disease that again has 3 stages. The primary stage of the disease looks like this particular image. It develops like a bullseye. You can see that it starts developing. It gets larger. The image gets larger and larger. This is the primary stage. This is called erythema chronicum migrans. So a history of being bitten by a tick, a history of being out in the woods where you have the white-footed mouse or the white-tailed deer. In the states that have this, we have lots of it in Oklahoma. Of course, Connecticut was where the disease was discovered. Now, this primary disease will go on into secondary. The secondary disease is more neurological. Then it will proceed into tertiary. The tertiary disease is an arthritis, a very severe arthritis. The third genus of the spirochetes is Leptospira. This is not nearly as important for your information as Treponema and Borrelia, but I want to mention this very briefly. This organism is spread by urine. Wild animal or domestic animal urine spreads this organism. You leave some food out at night and a mouse eats this food. It urinates on the food. You come in and eat the food the next day, and this is how you get this disease. Now, obviously, that doesn't happen very often. This is a disease that's more common in Oklahoma than it is in New York City or some other areas because we have lots of cattle. We have lots of ponds. We have kids that learn how to swim in ponds. So as a result of that, this particular disease is more common in Oklahoma and other areas where you have contaminated water. This is a dangerous disease because there is a triad to this disease. You have renal failure, meningitis, and myocarditis. There are lots of triads of diseases that I would rather have than those 3. I would rather have a headache and a runny nose and a sore throat than I would renal failure, meningitis, and myocarditis. Again, it is infected animal urine. We have now discussed the 3 spirochetes, Treponema, Borrelia, and Leptospira. 2 of those 3 are very high yield. I know at this particular point that you're going to be pretty happy because we really have finished the true bacteria now. So we don't have to do any more on those. Now, we still have organisms that some people place in with bacteria, bacterial-like, etc. And that's the chlamydia and the rickettsia. If you'll look at table 2-26, it has a comparison of some different organisms. For instance, typical bacteria are not obligate intracellular parasites. But you'll notice that chlamydia and rickettsia are obligate intracellular parasites. You can't grow them on artificial type media. You'll also note one more organism that we'll do after we do the rickettsia and the chlamydia is going to be the mycoplasma. Mycoplasma are not obligate intracellular parasites. They're like bacteria in that particular instance. The other thing on mycoplasma, and we will again cover that later, is they have no cell wall. So you cannot use penicillin or cephalosporins in treatment of mycoplasma pneumonia. Let's go to table 2-27. 2-27 has a great deal of detail about rickettsia. All of the rickettsia are not high level. Let me go through in order the rickettsia that I would make sure that you know that are very high level. The first one is Rocky Mountain spotted fever. We certainly have that in the United States, and that's an important rickettsial disease. The organism is called Rickettsia rickettsii, and you'll see it's listed as a bacteria, and that's fine. The vector is a tick. That you should know. That is very high yield organism. The second organism in order of high yield is Q fever. That is also in the United States. Q fever is an organism. The disease is caused by Coxiella burnetii, and you'll notice there is no vector for this. This is an organism that's found in cattle, sheep, goats. It's a farm disease. Those two I would make sure that I knew in great detail. Now, what other rickettsial diseases are a possibility? Well, epidemic typhus is a very dangerous disease. Epidemic typhus occurs when you have filth conditions. Rickettsia prausnickii. This is louse-borne, so when you get a lot of people in one area where they have lice, then this is a possible disease. The other one is the disease down at the bottom of the chart, ehrlichiosis. Ehrlichiosis is pretty widespread in Montana, Utah, Wyoming, etc. And it is a disease that's very similar to Rocky Mountain spotted fever. And we will talk about that in just a moment. The first one of these rickettsial diseases that we want to do in detail is the one that you should know best. You should understand and know Rocky Mountain spotted fever. This is Rickettsia rickettsii. This organism is an obligate intracellular parasite, and it is transferred by a tick bite. Now, there are other animals that carry this particular organism. There are reservoirs for this, but it is the tick that transfers it to us. This particular disease is a vasculitis. We are bitten by this tick. This organism enters us. It goes into the endothelial capillaries. It divides there, and it causes a vasculitis. You have extremely high temperatures. This treatment must be started fairly quickly, or this person is going to be in serious condition. Rocky Mountain spotted fever is usually identified by the fact that the rash starts on the soles and wrist and on the soles of the feet and the ankles. You will see from this particular slide, this person has Rocky Mountain spotted fever, and you will see that rash on different areas of that foot. This is the spotted fever case, and the rash is already spread to the trunk. That's the last place that it spreads to. How are you going to treat this? All rickettsia and all chlamydia are treated with tetracycline or doxycycline. How are you going to diagnose it? You're going to not culture it. This organism does not culture. You don't grow it. You don't try it. You do serological diagnosis. You can do a complement fixation test, or you can do a test called the Weil-Felix test. The Weil-Felix test is the fact that the patients that have this disease produce an antibody. This antibody not only reacts with the rickettsia, but it also reacts with Proteus vulgaris. It reacts with certain strains of Proteus vulgaris. It reacts with the OX2 and the OX19 strain, and that helps in identification of this particular disease. The second rickettsial disease that you need to know is Q fever. This disease is caused by Coxiella burnetii. It is unique in the fact that it doesn't do the things that typical rickettsia do. There is no rash, there is no vector, and there is no OX, Weil-Felix, test reaction. You have to use other mechanisms for distinguishing this particular organism. This organism is present in domestic livestock. This organism is spread by barnyard dust. It blows. It gets into our respiratory system. This particular disease, Q fever, is an atypical pneumonia. Now remember, that is a non-productive pneumonia. We talked about Legionella earlier in the lecture being an atypical pneumonia. Well, here is another atypical pneumonia. Diagnosis is serological. Again, treatment is tetracycline, and there is an occupational vaccine for high-risk people. Those are the two major rickettsial diseases. Others that we might mention, that you might be aware of, is ehrlichiosis, Ehrlichia. This particular disease is transmitted primarily by ticks. It infects monocytes and macrophages. This actual disease is called human monocytic ehrlichiosis. Again, I said that it was in Wyoming, Montana, Utah, and some of the western states. The disease is very similar to Rocky Mountain spotted fever. Now we're through with the rickettsia, and we're going to start with another group of organisms called the chlamydia. The chlamydia are obligate intracellular parasites. You use tetracycline or doxycycline for treating them. These are obligate intracellular organisms. These particular organisms have two phases to their life cycle. They have an elementary body stage. That is the infective stage. That is the stage that you would get from another person or from a swimming pool or from a hot tub, etc. And the reticulate body is the body that grows in us. It enlarges, and inside of it has the elementary bodies, and these elementary bodies are released, and then they go into the next host. So Chlamydia trachomatis is the genus and species of the organism that we're going to talk about for a few moments. I want you to note that it is found in the genital tract and the eyes. That's kind of unusual. What that really means is there are different kinds of diseases that this organism can cause. It can be sexual, or it can be an eye infection. Let's talk first of all about an eye infection. Here is the condition trachoma. It is caused by serogroups A, B, and C, and the organism is Chlamydia trachomatis. Now, not only does this organism cause eye infections, but it causes other infections. If you'll look at this print, this image, you'll see that this is a male, and this male has a chlamydial infection. This is a venereal infection. This is the #1 venereal disease in the United States, and it is caused by Chlamydia trachomatis serogroups D through K. Now that is different than the A through C serogroup. Not only can this cause an STD, but it can also cause inclusion conjunctivitis. Here is an eye infection with this organism, and that is caused by the same serogroup that causes the venereal disease. So it is possible for somebody to have the venereal disease and end up getting it in their eye or getting it in somebody else's eye. This is non-gonococcal urethritis. Gonococcal urethritis is caused by Neisseria gonorrhea. Not only that, but it can also cause a pneumonia in children. So in review, Chlamydia trachomatis serogroup D through K can cause pneumonia, inclusion conjunctivitis, and a sexually transmitted disease. The third serogroup that's important is the disease lymphogranuloma venereum. You will see this person has a large swelling lymphatic area. This is called a bubo. This particular disease is very dangerous. It's very common in Africa and Asia. It's not as common in the United States. Okay? Common in South America. But this is caused by serogroup L1, L2, and L3. Here it is in a female. This female has this large bubo right here. That is lymphogranuloma venereum caused by serogroup L1, L2, and L3. How do you know that you have a chlamydial infection? Obviously, you can do DNA probes. If you have a fancy STD laboratory, that is probably the preferred way to do it, along with gonorrhea probes at the same time. But other ways are used. Here is a fluorescent antibody. This fluorescent antibody shows the reticulate body. Now remember, inside of that reticulate body will be the developing elementary bodies, and that would be passed from one sex to the next sex. This particular organism also stains very good with iodine. So you either use a fluorescent antibody test or you use an iodine stain for identification of the organism. That's another reticulate body. This is a great reticulate body. In fact, it's either even rupturing and the elementary bodies are being liberated from that organism. Here is a great reticulate body and the elementary bodies are being liberated. Now, not only can you use DNA probes, not only can you use iodine and fluorescent mechanisms, but there is an ELISA test that is excellent. You would simply take a scraping from the female vaginal area or from the male urethra. You would take the swab and you would place this swab down in this tube. This tube has a bead, and that bead has an antibody on it. That antibody is an antibody to chlamydia. This is called an enzyme assay. We're not going through all the details of the enzyme assay, but this is a positive right here. So serological enzyme assays are also possible to do for this particular disease. You have two more species of chlamydia. The last group that we did was Chlamydia trachomatis. The next species is Chlamydia pneumoniae. Chlamydia pneumoniae is an atypical pneumonia, just like Q fever and just like Legionella. This organism does not have a productive cough. The third species of chlamydia is Chlamydia psittaci. This is transferred to us by birds. Normally, birds that are brought into the United States have to be quarantined, but some people sneak these birds in, particularly parrots, and we end up getting psittacosis. This also is an atypical pneumonia. You certainly want to be aware of the atypical pneumonias. How do you diagnose this in the lungs? You take a scraping, you do a fluorescent antibody, you do an iodine stain, you do an ELISA enzyme assay test, complement fixation test. There are different ways of diagnosing. Please remember, all chlamydia are treated with tetracycline or doxycycline. One of the last organisms that we're going to do before we start a discussion of medically important fungi is the genus Mycoplasma. Mycoplasma is a very unique organism. Sometimes a high school student, a medical student, will have a cold, chest pains, just don't feel good for a couple of weeks. They go into the infirmary or the clinic or to the doc. He gives them an antibiotic, and it just doesn't do any good. 2 weeks later, they feel just as bad. Well, there is a good chance that they have mycoplasma. Mycoplasma is the most common cause of pneumonia in young adults. So high school kids, college kids, medical school individuals may have Mycoplasma pneumoniae. The unique thing is that organism has no cell wall. So you cannot use penicillin, cephalosporins, and some of those antibiotics that you would use. It is respiratory transmitted. It goes from human to human. It is particularly important in areas of where you have a lot of crowding of people. Again, Mycoplasma causes an atypical pneumonia. Just think of how many we've already talked about. Q fever, Chlamydia psittaci, Chlamydia pneumoniae, and now we've got Mycoplasma. Mycoplasma is unique because of the colony that it looks like. If you grow it up on a media called Eaton's agar, it looks like a fried egg. You'll see that this is the yellow part of the egg, and this is the white part of the egg. There are several different diagnostic tests, but one of the tests that's used is called a cold agglutinin test. If a patient has this organism and you bleed them and set their blood in an ice box in the cold, it will agglutinate. Now, there are other types of tests that are a little bit more specific, but this is a pretty easy test. If you get a positive, then you know you got a positive. There are complement fixation tests, etc. Treatment of mycoplasma is excellent for erythromycin. Okay. Now, there is one more that is very, very important, and I would put this a little higher on my list, even though the notes don't have a great deal of detail about it, because 25 years ago, OB started kind of a new practice. They started in vitro fertilization clinics. They would have this couple that they're having trouble having kids. They would invite them in. They would charge them $15,000 to $25,000 to do the following. They would overstimulate the female to make large numbers of eggs. They would take these eggs. They would fertilize them in a test tube with the male sperm, the husband's sperm, and then they would in vitro place those eggs again in utero, place those eggs again, and see if she could get pregnant. Well, you know, some of the early cases, the first month she started making beta-HCG. Hooray, we got pregnancy. The next month she would abort. They didn't know why that was happening, but the reason that was happening, or one of the reasons that it was happening, is there is an organism called ureaplasm. You should be aware of that being a venereal organism. It is not Neisseria, so it's non-Neisseria. It's not chlamydia, it's non-chlamydial urethritis. So today we have discussed several different venereal diseases that certainly are high yield. Chlamydia, gonorrhea, syphilis, soft chancroid. We have now finished our discussion of bacteria, chlamydia, and rickettsia. We're now going to start a whole new area of mycology. Mycology is a study of the fungi. A few years ago, the board had very few questions on mycology, but due to the advent of HIV, various types of chemotherapies, various types of immunocompromised patients, various immune deficiency diseases, we have a lot of fungus organisms now, and the board considers those very high yield. Some individuals do not have as much background in mycology as you would have in bacteriology, for instance. So we want to make sure that we go at a pace of where you understand what the fungus organisms look like and how you identify the major ones that are associated with human disease. Funguses are very complex organisms, just like us. They have ADS ribosomes. However, fungi have a chemical called ergosterol. That ergosterol is in their cell walls, and that is an excellent mechanism hit for antibiotics or antifungal drugs. Some of those antifungal drugs that we will talk about will be amphotericin B. Amphotericin B binds to ergosterol in the cell wall. All of the imidazoles inhibit ergosterol synthesis. So some of our primary antifungal drugs are involved in that chemical ergosterol in the cell wall. Let's first of all talk about some fungus terminology. There are two major forms to the fungi. They are either hyphae or mycelium. This is a hyphae or a mycelium. Particularly, it's a hyphae. A mass of hyphae are considered to be mycelia. But here is a hyphae. That hyphae does not have any divisions. You'll see that it's solid. This is called non-septate or aseptate hyphae. Now you say, well, why would a medical doctor want to know that? Because we have a very serious disease that is caused by this organism in immunocompromised patients. So you need to know what a non-septated or aseptate hyphae is. Now this is different. You can see that this hyphae is divided. That is a septated hyphae. Some hyphae have color. Hyphae that have color are called demaciaceous. You'll see that this fungus hyphae, it is red. It may be brown. It may be black. This stain caused it to be red. But a hyphae that has color to it is called demaciaceous. If the hyphae is clear, it's called hyaline. Now another form to the fungus is the yeast form. If it's not a hyphae, it's going to be a yeast. And here is an example of a yeast form. This happens to be Cryptococcus, which we'll spend some time on later. You can see this great big capsule that the organism has. In fact, it's even budding right there. It's putting out a bud. So there are two major forms to funguses. They are either hyphae or they are yeast cells. We're going to talk about, in the discussions, we're going to talk about some major fungus diseases that cause real problems in man. Some of these really bad fungus diseases are called dimorphic fungi. We'll be talking about histoplasma, blastomyces, coccidioides, and sporothrix. First of all, the terminology that you should understand is dimorphic. Dimorphic means that it is one form in us and another form on culture. So if it is a yeast in us, when you culture it, it will be the mold form or the hyphae or mycelial form. So dimorphic fungi are very important in identification of different diseases in us. Some funguses, such as Candida albicans, may have several different forms when you culture it. This particular model shows a Candida albicans. It shows you this Candida having some little microconidia. It shows you having chlamydospores, and it shows you having pseudohyphae. This is some of the characteristics that help identify the fungus Candida albicans. Now there are different spore types that you have in fungi. Here is an example of one spore type right here. These are called conidia. You'll notice here comes this mycelium, and on the end of this mycelium you have these spores being formed, and those are called conidia. They are asexual spores. Another type of spore that you have is called an arthroconidia. An arthroconidia means that the spore is found on the inside of the mycelium, and it does not swell the mycelium. Now you say, well, do I need to know that kind of detail? Yes, you do, because this particular organism right here is one of our serious dimorphic fungi. So this is an arthroconidia. What is an arthroconidia? It is a spore that is found inside of the mycelium itself. Spherules. This is a spherule. This is found inside our lungs, for instance. And this spherule is entirely filled with little endospores. You can see those little endospores. So what we've done first here on the fungus is we have identified some terminology. You should know what a conidia means. You should know what a yeast bud means, what an arthroconidia means, what a spherule means, what septated and non-septated hyphae mean. Now we're going to go, and I want you to observe 3.1. This tells you about preparation of fungus materials for identification. If you will look on the next image, you will see that you can't tell much about that. You can't tell much at all. You can kind of see a mycelium running there, and that's all you see. Lots of times, this is what a fungus sample might look like coming out of us. So you have to treat it. This fungus sample, first of all, will be treated with potassium hydroxide. This is on that table 3-1. The purpose in treating it with potassium hydroxide is to dissolve the human tissue away. In this picture right here, in this particular demonstration, a lot of that is human tissue. Now there are some stains for fungi. What stains should you know for fungi? You should know what a silver stain is. This is a silver stain. This is called methenamine silver. The reason you should know this is the stain that you use for the organism Pneumocystis. Pneumocystis is a fungus organism that is the #1 killer of HIV patients. So you must understand that in HIV patients, if they start getting a pneumonia, this is a scraping, and you stain it. You stain it with methenamine silver, and this proves they have pneumocystis, and they have to be treated for that pneumocystis. Here is an India ink stain. This is for Cryptococcus. Here this great big yeast is, and here is the India ink stain for this particular organism. Now there is another stain, and that stain is not in that chart, and I would suggest that you add this stain. It is called lactol phenol cotton blue. LACTOPHENOL, lactol phenol, PHENOL, cotton blue. You'll see the blue color to this particular stain. That is an excellent all fungus stain. You can stain almost any fungus with that material. You should understand that when you culture fungus, there is a special media, and that media is called Sabarod's media. That is what you use to culture most fungi on. How do you test somebody for fungi? #1 is you can do serological testing, in which you are testing that person for antibody. Now that is going to be important. #2, you can test people for antigen. You can do a spinal tap to find out if that person has antigen in them. So, in essence, what can we do for funguses? #1, we can stain them. #2, we can culture them on Sabarods. #3, we can check the patient for antibody. #4, we can check the patient for antigen. You also can skin test for it. Some of these fungi have skin test. Blastomycosis, histoplasmosis, cocci has a skin test. The first organism that we're going to talk about is actually the first dimorphic fungus that we've got. This organism is called Sporothrix schinkii. It is a dimorphic fungus. When this organism is in tissue, it looks different than it looks when it's in us. This is an environmental organism. It's found out in the soil. We get it by traumatic implantation. This is a little old lady's rose garden disease. She's working in her flower bed. She gets stuck with a rose thorn, and she gets this organism. This is called rose gardener's disease. It's called sporotrichosis. It is called lymphocutaneous sporotrichosis. It works up the lymphatic channels. This is what it looks like in culture. These are called daisy clusters. Daisy-like clusters of conidia. Here it is again in culture. This is daisy-like clusters. This is Sporothrix schinkii. That culture also may assume this form. You'll see where these conidia are along this mycelial area. This is called a sleeve conidia, a sleeve of conidia. This particular disease primarily is from traumatic implantation. In us, the form of the disease is a cigar-shaped yeast cell. Here are these yeast. That's what's in us. This is what moves up the lymphatic channels. Here is a case of sporotrichosis. That person stuck themselves somewhere there, and it has started moving up the lymphatic channels. Here's another case. You can see it moving up the lymphatic channels. Here's a great picture showing it. This organism is moving up those lymphatic channels. Again, it was from a traumatic wound. And again, we have a wound on the foot that has started moving up the lymphatics. Treatment of this is very specific, so that's why you have to make sure you know exactly what the organism is. In treatment, you give potassium iodide in milk. That person actually drinks potassium iodide for a long period of time in milk. Not only that, but the potassium iodide would be sponged on these lesions. You would just take a little cotton swab and you would sponge the chemical on to those lesions. That is the first dimorphic fungus. For board purposes, you be sure you know that the stage that's found in us, the in vivo stage, is a budding yeast cell, cigar-shaped. In culture, it is a daisy-like cluster or a sleeve conidia. We're going to continue on with our discussion of dimorphic funguses. And now we get to the really bad guys. We get to the deep fungus diseases. These are the systemic fungus diseases. These three are the most likely ones that they would ask you on board questions. So these are extremely high-yield discussions. The first disease is called histoplasmosis. This particular disease starts out as an acute pulmonary disease. All of these three diseases must start in the lungs. So if you find a lesion in some area of the body other than the lungs, it is already spread systemically, and that person has poor prognosis. So it becomes a lung to other area disease. This is a dimorphic fungus, so that means that it has two different forms. In culture, the form looks like this. This is called a tuberculate chlamydospore. If you look in your notes, you will find that terminology, a tuberculated macroconidia or a tuberculated chlamydospore. In culture, you also have little bitty microconidia. These microconidia are probably the forms of transfer to our lungs from the environment. This is also found in the environment. Here again is a different stain of the tuberculate macroconidia. After that organism gets into us, it changes. It changes into the form that's in us, and this certainly you need to know. This is a yeast phase, but it is intracellular. You'll notice that this is a phagocytic cell. Here is the nucleus of the phagocytic cell, and these are the intracellular yeast. This organism is found intracellular inside of our reticuloendothelial phagocytes. This is histoplasmosis. It is extremely dangerous, and one of the most important things that you want to understand is There is an endemic area in the United States. Figure 316 shows you the picture of the endemic area in the United States. It is right down the center of the United States. It follows the Mississippi, the Ohio River Valley. So we're talking about Arkansas, Oklahoma, Kansas, South Dakota, North Dakota, Minnesota, Missouri, Tennessee. All in that area is the endemic area. This particular organism is found in soil. It is found in bird-enriched soil. Chicken feces, bird feces, enriching the soil stirs up these organisms, particularly when you build a new barn, when you cut down a bunch of trees where starlings have been nesting. This helps spread that particular disease. Now, what do you need to know? You need to make sure that you know the stage that's in us is an intracellular yeast inside of phagocytic cells. The stage in the environment or in culture is a tuberculate macroconidia or a microconidia, and the microconidia is the form that is spread to us. This is a very dangerous disease. It's particularly dangerous in immunocompromised, HIV, etc. patients. How do you treat it? You treat this with amphotericin B. If somebody has this disease, again, let me show you the in vivo form in us. Here's what's found inside the phagocytes. It's yeast cells. It's a very innocent looking fungus culturing it, very fluffy, white looking. And here is a case of it. Now recall, the first thing I said was if you find this organism in some other area of the body other than the lungs, it has already gone systemic. So that person right there has to be treated with amphotericin B. How do you know that it's successful? The way you know that this fungus treatment is successful is you do an antibody test. Normally, antibody is great. But in fungus diseases, we depend on cell-mediated immunity to get rid of those fungi. We do not depend on antibody. If an antibody titer goes up with this particular disease while you're treating with amphotericin B, that is poor prognosis. If the antibody titer goes down while treating with the amphotericin B, and that person is feeling better, then that is good prognosis. The second systemic fungus disease is Coccidioides immitis. Now this is our third dimorphic disease. Coccidioides immitis also has its unique area, its own endemic area in the United States. It's found in Southern California along the San Joaquin Valley area, Arizona, New Mexico, Texas, on down into Mexico. This particular organism is found in the environment, and when it's in the environment, it is in this form. You will see that form we talked about a minute ago, these are called arthroconidia. They are inside of the hyphae. They do not swell the hyphae. Here's another example. These are arthroconidia. This is what is blowing around in the environment. You're out in Southern California, you're from New York City or some other area that doesn't have this disease. You get out into the dust of the desert. This is blowing around all over everywhere, and you get this particular organism, particularly if you are immunocompromised. Now, after that organism gets into us, it forms a different stage. A minute ago, we showed you the spherule. Here is a spherule. This spherule has these endospores. This is the stage that's found in us. Here is an extremely large spherule with endospores. Again, there is an endemic area in Southern California, New Mexico, Arizona, Texas. The infective form is the arthroconidia. The form that's in us is a spherule with endospores. You treat this disease with amphotericin B just like you do histoplasmosis. Here is a person with this disease. Now you already can tell me that that person is in bad shape because it's already spread from the lungs systemically to this area of the body. Just like histoplasmosis, if you're treating this person with amphotericin B and their antibody titer increases, there is poor prognosis in this particular disease. Let me make sure that you understand what is the stage of cocci that's found in us. It is the spherule with endospores. What is the stage of cocci that's found in culture? It is the arthroconidia. The next dimorphic fungus and the last dimorphic fungus that we're going to do is North American blastomycosis. This is the third systemic fungus, and it's the fourth dimorphic fungus that we've talked about. This particular fungus also has an endemic area. It is found in the endemic area of the East Coast, and it overlaps histo to some degree. But if you have a fungus disease in North Carolina, South Carolina, etc., Virginia, it probably is North American blastomycosis. If you have a systemic fungus disease in Tennessee or Arkansas or Missouri, it very likely is histo, but it could be blasto. How do you know blastomycosis? Here is the stage that's found in us. It is a large yeast. It is double refractile. It has a very wide isthmus between the daughter cell and the mama cell. A very broad isthmus. It is double refractile. So in us, the stage that's found is a yeast cell. Here is a great yeast cell. You can see the double refractile. You can see the broad isthmus yeast cell. Now you understand that there is an endemic area in the United States. This disease starts off as a pulmonary disease and it spreads. So that means that this person is in bad shape. It is already systemic in their body. Here is another case of it. That's pretty bad looking. That is blastomycosis. Here's another. And the final case of blasto. In summary of those funguses, you want to make sure that you understand the three major systemic dimorphic funguses. Plus, there is a fungus that is a dimorphic that's called sporotrichosis, but it does not go systemic. The next group of funguses that we want to talk about are the opportunist. The opportunistic fungi, such as Aspergillus, occurs when you are immunocompromised. This normally would not cause a disease, except in the case of immunocompromised people, HIV, chemotherapy patients, etc. Here is what Aspergillus looks like. It's a very fluffy looking fungus. Here are all the spores of Aspergillus. They would spread in the air. Aspergillus has several forms. The first form is just an allergic bronchitis, bronchopulmonary allergy. Somebody that goes out and works in the wheat fields probably would get this in the summertime, but they would end up getting over it. The next time they worked in the wheat fields, they would get the same thing. But it may progress further. It may form a fungus ball. This is an illustration of a fungus ball. Here is a mass of fungus right here in this lung. Here is a great big fungus ball in this lung. It's caused by Aspergillus. Aspergillus becomes very serious when it becomes invasive. I want you to understand that in burn patients, in cystic fibrosis patients, in neutropenic patients, if you get a fungus, it may be Aspergillus. Remember, if it's a bacteria, it may be Pseudomonas. So you want to keep that in mind. Aspergillus, if it's systemic, you may have to use amphotericin B. One of the most dangerous parts of the invasive aspergillosis is the mycelium starts to penetrate blood vessels. And as a result of that, you get a great deal of blood in the lungs. Again, this disease is very dangerous in HIV patients and immunocompromised patients, in burn patients, cystic fibrosis patients. Aspergillosis is an opportunist. The most important things you need to know on the fungus are the dimorphic fungi, particularly the systemic ones. And the second thing is the opportunist, and we're discussing those opportunists now, aspergillosis being the first one. The second opportunist is candidiasis, the organism Candida albicans. This particular organism, in culture, you will find it to be a yeast cell unless you use a very special media for growing the organism. You will see illustrated in this slide the yeast of Candida albicans. This particular organism is certainly an opportunist, but it doesn't have to be just HIV patients or chemotherapy patients. Individuals, particularly females, who are on some form of antibiotic, it might be for a urinary tract infection. That antibiotic will knock out most of the urinary organisms. It will knock out organisms in many areas of the body, and it allows Candida albicans to start growing. Identification of Candida albicans can be done by taking the organism from the sample from the patient and putting it into serum and growing it in serum. Very quickly in serum, Candida albicans forms germ tubes. This next image shows you the germ tube being formed by this organism. And this is an identifying characteristic for Candida albicans. There are different kinds of different forms of disease that you get from Candida albicans. When you take Candida and grow it up, you may get a very unusual type growth, particularly if you use a media called cornmeal agar. You will form a very characteristic type of culture, and you can see that in the next image. You can see small microconidia. You can see chlamydospores. You can see pseudohyphae. And this is helpful in identification of this organism. Some of the forms of disease in this organism, one form would be oral thrush. This is demonstrated in the next image. You can see the organism is growing in the roof of this individual's mouth. Here is another case of oral thrush in this particular image. Candida albicans is very dangerous in immunocompromised or HIV patients. Usually the area of the body that it attacks is the esophagus or the stomach. And when it's growing in patients that have HIV or immunocompromised, it does not grow in the yeast form, but it grows in the mycelial form. This is kind of reverse dimorphism. You remember in the dimorphic forms that we talked about in systemic fungi, it was the yeast that was in us, and it was the mycelium on culture. But in Canada, in this next image, you can see that this particular esophagus no longer has any stratified squamous lining. It has been completely removed by this mycelial mat of fungus, and this is Candida albicans penetrating the esophagus in this particular individual. Little fat babies in the hot weather lots of times get Candida. In this image, you can see where that little baby has this growth underneath in the chin area, where that little baby is going to sweat a lot and allow that organism to grow. Here is another image of Candida. That image, it looks a lot worse than it actually is. This organism is also a venereal disease. Here it is in a male, and you can see the organism growing on the end of the penis in this particular male. Here it is in a female. The organism is growing around the vaginal anal area, all along in this area here. Candidiasis can be treated. It is treated with a variety of drugs. One of those is nystatin. If this organism is spread in HIV patients, it may take something much stronger than that. It may take amphotericin B. It may take fluconazole, depending on the physician and depending on what areas of the body happen to be infected. So that is our second opportunist. Our first was Aspergillus. Our second is Candidiasis. The third opportunistic fungus that we're going to talk about will be Cryptococcus. Cryptococcus only has one form to its life cycle. It has a yeast form. Here is the yeast form to Cryptococcus. This organism usually starts out in the lungs, and it will spread, and one of the major places that it spreads to is it spreads and it causes meningitis. Here is Cryptococcus that has spread into the brain area, and it spread from the lungs. Here is Cryptococcus in the brain, the meninges of the brain. You can see this mucoid-looking material present in that brain section. Cryptococcus in the lung, you will see the large yeast, and you can see the capsules on those yeast. Cryptococcus is diagnosed by taking spinal fluid. If you take spinal fluid, you will find the antigen present. Now remember, we told you on the dimorphic fungi, on Blastomyces, Histo, Cocci, you determine the seriousness of the disease and the effective therapy that's going on in that patient by checking for antibody. Cryptococcus is opposite from that. You're going to do a latex test, latex agglutination test, on the antigen present in the spinal cord, spinal fluid. You're going to take that material, and if the titer of that keeps increasing and you are treating that person with amphotericin B, their prognosis is poor. So what you want in a crypto patient is treating with amphotericin B, the latex agglutination of the antigen, the titer of that antigen to decrease. Cryptococcus is a urease positive organism. You can see in this image, this pink, that is a urease positive test. Now we've already had several positive urease organisms. We had the organism ureaplasm. We had the organism Proteus. These are all positive urease tests. Here is a fluorescent antibody picture of a crypto in the brain. You will see the pink area is Cryptococcus, and you can see the capsules surrounding that particular organism. So a direct fluorescent antibody test is possible. This particular organism is treated with very strong antifungal drugs, amphotericin B, fluconazole, some of the others. It may be mixtures of those that are used. The next group of organisms are the organisms that have no septum in their hyphae. These are common organisms found in the environment, mucor and rhizopus. And in immunocompromised patients, these become a real problem. They enter by way of the nose, the nasal area, and they penetrate and go to the brain. This is particularly dangerous in diabetics and in leukemic patients. This organism is mucor, and it's very, very difficult. It's very rapid in its activity, and it must be diagnosed very quickly. The mycelium are very, very broad-based, and the angles of branching of these mycelium are about 90 degrees. The last opportunist that we're going to talk about is the #1 killer of HIV patients, and this is a fungus. It is pneumocystis. This particular organism gets into the lungs in the immunocompromised, the HIV, the chemotherapy patient, and starts growing in the lungs. And one of the classic identifications that you do for this organism is you do a silver stain. We had mentioned these stains before when we first started the fungus. But here is a methionine silver stain present in the lungs of this HIV patient. You can see the silver staining organism. Here is one of the forms of the organism. Here is a big cyst. It is a fluorescent antibody shot. You do not culture this organism. You usually take a scraping from the lungs and you either do a methenamine silver or you do a fluorescent antibody test on this organism. The next image shows a negative fluorescent antibody test. The next image shows a positive. So you can see this organism in this area as being a positive stained organism. This organism must be treated, and the typical treatment is trimethoprim sulfamethoxazole. So all HIV patients that have this will take this particular drug. That completes the fungus section. Again, the most important things that you need to know on the fungi are the systemic dimorphic funguses and the opportunistic funguses. Due to chemotherapy and HIV, fungus diseases are increasing a great deal, and as a result of that, you certainly should be aware that the Step 1 board questions on fungi are going to increase accordingly. We are now going to start our last group of organisms in this lecture series, and it is going to be on medical virology. Let's talk a little bit first off about viral structure. The very first part of this lecture, we told you that viruses have either DNA or RNA. They do not have both. So the viral genome is composed of DNA or it's composed of RNA. Covering that viral genome will be a protein coat. This is called a capsid, C-A-P-S-I-D. And that protein coat may consist of several different repeating units. Those repeating units are called capsomeres. Some viruses may have 252 capsomeres, 162 capsomeres. The specifics of that you do not need to know. But if the virus only has the genome and the protein coat, that is called a naked virus. There's only two parts to that virus. Some viruses are more complex. They not only have the genome and the structural protein, but they also have an outer covering, and that particular virus is an envelope virus. So there's two major structural types of viruses. There is a naked virus, and there is an envelope virus. You will see on this picture, this RNA has a little star by it. That is very, very important, and this terminology is on the figure 5.1 at the bottom of the page. Now you understand that there are DNA viruses and there are RNA viruses. There are actually two types of RNA viruses. An RNA virus that is termed a positive sense RNA virus means that when that genome enters the cell, it can hook up immediately to the ribosome and it can start synthesizing viral protein if it is positive sense. The reason this star is there is because RNA viruses all are not positive sense. Some of them are negative sense. If they are negative sense RNA viruses, that means they are complementary to messenger RNA. They cannot be used as messenger RNA. They actually require bringing into the cell that they're infecting an enzyme called an RNA-dependent RNA polymerase in order to convert this to a negative strand to a positive strand, from a negative strand to a positive strand. And then the positive strand can hook up to the ribosome and start making protein. We want to take a lot of time on viruses today because the board considers those very important, and we want to make sure that we understand. Number one, there are DNA viruses. Number two, there are RNA viruses that are positive sense. That means they can hook directly to the ribosome and start making viral protein. Number three, there are negative sense RNA viruses. That means that piece of RNA has to bring in with it an RNA-dependent RNA polymerase so it can be converted from negative strand to positive stranded RNA. Here is a picture of a naked virus. You can see that it has no envelope on the outside. All there is just genome and capsid. On figure 5-3, you will see some of this discussion that we just finished. Here is a naked virus. Here's the genome, and here is the capsid covering. This particular virus is cubic shaped or icosahedral. A lot of viruses that we're going to talk about will be this shape. The other shape that viruses can assume are helical. So you have two major virus shapes. You have cubic and you have helical. Now remember, these are considered naked viruses because they have no envelope. At the bottom of this figure, you will see that this is a cubic virus. Here is the genome of the virus, and it has an envelope covering. Here is a helical capsid with the genome, and it has an envelope covering. So you will need to know which viruses and what type of structure they have as we go through the discussion on these organisms. Again, here is a naked virus, and here is an enveloped virus. You'll see this envelope on the outside of that particular virus. This is a good example of an adenovirus. This is a good example of a herpes virus. No matter what microbiology course you have, you probably had a great deal of information given to you on the bacteria. You may or may not have had a lot of information given to you on viruses. Some microbiologists are not good virologists. They know their bacteria, but they do not teach a lot of virology. This is very, very important for the boards, so I want to make sure that we go through And we have a lot of time on this material to make sure that you absorb this material. The first group of viruses that we're going to talk about is we're going to talk about the DNA viruses. And you know what I want you to do first of all is I want you to mark through pox virus. We haven't had any pox virus in the world since 1968. I think that was the last case. So there is no longer any pox virus except being stored by two of the great nations of the world. So as far as discussions of this as a disease, we're going to get rid of this. We don't want this. But I'll tell you what I want you to put in place of this picture in your notes. I want you to draw another virus that looks very similar to this. Make it a cubic shape and make it have an envelope on it. And just draw it right over here in place of this virus. And I want you to put hepatitis B. Hepatitis B. Okay, now we are now going to talk about the DNA viruses first. After we finish this chart, I want you to keep this chart handy where you can keep turning back to it. Because we will come back and we are going to go through each one of these virus groups and discuss the viruses that are in these groups. So we're going to have 5 groups of viruses that are DNA viruses. The parvovirus group, the papovirus group, the adenovirus group, the herpes virus group, and hepatitis B. Again, get rid of this pox virus and draw you a cubic virus that has an envelope that looks very similar to herpes, except label it hepatitis B. This particular virus right here is parvovirus. This virus also, if you want to label it, is called B19. The disease that it causes is called fifth disease. And we will do the details of each one of these diseases later. But the more you get this in your notes, the more times you have it. I love repetition. This is called the papovirus. This is the different groups of warts viruses. And we will be talking about those in more detail. These are the adenoviruses. You can see that it has cubic symmetry. Here is the herpes virus. What all is in the herpes viruses? Herpes 1, herpes 2, Epstein-Barr virus, CMV virus, and varicella. I'm going to repeat that. If you want to write this down now, you don't have to, because later on you will have this in your notes again. Herpes 1, herpes 2, CMV virus, Epstein-Barr virus, and varicella, chickenpox virus. Now you look at this and you'll say, Dr. Dunn, I never will be able to learn all of this. It actually is very easy. It looks difficult right at first. What you want to do is you don't want to look at the whole forest. Do not look at the whole forest. Look at the individual trees. Tell me what shape that is. It's cubic. This is cubic. This is cubic. This is cubic. And hepatitis B is cubic. From what I said just then, you understand that you can now start making a characteristic list of DNA viruses. All DNA viruses are cubic symmetry. So you can see that. Okay? Now let's make this as simple as we can. Let's build a foundation of these viruses. What viruses do you think are going to be the most likely viruses that are asked on the board? Number 1 is HIV. Number 2 is herpes. There's herpes right there. Number 3 is hepatitis. That is the 3 organisms that you need to know best. HIV, herpes virus group, and hepatitis. Here's hepatitis B we had you draw. Now I want you to understand that DNA viruses, there are 2 DNA viruses that have envelopes. And it's 2 out of those 3 that you need to know. You need to know herpes and you need to know hepatitis B, and they happen to be enveloped DNA viruses. This picornavirus did not show up very good, but on your slide you will be able to see this on your figure 5-4. It is a very, very small cubic virus. This is the reovirus or the rotavirus group. This causes diarrhea. I also want you to draw one more. I want you to draw one more cubic virus. Just draw it right here in your notes. And I want you to label that virus the calcivirus. C-A-L-C-I-V-I-R-U-S. Calcivirus. So you've got this little picornavirus that's cubic, this reovirus that's cubic, and this calcivirus that's cubic. You'll notice that most RNA viruses are envelope viruses. There are three groups that are not. The picorna, the reo or the rotavirus group, and the calcivirus group are not enveloped. Let's look at these two virus groups. Again, we don't want to learn all of the forest at one time. We'll be coming back to each one of these groups. That's why I suggest that you keep figure 5-4 handy as we go through these different groups of viruses. The flavivirus and the togavirus are cubic viruses, but they are enveloped. I want you to draw a line right here. You should have a line right here. And I want you to understand that everything on the left side of that line means the virus is helical shaped. Everything on the left side of this line means that the virus is enveloped shaped. So now we've got a set of viruses. We have told you that there are three groups that are cubic, non-enveloped. There are two that are cubic, enveloped. And the rest of the RNA viruses are helical and enveloped. So what can we say for sure about RNA viruses? You want to start working on your set of notes for RNA viruses. One thing you can say is all helical viruses are RNA viruses. All helical viruses are enveloped viruses. Now again, I want you to keep figure 5-4 right in front of you in your notes, so as we go back and forth through these different organisms, we can refer. There's one other thing that you might want to put, just right over here. I want you to put positive sense RNA viruses, just over in this area right here. Over in this area right over here, I want you to put negative sense RNA viruses. Now, as we talked about before, if it is a positive sense RNA virus, that means that the genome of these organisms can enter the cell and immediately bind to the ribosome and start making protein. If this is negative sense, that means that it had to bring into the cell with it an RNA-dependent RNA polymerase, and it goes from a negative strand to a positive strand. Then that positive strand can bind to the ribosome and start making protein. We will continue on with our study of viruses. Again, please keep figure 5-4 handy. If you will now turn to figure 5-5, we will talk about very briefly and very superficially at this particular time viral replication. Viruses, in order to replicate, they will have an attachment receptor area on the cell. This virus attaches to a specific receptor. The virus penetrates the cell. This virus uncoats, that means the capsid releases the genome, and this genome is now ready to go to work. Now remember, if this is a positive sense RNA virus, it can hook to the ribosomes and immediately start working. If it is a negative sense, then that means it is going to have to go from a negative to a positive sense first, and it does it by that enzyme that it brought in. If this is a DNA virus, it is going to go into the nucleus in order for it to start working. We told you that all DNA viruses, if you want to go back to your picture on figure 5-4, you will see that all DNA viruses are cubic. I also want you to write that all DNA viruses replicate in the nucleus. So if this is a DNA virus, all of this mechanism is going to happen, and that DNA is going to be in the nucleus. If this is an RNA virus, that replication is going to be out in the cytoplasm, with two exceptions, and we will bring these up at different times. HIV replicates in the nucleus. Influenza replicates in the nucleus, but all other RNA viruses replicate in the cytoplasm. But we're really not talking about specifics, we're talking about generalities right now. Here comes this genome. What is the responsibility, or what are the three things that happen in viral replication scheme? Well, after this occurs, there's three major things that happen. Number one is early messenger RNAs are produced and early protein is synthesized. Number two is replication of the genome. And number three is synthesis of late messenger RNAs. Now I want you to understand that if this is a DNA virus and this is in the nucleus, the only thing there is DNA. So it relies on the host to produce its early messenger RNAs. Well, what does the host cell have in there that can convert DNA to messenger RNA? It is the same enzyme that we do that procedure with. It would be DNA-dependent RNA polymerase. And we produce those early messenger RNAs. Now, one of those early messenger RNAs is going to cause the production of an enzyme that can replicate the genome. Well, if this genome is DNA, that means one of these early enzymes must be DNA-dependent DNA polymerase. So we're going